co-chairs Senator Mary Doherty Abrams, who hails from Ireland, at least going back some generations, as I imagine many of us on the call are today. We have a number of bills for today's public hearing. We have a good number of speakers, and let us get to the business at hand. I will turn it over to my co-chair for any opening comments.
I'm excited. I'm Senator Mary Doherty Abrams. I'm very excited to hear the bills that we're hearing today. And
today's public hearing, we have a good number.
Somebody has.
Let us get to the business at hand. I will turn it over to my co-chair for any opening comments.
It's like a reverb. Okay. I'm Senator Mary Doherty Abrams and a co-chair of Public Health, and I'm excited about today to hear the feedback on these bills and to see how we can make them the best they can possibly be. So thank you very much. Hope we have a great day. Jonathan, you're muted.
I don't remember muting myself. Happy St. Patrick's Day, Representative Pettit.
Thank you, Mr. Chairman. A busy day in front of us with 5 bills and almost 130 people signed up. So I hope we will get to the point and ask incisive questions and do the best we can to determine whether any or all of these bills need to proceed forward. And happy St. Patrick's Day to everybody. We will probably see you tonight at around 10 p.m.
Well, I hope you're wrong about that, Representative. Senator Wong.
Thank you, Mr. Chair, and happy St. Patrick's Day to all. I am eager to hear the testimony as well, particularly a number of the bills, but particularly on the Senate Bill 1 on the mental health, behavioral, and physical health during this pandemic. And it is critical, and I want to be able to offer that this is a concept that has true bipartisan support. And through the public hearing process and input from various shareholders, that we can indeed craft a bill meeting that goal. So I'm eager to learn more, but I also wanted to share that there are many other committee hearings going on via Zoom, that there may be many of our colleagues that are going in and out, knowing that this is of very strong interest. I know they're going to be very engaged, but I wanted to acknowledge that.
Thank you, Senator. Very excellent point. We have a number of people who need to speak today, and we have a number of committees that people need to be listening in on. So the best way we can honor all that is to be as expeditious as possible. I do not see Senator Summers this morning yet. She's probably arriving later, isn't it, another meeting. So without further ado, we'll get to the matter at hand. And first up is the President Pro Tem of the Senate, Senator Martin Looney. Welcome, sir.
Good morning, and thank you. It's great to be before the Public Health Committee this morning. This committee does such wonderful work, and happy St. Patrick's Day to all. Representative Steinberg, Senator Mary Doherty Abrams, and Senator Huang, Representative Pettit, members of the Public Health Committee. I'm Martin Looney, State Senator of the 11th District, representing New Haven, Hamden, and North Haven, and I'm here to speak in support of Senate Bill 1, which Senator Huang just mentioned in his preliminary comments, an act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. Of course, in addition to the shocking number of deaths and cases of serious illness and long-term disability caused in the course of the pandemic in the past year, the mental health of many of our people has been dealt a serious blow, as well as so many other aspects of society being impacted. And we know many civilizations have suffered deadly pandemics, going back to the plague of Athens in 430 BC during the Peloponnesian War, and on to the Black Death in the Middle Ages and the 1918 influenza that killed millions of people around the world. And just as those before us, we're now faced with the challenges of grappling with the powerful after effects of a pandemic. And unfortunately, the current effects of it continue. The last year has taught us a great deal about not only our healthcare delivery system, but also our society as a whole. And Senate Bill 1 endeavors to take some of the lessons of that year and use them to create responsive policies that will provide future benefits, and recognizing that mental health harm has been a substantial component of what we've experienced. And the first lesson, I think, is that another pandemic will come, and we need to be prepared for that by applying the lessons of this one. Over the last 20 years, the world has seen 6 significant infectious disease threats: SARS, MERS, Ebola, avian influenza, and swine influenza. And in the words of Professor Matthew Bayliss from the University of Liverpool, quote, "We dodged 5 bullets, but the 6th one got us." And that's what we've been dealing with now for the last year. To this end, Senate Bill 1 will require the Department of Public Health to conduct a study on the state's COVID-19 response and report to the Public Health Committee regarding their recommendations for policy changes and amendments of the general statutes that would be necessary to improve the state's response to future pandemics. It requires DPH to designate an employee within the Office of Public Health Preparedness and Response to serve as the Pandemic Preparedness Officer, to be responsible for, among other things, providing periodic updates to us in the General Assembly during a pandemic-related public health emergency. The bill will also contain other preparedness initiatives, such as the adoption of the Uniform Emergency Volunteer Health Practitioners Act, which is model legislation that during a declared emergency allows a state to recognize the licensure of physicians and health practitioners in other states if those professionals have registered with a registration system, thus increasing access to care during a critically difficult situation. That is one of the concerns that we have seen, is getting credentialed people on the spot in a place to take action when needed at the height of a crisis. COVID-19 has also revealed a profound need for additional healthcare resources, not just physical care, but mental health as well. Public health actions such as social distancing are necessary to reduce the spread of COVID-19, but can also make us feel isolated and lonely and can increase stress and anxiety. And the pandemic has laid bare the need for significant improvements in access to mental health resources. Senate Bill 1 will require DPH to establish a certification program for peer support specialists, which is a person with lived experience who's been trained to support those who struggle with mental health, psychological trauma, or substance abuse. It requires DEMAS to develop a mental health toolkit to help employers in the state address employee health needs that arise as a result of COVID-19, and requires boards of ed to provide students who withdraw from school without graduating or being granted a diploma to provide resources pertaining to mental health services, adult education opportunities, and apprenticeship programs for at least 1 year after their withdrawal. The bill also pledges more money to mobile crisis intervention services and school-based health centers. It requires DPH, in consultation with DCF, to conduct a study to identify areas of the state where access to quality and affordable mental and behavioral health care for services for children in particular is limited due to various barriers. This information will be critical in making future decisions about where to locate additional school-based health centers, which have been so effective and creative in providing comprehensive care to school-age children during the pandemic. And we also know that insurance coverage for mental health services is not what it should be, and there are tremendous gaps in that area. And one of the most striking aspects of the pandemic is the disproportionate toll it's taken on communities of color. And these outcomes are not a result of the disease itself, but inequalities in the social determinants of health. And according to the CDC, factors that contribute to increased risk for racial and ethnic minority groups include discrimination, healthcare access and utilization, occupational, educational, income and wealth gaps, and housing disparities. And to achieve health equity, barriers must be removed so that everyone has a fair opportunity to be as healthy as possible. So we therefore have a duty to reform our system in a comprehensive way to ensure equitable treatment of all Connecticut residents. And we think that we need to make equity and social justice a theme for this session in everything that we do. For this reason, Senate Bill 1 declares that the policy of the state of Connecticut is to recognize that racism is a public health crisis. Further, the bill creates a Truth and Reconciliation Commission to examine racial disparities in public health across state and local government, and it also mandates improvements to our data collection practices and makes changes to our hospital community benefits program statutes, which would encourage the use of hospital community benefit plans to address racial and ethnic health disparities and to facilitate the integration of such plans with the actual needs of the community. The bill also takes steps to improve the health of women of color, specifically during the pregnancy and postpartum period, by requiring each hospital to provide implicit bias training to staff members who provide direct care to individuals who are pregnant or are in the postpartum period, establishes a task force to study racial inequities in maternal mortality and severe maternal morbidity in the state, and requires DPH to conduct a study on whether Connecticut should certify doulas, trained non-medical professionals who provide continuous physical, emotional, and informational support to pregnant women. Thank you for your attention to this critical issue on behalf of the residents of our state. Over the past year, we've learned about vulnerabilities of our society that we may never have been forced to consider before. And I want to express my deep appreciation to the chairs and leadership of this committee and the members for all of your work at the forefront of all the issues that we have been compelled to face in the last year with greater urgency than we ever had before. Thank you so much.
Well, thank you, Senator. I particularly appreciate the historical context you provided us. As the saying goes, those who ignore history are condemned to repeat it. And we certainly do not wish to repeat some of the hard lessons learned during the pandemic, and certainly hope to learn from them. And I want to also thank you for all your hard work on this very far-ranging bill, which covers so many of the inequities that we've discovered and knew even before the pandemic were problematic for the state of Connecticut. A couple of quick questions for you. You made mention of the fact that we're trying to improve access. We had a hearing just this past Monday on telehealth. The governor has also put forward a bill to ease the ability for out-of-state practitioners to practice in this state. Are you concerned at all that by enhancing access, that we are in any way compromising the quality of care we might provide?
I don't believe so, Mr. Chairman. I think that in enhancing access, we do still have to pay attention to credentialing. But I think it's important to recognize that someone who has equivalent credentials elsewhere and can demonstrate that should not be barred from bringing their skills to bear on behalf of our residents at a time of crisis. And we need to facilitate that again with the underlying presumption that that these are skilled, credentialed people.
Thank you for that. One further question, then I'll hand it off to other members of the committee. You made reference to finding additional funding for DEMIS, which I think we'd all agree has been historically underfunded, given its important role over recent years as we've been dealing with deficits. The recent federal relief package offers perhaps a short-term but unique opportunity to redress some of the inequities in funding for some of our most critical healthcare services. I know this has just come down the pike and we're still all reviewing it, but do you see this, even in the context of the next 2 or 3 years, as an opportunity to provide some robust support for critical programs, whether they're at DEMIS or DDS or DSS or DPH, in a way in which we can prove that more funding for these critical services may be a boon to the health of the citizens of Connecticut and ultimately actually save money?
I do, Mr. Chairman. I think that most of the federal money that we will be receiving is required to be spent by 2024. So we'll have something that will have an impact actually beyond the biennium. As you mentioned, some of the rules and regulations and constraints of the federal money are not necessarily fully disclosed yet or fully understood at the state level. So we are not yet aware completely about how much discretion we may have in using that money, how much of it is going to be tightly prescribed for certain purposes, but at least potentially it certainly creates an opportunity for us to address needs that have been not adequately met over the years that we've been in a budget crisis ever since the last recession.
Well, thank you for that. I think every member of this committee would argue forcefully that critical healthcare services should be given real priority while these monies are available. And we hope that your good work in collaboration with the chairs of the money committees help us find a way to accomplish that. Moving along, we have Representative Pettit, followed by Representative Claridis Detria.
Thank you, Mr. Chairman. Thank you, Senator, for your comments. I just want to get right to sections 6 and 7. One's really a philosophical question. Section 6 is really a sentence stating that declared policy of the state of Connecticut to recognize that racism is a public health crisis. I wondered if you could expand that on a little bit, because Section 7, the Truth and Reconciliation Commission, really seeks to look at those issues and redress what the problems are from a racial, socioeconomic, and other point of view. It's in my field of medicine, it's certainly been bantered about that language as to how the issue should be approached. So I wonder if you'd make a few more comments on that specific issue. Thank you.
Yes, I'd be happy to, Representative Pettit. And clearly on that section, I know that Senator Daughtry Abrams has had a high interest in both of those sections, as well as Senator Anwar as an advocate for as well. But I think that we know, I believe, that racism is a public health crisis, because whenever there is a public health crisis, it does affect racial minorities and lower income communities, it seems, greater than anyone else, both in terms of the number of people who get sick, their inability in many cases to get adequate care, and also their inability to access follow-up treatment. We know that in many cases, low-income populations are living in crowded conditions, so they're not able to maintain social distancing. Many low-income minority people are actually working in jobs that require them to be in direct contact with the public, and they're not able to work from home, as many people who have other occupations that are privileged to be able to work from home and be at the computer during the day rather than across the counter from a stranger whose health condition they're not aware of. So all of those issues that are factors often of race and income are highlighted when we have a crisis, that those who suffer the most in general circumstances suffer the most in exacerbated circumstances as well. And that's why I think we wanted to put that declaration in this bill.
Thank you, sir. And I would just make the comment that in my past days as chair of the council of the Connecticut State Medical Society, we had a separate committee that looked at disparities, and is still an ongoing effort. So with the many choices that are available to the people in the bill to select people, I think it would be great to be sure that we had someone from the State Medical Society who's been involved in the disparities discussion going back for the last decade. So thank you, sir. Thank you, Mr. Chairman.
Thank you. Next up is Representative Claire DeStitra, followed by Senator Wong.
Thank you, Mr. Chair. Hello, Senator Looney. How's the hip doing?
Oh, it's doing great. That's great. How's your mother's hip? Is she doing all right too? We had the same doctor, I think.
Yeah, as did I.
Yes, you did too, right?
Yep, the three of us are doing great. Great work.
Yes.
I hope you're doing well today. It's nice to see you.
Good to see you too. Yeah.
A couple questions. In section 1 of the bill, if a child stops coming to school, does it states that the district still has to provide services for a year? It's in lines 14, 15, 16.
One of the concerns we've had is, and as you know, distance learning or remote learning has worked much better in some communities than others. There's been a real drop off in some communities about continuity of learning. Dropout rates are higher in certain areas, and we think that just taking a comprehensive view of public health should involve more follow-up and outreach to the students who drop out of school.
Okay, and how would that be implemented?
I think that there would probably be guidance through the State Department of Education, and then in consultation with the school districts around the state, and that there'd have to be, I think, a look at first of all whether the student has had a history of trauma, or whether the student's family would have been reported to DCF or any other agency for ongoing stressors in the student's life. So I think it would have to be a multi-agency approach to meet the student's needs. Also looking at what the plans for that student might be after his withdrawal, and whether there's been an issue like bullying or decline in academic achievement that resulted in the withdrawal, and also whether the student might have certain skills that could help him achieve financial independence even if he's not in school. Boards of Ed would have to provide students who withdraw without graduating or being granted a diploma. They would have to, under this, provide resources also pertaining to mental health services, because often students drop out because of depression or other issues related to mental health. So it would be, again, just saying that we won't let students just drop off the radar screen when they drop out of school.
And what in line 2 under section 1, I think it's more a clarification question. In the second line, it says each local and regional board of education shall conduct the exit interview. When it states board of education, I'm assuming that just means someone, meaning a teacher or guidance counselor. It does mean they're not going to sit in front of the board of ed panel. I see you, Mary. See you answering it.
That's right. Yes, I
Okay,
think that's right. That is, it wouldn't be the Board of Ed meeting with every student individually. That's right.
exactly. Okay, and then in section 2, line 22, is that a mandate on our school systems, a funded position? Will that be a new position our schools will have to incorporate?
I believe so, and it's also one I believe that we have a responsibility to help them fund at the state level.
Okay. And then in section 7, sorry, this is my last question. Section 7, 80 and 81 is as far as the different people on the commission. In number 1, the executive director of the Commission on Women, Children, Seniors, and Opportunity. Will there be another nonprofit commit on the commission? For example, team.
Well, I would say that is certainly up to the discretion of this committee if it should decide to alter the composition of any of these entities that are discussed here.
Okay, thank you, Senator Looney. Thank you, Mr. Chair.
Okay.
Thank you, Representative. Senator Wong, followed by Representative Zupkis.
Thank you, Mr. Chair. Welcome, Senator Looney, and happy St. Patrick's Day to you. You're a great example of Ireland's gift to Connecticut. Your
Thanks,
demonstrated
Senator.
great pride reflect the contributions of so many Irish Americans to American politics, and you are a great shining example of that by your continual support. So again, happy St. Patrick's Day to you, and thanks for being here.
Thank you so much, Senator.
Thank you. I will echo the questions that were raised by my colleagues beforehand in relations to section 1, 2, and section 6 and 7. And I hope that we will engage in a true bipartisan support, because at the end of the day, I believe both parties and both chambers believe this to be a absolute critical and essential issue. So I want to thank you for bringing it up. I want to get to the positives of this bill, which there are many. I want to acknowledge that your peer support certification, the recognition of individuals with lived experience to be able to provide clinical and supportive services is an absolute acknowledgement of the important role those players play. And so I want to thank you for acknowledging that. I also wanted to get a little bit better understanding of the DEMIS toolkit that you talked about. There are many great parts of that toolkit, but do you have a sense of what that timetable would be? Because right now we're living in the midst of the mental health crisis due to the pandemic. What do you see the timetable for that toolkit to fully come into effect?
Well, I certainly hope that it would be implemented beginning in the next fiscal year when this bill becomes law. And certainly time is of the essence, because frankly, we don't yet know whether we are going to be facing an additional spike or additional problems that may heighten the crisis before it subsides again. We looked recently at what's happening now in Italy, yet another wave. So we certainly can't say that we can look back at the crisis yet. We can look back at the first year of it. But for all those reasons, I think we need to move quickly on every component of this bill.
Thank you. Well, on this component of the DEMIS, you say till the fiscal year next year. Is there any option or any protocol that we could look to fast pace that as a toolkit made available to our important population that are impacted by this? Is there a possibility of that?
I would certainly support that, because we are in a crisis.
Thank you. And
Absolutely.
so I look forward to being able to work with you on that and with DEMIS to maybe facilitate some of the suggestions here to really get the help out there in the marketplace right now, if we could. And I want to compliment the sense of components of that toolkit, one of which is your support of school-based health centers. I know in Newtown, we have a terrific organization that in collaboration with public and private entities to be able to provide in our middle schools, and how incredibly resourceful and helpful to be at the point of interaction with students in need. Where do you see that expansion, and what is the financial commitment to that endeavor?
Well, I certainly agree that the expansion of of health centers in schools is critically important. Years ago in New Haven, we pioneered in that through the work of the Fairhaven Community Health Center, established one of the first school health centers at Wilbercross High School many years ago, and then expanded greatly from there. For many low-income inner-city minority students, all of their healthcare, in effect, comes through the school health centers. There, any problem that they may have that first gets identified there, and then they may get referred to other care from that site. So without those school health centers, in many cases, there wouldn't be care at all for many of those low-income children. And it has expanded throughout the state that many now community health centers have satellite facilities in various schools. So clearly, I think that is a budgetary matter, and it's something that I think we need to put more funding into, because that is one of the practical ways that we can generate an impact in low-income communities, and especially in because not every low-income community is in an urban area, but there are pockets of need in many communities throughout the state, and those school-based clinics serve all those populations. Right now, in fact, at least in New Haven, the Fairhaven Health Center I mentioned and the Hill Health Center are two of the major locations that are distributing vaccines right now, that people are flooding into those facilities on a daily basis and getting the vaccines. So they are a critical lifeline in our community, and their need is being proven yet again.
Thank you very, very much. And I want to be very respectful of your time, and I hope that you will accept my offer to work with you to facilitate some of the very good ideas that's proposed on this bill and work to make it truly bipartisan. Now, I want to ask in regards to the Truth and Reconciliation Commission. What would be your vision of the composition of that commission?
Well, I would leave that to the wisdom of this committee to detail that and to take into account the constituencies that should be represented there. And I think it's important to that it be constituted in a way that reflects the diversity that exists in our state, and that it would be charged with, as the bill said, looking at institutional racism in the state's laws and regulations impacting public health and other areas where racial disparities create hardships for low-income people, especially low-income minority people.
Thank you. And one of the points of,
I think you would need a diverse representation of points of view and backgrounds to make that truly a representative commission.
Thank you. And I do agree with you that the composition and the true reflection of all shareholders is critical. And one of the big components of that is obviously data collection. This committee has taken great efforts to try to recognize the important roles of that in regards to data collection. But one of the sensitivities that I wanted to point out in data collection is the real concern with disaggregation of data among the various racial ethnic groups. I think it's a very delicate matter that requires that there is a fair treatment of various racial groups, and that we should not be disaggregating one specific racial group or ethnic group versus another. What are your thoughts on that in regards to data disaggregation as we look at the important value of data, but nevertheless that as we collect data, we have to be very sensitive to the perception and the fairness application and the equal application of various racial groups in regards to disaggregation of such data?
Well, I certainly agree that if data is collected in a way that is comprehensive and then analyzed skillfully, a significant number of lessons and revelations can come from that, as we know, and that depends upon both the efficient and skillful collection of data and the interpretation of it. So, for instance, the city of New Haven last spring was able to do an examination of every street in the city and was able to look at how many public school students lived on individual streets and was able then to determine how many of them had successfully connected with remote learning in the last month or so of the school year after the schools closed down in March. And there was, just as you would expect, some striking information that emerged from that data. So, for instance, there was one street in the Fairhaven section of New Haven, which is a largely low-income Latino area, where there were 40 students who lived on that street and attended New Haven public schools who had not consistently connected with remote learning. Another street of about the same length in the Westville section of New Haven, which is a much higher income area, had a similar number of students enrolled, but had only 3 who had not connected successfully and consistently with distance learning. So when you're able to collect data at that granular level, you can learn a lot of valuable lessons from it. And that's the kind of thing we need to be able to do consistently.
And I appreciate that. And I do understand that data collection has tremendous applications in getting resources and support and diagnosing questions. And I think it's just important that we also have to be very proactively and respectfully understand that when you disaggregate the data, that it has to be fairly applied. So I completely agree with you on that. And I think the question and the example you posed, we are looking to address in some of the bandwidth concerns that have been raised as well. And so with that, I want to thank you, Senator Looney, for your work. And again, happy St. Patrick's Day. And I hope to continue to work with you on a bipartisan basis to make this the best possible bill for everyone. Thank you. Thank you,
Thank you,
Mr.
Senator.
Chair.
Thank you, Senator, and thank you, Senator. Representative Zupkis, followed by Representative Carpino.
Hi, thank you, Mr. Chair. Good morning, Senator Looney. Nice to see you and happy St. Patrick's Day.
Thank you, Representative. Thank you very much. Good to see you.
I have a couple of questions and I apologize. I don't believe they've been asked because I've been in finance, but I'm back here. But I have a couple of questions in section 1. And my first one is regarding the exit interview and how you see that process working. I know it's a Board of Ed, but what does that mean? One person come in the school, they go to the Board of Ed, who's present at the interview? What is the age of the students that we're talking about being interviewed?
Well, first of all, I believe that question was asked a little bit earlier, at least in part, but it wouldn't require the members of the Board of Ed themselves. It just means that someone would be designated in the school that the student is exiting from to conduct that interview and to gather information about the student. It wouldn't require the students to appear personally before the entire Board of Education for the community.
Understood. I did hear that. But what is the age? I mean, are we talking first graders? Are we talking 10th graders? What age?
I think it's primarily, obviously the committee can clarify this language at its choosing, but I think it's primarily intended to focus on those who are in high school and are dropping out for whatever reason.
And would a parent be present?
Well, again, would leave that up to the to this committee and to the Education Committee to weigh in on that. It's not a disciplinary interview. It's just it's an interview to try to evaluate the student's needs and find out what follow-up the school system could do with the student even after he or she is no longer attending.
Yeah, thank you. Yes, and I can see services being promoted after the student is no longer in school. What I would hope for is I certainly wouldn't want my 16 or 17-year-old student being questioned without me being present, because, you know, as I read this section, it talks about what we really want to find out. The data is, you know, is there a history of trauma? Well, what's trauma? Is there a history of bullying? What's the definition of that? Is there, you know, if you're going to withdraw, what are your future plans? So students, I don't believe, and I think of my own daughter, even though she's older than, she's 20, she's still young. And so I would want a parent to be there when this child is being interviewed to collect the data, because even though you may not specifically ask that question to a child, you know, has your house ever been involved with a DCF issue or something? That specific question might not be asked. The intent is to gather that information. And so
I think you're right, Representative. And for those reasons, I really do think a parent should be present, parent or guardian, whatever this family situation is, because otherwise the child himself or herself may not just absorb the information, because the purpose of that is to give them the array of options they might have to follow up when they're not in school. And it's probably as important, if not more important, for the parent to hear that than for the child to hear it.
I would agree. If my child was being questioned about anything, I would want to be present.
Right.
Because what they, as you said, interpret something is very different. So this section is it is concerning to me, quite honestly. So we need to really examine this section, in my opinion, because I think that we could offer toolkits or services to students. For example, my mother-in-law was a 40-year special ed teacher in Naugatuck. And when her kids, got older, she would know right off the bat when they were little, not their outcome, but if something happened and they were in the news or whatever, she says, I could see it. I knew that this student. And so I think that there should be services offered to these students that can be offered without necessarily an interview, I guess is kind of my point. So this interview process is just, again, I'll end with this, is just really of concerning to me, because I want to make sure we get the information that is needed, but the right information and the right people are in the room. And I don't know that we necessarily have to have an exit interview for that. Thank you.
Thank you.
Thank you, Representative. Representative Carpino, followed by Representative Betts.
Thank you, Mr. Chairman. Hi, Senator Looney. I have a few questions on the same section 1, and I don't think they've been answered yet. We have a bit of a different homeschooling withdrawal process than other states, and it's come up here in the building in years past. So I'm curious as to what your view would be if a student was being removed and parents were opting to homeschool. Do you believe, or is it in your intention that they too would have to go through this interview process?
Well, I think it would be different. I would leave it to the committee to decide, and with input from the education committee also, because clearly there is an alternate schooling plan in place when the student is being withdrawn for homeschooling purposes, as opposed to planning to no longer be in school at all. So I think that clearly is a different situation.
No, and thank you, because we've had conversations with the families that do opt to homeschool as to what their requirements are. And I just want to make sure that we take all reasons for leaving the traditional school process into account before we pass this. And my final point of clarification really is about funding for this. If a student withdraws, they're no longer enrolled. So what is your view as to the funding obligations of the state to a district for a student that has withdrawn and is not technically enrolled, but would be eligible for these services? And I apologize if that was quite the compound sentence this morning, sir.
No, I think it does imply some ongoing commitment from the state to provide resources to maintain contact with the student and provide services during the year after withdrawal.
And do you have any thoughts as to whether it should be an ECS funding mechanism? Should it be a staffing requirement, or should it be a per utilized service model? And I know these are very technical, but we're potentially talking in view of other legislation percolating through this committee, we could be potentially talking about many students being forced to withdraw from the public school system.
Well, I think we would leave that to the process of this committee and the appropriations process and the education committee to determine that, because it will probably require in some districts some additional staffing to maintain that contact, and the sheer numbers of students will differ greatly from district to district who would be involved in this process.
Thank you, Senator, and I appreciate you answering my questions. And I think you're spot on. I suspect when this bill leaves, it will be visiting with a number of committees who will want to weigh in. Thank you, sir, and thank you, Mr. Chairman.
Thank you, Representative. Representative Betts, followed by Representative Dauphiné.
Thank you very much, Mr. Chairman, and good morning, Senator Looney. And this really is clearly the issue of the year, and we have a real opportunity to work in a bipartisan manner to deal with an issue that's really existed long before COVID, and that's mental health. And I wonder if you could help me understand why you target racism as a public health crisis, because in my mind, at least, mental health affects everybody. And it doesn't make any difference what age you are, whether you're young, teenager, older. It affects everybody across the board. And it seems to me that the public health crisis is mental health, and that everybody across the board has been impacted and will continue to be impacted by that. Is that not a better way of phrasing it, as opposed to just trying to say, well, racism? I think mental health clearly transcends racism. Does it not affect everybody?
Well, certainly it does, but I think that the problems of systemic racism exacerbate the mental health problem in our state, just as it exacerbates so many other problems in our state relating to housing, to opportunity, to education, to the way people are treated by the police. Everything in many is impacted, I think, in many cases by racism, and this is another manifestation of that. But clearly, the mental health stresses that people have felt as a result of the pandemic have affected all communities. But once again, I think low on a per capita basis, I would bet that low income minority communities have probably suffered disproportionately here, just as they have in so many other areas.
Well, I think the one area we all agree on is anybody who has it, we want to help and have them help themselves. And I dare say we probably all know somebody or have experienced somebody in our families that have encountered this. And that's why I think it's important to make sure that it's all inclusive, and that no matter whether it's in the cities or whether it's in a rural town, the treatment should be equal in terms of accessibility and receiving the multi-layers of behavioral counseling that can be out there. The other question I wanted to pick up on was what you said dealing with insurance, because I think we're on the same page with this. But could you expand on what you mean the role of insurance plays in this really re-examination of the and resetting of the mental health system?
Yes, I'm glad you mentioned that, Representative Betts, because although we passed a bill 2 years ago, again, pushing the idea of parity for mental health coverage in insurance, as a practical matter, we hear reports all over the state that that does not exist. There are many psychiatrists and other counselors who do not accept insurance. So that cuts off a lot of people from the possibility of getting care right there. They're required to pay cash, or else they may have some insurance, but they can't find a provider who will accept that because they believe the insurance reimbursement rates aren't high enough. And many people just don't have the cash to pay for sessions. It's particularly acute from what we've heard in many parts of the state regarding access to mental health care for children, because there aren't that many specialists in juvenile mental health. There are more who specialize in care of adults, yet we're seeing a rising number of cases of children who have significant mental health problems. Once they get outside the school, whatever is provided to them through school counselors and the like is helpful. But in many cases, the problems are of such a severe nature that they need to have an ongoing relationship with a treatment provider beyond what's provided in the schools. And that's where the problem comes into place, where they're not able to make that connection in many cases, either because of the unavailability of someone in the community who is seeing young patients of that age, or the cost factor, that either the person does not have insurance or the provider is not taking insurance. So that really is an ongoing problem.
I totally agree. We're absolutely on the same page with that. My final question deals with the actual patient, if you will, who has mental illness or substance abuse. Excuse me, sorry. It has to do with the patient themselves. It's certainly been my experience. I'm sure everybody else has seen this as well. Someone may have a problem, let's say, with substance abuse, but they're in denial. You cannot force somebody to take treatment. And the commitment process is very rigorous, as it should be. But how do we, or what is it that can be done to get people to engage in mental health treatment if they're absolutely refusing to do it, because that's part of their mental illness? and I know it's an impossible question to answer, but we do need to recognize the fact that everything we do still will not work unless the patient wants help and wants to improve.
Well, you're right. This is one of the ongoing problems in society, is that there are circumstances where people can be committed against their will through the probate courts for periods of treatment. But if they're resistant to that treatment, obviously it may turn out not to be something of lengthy benefit. The other problem, and when you mentioned in terms of substance abuse and the interaction of substance abuse with the criminal justice system, is that very often we know that the recovery process for those who are addicted is not a straight line. They make progress, and then there's some backsliding. But unfortunately, in many cases, each instance of backsliding is a new criminal offense. In some cases, that can send them spiraling into a situation that's even worse, despite the fact that we've decriminalized possession of small amounts of various substances. But that is the problem, is that even people who have made a commitment to recovery generally are not able to maintain that commitment in a straight ascending line of improvement. That there are gaps in that line of improvement and backsliding, and then another step forward, 2 steps forward, and another one back, and the progress is incremental at best, rather than being able to predict that today you're making a commitment to your recovery, and 6 months from now you'll be at precisely this other predictable point. That we can't do, because every patient is different, and some have more fallbacks and more relapses than others. But that, you're right. I mean, that's one of the problems of the nature of the disease.
Okay. Well, thank you very much, and really look forward to continuing working with everybody on this very critical issue. I just want to be realistic in that whatever we come out with, it's not going to be, this is going to solve everything and it's going to work right away in the beginning, because this is a very long-term challenge, and it is going to require the insurance companies to pay more money so that people can afford the treatment. So thank you for this, and thank you, Mr. Chairman, for the opportunity to ask some questions.
Thank you, Representative Dauphiné.
Thank you, Mr. Chair, and thank you, Senator, for coming this morning and talking to us. From what I can read, this bill has been prompted by or in response to the COVID situation that we've incurred over the last year. Do you see this, I'm talking specifically to Section 1, this as a permanent monitoring and tracking system of our children going forward permanently?
Well, I would hope so, because I think that is the situation addressed in Section 1 has been exacerbated by the pandemic, but in many ways was existing prior to that, but maybe not at the same degree. We've seen an enhancement and a growth in all of these problems but many of them are pre-existing. So I would hope that we would continue to devote resources to it beyond the pandemic.
Thank you for that answer. And I share concerns, as did Representative Zubkis, with regard to the specific age you're talking about with this monitoring system and tracking system, and with regard to the lack of parental consent mentioned in this bill. Additionally, one of the purposes is to collect information from your child about whether the family has been reported to DCF or any other agency for needs not being met. Needs could be anything. Could you please describe what the needs might be?
Well, I think that could be further defined by this committee or other committees that may have cognizance of this. I think that one of the needs would be to see whether or not there is support in the home for the children, the child's learning atmosphere. In other words, are the parents able to provide assistance at home, a supportive atmosphere for study? Are there resources to provide assistance to make sure that homework gets done, that children are up in the morning and are ready to go to school on time, and have sufficient food or sufficient rest? Or are there disruptions going on in the home that undermine what a child is bringing to school with him or her every day? Are there other siblings that perhaps an older sibling is involved in giving care for them? I heard a teacher once talk of a stressed child who came to school, who was the she was only about 9 and was the oldest of 4 siblings and had to help prepare her younger siblings for school every day. And the mother was disabled largely by a mental health condition. And the girl hadn't done her homework one day and walked in, and the teacher asked her how many legs a certain kind of spider had. And she looked at the teacher and said, "Lady, I wish I had your problems." So those are the kind of situations I think we need to address and figure out what the home situations are.
So are you saying that you believe that someone from our state government would determine if those needs are being met as you listed?
I believe it's necessary to at least get an overview of what the circumstances are and see if there are obvious gaps, and then a determination could be made. Is there anything that could be done to help that family as a result of that interview, and what might be revealed during that interview?
Thank you for that. And another purpose of the exit interview is to find out whether the child is trainable in skills that will provide financial independence. What does trainable mean?
Does the child have the skills or potential at this point to perhaps go into some or be trained for some trade that could provide a living, even if it doesn't involve moving on to traditional higher education? So does the child have a natural tendency of skill in anything that might lead to perhaps a job in the building trades? Or some
And
other
again,
field?
and so who would determine whether they were trainable?
I think just a result of looking at the combination of their interest and the and what aptitude they have shown in school up to that point.
But who specifically would determine whether they were trainable, I guess is my question.
Again, that would be part of the review process here that would need to be fully determined by this committee.
And if they weren't trainable, what would you foresee the next plan or step would be?
Well, there'd have to be some other option for them at that point, because if one path doesn't look realistic, there ought to be some planning to suggest something else for them.
So are you implying that this bill would incorporate or encompass post-education in some sense of what we're a little bit differently than what we're doing currently? An expansion of our education system?
Potentially, or at least some perhaps better coordination between our education system and apprenticeship programs in various fields.
And if they weren't trainable, what would you see or foresee the plan to be going forward?
I think at that point would be, again, more remedial help for that young person, as long as he or she is willing to engage in it.
And then, could you define financial independence? I see that in here as well, and I'm just wondering how you would see financial independence. Would that be, could you be more specific with that? Living on their own, having their own apartment, sharing an apartment with several individuals? How would you see financial independence?
Any of those that you mentioned.
Okay. And then I think my last question, and I think you said you didn't really know the answer to that. I wanted to know what the definition of trauma was and what exactly you meant, or what it meant in the history of trauma. What exactly was trauma?
It can be physical trauma, it can be psychological trauma. It can be anything that comes under the dictionary definition or medical definition of trauma.
So would you say that the person that's doing this interview would be making assessments on all of these things?
Not necessarily. I would think that it would be an initial intake that might perhaps then lead that person to seek consultation and direct the student for additional services. Again, all that can be done as a result of that interview would be to make recommendations and to give the student and his or her parent or guardian options to follow up on in the course of so that the student doesn't walk out of school into the darkness without any guidance or options or suggestions for help.
Thank you, Senator. Thank you for your answers, and thank you, Mr. Chair.
Thank you, Representative. One more question for you, Senator, and I want to thank you that appropriately on St. Patty's Day that you've corrected the pronunciation of my co-chair's maiden name that I've been mispronouncing for years. Senator Mary Daughtry Abrams, you're up.
Thank you both for trying so hard to pronounce my last name. It's done many, many ways, so I'll accept any of the above. Thank you so much, Senator Looney, for being with us today. And thank you so much for your leadership on this bill and on the bills that I know are in other committees to look at the same thing. This is just a piece of a mosaic to make sure that we are taking into account what we've been through in the last year and what we've learned from it, and how we can do a better job, particularly in the area of equity in many areas. So your leadership's been incredible on this, and I just thank you so much. I want to say too that I'm so encouraged by hearing my colleagues' questions and input, and I think that we can work together to make this bill even better and make sure things are clear and clarified for everybody. So I'm very encouraged to hear the conversation that's happened so far, and the fact that you have been able to take the time now, because I think now is the time to start to recognize the inequalities that exist in our healthcare system and to try to address those things, and also to, you know, find out how we can do better. And as you said, this may not be the last pandemic that we're going through, and we haven't even gotten through this one. So how do we continue to do better? So I just want to thank you for that and for your incredible leadership in all these areas. And I am hoping, as some of my colleagues on this committee have said, that we can make this a truly bipartisan bill, because I think that we all are interested in addressing these issues in our state. But without your leadership, it wouldn't be happening. So I thank you so much for your time this morning and for answering everyone's questions. And I want my colleagues to know that I'm available to answer any questions and to work with them on this as well. Thank you, Senator Looney, and happy St. Patrick's Day.
And thank you, and the same to you, Senator Daughtry Abrams, and I want to thank you for all of your work as well, Representative Steinberg and others on this committee. I think this is an issue of grave concern to all of us. That's why we designated it as Senate Bill 1, a broad concern about public health, mental health, just as last year Senate Bill 1 had to do with the crisis and the cost of insulin and insulin supplies, and we were able to get that done as part of the summer special session. So I'm hopeful and encouraged that this will be a strong bipartisan effort to address a problem that's been existing for a long time, but has been underscored by the pandemic.
Thank you, Senator. And Senator Looney, I spoke too soon. We still have one more questioner, Senator Anwar.
Thank you, Mr. Chair. Thank you, Senator Looney, for your testimony and answering some of our questions as Public Health Committee. Senator Looney, one of the questions that was asked of you was suggesting that by helping address the healthcare disparities, we are taking resources away from some of the other communities. And I did not see anything like that in the bill. I just wanted to clarify that. Did you see anything like that either?
Well, no, I don't, Senator. I don't think there was anything about a reallocation of resources. It has to do with bringing more resources to bear where most needed.
Right. And because of the racial disparities, it's pretty clear that we have a public health crisis with respect to the racial bias and some of the policies. And when we are going to intervene, we are going to be able to help some of the communities who have been left behind. But to suggest by anybody that when we do that, we are taking resources from another community was probably not accurate. And I just wanted to reiterate that. And thank you for clarifying that, Senator Looney, and thank you for your testimony.
Thank you, Senator.
Well, I think that's it for you, Senator. Thank you for your testimony. And as I said, all of your hard work on SB1 and everything else that you do, we really appreciate your joining us today. We are approaching the 1 hour testimony point. We'll hear from the Department of Public Health and then start alternating with members of the public. Commissioner Gifford, good morning. You and your cast of thousands who have joined you today to answer every question we could conceive of. The floor is yours.
Good morning, Representative. It's a cast of dozens, I think. And I'm very happy to be joined by them. Good morning to you, to Senator Abrams, Senator Summers, and Wong, Representative Pettit, Senator Looney, if he's still there, and members of the Public Health Committee. Deidre Gifford, Acting Commissioner of the Department of Public Health. And I'm here to testify on DPH agency bills and the other bills before you this morning. And I'd very much like to thank the committee for raising the department's bills. I will jump right in, Representative, with just a few high-level comments on each of the bills. And then obviously I and the team from DPH are here and happy to answer any of your questions. First of all, with respect to House Bill 6549, an act concerning amendments to marriage certificates. This is a DPH bill, and it would allow amendments to marriage certificates to reflect a person's change in gender designation. This will also allow a person to change the name on their marriage certificate so that it aligns with their new legal name and gender. As a note, the department has been in conversation with GLAAD and the LGBTQ plus community about potential revisions to the language of this bill, and we will obviously continue to speak with you and keep you updated about any substitute language requests that result from those discussions. House Bill 6615, an act concerning safe drinking water. This is a DPH bill, and we are obviously strongly supportive. This bill would do a number of things. First of all, it requires water companies to provide potable water to customers if there is a break in service or pressure for more than 8 hours. And water companies must update their emergency response plans to indicate how this provision of potable water would be done. It also requires water companies to produce Tier 1 written notifications to customers in languages that are predominantly spoken in the service area. And water companies must update their emergency response plans to note in which languages the communications will be offered. Community water systems must report operational status to the web-based Emergency Operations Center portal, or WEB EOC, within 8 hours after the governor issues a civil preparedness or public health emergency declaration, and must update WEB EOC if there is a status change. And that's to help keep DPH and the rest of the Emergency Operations Command updated on the status of water systems in a timely fashion during an emergency. The bill would require small community water systems to complete a capacity implementation plan by January 1st of 2025 and require the system to provide a summary of its capacity plan in their consumer confidence report. The bill requires water bottlers, and there are 4 in Connecticut, to sample their source supply for PFAS and other unregulated contaminants before any water treatment. The testing must be performed by a licensed environmental lab, and bottlers must report the lab test to DPH and DCP within 9 calendar days of receipt of the test results by the lab. It requires environmental labs to report test results on public water system, EPA drinking water exceedances or contamination within 24 hours to both the test requester and to DPH. And it allows the commissioner or designee to report such results to the chief elected official of the municipality where the water system is located. And it also requires healthcare institutions to obtain potable water as a temporary measure to alleviate a water supply shortage, either from a Connecticut licensed water hauler or a Connecticut licensed water bottler. With respect to Section 4 in the bill, we are respectfully requesting some substitute language there. The drinking water assessment fee language is included in Section 23 of the Governor's Budget Revenue Implementer, House Bill 6443, so we would prefer that that language remain in that bill. Senate Bill 834, an act concerning water quality notification. The department is very supportive of SB 834, which requires the owner of a property supplied by a public well or a well for semi-public use to notify each tenant and lessee of water quality test results. This notice would alert the tenants to when there is an exceedance of federal maximum contaminant levels or state drinking water action levels. The notification requirements under this bill will enhance and strengthen the existing regulations which encourage property owners to share water quality violation or concern notices with the users of the water on that property. Senate Bill 1030, an act concerning long-term care facilities. This bill implements the recommendations from the long-term care facilities from the Nursing Home and Assisted Living Oversight Working Group, commonly known as NALWOG. It has been our pleasure and honor at DPH to serve as co-chairs of the NALWOG with members of the General Assembly and representatives of the Department of Social Services and OPM. We are grateful to Representative Walker and the leaders and members of each of the subcommittees for the significant time and attention they have devoted to the work of the group. Just very briefly, there are a number of provisions in this bill. I'll just comment on a few. Section 1 would require long-term care facilities as defined in the bill to employ a full-time infection preventionist. We have a couple of comments that we share in our written testimony about the definition of long-term care for this particular provision and some clarifications we might want to make. We have found, obviously, over the course of the pandemic, that at times, the individual in charge of infection prevention was handling multiple positions within a long-term care facility or working part-time or unable to provide the support needed. The department does support this initiative in the nursing home setting for a full-time infection preventionist, and we've already begun work with long-term care facilities on this. Section 3 requires DPH to maintain a 3-month stockpile of personal protective equipment, and it requires us to supply PPE as we read the bill to long-term care facilities. We would just like to point out, obviously, adequate PPE is of critical importance and was a significant challenge at the beginning of the COVID pandemic. However, it is the responsibility of these privately operated facilities to purchase and maintain supplies of personal protective equipment. We did put forward during the pandemic a commissioner's order that required nursing homes to have a reserve stockpile of enough PPE and hand sanitizer to manage an outbreak of a significant proportion of the facility's average daily census for at least a 30-day period. And we also agree that a comprehensive strategy needs to be in place during extraordinary circumstances, such as the COVID pandemic. But again, we would like to work with the committee with respect to the requirement specifically that DPH provide PPE to long-term care facilities. Section 6 requires administrators of nursing homes and supervisors of long-term care facilities to complete a CDC nursing home infection preventionist training course. We're very supportive of training in infection control and prevention to reduce the spread of infectious diseases. In our written testimony, we do request that the committee consider removing the specific reference to the CDC course and replace that with a more generic description of contact hours or continuing education in infection control and prevention, which would allow administrators to continually train on best practices for infection control. With respect to Section 7, which requires DPH to provide each long-term care facility with a frequency for testing staff and residents during the outbreak of infectious disease, DPH feels that we already do this. We are in constant communication with our long-term care facilities with respect to CDC recommendations around testing. The language in this section may be a bit over prescriptive, given that depending on the infectious disease and the outbreak, there may not be testing available. There may not be formal recommendations promulgated yet. So we're requesting a little bit more flexibility with this particular section. Section 8 requires each long-term care facility to establish a family council to enhance communications between the facility, its residents, and families or representatives. The department is supportive of this effort to facilitate communication between facilities and families, as we know that this communication is imperative for the well-being of the residents. Section 10 requires the department to establish an essential caregiver program for implementation, and we are currently working with the State Long-Term Care Ombudsman's Office and other stakeholders on developing an essential support person program. Section 13 requires DPH to establish minimum staffing level requirements for nursing homes and also to eliminate the distinction between chronic and convalescent nursing homes and a rest home with nursing services to ensure minimum staffing ratios for all nursing homes. Currently, the department does recommend that all facilities have adequate staffing with the appropriate competencies and skills to provide nursing and related services based on a facility assessment. Also that to assure resident safety and attain or maintain the highest practical level of physical, mental, and psychosocial well-being of each resident. The facility assessment uses individual resident assessments and plans of care to ascertain the number, type of diagnoses, and acuity of the facility's residents' population. And regulations do require that the administrator and director of nursing meet monthly to determine adequate staffing levels using a tool based on the acuity of their current residents. And I'll just note for the committee that I'm joined this morning by Adelita Orafici, the DPH Chief of Staff, who co-chaired the NALWOG, and I will be happy to entertain any of your further questions.
Well, thank you, Commissioner. And let me take this opportunity on behalf of not just the committee and the legislature, but all the citizens of the state of Connecticut, to thank you and your staff, who's well represented today, for all the amazing work, the extraordinary work that you have done on behalf of the citizens of Connecticut during the pandemic. Virtually heroic work, given all your current responsibilities, which would be plenty under any circumstance, to let alone taking on all that you have in the past year. And we wish you hopefully a speedy conclusion to the pandemic so that you can maybe return to your already significant workload. But we'd be remiss if we didn't thank you for the amazing work above and beyond the call that has really led to saving lives and to preserving, to the degree we can, learning the hard way in some occasions, quality of life for so many people here in the state of Connecticut. Obviously, you've covered a lot of ground. I'll just ask a few questions and then allow others to speak. Just starting with the marriage license bill, we appreciate your taking the time to update some perhaps antiquated nomenclature. Another thought for you. I believe that the marriage certificate currently says bride and groom. Would you be amenable to changing that appellation to spouse one and spouse two, recognizing the variety of unions that are available in the state of Connecticut?
Yes, Representative, I think we'd be open to further conversation on that topic.
Thank you. You have a number of bills that relate to protecting water quality and availability in the state of Connecticut. I consider myself a water guy, so I can't resist but get into that a little bit. You mentioned that we're imposing a requirement that water companies provide bottled water in the case of an emergency after 8 hours. How did you arrive at the 8-hour limit?
Thank you, Representative. I'll call on Lori Matthew, our branch chief for drinking water safety and environmental health.
Thank you, Representative Steinberg and Commissioner. How did we arrive at the 8 hours? Most of our public water company, community water system issues are much less than 8 hours. Whether we have a water main break, a lot of these are water main breaks, and the water utilities are able and capable of fixing that within the 8-hour limit. We had this bill is based upon one or two lengthy experiences. One in the town of Ledyard with a small system where the department had to step in and actually bring bottled water where the water company refused, essentially. We were sort of shocked at that. And leadership and us worked together on this language because there is no requirement right now. And we're not saying bring bottled water to everybody, but supply water in a centralized location, bring water like a filling station, a secure sanitary filling station, or provide bottled water where people could come and pick that up. Or also in this case that we were talking about in Ledyard, we actually had homebound people for, and this went on for many hours, at least 48 hours from what I recall. And the people that are homebound were able to get, working with the mayor in Ledyard, to actually get water delivered. So the people who were homebound actually had bottled water to drink and consume. So it's based on a couple of experiences that we've had, and 8 hours is one where the majority are already addressed within that 8-hour block of time. So it's based on our experiences in the past.
Thank you for that. And while I have you, one last question related to this. Obviously, and I want to thank you for your good work in collaboration with DEEP to look at the problem posed by PFAS in our water supply. I know we're trying to impose a better testing regimen for PFAS going forward, but do you foresee contaminations such as PFAS, which I know are hard to measure and are unfortunately are becoming ubiquitous in some water systems, as another reason why bottled water may need to be available sometime in the future?
Possibly, yes. Once the testing starts in our state, unfortunately, as you know, Representative Steinberg, as the water guy, there are over 2,500 public water systems. There's over 4,000 groundwater supplies. Many of those sources have yet to be tested for PFAS. Once that starts and that's initiated, we will find it, no doubt. We have 170 public systems that are schools. So once that testing starts, the provision of bottled water will be important. And so very good question, because once we get going on this, and there's funding for staff and funding for equipment at our state lab, which is very important to the effort overall, and working with our colleagues at DEEP, getting the ball rolling this year is going to be very important. So this is an important sort of dovetails with the PFAS testing initiative as well.
Well, thank you for all your good work on these issues, and I'd love someday for you to have to monitor fewer water companies across the state. It would make it easier for all of us and assure quality and access. I'll turn it over to others. Thank you for that. Representative Cook, followed by Senator Daughtry Abrams.
Thank you, Representative Steinberg, and Commissioner. It's nice to see you. I want to echo my chairman's comments regarding all of your department's efforts regarding this pandemic and your willingness to partner with us on the nursing home conversation, which is where I will focus my questions specifically. So as you know, I was chairing the staffing levels with Kate McAvoy, and we had learned some incredible things over the many, many months that we had been meeting with experts and family members and their experiences. So I hear you, I appreciate the infectious disease protocols moving forward. I do have a clarification question on that. Would we be requiring one infectious disease person per facility or per like so many population like we do with school nurses? Could you please explain that a little bit more?
Yes, and thank you for your kind words. Nice to see you as well. As currently drafted, the language requires a full-time infection preventionist per facility.
So with that, would that be somebody that is on around the clock or just a 40-hour full-time? So would they need to have somebody that is specialized in infectious disease, within that 24-hour time period? We know that care in a facility does not stop from 9 to 5 or 7 to 3. So what would that look like, if you could please explain a little bit more?
Yes, I'd be happy to, and I will turn to Lita Orefici. But I will say that we agree with you, and we've been doing some work on something called shift coaches as well. And so one of the responsibilities of this full-time individual when there's not a pandemic is to be sure that they are doing adequate training, and that everyone who works in the facility, no matter what shift, has the adequate infection prevention training and understands their responsibilities. Lita, do you have more to say about the shift coaching or how we would support the second and third shifts?
Yeah, the shift coach model is part of that. It's meant to build on the foundation that gets created when you have a full-time infection preventionist on staff. And so that's the model that we have been proposing and have a pilot that is about to get underway so that we can test out the program and then roll it out to all the facilities with some best practice guidance.
And so what would be the difference between what was currently in statute and what we are proposing moving forward? Because my understanding was every facility was already supposed to have an infectious disease specialist in there, and they were not. So why would we think, and I'm all about it, so, but why would we think that this legislation is going to change that? How are we going to look at accountability?
So the infection preventionist requirement currently is required by CMS, the Centers for Medicare and Medicaid Services. And I'd ask Barbara Cass, who I think is on as well, to talk in more detail about that. But that requirement didn't compel facilities to have a full-time infection preventionists, and nor did it require the infection preventionist to sort of be, sort of exclusive to the role. And so what we found through the pandemic is people wearing multiple hats playing that role. And clearly during the pandemic, that part-time aspect of it didn't appear for a lot of facilities to be enough. I know that the bill in front of you also includes training for other senior leadership in the facilities, like the administrator, on infection prevention protocols. And that is in part to have that larger foundation or stronger foundation of infection prevention throughout the leadership and management team of a facility. Because even if you have, the full-time infection preventionist and your team of shift coaches, what we saw also during the pandemic is sometimes the infection preventionist was the one who got sick. And then you needed to have a backup. You needed to have enough of a safety net of competency in the facility to cover that.
Thank you for that. I think it's extremely important, obviously, from what we've learned in the, in the shortcomings of our facilities in this area. So I want to thank you for that. And I do want to ensure that we figure out a way to look at some type of oversight in that area. Even though we were supposed to have part-time folks, we know that they didn't. And so it's extremely important that we start holding these facilities accountable for their shortcomings, because they are putting lives we're costing lives, quite frankly. The other thing I would like to address would be the staffing levels. I'm sure that you figured that would be where I would be going. So when we're looking at the staffing levels, I want to thank you all for your support in that regard. And I know that we have suggested a variety of different opportunities for shift options and so forth and so on. Is the department, and I heard your testimony, but I didn't hear you say one way or the other, are you in complete support of where we are, or are you looking at alterations from the recommendations that we have for staffing level ratios, et cetera?
Representative, I think the department would like to continue to have the conversation about minimum staffing ratios. We certainly understand the impetus behind it and ensuring that there is always adequate staff to meet the needs of the residents based on their acuity. I think we would also want to talk about the implications of the minimum staffing ratios for financial support of the facilities. So I think we probably are aligned on the intent and want to just engage you a little bit more on the specifics and how it would be implemented and supported.
So, and I'm happy to continue this conversation. It's a conversation that I've been having with the departments for many, many years, pre-pandemic, and I'm sure that'll go on post-pandemic. My fear is that if we do not figure out a way to invest and hold our facilities accountable, especially the for-profit facilities, when their owners and operators are taking a very nice salary and we are shortchanging our residents, that for me is criminal. We've seen a significant amount of lives lost because of the pandemic, but I don't believe that all of the lives that were lost during the pandemic are lives that should have been lost for a variety of reasons. And I don't think that there's anybody here that would argue that point. So I'm very cautious when we talk about any type of alteration on a minimum staffing level. I understand what we're saying about financial, but if we have looked at what it has cost us in the loss of lives because of the lack of staffing, for me, that is an investment well worth making and us figuring out how to do that. I understand that there are, we give a little, we have to take from somewhere else. But we're talking about lives, and with the folks that are in congregate care facilities, most of them are our elder population. And if it weren't for them, we all would not be here, and we should not treat them with a disrespect or a lack of care and concern for their years as they exit out of the life well lived, if you will. And I'm hoping that somebody cares enough for me and for everybody else as we age. So I would hope that we kind of put aside the cost conversation. I know there's always the dollars and cents, but we really focus on what it means about true care in a facility. And how do we hold those facilities accountable? We've done, an enormous amount of things, post the things on the boards and do this, and the facilities still aren't doing it. And I am not one to find a facility to where they can take the money out of the care pot, if you will. I would like to figure out a way to take the money out of the directors and the owners, if you will. That's where we see good, effective change. So I'm willing to continue to have that conversation. And you talked about we would staff according to need base, which I believe we're already supposed to be doing. My fear for that is all subjective. Depending on if there's a doctor that shows up, what happens immediately. We know that in these facilities, someone's care, depending on what their conditions are, can change within a millisecond. And so the amount of staffing could change within that millisecond, but those don't change. So how do we move forward in that regard? I just don't have the confidence in those facilities to say that that's what's going to happen.
I understand, Representative, and agree, obviously, that a new approach is warranted. And furthermore, I believe the industry also agrees that a new approach is warranted. So that's good, that there's alignment, that this has taught us all a lot about the long-term care industry and how to move forward. I would point out, and we've discussed with a number of you in other contexts, that working with OPM and the Department of Social Services, we have begun to talk about exactly what you are addressing, Representative, which is how can we devise a payment system that rewards facilities for high quality care and that takes into account the severity of illness of each individual resident. In other words, how much hands-on care is required by that resident based on their level of need for assistance with their activities of daily living. We don't currently pay more for individuals who need more care. So those conversations, as you know, are happening along a parallel track. And I think we believe that if we can begin to move our system of support for long-term care facilities to align with all of the very real concerns that you're articulating, that's how we'll be able to drive sustainable change in terms of how nursing homes operate.
I appreciate that. I think that, we have incredible caregivers, and you can only do what you can do with the manpower that you have. I don't want this to be a target on, our nurses or our CNAs. They are only able to do with the tools and the assistance that they have, and there's no reason why a loved one who have been locked out of the nursing homes for a year now, who still cannot get in even by the direction of the department. People are still being locked out and not able to see their loved ones. There is no way for us to know what's happening in that facility. And so if it's one staff for 20 residents, I wouldn't know that if my loved one was still alive and in there, because I'm not allowed to get in the door. I wouldn't be able to see the board because I'm not allowed to get in the door. And these are the things for me that are constantly troubling. For the ones that still do have folks that are in the facilities that are still being locked out in defiance of the orders of opening the doors for visitation. So my apprehension, and it is not a disrespect to the department, It is just an overall reality that even though we put guidance in, they are still not following the guidances. And that for me is unacceptable. And especially because we know that isolation, it's killing people. COVID neglect is killing people. And there's loved ones that can get in there to take some of the load off of the short-staffed CNAs and nurses, but facilities aren't still allowing them in. So I just want to, put that on record and thank you for the continued work and dedication to this, and hope that we start putting people before the argument about dollars and cents. Thank you, Mr. Chairman. I am finished for the moment. I appreciate the time.
Well, thank you, Representative, for all your hard work on the NALOG. Gee, I hate that acronym. It sounds like a Native American name for a rare crustacean or something. But all your amazing work on bringing forward many of the things that we see reflected in the bills before us. I know a number of members of this committee have served in various roles on those subcommittees. And I, for one, am very proud of the efforts we put in combination with DPH and other experts. So again, thank you for your diligence and your relentless focus on making it right. That's really what we want to accomplish here. Next up is Senator Abrams, followed by Representative Pettit.
Thank you, Representative Steinberg, and welcome, Commissioner. I want to begin just by clarifying a couple of things that we've all been alluding to during this conversation, which is, first of all, the incredible communication that we've had with your department throughout this pandemic, your availability, and particularly as we discussed this issue of what was happening in our long-term care facilities. And I want the public to know that we worked together and diligently to try to address things as they came up, and just how receptive and open your department was. And I just can't say enough how impressed I am with how hard you've all worked. And as I've said in other meetings that we've had, that you were doing that as well as keeping the rest of the department going. So you, as you often admit, Commissioner, have the most incredible staff. So I want the public to know that we were in communication throughout that time as challenges would arise, as we would learn new information to try to address this crisis as best we could as a state. So I thank you for that. And part of the outcome of that was that a report was commissioned called the Mathematica Report. And we had an interim feedback on the report. I believe it was maybe in August. You know, time is kind of strange during this past year. And we began to work as a group, both members of this committee and other legislators on different committees, appropriations, human services, to come together to start a working group that we co-chaired, both members of your staff as well as members of the different committees that I just mentioned. And we broke up into subgroups, and we worked very hard to learn what we found out were the challenges, and what we found out that regardless of whether or not we were in a pandemic, ways we could do better in our long-term care facilities. And I think that was really the focus of what the work we tried to do. What did we learn from this, where we could do better overall and moving forward? So I think it was an incredible effort. We met for several months. We came up with recommendations. People put those recommendations together to the Public Health Committee and to some other committees. And the result is the bill that the Public Health Committee has put forward for the long-term care facilities plans. I think one of the things that we found out, and what some of my colleagues have already spoken about, is the fact that there might be things in our current statutes, in legislation, that needed to be made more clear or firmed up. We've had for instance, the infection preventionist position has been a part of our statutes, but really understanding what their role is and should be and how we could better utilize that role, those were things we found out. We've always had in our statutes an infection prevention and control committee that's required, but again, needs to be more clarified as to what we see their role is ongoing and when there is a infection outbreak. We've always been dealing with staffing and with looking at how we can better help residents of long-term care facilities in terms of their isolation and their social emotional needs. And so I think those are always things that have been part of legislation, that have been things your department has worked on and other departments. So these aren't new concepts. They were just things that we found through this pandemic that we needed to do a better job in clarifying what they would do and how they could best serve this community. In addition, you know, we found that there were challenges in terms of communicating with families. And so we tried to address some of that in this legislation with family councils and other, you know, pieces as part of this legislation. So I just want to point out that this would not be as good a bill as it is if it wasn't for the incredible dedication of many members of this committee to this particular issue, but also to the incredible staff that you have and how hard they've worked at helping us come together. And, you know, we also had input from facility owners and facility owner organizations. We had input from workers and unions that represent them. We tried to look at a very wide stakeholder group to make sure that we heard from everyone so that we had the best information possible. So I think this is something that we'll continue to work on, but I think this is a good step forward, and I look forward to working with you on the points that you brought up and ways that we can make this bill even better. And I just want to thank your department for all their hard work and for everything that they've done during this crisis. And yes, we didn't maybe earn an A+, but it wasn't for lack of effort. I think that the effort was there, and sometimes the challenges were just, you know, too great in some respects. And so I think that this bill shows that we want to continue to learn from that and move forward as best outcome possible. So thank you, Commissioner.
Thank you, Senator, and we value your partnership as well and all the collaboration. So thank you for those remarks. Very much appreciated.
Thank you, Senator. Representative Pettit.
Thank you, Mr. Chairman. A general question, a very specific question. Thank you, Commissioner. The first one goes to what Chairman Steinberg was talking about, the water testing and PFAS and other organic volatile hydrocarbons, et cetera. It's still not clear in my head whether we have adequate staffing, money, and facilities to do the testing that you feel that we need to do in the state of Connecticut to ensure the safety of the water supply. I wonder if you or Mrs. Matthew could comment on that in general.
Yes, I will allow Lori to elaborate on the details, but under different legislation and in the governor's budget, we do propose additional staffing and testing resources, Representative, for the reasons you're alluding to. The department, as part of the PFAS action plan and in partnership with our colleagues at DEEP, does feel we need additional resources, and that is found in the governor's budget. I don't, Laura, if you want to give a little overview quickly of what's in there.
Sure. Thank you, Commissioner, and thank you, Representative Pettit, for the question. Yes, there are positions in the governor's budget. There are 4 for the Department of Public Health, and there's also funding to support the equipment at the state lab to test for PFAS in drinking water. And so there's a chemist, there's a lab consultant, there's another toxicologist, and there's an environmental analyst. That is an excellent start to get us going and moving in the right direction. Once we start testing, as I mentioned previously, with the 2,500 water systems that we have, and there's 500 that are community systems, 170 that are schools, you know, we will continuously, as we have done under the leadership of the governor with the task force back in July of 2019, to continuously update our plan and make sure that we are on top of this. This is a very challenging chemical. There's over 9,000. When we started this, we were 4,000. Now there's 9,000. And I know there's a number of PFAS bills that are out there, one in packaging, another one in AFFF foam. So it is very challenging. These are the forever chemicals. They stay in the ground for a very long time. Their fate and transport in the groundwater is unknown. There's a lot of unknowns. It's very challenging to the drinking water industry. Could be very costly to the drinking water industry. We want to work hand in hand with our drinking water SRF, the State Revolving Loan Fund, to be able to provide opportunities for funding for treatment. We are engaged nationally and internationally on what is taking place on the latest treatment technologies, working with our colleagues from EPA headquarters, from ORD, the research arm of EPA, working with CDC to learn about health effects. There's a lot going on. And the good news is the Biden administration is moving this forward and moving it forward as quick as they can at the federal level. But that's not fast enough for us. There's a lot of work to do. So the funding, within the governor's proposal is an excellent start to get us moving in the right direction. So we're very pleased to get that started. And the support at the equipment at the state lab will be fundamental to help us as well as DEEP and move forward.
Lauren.
Well, I thank you both for that, because in spite of within 3 or 4 years being fairly arcane, it's now come to the mainstream, and I get emails every week from constituents about the issue of PFAS, because no safe drinking water, we're all in trouble. My second question really gets into sort of nuance, and it has to do with the nursing home bill and N95 masks. In the bill, in your testimony, it talks about fit testing people 4 times a year versus once a year. And I'm a little confused if we're going to require the nursing homes to do it 4 times a year or 1 time a year, and whether we will have an adequate supply. We have an adequate supply of N95s, or whether they'll need to use KN or other lesser quality masks, or have we gotten to the point where we've caught up enough that we're able to use the best quality masks? Thank you for your answer.
Yes, and I think that we would, on the N95 fit testing, I really do think the department would defer to OSHA on that in terms of the recommended frequency of N95 fit testing. I'm not sure, but defer to members of the committee if they have evidence to the contrary, that there's any thing that suggests that more frequent fit testing would be a benefit. So I think we would defer to OSHA standards, as we typically do on that front. With respect to the supply of N95s, that has substantially, as you know, Representative, come back to normal levels. So we would anticipate that, routine use under regular standards of care of N95s would be in place in our long-term care facilities. Lita, anything to add on that I missed?
No, I think that's it, Commissioner. Thank you.
And finally, on the issue of the IV starts that you commented on in nursing homes, what do you think is a reasonable compromise to create language that allows the homes that rarely do it to bring in outside services to perform that procedure versus having someone on staff trained?
Yes, we understand the impetus. We don't want individuals who need a temporary IV to have to be transported to the emergency department. That's not good for them or our emergency departments. So we agree that having the capacity to start an IV makes sense. The question is whether that needed to be a staff person when that may happen infrequently, and maybe it would be better if there was a service that was on call 24/7 that could be deployed for that function.
Thank you very much for those answers, and again, thank you for all your hard work. Thank you, Mr. Chairman.
Thank you, Representative. And that seems to conclude the questions for you, Commissioner. Once again, thank you and your staff who have joined you today for answering our questions. As you've heard, we think that we have some opportunities for further collaboration to refine some of this language, but we're very pleased that we're at this point where we're talking about some pretty significant improvements for the citizens of the state. Again, thank you for being here today. I discovered that this concludes our agency and elected official testimony, so we won't need to alternate back and forth going forward. Next up is someone who is virtually one of our key officials, and that would be Mairead Painter, the State Long-Term Care Ombudsman. Welcome. She'll be followed by Stephen Wenkus, I got that wrong, Karp, from the National Association of Social Workers Connecticut chapter. You can correct me when we get to you, but welcome, Mairead.
Good morning. Good morning, Senator Abrams, Representative Steinberg, Senator Wang, Representative Summers, Representative Pettit, and distinguished members of the Public Health Committee. My name is Maria Painter, and I'm the State Long-Term Care Ombudsman. I appreciate the opportunity to testify before you today on Senate Bill 1030. The Long-Term Care Ombudsman Program supports this bill as it addresses the challenges that we have faced in our long-term care communities for years. Things like physical plant issues, paring back of staff, and staff carrying out multiple roles. There are so many concerns that have been further highlighted due to the pandemic. One of these is access to quality of care. This addresses and requires appropriate staffing levels for individual roles like infection preventionists and nurses who are skilled in diverse areas of care. For direct care staff, allowing staffing levels to be determined by facility assessment of residents' needs and how they are met has often led to an underassessment and does not support the quality of care that residents need. Connecticut has one of the country's lowest daily requirements for hands-on care at 1.9 hours a day. When complaints are filed, we are often told that the building met the minimum staffing levels and that the team was not able to identify how the residents' needs were not met. Residents often cannot express the date and time they waited, the needs that were not met, and the overall care that was impacted. During the pandemic, this was greater impacted due to family, friends, and ombudsmen not having regular access to the building, highlighting and documenting these concerns. In addition to the need to increase the ratios for CNAs, the ratio for social workers and recreation also needs to be increased to more appropriate levels as addressed in this bill. All of these areas have come to your attention now, but are a result of years of paring back in our long-term care communities. Residents and family members want to be a part of the solution and want to be heard. Not just listened to, but really heard and a part of the change. Resident and family councils can be amazing tools, helping long-term care communities understand the challenges they face, address them, and find success when doing it together. This also includes their ability to respond in emergencies. We often talk about person-centered care, but that doesn't mean just writing a plan that talks about what the resident wants. It means talking with the person and identifying who and what is most important to that person, how they see their goals and needs being met, and by whom. Working together to identify meaningful interventions that help the person achieve their highest quality of life. We lost much of that this year, and we have seen the devastating consequences that these changes have made. Visitation and access are areas protected under residents' rights at a state and federal level. When CMS rolled back these protections and banned visitors, they were doing so to protect residents from the virus, to protect some of the most at risk. But without other supports in place, they left them at significant risk of other unintended consequences. Residents need meaningful connections and should always have access to the essential supports of the people they identify as best helping them reach their quality of life and maintaining it. Residents should also have the right to communicate and use technology that best accommodates their individual choice while providing protections for privacy. Our program supports the ability for nonverbal, and to that point, even verbal residents to have the use of electronic monitoring devices in their rooms or private living spaces. This bill addresses many of these long-standing concerns by incorporating recommendations out of the Mathematica and nursing home and assisted living oversight work groups. Residents and family members had the opportunity to participate in these groups, and I appreciate the committee's desire to make residents a priority through this bill. As I look at the testimony list today, I see that there are many family members and staff who will be able to share with you firsthand the stories and the impact that the last year has had on them, as well as the residents that they care about. This impact is due to not having policies like these in place. These stories and situations are things that my office hears about on a daily basis, and we've been trying to address, and we truly appreciate your partnership as we move forward. Thank you.
Thank you for that. It's hard for me to express how much we value the role that you play in all this, making sure that the voices of those who are directly affected are heard, not only well represented, but on a timely basis. You serve a critical role, and I think that last year has only underlined just how critical that role is. We've learned a lot, as I said before, to some degree, the hard way, but I hope we're better off for it. And again, your representation going forward is critical for us trying to do the right thing as we struggle with the changes and the budget constraints that have put us where we are today. I don't see any questions for you. I think you really covered the ground very effectively. Thank you again for all you do. And I'm sure we will talk to you again really soon. All right.
Thank you very much.
Thank you, Mairead. So next up is Stephen Wenzik Karp. I don't know if I got that right. Followed by number 19, Gretchen Rafa.
Thank you. I'm Stephen Wenzik Karp. I'm Executive Director for NESW Connecticut. We represent over 2,300 social workers throughout the state. And first, I want to thank the committee for raising this bill, and also especially thank those members of the oversight work group that really did some amazing work in a very short period of time to put together these recommendations. You know, nursing homes have sort of been the underbelly of healthcare for many years, sort of really ignored by policymakers. And I think the results of the pandemic really speaks to what happens when we don't pay enough attention to our long-term care facilities. Section 13B2 is of particular interest to us because this is a section that requires the Commissioner of Public Health to decrease the ratio of beds to social workers that currently exist at 120 beds to 140-hour social worker as the minimum requirement. And there are homes that are at the minimum requirement. This is a ratio that's existed for about 30 years. It bears no resemblance to the needs and the care of residents. And it really leaves the social workers with far, far too little time to provide their work. The social worker is the sole professional in the nursing home responsible for psychosocial needs of residents. And as you can imagine, there are huge psychosocial needs, but it's not just the residents that the social worker works with. Social worker is often the primary person in working with families, the communication between families and the facility. When the social worker helps people to adjust to their facility, they deal with counseling issues. And my testimony actually spends a couple of paragraphs just talking about all the ways that social workers, all the functions social workers provide. I want to highlight a couple of things. First of all, the current ratio is a major reason why nursing home social workers have a high turnover and burnout rate. It just becomes an undoable job. We did a study, and it's now about 10 years old, but NESW did a study of nursing home social workers and found that 72% of them answered their number one challenge was not having enough time to complete the work effectively. This is way before COVID. We also know that from another study we did that at 120 beds, each social worker has about 11 to 12 minutes a week, perhaps, that they can even spend with a resident because there's just way too much time. And we've heard from a couple of social workers recently who have a ratio in their facility of 60 beds to one worker. They're working 42 to 50 hours a week under the pandemic. And they're saying the same thing we've heard all along from our members in the facilities. You just can't get the job done in time. It's just too high of a ratio of beds. If you look at the National Consumer Voice for Quality Long-Term Care, they proposed to CMS that every facility employ at least one full-time social worker for every 50 long-stay residents and at least one full-time social worker.
Mr. Wenzik Karp, you've reached your 3 minutes if you'd like to give a conclusion.
Sure, for every 15 short-stay residents. So we strongly support this recommendation to have the Department of Public Health reduce the ratio of beds. We also support Section 9 that addresses social emotional needs of residents, where again, the social worker plays a role. And we support the family councils. Again, something a social worker has the skills to facilitate. So we strongly encourage you to pass this bill and to make it possible for us to begin to work on having a reasonable ratio of beds to social workers in long-term care facilities. Thank you.
Thank you for that testimony. Representative Gilchrist has a question for you.
Thank you, Mr. Chair, and good to see you, Mr. Karp. Just wondering, you mentioned burnout of social workers as a result of the staffing ratios. Can you tell us a little more what you've heard from social workers in the field on what they're experiencing, especially during COVID?
Sure. So what we're experiencing as social work in the field is that they're dealing much more heavily with family concerns. For instance, there's tremendous isolation because people couldn't visit loved ones. So our social workers are trying to figure out ways to make it possible for a family to see their loved one, whether it's setting up FaceTime, whether it's bringing them to a window. They're finding that the staff themselves are coming to social workers much more because the staff are feeling the pressures of the work. So staff are raising questions and looking for support. We find that when people are moving in and out of nursing homes, that it becomes a longer process at this point because of the pandemic, and the social workers have to be directly involved in that process. Generally, they're just saying that the job has become from difficult to near impossible, and that the pressures upon the social workers to get the work done. There's also a tremendous amount of paperwork that is required. And that's been an issue for years now, but again, I think you've seen that just increasing. So overall, what we're seeing is that our workers are feeling much more pressured. We're hearing from workers saying, we go home after our 45, 50-hour week, we're home, and the facility is calling us. The nurses are calling us because there's a problem with a resident, social emotional issues are coming up, and they don't know what to do. So our workers are really feeling like they're never really have a time to themselves and their family. They're always sort of on call and working beyond the hours that they're already being paid to work for. So overall, what we're just hearing is that the pressures of the pandemic has made the job much more difficult, and it was a difficult job before the pandemic.
Thank you so much, Mr. Carpin. As much as we need social workers to provide support to families and to the residents, we need to provide support to those social workers as well. So thank you. Thank you, Mr. Chair.
Thank you very much. It's Madam Chair, but
sorry about that.
I tricked you. Thank you so much for your testimony. I don't see any other questions, but thank you for highlighting the important role that social workers play in long-term care facilities. I really appreciate that.
Thank you very much for the time.
Next, we have Invalada Soar, number 17. You need to unmute yourself.
I don't think she's here.
Go right ahead.
Yeah, good morning, everyone.
Good morning.
I won't take much of your time. Thank you so much for your presentations, the eye openers. When I joined the forum, I thought we are giving like testimonies of our experiences going through maybe systemic racism or institutional racism. But after I've listened to the conversations, it took like a different trajectory. But I have one question about, so
excuse me, ma'am. I just want to be able to explain to you, we're hearing many different bills. So some of the conversation has been about long-term care, but we do have a bill, SB1, that we're also hearing today that addresses what you just spoke of. So feel free.
So I add that right now or later when that's?
Nope, go right ahead. Now's the time.
Okay, yeah. For me, I've experienced like systemic and institutional racism. And it happened that I tried to resolve the problem at the institutional level, and it wasn't working at all until I walked away from my job February of last year and had to involve a lawyer for the issue to be resolved. And how this has affected me during this pandemic is that I walked away from that job in towards the end of January when I was just trying to look for other jobs, and the pandemic came, and I've not been able to get a full-time job. I currently do a per diem job, and it's been a struggle for me. So, but it's just so sad that like even when someone realizes you noticed what was going on, they're not able to sit back and do a reflexivity of their actions and decide to like, I can do better than this, or maybe I would have done things differently. the director I was working with was not able to come up with any way to help me. I think she didn't care at all about what I was going through, because I told her what I was going through. I'm an immigrant. I don't have family. I don't have relatives. All the bills are on me. So if you cut my pay, what happened? They dropped my pay by $4.50 from $18.90 something cents to $14. And according to my even qualifications, I had never taken up a job of such a pay rate, because I know I can do better, and I know there are other jobs and opportunities for me out there. So she did it without consulting. It was not discussed with me. They just decided, you're dropping your position, you're dropping your pay rate. I had no disciplinary issues. I know that I wasn't productive. I'm in special education. I have the experience, long-term experience. I have 2 masters, but still someone decided to drop my pay. And when I asked her what happened, why did you do this? She had no substantive answer to give me. She only told me because I had to travel back to Africa. I traveled for only 2 weeks of the school time. That didn't warrant my pay being dropped and my position also being dropped, you know? So, and even when I contacted human resource, nobody was willing to listen to me until I had to involve an attorney. And must it get that far, you know? And then
Ma'am, you've reached your 3 minutes if you'd like to give a conclusion.
Okay, thank you. So I would like that to be addressed, what we go through in schools. And then there's a representative who mentioned about students who drop out, follow-ups. Can we try to find out how we can retain them instead of waiting for them to drop out, then we start making follow-ups on those students? Thank you.
Thank you so much for being here today and for testifying to this committee. We really appreciate hearing your perspective. So thank you so much for taking your time to do that. I don't see any questions, so have a nice day. And again, thank you. Next, we have number 20, Kathy Flaherty. Kathy, you need to unmute yourself.
Good morning. Good morning, everybody. Members of the Public Health Committee, my name is Kathy Flaherty. I am the Executive Director of Connecticut Legal Rights Project. We provide legal services to people who are eligible for mental health services from the Department of Mental Health and Addiction Services. I submitted written testimony on 2 bills, SB 1 and SB 1030. I haven't seen it up on the website yet, but I did get it in before the sign up deadline. So hopefully you will see it soon. I'm not going to read my testimony, but I want to supplement my written testimony. I think SB 1 generally support because it accomplishes a lot of things that I think the state needs to do. I think we have to look beyond those simply declaring that racism is a public health crisis and take some action in response to that. And the suggestion I have for you is to look at the written testimony of my colleague Sheldon Taubman from New Haven Legal Assistance, because he and I were both part of a large group of agencies and organizations and grassroots people, including Disability Rights Connecticut, Brown and Black United, ULA, the Connecticut Cross Disability Lifespan Alliance, to try to get Department of Health to issue statewide guidance for all the hospitals in terms of not rationing care for people with disabilities, people who are brown, black, Asian, disabled, because the standards the hospitals were using were frankly discriminatory. So I would urge you to require DPH to issue that statewide guidance. Also, join my colleagues in the mental health advocacy community in asking you to strike Section 2 of SB 1, because there already is a separate bill dealing with peer support services that does not involve DPH. DPH is not currently involved in peer support services. I don't think we need to put this on their plate. You already came up with a process, so I would urge you to do that. The thing that I really want to focus on the rest of my time, though, is 1030. I appreciate everything the nursing home oversight group did. But I think this state in general forgot a lot of disabled people in other congregate settings that were not nursing homes and not assisted living facilities. And the people that we forgot about collectively, some of us, were the people in DEMIS facilities and DDS facilities. The geriatric unit at CVH experienced another wave of COVID in January, when they should have had access to vaccines far before that, the same time the nursing homes and assisted living facilities did. Because they did not get the vaccine till later, an entire unit ended up in COVID isolation or at Middlesex Health. The state should have treated the people in its own care better. And when you are talking about regulating nursing homes, which, as I've heard you say, and other people say they are private entities, please regulate the state itself. Require them to serve the people in their care.
Ms. Verity, you've reached your 3 minutes. If you'd like to give a conclusion.
I can. Please consider adding communication rights under the Patient's Bill of Rights. I gave you language again. And then I'd also encourage you, the one recommendation from the Mathematica report that pretty much everybody has forgotten about was the right of people in long-term care facilities to be living in the community with home and community-based services. There was just a bill introduced in Congress yesterday that would increase access to HCBS. Connecticut should be ready to get that money and move people out of nursing homes into the community. Thank you.
Thank you for your testimony, Representative Dauphiné.
Thank you, Madam Chair, and thank you, Kathy, for your testimony. I just had a question. I think you mentioned that you saw discriminatory policies in the hospitals. Is that true?
Yes.
Yes.
I can give you some of the examples.
Yes, please.
There was the application of test of likely survival for 5 years after discharge. That's a test that directly discriminates against older people, Black and brown people with inherently shorter lifespans, and people with disabilities, and adding points to people's scores. Because Connecticut was fortunate in some ways, because a lot of people here did the right thing, used masks, did social distance. We didn't get to the point where our hospitals were so over capacity that they had to institute those triage things. We cannot guarantee that that will always be the case. And in most other states in the country, the states did issue statewide guidance to their hospitals. DPH deferred this to the hospitals and said, come up with your own plans. Some of the hospitals improved their plans after the coalition got involved and was reaching out to those hospitals. But there are some things that we should just simply not defer to hospitals to each be able to come up with their own plans.
Thank you. So could you just expand on your explanation of the application of the test with regard to 5 years and just explain what that is? I'm still not understanding what that is, how it discriminates.
The way it discriminates is you get to a point where a hospital institutes these triage protocols. And I would say this question is better answered probably by somebody who's a hospital administrator. But imagine that the hospital is so overwhelmed with patients and, say they're getting short of ventilators or something like that, that's a limited quantity. And you're going to choose who you would provide the treatment to and who you're going to decline that treatment to. You do it based on these scores on various tests. And if you have a test that is inherently biased and will produce results that will punish a protected class of people, it's a problematic policy. There are ways to design these policies in ways that don't do that. And that's what we were asking the state to issue guidance about that to the hospitals. We are fortunate in Connecticut, we never got to that point, but they did in other places around the country.
I'm still trying to understand how the test would prove to be biased, because my experience as a nurse is we always triage based on acuity level and medical needs. So I'm trying to, could you be a little bit more specific just so I can understand?
These are rationing criteria. This is not the thing that you're ordinarily going to do. It's when the hospital is in a crisis state and is deciding who they're going to treat and who they're not going to treat. And at a certain point, they don't do it based on acuity, because if that were true, there were people around the country who died when they were denied care in hospitals because they did not have the right score on these tests. So I don't know how else to explain it to make it clearer. But that when you get to that point, the bottom line is that people who are disabled, people who are older, people who are Black and brown, all the people bearing the disproportionate burden of this COVID crisis were the same people who would be punished under these rationing things. We're just fortunate that none of the hospitals in Connecticut got to the point where they had to do that, but they did in other places.
Thank you for that. I'm just trying to understand, and I would really appreciate more information on that because, you know, again, I think when we talk about acuity, we're putting a lot of things in the bucket along with acuity based on the possibility of survival, based on, you know, where they're at in their treatment. There's a lot of things that go into that, and I would really be interested to see the piece that discriminates, because I would have concern with that, obviously, and I would want to know what that is. And it hasn't been my experience as a medical person to ever discriminate with regard to anything beyond the fact of our ability to treat someone, what the what we have on hand to use, and I can think of so many things, but in the medical world, we look at many things to see probability and how we can help people who, how we're going to get, most likely good outcomes and that sort of thing. There's a lot of things that we look at, and I would like to see that piece that you see as discriminating in there, because I would have concerns with that.
Thank you. I would encourage you, Disability Rights Connecticut, as many of you may already know, is the protection and advocacy system for the state of Connecticut. Because they are federally funded, there are restrictions on their ability to lobby in favor or against a particular bill, but they are available for you to reach out to. And if you make an inquiry of them, they can respond in terms of providing information, education, advice. And they are really the experts on the legality of these complaints and where the discrimination comes, at least in terms of people with disabilities. Like I said, my colleague Sheldon Taubman should be testifying in front of you later. He may be able to answer more of these questions for you.
Thank you for that. And you spoke about adding scores to people's score, or adding numbers to people's scores. Can you be a little bit more descriptive about what that is?
I would just say, if you ask somebody from a hospital how these triaging plans work, and they give people what they call survivability scores. I'm not a medical person, okay? I would suggest asking that question of a person who runs that hospital department. I'm sure there are people from the Hospital Association who've submitted testimony. I don't know whether they're coming to testify in person, but I cannot share with you more than I already have, and suggesting the other people to contact about those questions.
Okay, thank you, Kathy, and thank you, Madam Chair.
Thank you, Representative. I don't see any other hands raised, so thank you very much for your testimony today.
Thank you.
Next is number 22, Jeff Leakey. I'm probably not pronouncing your last name correctly. Oh, there you are.
It's a silent E, just Leak.
Okay, thank you. Go right ahead.
Thank you. Happy St. Patrick's Day to you all. Senator Abrams, Representative Steinberg, Senator Huang, Representative Summers, Representative Pettit, and members of the Public Health Committee. My name is Jeff Leak, a Connecticut teacher and president of the Connecticut Education Association, speaking on behalf of the thousands of our members across Connecticut in support of Senate Bill 1. We believe that this bill is critically important because we have experienced escalation of instances of racism in our country and state, and are now 1 year into the worst pandemic of our lives. The time is now to address these crises, and clearly time to take action as outlined in this bill. We know that our education system has lost connections with too many students during the past year, and so we support the idea of conducting exit interviews for those who have withdrawn without graduating or being granted a diploma. We must do whatever we are able to reconnect with these students and provide the resources that they may need to enjoy a productive life. In order to do that, this bill clearly identifies supports these students will need to become productive citizens in Connecticut. We support the acknowledgement, unfortunately, that racism is a public health crisis. This has become more and more evident over the past years, and both our National Education Association and the Connecticut Education Association have recognized the crisis of institutional racism and the damage it continues to inflict on our society. That recognition acknowledges that injustices have been done for years, decades, and centuries, and we know these injustices must be addressed. In order to begin to address these injustices, we have developed resources to help facilitate conversations about race, including classroom appropriate lesson plans, guides on how to have tough conversations with peers and students, and more. Regarding the establishment of a Truth and Reconciliation Commission, we only suggest that a member of our organization be a part of that commission. Our ability to access the work that NEA has engaged in over the years would be valuable additions to the work of the commission. We are also in full support of the study suggested beginning in line 563 of the bill. It is clearly in our best interest to understand the availability of affordable mental and behavioral health care services across our state. This is especially important as we acknowledge the increased need for these services as we begin to move past this terrible pandemic. We need to have an education system going forward that addresses the needs that we know students are going to have as we get into the 2021-22 school year and beyond. And we thank all of you for working on this and supporting Senate Bill number 1. Thank you.
Thank you so much for your testimony. It is really important as a retired educator myself that we consider that aspect. So your perspective is really very helpful. And I appreciate you taking the time to share that with us today.
Thank you.
I don't see any hands raised, so have a wonderful day. And again, thank you for being with us.
You too.
Next is number 23, Jeffrey Frazier. Hi, Jeff.
Hey there. Good morning, Senator Abrams, Representative Steinberg, members of the committee. I'm Jeff Frazier from Meriden, and I speak in support of two bills, 1030 concerning long-term care facilities and 834 concerning water quality notification. My mom, Florence, is 103 years old. She's a resident of assisted living in Stamford. Last year, her facility became a COVID hot zone. Of a total of 70 residents, there were 10 COVID-associated deaths, 10 out of 70. I was terrified. At my mother's facility, there is a family council, which I value so much, for the mutual support we give to each other, and for our collective strength to advocate for changes in facility policies when necessary. Since January, Mom's facility has conducted 3 vaccination clinics for residents and staff. Our family council requested statistics on vaccination rates. Management initially refused to disclose this information, but after our continued pressing, finally relented. We recently learned that 95% of residents, but only 58% of staff have received 2 doses to date. I urge that COVID-19 vaccination data for each facility be made publicly available. And also that the statute require management to support the role of family councils. Now, I'd like to address 834 concerning water quality notification. First, I would want to ask that all public water supplies are covered, not just well water. I believe that was the committee's intention to be all-inclusive. As a Meriden homeowner, on several occasions I've opened my water bill and I found these kinds of little slips of paper with notices about drinking water hazards. There have been notifications about haloacidic acid and excessive sodium levels. The sodium notice stated, If you have been placed on a sodium-restricted diet, please inform your physician. Current law requires a public water system to notify its customers of unacceptable water quality, but the law requires only that it notifies its direct customers, homeowners, landlords, businesses. There is no requirement to notify tenants. If you're renting an apartment, you may be drinking contaminated water and never be told about it. Renters are disproportionately people of color and low income. Too often around the country, injurious environmental practices have harmed minority communities. One lesson that we should have learned from the tragedy of Flint, Michigan, is that the safety of your drinking water must not depend on your economic status. 834 will correct this unconscionable situation in Connecticut. And just to close, I want to give a shout out to Senator Mary Abrams. I've spoken to Senator Abrams many times about my mom's situation, and she's always been so patient and helpful. Thank you, Senator.
You're very welcome. And I was going to thank you actually, because it was so helpful to hear from, your experience and to know what the challenges were from your perspective as we moved through this last year and how we could do better. And that's reflected in both the bills that you discussed. I think the long-term care facility bill, much of what was thought about had to do with the things that you brought up. So I really appreciate that and a better understanding of how assisted living fits into that milieu. And so I think that's how we do our best work, is when we listen to the people that we serve. So thank you for that. And also, as you pointed out, we were working on this bill in 2020 to include tenants in getting water notifications for the reasons that you stated. And it is my intention to expand this bill to do so again. I think just for the reasons you pointed out, it's so important that people could be drinking water that they're not notified of what the condition of that water is. And that's not really, I think, what we want to be doing in this state. And you mentioned residents, but I would also expand that into commercial buildings, because the people that are working there should know the condition of the water of the building or the space they may be renting. So we need to make sure that everybody has that information, because it is important to their health, and that's what we're here to do. And I wouldn't have had any idea about that if it wasn't for your advocacy. So thank you so much.
If I can just add that my written testimony does suggest that the language be changed from residential properties to all properties, because certainly if you're an office worker in a commercial property, you're using that water to make your morning coffee, to make your instant noodle lunch. So office workers need to hear that too.
Thank you. I thank you for your unique way of expressing those things. I always enjoy it. I don't see any other hands raised. So thank you for your time and thank you for your advocacy. It's a pleasure working with you.
Thank you.
Next, we have number 24, Patricia Hansen. Ms. Hansen, go right ahead.
Okay, please bear with me with my voice. Good afternoon, Senator Abrams, Representative Steinberg, members of the Public Health Committee. My name is Patricia Hansen. I've been in the healthcare field for over 30 years. I have worked as a CNA scheduler, office manager, and am currently an excellent LPN. The reason I am an excellent nurse is because I work with a group of great CNAs. I'm here to testify in support of Senate Bill 1030 with some changes. Specifically in the Section 13, the LPN portion of care hours should be 0.75, and the RN portion of care hours should be 0.54 of the 4-to-1 care hours that residents receive. LPNs and CNAs do more direct care than RNs, and so we should have higher ratios in them. We have elderly in nursing homes living longer, and their needs change on a daily basis. I find it very inhumane for our residents. I'm a patient advocate first and foremost. At any given time, the CNA can have as many as 12 residents at a time, not to mention all 12 can be fall risk, not able to feed themselves. They need to be earned and positioned and toileted every 2 hours. This does not include their showers, grooming, so the residents can look and feel decent and hopeful. It will have the will to continue to thrive. Healthcare workers have become social workers, mental health workers, and hospice care to the ones dying without family because we don't want them to die alone. Not to mention more so with the COVID. We have joined hands and circled the dying with prayers as their last rites. Yes, unless you work it firsthand, you will never know what it's like. Senate Bill 1030 is a good step. It mandates vibrations, but I am also begging all of you to listen to the staff that do hands-on care, put more money into the staffing, because without funding, we will not be able to make these ratios work. What you don't see in long-term care is the elderly that helped build this country ended up like this and no fault of their own. They once had houses to live in and had to exhaust their assets to have a roof over their heads in long-term care. Staffing needs to be looked at yearly as the care and the needs of the residents change. After last year, nursing home staff are mentally and physically drained. Mandating 12-hour shifts is not the answer to staffing problems. Sometimes we do 12 hours or more in a shift because our staffing levels are so low. Making it a law is not the answer. It will make more of us tired. CNAs are the eyes, ears, and back of the bone of any facility. It's about time they are recognized for their jobs. You may think that they're overpaid, but you have no idea how much they're underpaid. Nurses are so overwhelmed as the needs change.
Ms. Hanson, you've reached your 3 minutes if you'd like to give a conclusion.
Sure. What I'm asking for you is to please take this bill serious and fund the nursing homes. The residents deserve it. They've earned this. Thank you.
Thank you so much for your testimony. It's so important that we hear the perspective of workers. And you said at one point that it'd be hard for us to understand what you all have been through. And I think that's true, but we certainly are going to try to do our best to learn from your experience so that we can do better for our long-term care facility residents and for the workers. So thank you so much for what you've done. Representative Dauphiné.
Thank you, Madam Chair, and thank you for your testimony today. I'm a nurse and I've worked in many different departments of nursing: acute care, hospice care, long-term care, camp nursing, school nursing. And I so appreciate everything that you've brought to the table and mentioned today. Thank you for all that you do. And I know the CNAs do work very, very hard and are so oftentimes understaffed. So thank you for your testimony.
Thank all of you for listening.
It's our pleasure. That's what we're here to do. And again, thank you for all your work during this pandemic and for all the work you've done previously and continue to do. So thank you for that. Have a wonderful day. Thanks for being here. Next, we have Michaela Fissel, number 27. Go right ahead.
Hello, respective members of the Public Health Committee. My name is Michaela Fissel and I'm a registered voter in Windsor, Connecticut. I'm also the Executive Director of Advocacy Unlimited. I'm testifying today in opposition to Section 2 of SB 1. I ask that you strike Section 2 of SB 1 and substitute language that replicates Section 2 of HB 6588, which establishes a task force comprised of people with direct lived experience navigating mental health challenges, addiction, and trauma. 2, study insurance reimbursement for peer services. HB 6588 is highly supported by Connecticut's mental health and addiction service and recovery communities. Currently, DMIS already endorses a statewide curriculum and examination of recovery support specialists who provide non-medical recovery supports to people who experience mental health and addiction challenges. In addition, CCAR offers a nationally recognized educational program for recovery coaches who are employed in spaces such as emergency rooms and in methadone clinics. Peer support services are critical to advancing the recovery pathways and are already considered an evidence-based practice by SAMHSA. We know that peer support specialists shift what's called the locus of control and strengthens an internal regulatory system where people themselves can choose the steps in their life to take to move ahead and become contributing members of society. DEMIS, since the early 2000s, made a commitment of our state to become recovery-oriented, and yet our state continues to remain behind in two areas. One, the inclusion of people with lived experience in the planning, implementation, and evaluation of services, and also in peer support as an required service across the entire system of care at every level. These two components continue to remain underfunded and as second-class priorities. I must commend the efforts of Senator Mooney and others who have signed on to this bill for creating such a breadth of policy that is both balanced and considerate in so many areas of equity and inclusion. This must remain a priority for decision makers, and thank you for considering this bill today. I must also share that Section 2 contradicts this effort. The Department of Public Health may have the best intentions. However, without a representative group of people with direct lived experience overseeing peer recovery services, you are opening.
Bissell, you've reached your 3 minutes if you'd like to give a.
Sure, thank you. Are opening all of us up to egregious human rights violations and the abuse of people who learned helplessness at the hands of the system. This is a mirror version of many civil rights movements, and today I ask that you stand with us. I ask that you strike Section 2 of SB 1 and support Section 2 of HB 6588. Let us step forward together. Thank you.
Thank you so much for your testimony today, Ms. Fizzle. Representative Steinberg.
Thank you, Madam Chair. Thank you for your testimony. I just want to follow up on the point you just made about Section 2, how it runs contrary to the general intent of the bill. Could you elaborate a little further, please?
Absolutely. This bill speaks to so much, and, calling for racism to be identified and acknowledged as a public health crisis. It's hugely important. So many other areas of this bill speaks to the need for equity and inclusion. Section 2, by putting authority in the hands of the Department of Public Health to provide for the certification and education of peer support specialists and specify the peer services that are certified, the services that certified peer support specialists can offer, marginalize an already historically disadvantaged group of people, which are people who are recipients of mental health and addiction services. And if you look back into the history of our mental health system, we have not done right by them at all. And we continue to struggle to really meet their needs.
Well, you recognize the intent of Section 2. Is there another way of going about it that you would find preferable?
Yes, absolutely. I would ask that you strike this language and that you adopt or substitute language from Section 2 of HB 6588, which will establish a representative task force of people who also include about 50% representation of people who have mental health and addiction challenge histories.
Thank you. I'll have to take a look at that other bill. I appreciate your testimony.
Thank you.
Madam Chair.
Thank you, Representative Tersiak.
Thank you very much. Thank you, ma'am, for testifying today in favor of this bill. I just wanted to say a word thanking you also for the good work that CCAR is doing and recovery coaches. And to speak to my experience, which is when people call asking about getting help to get somebody in treatment or somebody who needs detox, one of the first things I mention after saying head to the emergency room is, because especially now that's the way into everywhere, is make sure you ask for a recovery coach. And CCAR in particular has been wonderfully responsive. In the middle of the night, when you're looking for a recovery coach who has a particular background, who is of a relevant age to the person who's going and looking for help, it's the CCAR folks who are able and willing to identify somebody and that get that person in. It does seem to be an oversight to not be including the peer support specialists in the planning for and supervision of the field. So thank you very much for your testimony today. It's great. I think this is really important, and I appreciate what you and your folks are doing. Thank you very much. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands raised, so thank you so much for your testimony today. It's very important for you to hear from you.
Thank you. Have a great afternoon.
You too.
Thank you.
Next, we have number 29, Zaria Smith.
Good morning,
Hi,
everyone.
welcome. Go right ahead.
Senator Mary Dowdry Abrams, Representative Jonathan Steinberg, and members of the Public Health Committee of the Connecticut General Assembly. My name is Zaria Smith, and I serve as a Health Policy Fellow for the Connecticut Commission for Women, Children, Seniors, Equity, and Opportunity. The CWC SEO serves to inform and engage all policymakers about constituent needs for women, children and their families, seniors, and the African American, Asian Pacific American, and Latino and Puerto Rican populations in Connecticut. We are a nonpartisan agency with data-driven, cross-cultural approach to policy innovation and work to eliminate disparities by identifying opportunities, building connections, and promoting change. The Commission stands in support of Senate Bill Number 1, an act to equalize and comprehensive access to mental, behavioral, and physical health care in response to the pandemic, with a special focus on Section 10 of the proposal. According to a 2018 study conducted by the Connecticut Health Association, Black babies are 4 times more likely to die before their first birthday compared to their white counterparts. Furthermore, Black infants are twice as likely to be categorized as having low birth weight than white babies. Researchers at Harvard and other institutions have attributed this maternal disparity to poor social and economic conditions faced by Black women in the United States. This phenomenon, also known as weathering, raises stress hormone levels, which result in premature deterioration of the mother's body. Weathering is not only harming our Black mothers, but is also killing our Black infants. Evidence strongly suggests that providing doula support through Medicaid is likely to reduce these significant racial health disparities. Use of doula services has been shown to reduce incidences of low birth weight and premature births, result in shorter labor lengths, and decrease pain and anxiety. Doulas serve as a protective factor for minority women by empowering them to make decisions for themselves and their families. They give both parents a voice in the birthing process, while also providing them with the necessary non-medical support to reduce stress and anxiety both before, during, and after labor. While doulas have proven critical in reducing health disparities across the state, access to doula services remains limited without adequate reimbursement. This policy proposal is a crucial first step in advancing health equity by offering a key step towards Medicaid reimbursement. The title protection offered in Senate Bill Number 1 provides stronger identity and credibility to the profession and prevents misrepresentation of doulas. As a student of public health, a health equity advocate, and Black woman, I commend the efforts of the proposed study in establishing a state certification process. However, I urge members of the Public Health Committee and Connecticut General Assembly, as representatives of Black mothers and infants across the state, to include the following definition of the term doula to ensure that access to doula services are provided in an equitable fashion, no matter the circumstance. Doula means a trained non-medical professional who provides physical, emotional, and informational support to a pregnant person before, during, and after birth, in person or virtually. Thank you for the opportunity to submit this testimony regarding the doula profession. In closing, the Commission urges you to support Senate Bill Number 1 to define the doula profession. Please continue to use the Commission as a resource in navigating this important decision. Thank you.
Thank you, Ms. Smith, for your testimony. I was wondering, could you please describe for me again what weathering is, what that phenomenon is?
Absolutely. So basically, weathering phenomenon it was coined by researchers at Harvard University, and so it's usually explained to it used to explain the maternal health disparity faced by Black women in America. So the idea is that as a result of chronic exposure to racist and racism within the United States, this raises stress hormone levels within Black mothers, and these levels typically result, when you think about it, in high blood pressure, increased heart rate, which causes increased inflammation. And so that chronic inflammation over time leads to early deterioration of the body when compared to white counterparts who don't necessarily face, racism and, have to interact with these racist institutions. And so as a result of that, that's when in these studies, when you're looking at differences in maternal mortality and infant mortality, typically after you control for things such as socioeconomic status, education, et cetera, you're going to still see these significant racial disparities. And so it's thought that, again, this weathering hypothesis is the main reason for this disparity. So it's important for us to address, the actual racism component. And what doulas do is, again, they empower women and act as a liaison between the patient as well as the provider, and making sure the patient is heard, is listened to, and that their needs are met, both during and after the birthing process.
Thank you so much for that explanation again, Ms. Smith. I really appreciate it. As a mom and a grandma, this has been an issue that's very important to me in supporting women, particularly women of color, because this is a phenomenon that we can't be blind to or accept. We have to do all we can. So I appreciate your support in our initiative to try to address that. And we will continue to try to do whatever we can to make sure that all women have good health care and good outcomes for themselves and their babies when they choose to have children. Next is Representative Foster.
Hi, thank you so much for testifying before us today. I'm glad that you raised for discussion the section of the bill. Something I've wondered since I've read this initial language is there was a recent publication in the American Medical Association about maternal mortality differences by race and ethnicity. I'm sure you know the paper I'm referencing. And one of the things that they found is that having a person of color who was your primary medical provider was protective. And I know when I speak to my friends who are people of color in their medical system, they feel, and I think that this is a common experience for women in general, exacerbated by race, definitely an intersectional issue, that women aren't believed when they describe their symptoms and feelings in the healthcare sector, but if that's exacerbated by racism, outcomes are worse. And I think a lot of us like to believe that childbirth is a natural and safe process, but there are certainly disproportionate risks by race and ethnicity in delivery of a child and in the surviving of an infant, which is tragic and upsetting to talk about. So as we have these conversations, do you think that elevating this opportunity for doulas reimbursement serves to address potentially having a more diverse possibility of healthcare providers who might listen, empathize, and trust, believe the words of women when they say something is wrong and feels wrong and want care? I think I can think of, like most of my friends, I can think of times where they said something during childbirth and something was wrong, and it took a long time for someone to respond to them and provide them the care that they needed. And so I know, like from real examples, do you think that this allowing doula reimbursement serves to address that and increase the disparity of healthcare providers that can advocate on behalf of women?
I couldn't agree more. Absolutely. So I think one of the main duties of a doula, right, is to liaise between the patient and the provider, right? So when, of course, giving birth is can be a very traumatic process. It can be very stressful. It can be overwhelming. So what doulas do is sort of try to calm that process down or make it easier for the mother, whoever is giving birth, to communicate their needs to the provider, right, who may otherwise, not listen. And I think another part of this is that, doulas can be sort of culturally sensitive, right, for the patient And that might not always be necessarily the case, with your the person who will be delivering your child, right? Because it's basically whoever's available on site. But this doula has worked with you, throughout, your labor and your birthing process, and really helped you prep for this. So they really understand your needs and are an advocate for you. So I think that is why in a lot of the literature, you're seeing a correlation between, doula services and, decreasing cases of, cesareans. There's a less likelihood that the baby will be born with a low birth weight. So there's a lot of health outcomes here, right, that are attributed to doula and doula services. And I think that it's partly because of that reason, right, of just having an advocate in the room, communicating with you and, making sure your needs are being met. So absolutely.
And do you think that it's sort of, I think an in vogue term in healthcare these days is patient-centered care. But I do believe that very often our experiences around childbirth aren't necessarily patient care, they're very medical. And I think that there's a movement now for people to have more inclusion of people who care about like the family's birth plan and experience with childbirth. And so it's my hope that through enacting legislation like this, that we can take a step towards steering that patient-centered care, because people's risks are unique and different by a lot of different factors. But I'm sincerely optimistic that this could make a big difference. But I know that this is just the tip of the iceberg in the work that we need to do to address health disparities. So I thank you for testifying before us today, and good luck with the rest of your studies.
Are you all set, Representative Foster? Thank you. Representative Claire DeStitria, followed by Representative Dauphiné.
Thank you, Madam Chair. I'm sorry if someone already asked this question, but I'm jumping, like many of us, jumping back and forth to different committees. Thank you for your testimony today. So my first question, just to clarify, what's the historical role of the doula and how can it contribute to the health and well-being of not just the mother through childbirth, but beyond?
Sure. So I believe historically, I think the term doula is actually Greek and it means woman servant. So historically, doulas have served during the childbirth process. Again, these are non-medical professionals, so they're not giving you they're not necessarily taking your blood pressure or giving you any medications or anything like that, but they're really providing you with emotional and physical support. So thinking about, for example, teaching you different techniques for breastfeeding, or assisting you perhaps with breathing techniques prior to you giving labor, different positions that may make you more comfortable, et cetera. And then, as I previously stated, they do act as sort of liaison between patient and provider, right? And being sort of that advocacy, that voice. And so again, we see that with doula services, right, there is improved health outcomes, especially among Black women, with lower cases of cesareans, less likely to have a low birth weight. And as well as a number of other health outcomes that are, I believe the study came from the Cochrane Institute or organization. I'm sorry, can you repeat your question one more time?
And beyond, just from childbirth and beyond.
Yeah, absolutely. And so there's a couple different types of doulas. So there's postpartum doulas, which I think is kind of what you're referring to now. So they assist with services that occur, after the child is born. So again, this ties into the breastfeeding, but also providing with some emotional support, since having a child and even taking care of a child can be very emotionally intensive and just very new for some people. So they really help you ease into that transition by giving you, again, that emotional, physical support that you do need.
Thank you. And then my other one, I know that the commission organized a task force that brought women in the doula profession together to discuss what certification, should look like. Is the commission prepared to aid the department to bring together the right people to form this process?
Absolutely. So in my testimony, I'd mentioned that please continue to use our, our organization as a resource. Again, we are here to serve you all, as well as, the constituents of Connecticut. But I'd be happy to connect with you, perhaps, after this hearing, or at any other time, to make sure that you all have the information that you need to make this decision.
Great. Thank you so much for the testimony and your information. Thank you, Madam Chair.
Thank you, Representative. Representative Dauphiné.
Thank you, Madam Chair, and thank you, Zaria, for your testimony. I'm most curious about this term weathering that you've used, and I tried to look it up. Is that weather like the weather, rain and snow, or is that weather like W-H-E-T-H-E-R?
WEATHERING.
Okay, I will continue to look it up. You spoke about stress levels and specific to the weathering. Is that what weathering is, or maybe you can expand on that definition?
Absolutely, yeah. So weathering, again, so it's a coin. The term is coined by researchers at Harvard University, and so basically what it is, right, is that Black women, as just a result of being Black in America, are more exposed to racism and racist in institutions. So thinking about interpersonal forms of racism, institutional forms, interpersonal forms, et cetera. And so because of this chronic exposure to racism and racist incidences, we're more likely to have elevated levels of cortisol, right, which is a stress hormone. So as a result of that, basically that results in chronic inflammation, because when you're thinking about stress, or your fight or flight response, you have elevated heart rate, you have shortness of breath, et cetera. And so what that results in is that if you continue to have that over time, right, if it becomes chronic, that is going to weather the body, right, in terms of wearing away at the body's immune system, defenses, et cetera. And that's going to result in premature onset of disease, especially among Black women. And so within the context of maternal health, that is thought to contribute to the increased incidences of low birth weight, and just overall poor maternal and infant health among Black women within the US.
Okay, thank you for that. I just wondered, does it include all women or just Black women? I'm just curious because we know that there's many women out there in the workforce that are also experiencing high stress levels of trying to manage a family and a career, others that are in some economic distress. So is this just specific to the Black female community, or is it a term that would be used for any female that would, encounter stress levels that would increase their cortisol levels?
So again, as you just stated, of course, anyone who has sort of this chronic, chronic stress could result in an early onset of disease, but this term is specifically used to explain the disparity between white and Black women, right? Because again, Black women are, if I can go back to my testimony, give me one second. So again, Black infants are 4 times more likely to die before their first birth compared to white infants, right? So the term is used to explain that disparity. And even in some studies, when they've controlled for, socioeconomic status, when they've controlled for education level, when they controlled for income, right, or they controlled for neighborhood, those disparities in maternal and infant health still exist, right? So this isn't just a result of, just like, oh, they're low income, they don't have access to certain resources. This isn't necessarily just a result of, they're not in a great environment, right? Because even when you control for these things, we're still seeing these huge disparities. So this is a direct result, again, of racism and encounters with racism, especially within the medical community, right? Thinking about physicians not listening to Black women or not believing Black women because of, older preconceived notions about how Black bodies operate.
Thank you for that. So if I understand you right, this is just one piece of the puzzle that you're trying to put together, correct?
Absolutely.
Okay, thank you very much. Thank you, Madam Chair.
Thank you, Representative Terziak.
Thank you very much, Madam Chair. Thank you very much, Ms. Smith, for coming and your advocacy for doulas. The state's got a lot of experience with them. Like Representative Dauphinais, I'm a nurse, and I've also worked a lot of different kind of settings, including community nurses. And I think it must be 8 years ago when I first met a doula who was seeing one of my patients. And since then, I've seen others worked with them. One of the things it always means is that the higher end nursing services are likely to be decreasing, because through the relationship with doulas, we see patients taking more and more responsibility, setting better goals for themselves and achieving them. Outcomes are wonderfully different. I think this is a bill that can make a big difference for a lot of people, and it's someplace we should be going. So thank you for your advocacy. And if people have questions, we should look to the history of young adult services in the state. That's where I first came into an apartment in Medadoula and saw what was going on. And I think that they can tell you from years and years of experience about the positive difference it makes in measurable outcomes for the people that are served with them. So thank you very much for your advocacy. I appreciate it very much. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands raised, but your testimony's been very informative, and I think that we've all learned something and appreciate hearing from you. So thank you so much, Ms. Smith, for being with us today.
Thank you.
Next up, we have Betsy Gara. Go right ahead.
Thank you. My name is Betsy Gara. I'm the Executive Director of the Connecticut Waterworks Association, which is a trade association of private, municipal, and regional water utilities throughout Connecticut. I'm here to testify on House Bill 6615, an act concerning safe drinking water. I did submit written testimony, a little late, I admit, but I will summarize that now. We certainly support the intent of Section 1 of the bill, which requires water utilities to ensure that there are alternative water sources available in the event of a water supply disruption. Our concerns relative to this provision has to do with the fact that it could be a very difficult, very impractical compliance burden on water companies and actually undermine efforts to address the water supply disruption. We talked a little bit about this last year, and I know there's been some conversations with the department since then, but and I know that there were some changes to this year's draft, but we continue to have some concerns. Water companies already provide as much notice as possible to customers, either prior to, during, and upon restoration of water supply service interruptions. But in significant service disruption events, we evaluate the need to provide temporary water supplies to affected customers, but they can occur at any time, any day of the night, because many of these are subject to concerns regarding winter months, and water main breaks occur very regularly during winter months. We are concerned that we need to be careful that the provision of alternative water sources is dependent on the specific circumstance associated with the disruption. And so as currently drafted, in addition to determining whether or not the disruption may last 8 hours, and you don't know that sometimes when you're going into the situation. There are situations where you could be 4 hours in and realize that you now have to address something else with the system that will push you beyond the 8 hours. But it also requires you to get a determination from the Department of Public Health that the disruption will impact the quality or quantity of water. And again, considering that these occur any time of day or night, weekends, et cetera, it's unclear to us how we would be able to obtain that determination from DPH and determine that the outage is going to last more than 8 hours without creating some significant compliance burdens on water utilities. The issue that gave rise to this particular language was a very isolated incident. It involved vandalism of a pump station and concerns that those vandals had ended up dumping chemicals into the water supply. So a very different situation than applying it to a main break. That said, we are committed to working with the department to try to figure out a way to address this in a way that doesn't impose some very impractical, costly considerations on water companies and our customers. In addition, on Section 2, which requires—
Ms. Gara, you've reached your 3 minutes if you'd like to give a conclusion.
Sure. There's a lot in the bill, and we have a lot of comments on the other provisions. I'd be happy to respond to any questions regarding that. Thank you.
Thank you for your testimony. Representative Steinberg.
Thank you, Madam Chair. Betsy, good to see you. I appreciate your comments with regard to the water emergency, clarifying the language. I have not had a chance to read your testimony, but if you have any specific suggestions on how we could make that clearer and more reasonable, I know we'd be glad to do that, and if need be, broker a meeting with DPH to get it clarified. So thank you for that. I just want to afford you a chance to make your second point at the very least that was cut off. I know you'll try to be as brief as possible.
I will. So the Tier 1 notices, they're provision in section 2 of the bill requires water companies to provide those notices in languages which are predominantly spoken by the consumers in the water company service area. We support the intent. We're just unclear as to how the water company would determine which languages are predominantly spoken in that service area, how the service area, which may include several towns and portions of towns, is delineated, and given the various distribution methods that are required for Tier 1 notices, how we can satisfy that requirement. So the Tier 1 notices, if you go on DPH's website, they provide 4 different mechanisms for providing those notices to the public, including TV, media, posting them on doors, etc. So thank you.
Thank you, as always, for your advocacy on behalf of water organizations. We really appreciate it. Thank you, Madam Chair.
Thank you.
Thank you, Representative. I do not see any other hands raised, so thank you so much for your time, and we look forward to continue to working with you on this bill.
All right, thank you. And I just briefly, there are provisions in here relative to the safe drinking water fee, and we do have concerns about that. So I hope that you take a look at our testimony, and I will follow up accordingly. Thank you.
Thank you. Next, we have number 33, Tina Yep. Yes, are you here? Go right
morning.
ahead.
Sorry, I had to unmute my line.
Right ahead.
Senator Abrams, Representative Steinberg, Senator Summers, Representative Pettit, and esteemed members of the Public Health Committee, thank you for the opportunity to offer testimony in opposition to care homes in Senate Bill 1030, an act concerning long-term care facilities. My name is Tina Yitz, and I'm the Vice President of the Connecticut Association of Residential Care Homes, the trade organization for approximately 100 residential care homes in the state. Residential care homes are a non-medical model of community living. The majority of our residents have mental health diagnoses with many other ailments. Our residents are mostly in shared rooms with communal living spaces and are provided meals, medication administration, personal care assistance, laundry, and other home services. Residents in our home are often mobile and free to come and go home. Our residents can range from adults in their 30s to seniors in their 80s and 90s. The pandemic was a particularly challenging time for our residents and staff in our homes as congregate settings with shared living spaces. Our employees worked on the front lines during the pandemic for wages slightly above minimum wage. Our administrators and experienced staff often covered additional shifts and at times worked 80+ hours due to the lack of staff. Most of our residents spent months in lockdown with limited contact outside the home, and some becoming ill with the virus as well. Senate Bill 1030 tries to take a one-size-fits-all approach to long-term care. By doing so, the requirements to residential care homes would frankly change the current residential care home model. We're also concerned that such sweeping legislation would be proposed coming from the nursing home and assisted living work group without our inclusion as an association or individual homes. We were not invited to the table, and for good reason. We are a different model, and the concerns of residential care homes during the pandemic were more in line with group homes. In fact, the requirements in sections 2 through 10 of the bill run counter to other efforts being made by the administration and this legislature to ensure that the residential care homes are a home and community-based model. It is clear that the drafters of the proposal do not understand the clear differences of residential care homes with nursing homes, assisted living, home care, and other models of long-term care. We welcome the opportunity to discuss our model with legislators, but instead have faced a barrage of proposals that either seek to make us more like a medical model, such as this bill, or that seek to ensure our community setting is more like a landlord-tenant model, including a bill passed by the committee last week. In the past, we've proposed a bifurcated model of residential care homes for this very reason. There's not a one-size-fits-all for residential care homes. There are some homes that are located in the same site as a nursing home, while others are multifamily homes located in neighborhoods across the state. For additional specifics, please find in our written testimony a section-by-section list of our concerns.
Ms. Yates, you've reached your 3 minutes if you'd like to give your conclusion.
Thank you. With all of these facts in mind, we hope you better appreciate that a one-size-fits-all approach does not work for residential care homes. If you move forward with this bill, we urge you to remove residential care homes from the bill. Thank you for your time.
Thank you very much for your testimony, Ms. Yes. I don't see any questions at this time, so have a nice day and thank you for bringing that to our attention.
Thank you.
Next, we have number 34, Jill Holmes Brown.
Good morning.
Good morning. Go right ahead.
Thank you, Senator Abrams, Representative Steinberg, and members of the committee that are here today. Thank you for the opportunity to discuss Section 33 of SB 1, specifically the increased funding for school-based health centers. My name is Jill Holmes Brown. I am a licensed clinical social worker. I'm the chief operating officer for a nonprofit that operates school-based health centers. And I am the advocacy chair for the Connecticut Association. School-based health centers work. That's what Representative Tony Walker said to me 2 weeks ago when I was testifying in probes. School-based health centers provide access to those that may not have it. They serve at-risk, vulnerable populations. They help with absenteeism. They keep kids in their seats and not outside for medical, dental, and mental health appointments. They build relationships within the schools. It's a safe and trusted resource. But what is a school-based health center? And I want to take a second to address this because from the Connecticut Association, it is a comprehensive integrated model with both medical and dental. And school-based health centers are operating all over the states by hospitals, by municipalities, by FQHCs, by nonprofits, each with its own separate funding sources, with their own billing structures and reimbursement rates. And I just want to talk about for a second that these standards have been something that we've been discussing for years, but had not been adopted into statute. And these standards offer and adhere to a level of quality that we would want to make sure that we're looking at. Because as we would all agree that children and adolescents are in dire need of mental health services right now, I would advocate that especially now that we treat the whole child and that we do not operate in silos and offer piecemeal services. Continuity is care. Continuity is key, excuse me. And there are whole pockets in the state where there are no services for children. And the other part that's super important to understand too is that medical and mental health often go hand in hand, and dental as well if you're lucky enough. I'm very fortunate. My sites all have dental as well, but students may present with a medical symptom. And I know we have several MDs that sit on this committee. They present, oh, my stomach's bothering me, I'm not feeling well. But really, it's a somatic, symptom of something that's going on, maybe at school, with their peers, at home. And it's the same thing with mental health. We would never, and as a mental health clinician, I would never want to provide care for a child when I wasn't absolutely sure that it wasn't some underlying medical condition that may be transpiring. You can't become a partner with the school and the teachers and the staff and administrators if you're only in the building.
You've reached your 3 minutes if you would like to give a conclusion.
Okay. I advocate for this integrated health model as I've been working in school-based health centers for 20 years, and access is just not 2 days a week. Quality does not mean quantity. So I would encourage that as we look at this going forward, that the RFP process is fair and equitable and addresses the whole child. Healthy kids make better learners.
I couldn't agree with you more in that healthy kids make better learners. It's better everything. So we need to keep our kids healthy. Representative Steinberg.
Thank you, Madam Chair. Jill, good to see you. I have to ask, in your recent conversation with Representative Walker, did she promise you any more money on the appropriations line to accomplish some of these things?
She did not, sir.
Well, I would suggest there's still an opportunity there, particularly with those federal funds that are coming down the pike. We'll have to see what strings are attached and see if we can apply some of those. But I really want to address your comments, which I think we all agree with regard to establishing good standards, a holistic approach as you described. I assume money's a factor in this in terms of both its expansion and its breadth. But do you have any other specific suggestions, particularly with regard to the RFPs that we can be considering?
I think just that it's, they're equitable to all. And to your point, sir, there is some, for the first time, federal money coming down for school-based health centers, but it's only for federally qualified health centers. And again, nobody wants to deny that they play a huge role in that, and they service, a large population, but it should not just be to that population, because they're already getting federal funding, they're getting state funding, and they do get a higher reimbursement rate. And it's just, it can't be the only game in town. And it's not, to my point. There's lots of school-based health centers that are operated under, different agencies in different ways. And I think that's, and that's okay. And I think we just need to recognize that.
Well, I'd submit that at least some of the state funds are fungible. And perhaps during at least these period of years where there's additional federal funding for the federal centers, maybe we can move around some of the dollars and make sure that the non-federals also get the support they need, at least for the next several years. Thank you for your testimony. Thank you, Madam Chair.
Thank you.
Thank you, Representative. Representative Lenahan.
Thank you very much, Madam Chair. And hi, Ms. Holmes Brown. Thank you so much for being here today. I have a couple of questions. There's something you said in your testimony that really struck me, and it's about treating the whole child, and that healthy children are good learners. And we know this to be true. So I wanted to ask you if you, or if someone in a school-based health center sees a child, say, with stomach pain, is one of the things that you consider that there is anxiety, depression, or emotional pain associated with that?
Absolutely, Representative. And it is a great question. And that's why I think it's so important that we have these comprehensive services, is that you have, a social worker and a nurse practitioner or a PA. Again, a lot of the sites are set up differently, but that you're treating the whole child. And school-based health centers, according to the standards, are that integrated model. And we're available for kids 5 days a week. Another point, this is in my written testimony, is that, and we will all agree that having mental health services even 2 days a week in schools is incredibly valuable, but it's not the same as when you're there 5 days a week, offering consistent services. And I can, in one of my school-based health centers, the kids just all started coming back 4 days a week on Monday. My social workers have been so busy. Yeah. And so when you have these kids that are just coming back, they've been out of school for a year, they really need to have a visit with the APRN. They really need to check in. We need to be doing risk assessments. And a lot of this is about prevention as well. We can treat an asthmatic in a school-based health center for $50. Would you rather them go to the emergency room, which could cost thousands? And right now, that's the model that unfortunately we're operating under. And if more schools had, and again, it's always about money, right? But a little prevention is key here, and school-based health centers do just that.
Yes, thank you so very much. I mean, I'm a huge fan of the school-based health centers. And now as we are hopefully, fingers crossed, exiting this pandemic, I am still in the firm belief that we are going to continue with an epidemic of mental health concerns for children and adolescents. And so in what you said really struck a chord with me, in that, my child could have a great relationship with our pediatrician, but she's not going to see that pediatrician every day and form a rapport that she would perhaps with someone in a school-based health center. And when our kids are going back to school full time, and there's this adjustment period. And along with that, over the past year, we've seen levels of anxiety and depression skyrocket. And so having a school-based health center 5 days a week means that if a child is having a crisis while in school, there's someone that they can go to. Because as we've seen time and again, we also need more social workers. We need, so this adds to that, I believe. And I think it's strengthening a foundation for our children in terms of mental health. So there are a couple of bills in a couple of different committees. I chair the Children's Committee, and we have a bill and that passed out of committee that actually would expand school-based health centers to have mental health clinics. And so what you're saying here today is important to this bill, but it's also important to the bills that we passed out of Children's. So I guess just finally, and I don't mean to put you on the spot, but if you can answer this, mental health concerns were always an issue to those of us in the know. And the pandemic has absolutely exacerbated the problem. But what would you have said on a scale from 1 to 10, I'm going to overly simplify it. On a scale from 1 to 10, having a mental health clinic inside a school before the pandemic, what would you say on a scale from 1 to 10 was an importance of having that available to children? And then during and after the pandemic, what would you change that number to be on a scale from 1 to 10?
Thank you, Representative. I would say that it was probably an 8, a 9, or a 10 before, and it remains the same. And I think to your point about some of these other bills, I just want to point out one last thing that, and this is where Representative Walker said this to me. I was, advocating in Children's Committee, is that what's super important that we've heard time and time again too, is that we have lots of folks that are concerned about kids being treated without their parents' consent. And I know the mental health law of allowing the 6 visits in the crisis, having a school-based health center and the complete, both medical and mental health model really reassures families and administrators and teachers. Again, we become integrated, so you don't have those questions anymore, because this is a collaborative relationship. And I think we would all agree that nobody's advocating for mental health services where we're leaving parents out. And I believe it was Representative Wielander 2 weeks ago that said the same thing. There's a small pocket, and there's certain instances where we need to have that emergency, number of students, visits for students who need it. This isn't for every student, but to your point, I think it's a 10. It's a 10 on having these services in the schools and embedded. And so that educationally and medically and mentally health, we're really holistically treating the whole child and able to have access to the family and refer them to the much needed services that they're going to need as well.
Yeah, thank you so much for that. And I agree with everything that you said. I thank you so much for your work and your advocacy. And I will just leave it with this. You know that I am a believer in having the child to be seen as many times as necessary, however is necessary, because I think what's most important for me as a parent is to have a child who's alive and healthy. And so that's where I sit. And again, I thank you for everything that you do, and thank you for your work on all of these pieces of legislation. Thank you, Madam Chair.
Thank you, Representative. Senator Anwar.
Thank you, Madam Chair. Thank you for your testimony. And I am actually honored to be one of the co-chairs, co-chair with Representative Lenahan for the Children's Committee. I know there's a concern that has been raised, and what you just said really helped clarify what many of us have been suggesting. But I think, would it be possible for you to give us something written about this, so that the organized effort at the state level to say that these children who are getting their health in the school-based healthcare system is against the parents' wishes? Because we've been trying to explain that it's not, but I guess if we have a written word from you, that would help us overcome a little bit of inertia of understanding.
Senator Anwar, from the association's perspective, are you referring to that from the Connecticut Association, we have a position and help support that?
Yes, please.
Yes, sir.
Okay, thank you. This would really be helpful, because I think there's a lot of misinformation that's out there, and we really want to help the children, and we are having some hurdles in the process. Thank you, Madam Chair. Thank you so much.
Thank you, Senator. I don't see any other hands raised, so thank you for your time today and for your testimony. Have a good day. Next is number 37, Cynthia Hayes.
Good afternoon, everyone. I am Cynthia Hayes, and I live in New Haven, Connecticut, and I stand in support of SB 1 concerning the statutory definition of a doula. I became a postpartum doula almost 17 years ago, and I was with an agency for almost 12 years that charged a sizable sum to any families in the Fairfield and New Haven counties primarily, anyone that could afford it. And I enjoyed supporting families in this way. I felt called to do this work. And to my surprise, I discovered that there were many families in Fairfield County that were often transient and had very little family support. And very early in my career, I came across a woman, although very wealthy and living in Fairfield County, was having a horrible time postpartum. She was recalling trauma during the birth of her child. And I was able to sit with her and listen to her and talk to her. She was very afraid. There was bruises on the baby and all these types of things. And it left an impression upon me. And of course, as a Black woman myself, I kept thinking, what are other Black women experiencing when they give birth? And so from there, I became aware of other communities throughout the United States that have established doula programs for Black mothers and others that are part of disadvantaged populations. It was by this time that I had already learned that the United States had the highest rate of pregnancy and child-related deaths in the developed world, and that the death of Black women could be anywhere from 3 to 12 times that number of birth-related deaths. So I sought for more in-depth training to be birth and labor doula, and we have already committed to replicating doula programs throughout the state. And I couldn't be more proud of this work. And there are some of us in our group that have medical backgrounds, some are teachers, some are social workers, licensed clinicians, and others. And we are all there to provide childbirth education, continuous support during labor and delivery, and lactation support because of this important work that we do, and we understand the impact of the work that we do. And the time has come for proper recognition of doulas in Connecticut as a profession so that we can further the work, because we believe that everyone in Connecticut deserves a doula. Thank you so much for your consideration and support for Connecticut families.
Thank you very much for your testimony today. Appreciate it. Representative Foster.
Thank you so much for testifying with us today. I really appreciate hearing the perspective of someone who's practicing. I was wondering if you could maybe give us an example of a situation. You gave us one example of a mother experiencing postpartum struggles, but I think as we talk about infant mortality and maternal mortality, I'm thinking about in the labor and delivery time. Can you think of examples where the care of a doula as sort of a patient advocate could have, would have, or did make a difference for a patient receiving care in the healthcare sector, particularly would just address racial disparity in care?
Absolutely. I think, well, you had mentioned postpartum. Definitely postpartum, we can be there for the mother, but more importantly, during birth and prenatally, we're there to provide that constant physical and even now virtual support and providing information and education to the mom so that she's aware of all of the different options that she has. Many just feel as though they aren't heard. And so by speaking with a doula and other perinatal advocates, they feel as though they're getting their answers, getting answers to much needed questions, especially about unwanted or unwarranted medical interventions. Many times they're being told, okay, this is what's about to happen to you, without providing any other information to the mother about the situation and giving her a chance to think about any alternatives. They're often thought that they should just say yes and they should acquiesce because they don't have any choice. And many times they don't feel as though they don't have choices because they just don't have enough information. That's one way.
I appreciate you sharing that example, and I can imagine how that could be a matter of quality of care being received being significantly different. I mean, even if we look at the history of childbirth in this country, we can see significant shifts in the standard of care and practice that has been given to folks in the labor and delivery setting, and disparities in sort of coming up to speed with what's viewed as that standard in practice across the sector. So I really appreciate you testifying. That is my last question, but thank you so much for being here with us today and speaking about your profession for us. Thank you.
Oh, thank you so much for the opportunity. We really appreciate it.
Thank you for your testimony. I do not see anybody else with questions for you today, but thank you for your testimony. I believe next up
Thank you.
is number 38, Maribel Sanchez, with her interpreter, Maribel Rodriguez.
Good morning. I will be reading Maribel's statement because her English is not the best. She is on with us. In support of SB 1030. Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Maribel Sanchez. I am a certified nursing assistant at the St. John Paul Nursing Home in Danbury, Connecticut. I have worked there for 3 years. I come before you today to testify in support of SB 1030 with changes. I have always been a caregiver and love the work I do. Before moving to the United States 10 years ago, I was a nurse in the Dominican Republic. After moving to the United States, it made sense to pursue a career in healthcare. My mom was in a nursing home for a time before she passed. So when I'm caring for my residents, I view them as my mother, my father, brother, or sister. During COVID, residents couldn't see their family, so we were their family. You can't do this job for the money because the pay is not good. You can only do this job if you care about your residents. As a CNA, I feed people, help people with their hygiene, and all around take care of people. Finding the time to attend to all needs of residents can be very challenging with short staffing. It is not uncommon to have one CNA caring for over 35 residents, specifically during the first shift. While staffing has been always problematic, it became much worse during COVID. A lot of people quit out of fear of getting the virus. Without more staff to fill shifts, my coworkers and I were working over 50 hours a week. It is very hard to give quality care when we are short-staffed. Finding time to do anything was hard. Even finding the time to sit with a COVID positive resident as they passed away meant potentially falling behind on our work. We are supposed to get 2 15-minute shifts, but often can't take one break, let alone 2. At the height of the pandemic, we also suffered from lack of PPE. My facility did not have enough PPE stockpile, so we were forced to reuse PPE, even though it was designed for single use. This made my coworkers and I feel like saving money on PPE was more important than our own lives. This is unacceptable.
Ma'am, you've reached your 3 minutes. If you'd like to give a conclusion, please.
Sure. I'm almost done. Another major issue in nursing home was amplified by the lack of adequate training staff. What little training we received for infection control was largely inadequate. Not only with the scope of the training limited, but the training and its materials were not offered in any language other than English. As a bilingual woman, I am shocked more effort wasn't put to ensure our staff was trained efficiently. We are a diverse staff caring for a diverse population. I am in support at SB 1030 because I believe it will address these issues. The bill would improve staffing standards, will reduce stress and burnout among staff. It would also require nursing home to stockpile 3 months of PPE. I think it's a good.
You've reached 3.5 minutes. If you'd like to give a conclusion.
Thank you for your time.
Thank you, Maribel. You're dealing with a lot there. Thank both Maribels for your testimony. You mentioned a number of really key points that we're hoping this bill will address. So thank you so much for taking the time today and for working as such a good team to confirm, reinforce many of the things we're trying to do. I see no questions. So again, thank you for your testimony. I understand number 28, Ryan Parker is available. If Ryan could go next, and then we move up to number 39, Gladys Castro.
So I will also be helping Gladys Castro testify.
Well, maybe if Mr. Parker is willing, why don't we just take care of your testimony right now, Gladys, with Maribel's help, and then we can go to Mr. Parker.
Good afternoon, Mr.
Please proceed. Gladys, Maribel, whoever. Okay.
Give me 1 second, please. I am also reading Gladys Castro's statement. Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Gladys Castro. I live in Danbury, Connecticut. I have worked as a CNA at the Western Rehabilitation Center for 12 years. I come before you to testify in support of SB 1030 with changes. I love the work I do as a CNA. It is a wonderful feeling to know the work I do uplifts my residents' lives. They rely on me for just about everything. And so the work I do is essential for their survival. The work is so important, which is why I get so frustrated when we are understaffed. Without sufficient staffing, our residents don't get the care they deserve. Our staffs are forced to rush through their tasks to try and get everything done during their shift. We don't have the time to give our residents the attention they need. Instead, we must skip our own breaks to ensure everything gets done. This is unacceptable and a direct result of understaffing. Another major issue with nursing homes is the lack of PPE at the height of the pandemic. Coming to work was scary. We didn't know if we were going to be that day bringing the COVID home with us from work. This fear was amplified because we didn't have enough PPE. My facility wasn't ready and ended up making us reuse PPE. We had to reuse the masks that were only meant to be worn once. This is insulting and dangerous. To make matters worse, my facility did not offer effective infection control education and training in my language. Instead, we were left to learn on our own. When training was offered, it was often offered in one language and with lackluster in its efficiency. I support SB 1030 because it will address these issues and more. This bill will create standards so my co-worker and I don't have to work to the bone. With that said, I disagree with making nursing homes shifts 12 hours. They should remain 8 as they are now. Furthermore, the bill will force nursing homes to keep a 3-month stockpile on hand at all times. This is good enough. This is good, although a 6-month stockpile would be better. Finally, this bill would mandate that nursing homes offer infection control education and training in a bilingual way. In doing so, we can better guarantee our staff are ready for the next pandemic. SB 1030 is a much needed bill. It will improve nursing home industry for its workers and residents. Please pass SB 1030. Thank you for your time.
Thank you, Maribel, once again for stepping in and representing Ms. Castro's testimony. It's much appreciated. I don't see any questions, so thank you for your testimony. Next up, I understand that number 25, Tanisha Williams, was on the phone and we missed her. That's our fault. So we could activate Tanisha on the phone and take her testimony.
She's all set.
Thank you.
Hello, my name is Tanija Williams. I'm from Arden House. Well, I work at the Arden House. I'm from New Haven, Connecticut. And I would like to start off by saying my name is Tanija. I'm a CNA at Arden House in Hamden. I love Working in the healthcare field at Arden House, I've been there since 2016, making 5 years. I'm here to testify in my support for the Senate Bill 1030 with changes. I love my job because I believe people are like books with their own unique stories that haven't been heard. I love when I have special moments with my residents and they tell me about monumental milestones that they've been through in their life. I had this one resident who owned 6 passports. All 6 passports were stamped up, every page from front to back, corner to corner. She literally traveled the world for a living. She first started traveling in her early 20s, and her last trip was to Paris in 2012. I remember thinking to myself, wow, this lady lived such a beautiful life. And all of a sudden, I started to think that all my residents live such a beautiful life. As a CNA, I provide numerous sources of services for my residents, like bathing, showering, dressing them, transferring them, and toileting them, feeding them, you know, the basic daily tasks for daily living. These activities are important because they deserve it. Just because you are in a nursing home doesn't mean that your life isn't valued. If anything, it is valued to me and my coworkers. Unfortunately, we don't have good staffing, so we can only do so much. With better staffing will come higher level quality care, plain and simple. I gave birth in December 25th, 2019 via C-section, right before the pandemic hit. Personally, after receiving a major surgery and going to work for the first time in the middle of a pandemic was a lot, especially being a frontline worker. It could be very stressful, and it was the cause of my postpartum depression. We as CNAs and nurses are burnt out from working short and working over 40 hours a week due to short staffing. This bill creates 12-hour shifts, which is really a bad idea because we are all tired. We all have our lives outside of work. Most of us are single mothers with kids, and that's another job that we have to attend to as soon as we clock out of our full-time jobs. And being a mom is a job you can't clock out of. I work on a dementia unit.
Ms. Williams?
Site unit.
Ms. Williams,
Yes?
you've reached your 3 minutes. If you'd like to give a conclusion.
Okay, I'm wrapping it up now. I feel very underappreciated. For example, one day there was a call out on my floor and I asked the administrator if she can pull someone to our floor because we only had 2 aides and with 33 residents. And it was my first time back to work after medical reasons. I still wasn't feeling 100% back to myself. She totally dismissed me and told me to get back on the floor right away because now there's only 1 aide on the floor. I felt belittled and extremely disrespected. But yes.
It's been 3.5 minutes. If you could please give a conclusion.
Yes, I'm concluding it now. I'm sorry. So as the result, I feel with better staffing will equal to better quality care for the residents, less stressful work environment all around. This bill is good for a start in fixing major issues in our workplace environment. Thank you.
Thank you for your testimony. Yes, you raised a lot of issues once again that we had heard during our conversations with the nursing homes, and we're very hopeful that we're addressing as many of those as we can. I don't see any questions for you, but again, thank you for your testimony. Sorry to have kept you waiting. Sometimes it's a little bit more challenging for us when we're dealing with people on the telephone. So greatly appreciated. Next up is number 40, Josh Pawelek, followed by number 41, Lori Collins.
Good afternoon, Senator Abrams, Representative Steinberg, members of the Public Health Committee. I am the Reverend Josh Pawelek, minister of the Unitarian Universalist Society East in Manchester and a clergy leader with the Greater Hartford Interfaith Action Alliance, or GIA. GIA is a partner in the Connecticut campaign to declare race racism as a public health crisis, along with Health Equity Solutions, the YWCA, Power Up Connecticut, and many others. I'm a resident of Glastonbury. Thank you for this opportunity to offer testimony in support of SB1. I am speaking specifically about lines 77 to 163, which state it is the policy of the state of Connecticut to recognize racism as a public health crisis. I'm convinced this declaration is necessary. The data on how the coronavirus has impacted Black, Indigenous, and people of color communities more severely than white communities across the country and in Connecticut should be enough for every reasonable person to recognize that racism is a public health crisis. Data on racial disparities in maternal deaths, infant mortality, diabetes, heart disease, and many other common diseases should be enough for any reasonable person to recognize racism as a public health crisis. Data on racial disparities in the social determinants of health, including access to healthy, fresh food, access to decent education, access to affordable housing, access to secure employment, and access to quality, affordable, culturally sensitive health care should be enough for any reasonable person to recognize that racism is a public health crisis for Black, Indigenous, and people of color. People of faith, regardless of religious affiliation, recognize a common moral obligation to care for the most vulnerable in society. In traditional biblical language, we might refer to the widow, the orphan, the leper, the prisoner, the alien residing among us. Today, mindful of the data on racialized health disparities, it is clear that Black people, Indigenous people, and people of color are living with considerable health vulnerabilities, and we are called to respond. I think the proposal to establish a Truth and Reconciliation Commission to examine racial disparities in public health is the right first step. The proposed scope of the examination is broad enough for the commission to understand the full extent of the crisis. It's a good first step, and I'm hopeful that we have arrived at a new day in Connecticut where all residents recognize the prevalence of racialized health disparities, recognize it as a crisis, find that crisis intolerable, and demand concrete solutions. So let's make this declaration. Let's commit to addressing this crisis with the same resolve, conviction, and dedication of resources we would give to any other crisis. Please support SB1. And if I have just another moment, I want to give a shout out to Senator Anwar. I know you're not unique in identifying this issue, but you are the person who first raised legislation on this issue, and I want to thank you for raising the legislation. This concludes my remarks.
Thank you for your testimony, and thank you and all your colleagues in the clergy for all the good work you do and for putting a focus on our collective responsibility to one another. It's very important. Representative Betts has a question for you.
Thank you, Mr. Chairman, and thank you for your testimony. I had asked this question earlier before, so I am interested to see your response to it. I'm unclear between the difference between a healthcare crisis, which I would say be something like a pandemic or mental health illness. I think that clearly is a public health crisis, but I don't understand systematic racism in the sense that clearly there is racism. Clearly, there are people who are not being served, but it's not just the minorities. And clearly, our goal collectively should be to help everybody, regardless of color, income, etc. I just don't understand how this is, quote unquote, a public health crisis. So could you explain to me the difference between mental illness or things that I think people could easily say is a public health crisis, including something like COVID, and what you're suggesting?
Sure. I think one of the problems is we never look at the totality of the data. We might see an article on kidney disease and how it affects people of color more broadly than white people, or maternal death or infant mortality. And there are so many areas in just our general health lives where these discrepancies, these disparities exist. If you take them in their totality, it looks like a crisis to me. It looks like people of color are experiencing this incredible amount of vulnerability, and I don't I'm not aware of anyone who's actually done that, taken it all and said, this is the difference between people of color communities and white communities. Certainly, we're not saying that these diseases don't impact white communities, but I think our health systems in general are missing the needs of people of color, and it is a crisis. If we only look at one thing at a time, we might not see it that way. I also think a lot of it is just, it remains invisible. And maybe that has to do with how the media reports it. Maybe it has to do with how the medical journals report it. And maybe it has to do with who's consuming the media where this data is being published. But it's definitely out there. And again, I think if you take it in its totality, it is clearly a crisis to me.
So along that
line,
let me just follow up with that. Following your logic that it clearly impacts the minorities and low income more, what about all the other people who are impacted by these diseases?
Well, it's not to say that we shouldn't focus on them either, but I do think when you ask, how is racism impacting a system, and you address the impacts of racism on a system, you actually improve the system for everybody. I believe that, and I think the cliche is, when you raise the I don't even remember what the cliche is, but I do think when you address in any system the most vulnerable populations, you do impact people who may not be as vulnerable but are still suffering from similar situations.
Okay, thank you, Mr. Chairman. Thank you.
Thank you.
Thank you. I don't see any further questions, so thank you for taking the time and for being patient today. We really appreciate your emphasis on this important part of the bill. We will consider your testimony very seriously. Thank you for your time.
All right.
And next up is Lori Collins, followed by number 42, George Werwick.
Good afternoon, and thank you, Representative Steinberg, Senator Abrams, members of the Health Committee. My name is Lori Collins, and I am the Association Director for the Connecticut Association of School-Based Health Centers. I'm testifying in support of SB1 today. I have the great privilege of representing school-based health centers that are in 27 communities across the state and that serve as the main point of contact for nearly 40,000 children to obtain medical, dental, and mental health care. School-based health centers provide a range of services, including medical care for acute and chronic illnesses, well child visits, immunizations, and individual, group, and family therapy for mental health and behavior conditions. And in some sites, oral hygiene and dental care. School-based health centers were designed to remove barriers associated with children's access to quality health care. Those things include barriers like health insurance limits and geographical barriers like provider shortages and a lack of reliable transportation. School-based health centers provide medical, dental, and mental health services on site at schools to all of the enrolled children, regardless of their ability to pay. So for many young people, school-based health centers become a lifeline for them to be able to access services quickly and easily. I was thrilled to see this legislation introduced, particularly Section 33. We know from data collected across the state and across the country that school-based health center model works. We know that it's cost-effective and a practical way to get services to children where they are and when they need it. We know that it has removed so many barriers to access care for so many Connecticut families. And we know that school-based health providers are committed to high-quality care for children. On the other hand, we also know that many students in Connecticut do not yet have access to these services. I appreciated Senator Looney's acknowledgement this morning that there were many pockets of need throughout the state and not just in urban areas. We know that rural areas in Connecticut have provider shortages, and in those areas, the children could desperately use the high quality comprehensive services of school-based health centers. We also know that the healthcare needs are about to grow exponentially for our kids. My colleagues talked today about the impact of things like social isolation, grief and loss, illness and fear, and how they have had a huge impact on children as we start to recover from this global health crisis. We need to consider that other things like missed medical appointments over the past year. Families have deprioritized mental health, and dental issues because provider offices have intermittent closures over the course of the past year. And, families have really struggled with issues like being afraid to have their kids brought to somewhere where other people might be sick and where they could be exposed. We need to consider the cumulative effect of all of the unmet medical, mental health, and dental needs of the children in Connecticut. And that's all of the children in Connecticut, with special attention to those
Ms.
children.
Collins, you've reached your 3 minutes. If you'd like to give a conclusion, please.
As you heard my colleague Jill Holmes Brown say, we need to ensure that the model of school-based health center is one which provides that comprehensive care to address those missed needs. We need to stress the importance of minimum standards to ensure that the quality of care is intact. The Connecticut Association of School-Based Health Centers is strongly in support of the expansion of medical, mental health, and dental services for children through the expansion of school-based health centers across the state, particularly in areas with extremely limited resources. Thank you for your time.
Thank you for your testimony. You raised some good points. And as you said, your colleague has put some of these on the table already. You really mentioned two different areas. One, which is addressing gaps that exist currently with existing centers, and then the expansion of centers to areas of need across the state. Given that we have at least some tentative hope that perhaps some state funds may be repurposed in your direction, maybe that's just my hope, but maybe it'll catch on. It'd be very helpful if you could, maybe not even right now, but help us direct those funds most expeditiously and efficiently to the areas in which we could help. I'm not sure how much we can do to expand centers, but at the very least, help us address the gaps by identifying key programs and services that the centers provide, such that at least we're doing a better job on that. Is that something you can help us with?
Yep, definitely. I know that Jill spoke earlier about being able to provide some more information. So I think as an association, we can get together and pull the information that would help move this forward.
I think it's definitely worth a try for all the reasons that you enumerated. I don't see any further questions. So until we talk again next, thank you for your testimony. It's really appreciated. We appreciate the work that all the centers do.
Thank you.
Next up, number 42, George Werook, followed by 43, Karen Prescott.
Thank you. Good afternoon, Senator Mary Abrams, Representative Jonathan Steinberg, and members of the Public Health Committee. My name is Waruche George, and I speak today as a concerned citizen. I live in Hamden, Connecticut, and I strongly support SB 1, declaring racism a public health crisis. I serve on the Hamden Human Rights and Relations Commission and on the board of Integrated Refugee and Immigrant Services, IRIS. The killing of George Floyd last year and the negative impact that COVID-19 has had on people of color are two examples of how racism can lead to devastating outcomes. Systemic racism is a social determinant of health itself and also produces inequities across all social determinants of health, from disproportionately high Black maternity and infant death rates, inequities in cancer, asthma, heart and lung diseases, to police brutality, environmental racism, and unequal access to healthcare. It affects large numbers of people. It threatens health over the long term, and it requires the adoption of large-scale solutions. Unfortunately, racism is deeply embedded throughout our systems, policies, and culture, but we can pass legislation with actions to dismantle or fix problematic systems and structures. Across the country, at least 185 different entities have declared racism a public health crisis, as well as 20 municipalities in Connecticut, including my town of Hamden. I'll quote the mayor of Hamden in his declaration of racism as a public health crisis this past July. And I'd also like to thank previous speakers like Zaria Smith and others who have done a great job of speaking on this earlier. He states, as a result of the trauma inflicted by racism and the purposeful disinvestment in social and economic well-being, people of color live with disproportionately higher cortisol levels, higher rates of chronic stress, higher rates of chronic diseases, higher rates of COVID-19 infection and death, and as a result, pay the ultimate price with their lives. This declaration will spur Connecticut to recognize racism as the public health crisis it is and address the problem by changing the way our state government works and embedding anti-racist principles in decision-making processes. Please consider this as a way to bring safety for all in our community. Thank you very much for your time, and happy St. Patrick's Day to you all. Thank you.
Thank you. And my apologies for just assuming we had your name backwards.
It's okay. It happens all the time. It's
I
fine.
bet it does. And again,
It's okay. Thank you for your time. Thank you.
that's what happens when you make assumptions. Thank you for your eloquence in the way that you phrased the importance of this subject. We really do appreciate it. Obviously, we're going to have a lot of conversation about how we make this manifest in the state of Connecticut. I don't see any questions for you. I think you said it all. We do appreciate it. Thank you for your testimony today. We move on then to number 43, Karen Prescott, followed by number 45, Maria Elena Nevado.
Hello, my name is Corinne Prescott. Senator Abrams, Representative Steinberg, and members of the Public Health Committee of the Connecticut General Assembly. My name is Corinne Prescott, and I am the president and CEO of Power of CT, which is a 501c3 nonprofit organization. Our mission as an organization is to give a voice to the unheard, educate our community on social issues, represent the underrepresented, and create meaningful change for the oppressed at every possible level in Connecticut. I stand in support of SB1 and Act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. More specifically, Section 77 and 163 to declare racism a public health crisis in Connecticut and establish a commission to study the impact of institutions' racism on public health. On January 6th, just like in Washington, D.C., just like the state capital, Washington, D.C. was attacked, I was attacked here by a white woman at our state capitol. She spat in my face when I yelled, "Black Lives Matter." I'm standing here as one of many women across the state of Connecticut who have been attacked by our white counterparts simply because we are Black. What does this do to us physically, emotionally, spiritually, has not really been fully studied over a long period of time. This country, including the state of Connecticut, has had a history of discriminating Black people, brown people, indigenous people, strictly because of the color of our skin. This fight or flight, this high stress level, increases high levels of cortisol, which means weight gain, acne, easy bruising, slow healing, depression, heart disease, muscle weakness, severe fatigue, difficulty concentrating, high blood pressure, headaches, and more. SB1 is a chance for our state to lead the pursuit of racial justice with action. We would like for this to happen by establishing a commission and renaming it the Connecticut Commission on Racial Impact and Reconciliation. We would like at least 2 members of this commission to be people of color, where specifically one of them is Black, and where at least one of them lives in a major city with an annual income less than $65,000. I'm sorry?
I'm not sure where that interruption came from. Please continue.
Oh, sorry. We would like to expand the racial ethnic data collection to explore disparities in communities. Also, a review and reform of the legislative process to improve public accessibility and set in place mechanisms to determine the impact proposed legislation on race. And finally, establish a clear racial equity approach and policy set forth by the executive branch. In closing, I urge you to support this bill, and I want to again specifically highlight Section 77 and 163, where we are declaring racism a public health crisis. When we look at individuals, we may say, how is this a public health crisis?
Ms. Prescott, you've reached your 3 minutes if you'd like to give a conclusion.
In conclusion, we can't look at individuals specifically. We have to look at overall the people in our community, specifically Black, brown, and indigenous people, and collect the data to see how this is affecting us physically, emotionally, mentally, and spiritually. Thank you.
Thank you for your testimony. I see we have some questions for you. Senator Abrams, followed by Senator Anwar.
I just want to say, Ms. Prescott, how fortunate I feel to have you come to our committee today and testify. I'm sure I speak for many people when I say that seeing what happened to you at that rally was horrifying. And I'm sure that, you know, I'm sure many people felt that way. I certainly did. And I'm just so pleased that it hasn't interrupted your advocacy or silenced your voice in any way, because it's important that we hear from you and others about what's going on and how it's affecting your lives. So, and I hope that SB1 is just a step in the right direction. I don't think that any of us feel that it is the end point, but only the next step on this journey to try to make sure that we address health equity in our state. So thank you so much for being here. I really appreciate it.
Thank you.
Thank you, Senator. Next is Senator Anwar, followed by Representative Foster.
Thank you. Karen, thank you so much for your testimony and thank you for your advocacy. I have been blessed to be able to spend some time with you, and you have been working at the grassroots level. Every Saturday, you actually go up in Manchester Green in the center and then speak about the fact that people are dying because of, unfortunately, policies that have resulted in health inequities that are in our state. So what you have endured yourself and the fact that you're using that as a positive energy to raise awareness and reach out to our community and our committee here as well to get us to do the right thing and stand up for what is right. So I truly want to thank you for that.
Thank you.
Thank you, Madam Chair, Mr. Chair.
Thank you, Senator. Representative Foster.
I'll avoid the redundancies, but I did want to take a moment to thank you for your speaking today, for the advocacy you've done in our community and region, and for the work that you continue to do in advocating for health disparity work. And I just wanted to thank you. And again, similar to what Senator Abrams said, what happened to you is entirely unacceptable. And I'm sorry that it happened. And thank you for continuing to be a voice of advocacy.
Thank you, Representative. Thank you, Ms. Prescott. I don't see any other hands raised. Thank you so much for your testimony. Next, we will hear from Maria Elena Novato, sorry. Oh, I saw her. Oh, there you are. Yep. We just can't hear you yet. Still not working. It says you're unmuted, but we can't hear you.
Did you ask for whom?
This is Maria Elena Novato.
You have the wrong person up. This is Mary Beth Semino.
No, I do have 45 up. I'll get to you in just 1 minute.
Okay, sorry.
That's okay. But Ms. Novato, why don't we come back to you? Okay. Next, we're going to hear from Jennifer Barahona.
All set.
Oh.
Yeah, I got to work now. Sorry about that.
Okay, Jennifer, if you could wait. Ms. Novato, go right ahead.
Thank you very much.
You're welcome.
Thank you to Mr. Chair Steinberg and Madam Chair Doherty Abrams, Vice Chair Anwar, Kushner, and Gilchrist, ranking and committee members for holding this Public Health Committee public hearing and for allowing my testimony to be included. My name is Elena Navedo, constituent of Farmington, Connecticut, current second-year medical student and immediate past president for the Latino Medical Student Association here at UConn. And I would like to take a brief moment to explain why I support Bill SB1 with changes. All opinions and views expressed in my profile are entirely personal and do not necessarily represent the opinions or views of anyone else, including other faculty, staff, residents, fellows, students in the School of Medicine at UConn. Neither the School of Medicine nor UConn have approved the material contained in this testimony. I take sole responsibility for its content. To start, as a second-year medical student at the University of Connecticut School of Medicine, it is my job to learn as much as I can about how the human body works and the common diseases that affect it. Part of this process involves learning which groups of people are more at risk for developing certain diseases. Over the past 2 years, I found it disturbing how often Black and African American people are listed as being more at risk for developing and dying from a wide range of diseases, including asthma and high blood pressure. One article included in our curriculum was written by Dr. Arlene Geronimus in 2006 of the University of Michigan, who proposed the weathering hypothesis, which was mentioned in the testimony of Ms. Saria Smith. Based on her research, Dr. Geronimus concluded that the repeated experience that Blacks experience early health deterioration as a consequence of the cumulative impact of repeated experience with social or economic adversity and political marginalization. What she found was that this chronic experience of stressors, quote, may cause disproportionate physiologic changes such that a Black individual may show the morbidity and mortality of a white individual who is significantly older. These measurements of early health deterioration were seen even among high income or affluent Black individuals when compared with their white counterparts. Why is this theory of weathering so important to this committee? Because issues of social and economic adversity and political marginalization, such as those included in Section 7 of this bill, are issues of public health because they contribute to the health disparities happening here in Connecticut. According to the Connecticut Health Foundation, COVID-19 continues to disproportionately lead to higher infection and mortality rates in Black and Hispanic or Latinx residents in our state. In conclusion, I urge the committee to approve this bill, and I deeply thank the co-sponsors of this bill, especially State Senator Anwar, for their tremendous work. I would make the one recommendation that wherever possible, that Black, Indigenous, Latinx, and people of color be included in the commission as much as possible. I believe Bill SB1 will provide the necessary framework towards naming, understanding, repairing, and ultimately preventing health disparities caused by institutional racism in our great state of Connecticut. Thank you very much for your time.
Thank you, Ms. Novato. I don't see any hands raised. Thank you so much for your testimony today.
Thank you.
Next, we will hear from Ms. Barahona.
Good afternoon, thank you. And I just want to say quickly, I have not appeared before you since the aid in dying testimony I gave, and I'm just deeply grateful for this committee for passing that out of committee, so thank you. I'm here though today on another issue. My name is Jennifer Barahona. I'm a resident of Fairfield and the CEO of Norwalk Acts, a collective impact organization working on systems change work for children and youth, cradle to career. And I'm here in support of SB1, and particularly in sections 6 and 7 that would declare racism as a public health crisis in the state and establish a commission to study the impact of institutional racism on public health and provide the proposals necessary to address the disparities. COVID has shown a light on an issue that many of us in the social sector have known for our entirety of our careers, that our systems are inequitable and our health outcomes for people of color are far worse than our white counterparts. Our BIPOC citizens are facing two simultaneous health crises, one a global pandemic and the other by hundreds of years of structural racism that continues to create inequities. As a resident of Fairfield, I was deeply struck by recent data that I learned that my life expectancy is 14 years longer than that of my neighbors in Bridgeport, and that a child born in Westport will on average live 20 years longer than a child born in Northeast Hartford. Those are chilling statistics. Racism clearly meets the criteria of a public health crisis. It affects a large number of people, threatens health over the long term, and requires the adoption of large-scale solutions. Our organization is the backbone of a systems change work necessary to improve those outcomes for historically marginalized populations. Just this morning, I participated in a press conference with the City of Norwalk to announce the progress for our Equal Justice in All Coalition. And yesterday, we provided a data walk for our members where we presented our disaggregated dashboards showing continual disproportionality and inequities in every data set we examine, including chronic overrepresentation of students of color in special education and disciplinary action in our schools. Across the nation, gaps in health are large, persistent, and increasing. Right here in Connecticut, there have been countless studies, many of which previous speakers have noted, that the social determinants of health are worse across the board. The data could not be more clear, and it's time for Connecticut to declare what is already evident, that racism is a public health crisis. We must act with urgency to acknowledge and address these disparities and inequities. The children being born today cannot wait any longer for change to come. I urge you to join the increasing number of states and municipalities across the country that have declared racism a public health crisis. Thank you.
Thank you, Ms. Barahona. I don't see any hands raised. Oh, actually I do. Senator Anwar.
Thank you, Madam Chair. Thank you so much for your testimony, and thank you for the work that you're doing and confirming what many of us have known and helping clarify for people who are not still sure about the ground realities in our state. Thank you so much.
My pleasure. Thank you.
Thank you, Ms. Barahona. I don't see any other hands. Thank you for your time today. Next up is Mary Beth Semino.
Good afternoon. Can you hear me?
Yes, go right ahead.
Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Mary Semino, and I live in Wallingford, Connecticut, and I have worked at Arden House Nursing Home in Hamden as a CNA for 39 years. I come before you today to testify in support of SB 1030 with changes. I love my job, and I've always loved taking care of people. Our residents have interesting stories to tell and wisdom to share. The oldest resident I ever took care of at Arden House was just 3 months shy of 115. I really enjoy working with them, and it makes me and my team feel proud and accomplished when we see someone we've been caring for go home in better shape than they had arrived. The people I work with have almost as much longevity as I. We have grown together, as have our families and our residents. We have reached milestones that most people never obtain within their own families. As cliche as it sounds, we have lived, loved, and laughed together. While I love the work I do, there are certainly major challenges that we must contend with on a daily basis. Short staffing, inadequate PPE supply, and a lack of quality training are a few of the issues my home deals with. This was problematic before the pandemic and became far worse because of it. Short staffing results in staff frantically trying to get all their responsibilities done while ensuring the residents receive quality care. We are often given unrealistic workloads by management because of short staffing. And when we have one person trying to do the work that would typically require multiple staff, the quality of care we can provide takes a hit. Furthermore, the staff that we are working with becomes exhausted, which hurts our morale and further reduces our ability to keep up with demanding work. We need to have you understand that sometimes the acuity should also be considered because a resident with a trach or a trach and a G-tube or a G-tube takes longer to care for than others. Without adequate PPE supplies, caregivers were forced to reuse single PPEs, or they resorted to making their own PPEs. Neither of these outcomes is acceptable, especially when trying to prevent our residents and coworkers from contracting this past deadly virus. Nonetheless, we continue to do our jobs under this circumstances, and because of it, we buried our residents, our coworkers, our friends, and even our families. A good portion of us were never properly fit tested for N95s. It wasn't just the PPE supply that was inadequate either. We weren't given truly comprehensive infection control education and training. Most of the time we were flying by the seat of our pants, and with any instruction that was given was not offered in a way that was efficient for all our staff. A lot of our staff primary language is Spanish.
Ms. Semino, you've reached your 3 minutes. If you'd like to give a conclusion, please.
We need bilingual infection control issues. This bill lacks any strong enforcement mechanisms, which is concerning to me. Nursing home operators cannot be relied upon to do the right thing simply because it's the right thing. Financial penalties or other enforcement mechanisms need to be added to the bill to ensure their accountability. With all that said, I am encouraging that this bill that is being debated, and I believe many of the proposals would be greatly improved with work standards expressed by the workers, as well as the care that we are able to give our residents. Please pass SB 1030 with changes I've mentioned.
Thank you, Ms. Semino. I don't see any hands. Thank you so much for your testimony and your time.
Thank you.
All right, next we'll hear from Gabriela Mendoza.
Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Gabriela Mendoza. I live in Denver, Connecticut, and I work as an LPN at the St. John Paul Center in Denver, Connecticut. I came before you in support of SB 1030 with changes. I love to take care of my residents. It is so rewarding to know that my hard work is having a positive impact on their life. With that said, it is frustrating that there is not enough staff to work the shift, not enough PPE, and insufficient training for the staff. As an LPN, I provide medical care, taking patients' history, maintaining documentation, and assisting them with their daily routine. These services are important because we care about the well-being of the residents, and the care we provide them is critical to their survival. We help them with showering, eating, toileting assistance, and socialization. When we are short-staffed, we cannot give the proper attention to our residents. We often will have 25 or more residents for one CNA. That is a lot of care to provide in only 8 hours. LPNs and CNAs end up running around, trying to accomplish all our responsibilities. It is very stressful and doesn't result in the best care for the residents. On top of the short staffing, we are constantly short on PPE or do not have the right type of PPE. This is unacceptable, especially in a pandemic. Nursing home staff need the appropriate amount of PPE. Finally, we do not receive adequate training as a staff. The training we received for infection control education was minimal and only offered in English. We are a diverse multilingual staff and must be offered training in multitude of languages. This will all allow us to better service our residents. I am supporting SB 1030 with changes because it seeks to address these issues. This bill could create a staffing standard to reduce the stress felt by staff. Although, as an LPN, I believe the hours requirement in this bill for LPN should be increased. This bill will require that nursing homes have 3 months a stockpile of PPE all the time, which is good, but could be improved by making this 6 months. Finally, this bill could create training standard that could allow our multilingual staff to proper training. Thank you. Could you please pass SB 1030?
Thank you so much, Ms. Mendoza, for your testimony. I don't see any hands raised. Thank you for your time today.
Thank you. Have a good evening.
You too. Next, we will hear from Valerie Marcella.
Good afternoon, Representative Steinberg, Senator Abrams, and distinguished members of the Public Health Committee. My name is Valerie Marcella, and I am a resident of Nyack. I would like to thank you for this opportunity to testify support on behalf of Bill 1030, an act concerning long-term care facilities, as it would help support and protect residents by helping them live a full and meaningful life in the facilities they call their homes. 3 minutes is impossible to emphasize the amount of damage from resident abuse, resident deterioration, or from the unnecessary and massive amount of lives lost. Addressing Section 10, establish essential caregivers, I would like to request language change to read resident appointed essential caregivers. Currently, this section will solve few problems as often the facility and the resident or resident's advocate differ on what is deemed critical to daily care and emotional well-being of a resident and differ on who may need essential caregivers. Theophilia, my grandmother, contracted COVID-19 through her facility staff 6 weeks after her family was shut out, plus 2 additional exposures by staff in quarantine while still denied family access. The facility had 100 COVID-19 confirmed cases, 23 COVID-19 confirmed deaths. She is now fully vaccinated. The restrictions put in did not protect her. Denying family access did hurt her. Facilities need to have an appropriate plan to prevent and contain the spread of future viruses and allow families in. Theophilia is hearing and vision impaired with dementia. She was always smiling, sociable, and fun-loving. Her family was with her every day, providing essential care, assisting with meals, hydration, exercise, access to outdoors, basic hygiene, beauty care. I cleaned, sanitized, and organized her room, washed her clothes. I read with her and wrote with her. I provided in-person assistance with medical needs and decisions at all hours, including overnight. I reported to the facility the multiple verbal and physical aggression she encountered from staff. Without in-camera, no reprimands occurred. Her dementia prevented her from giving details of time, date, and description of staff. During COVID lockdown, all social distance visits permitted were useless, especially with her impairments. I was denied compassionate care visits by the facility, regardless of the fact that she fit the guidelines provided. During isolation, she suffered, stopped smiling, became distant. She lost roommates to death with no family to console her, no love, no touch. She lost her ability to read and write. Her dementia progressed. She forgot family members. She suffered physically, lost muscle and movement, skin deterioration, dry, flaky, and bleeding. Also, she was denied access to a doctor until the next morning after she had reported to staff issues concerning her heart. When the APRN did an exam, they prescribed unauthorized new medications. This is unacceptable, dangerous, and illegal.
Ms. Marcella, you've
Yes.
reached your 3 minutes. If you'd like to
Okay.
give a conclusion, please.
Sure. Numerous agencies, including Mathematica, Consumer Voice, have highlighted that what isolation has done, including the death toll, and many families have spoke out against the devastating effects. With all this evidence, no change has been expedited for improvements. In conclusion, the restrictive guidelines leaving death and destruction in its path continue right now. We urge you to act now to prevent any future damage and save lives. I also wanted to thank all of the staff at the facilities for all of the work that they have done, all of the love that they have given while we were not able to be there. Without these individuals, the loss could have been much worse. Please support this bill and Bill 1030. And I thank you for your time and consideration. I hope we can be the voice of our most vulnerable citizens. I also have a submitted written testimony to support, and it's also more detailed.
Great. Thank you so much, Ms. Marcella. I don't see any hands. Thank you for your testimony and your time.
Thank you.
Next, we will hear from number 53, Chris Carter.
Yes, good afternoon, Representative Gilchrist and members of the committee. Thank you so much. My name is Chris Carter. I'm president of the Connecticut Assisted Living Association. I'd like to thank you for the opportunity to provide remarks today. CALA and its members actively participated with the Nursing Home and Assisted Living Oversight Work Group, and we are generally supportive of many of the concepts that were discussed. Indeed, the nature, structure, and model of how care and services are provided in Connecticut's residentially based assisted living setting have contributed significantly to much lower incidence of resident and staff infection and death stemming from the COVID-19 virus. From a regulatory perspective, we believe it is important to emphasize the difference between assisted living in Connecticut, which are non-medical settings, and nursing homes, which often provide skilled nursing care. Connecticut's assisted living model is structured as a residential platform governed by landlord-tenant law. While assisted living is licensed to provide assistance with activities of daily living, the license strictly prohibits the provision of skilled nursing care. Care and services are provided when needed, as needed. Connecticut's assisted living model successfully allows the provision of assisted living services in a wide range of settings, including state-funded congregate housing, HUD-financed low and moderate income senior housing, state pilot and demonstration program sites, market rate assisted living, memory care specific settings, and continuing care residential communities or life plan communities. It's important to note that Connecticut's assisted living model was designed and to this day provides a setting where a completely independent older adult may live together with their spouse who receives assisted living services both at the same assisted living community. For these reasons, we do not believe that assisted living should come under the definition of a long-term care facility. I don't want to take too much time here, so I'll try to summarize by commenting that the requirements set forth in sections 1B, 3, 4, 5, 6, 9, and 10 of Bill 1030 are not appropriate, again, because assisted living communities are non-medical settings. We welcome committee members to review Kayla's complete comments in my written testimony, and thank you again for this opportunity. We'd be pleased to serve as a resource going forward.
Thank you, Mr. Carter. I don't see, oh, I do. Representative Steinberg.
Thank you. Sorry for the last minute surprise. Chris, good to see you. Just one question for you.
Of course.
We recognize that assisted living facilities do bring in medically related assistive services. Are there aspects of this bill in which we have to recognize that quote unquote medical component, even if they're not quite at the same level of skilled nursing facilities?
Well, again, the licensure is structured in a way that the Assisted Living Service Agency is only permitted to provide assistance with activities of daily living. So, for example, inserting an IV line, this just doesn't happen in assisted living. Infection prevention training, it really isn't related. The nursing home course isn't relevant for assisted living settings. So, while hospice is provided in assisted living, Medicare reimbursable home care services are provided in assisted living, but the typical resident moves in and, as I say, can live completely independently until assistance is needed with ADLs, activities of daily living.
So to your point, some of the services that are often afforded those in assisted living facilities, they never go beyond ADLs. In other words, there's nothing more intensive than those activities.
In order for someone to live in assisted living there, it's required that a chronic and stable assessment be provided by their primary care physician. Once someone is no longer chronic and stable, they're no longer appropriate for assisted living. And as it's been said, the easiest way to understand chronic and stable is by understanding the opposite, which is medically complex and unstable.
Okay, just to parse it one more time. Could you be not medically complex, but need some, I don't want to use the term routine, but a more routine medical intervention in the assisted living setting, or would that immediately trigger the need to transfer to a different setting?
Again, if someone is no longer chronic and stable, they're no longer appropriate for assisted living. For example, sliding scale diabetes, that's not a stable condition.
Okay, just trying to make sure that there aren't some requirements we might still insist upon, even if we take you at your word and excise the reference to assisted living in the sections that you reference. Just want to make sure.
I would respectfully suggest that the bill really needs some redrafting or consideration regarding how assisted living is integrated. I mean, as you know, we participated actively with the oversight work group, and as you recall, we contributed actively in many of the subcommittees on many items, but including assisted living under the definition of a long-term care facility, as is described in this bill, is just not necessarily appropriate.
Well, thank you for that, Chris. We're going to look at it again with fresh eyes. Thank you, Madam.
Thank you so much,
Sure.
Representative. Yeah.
Thank you, Representative Steinberg. And thank you, Mr. Carter. I don't see any other hands. Thank you for your testimony and your time.
Thank you very much.
We're going to go back to number 50, Daryl McGraw, followed by number 54, Kay Hairston Wells. Mr. McGraw?
Oh, hello, everyone. Thank you, Rep. Gilchrist. Thank you for seeing me and recognizing me in the room. I really appreciate it. I want to thank the committee for taking this opportunity to be heard. So I would just like to say that my name is Daryl McGraw. I work at the Institute for Municipal Policy, Research and Policy at CCSU. And also I'm a formerly incarcerated person. That means that, I was formerly incarcerated. I spent 10 years of my life in and out of the Department of Corrections. I also am a person in long-term recovery, which means I haven't used a substance since May 7, 2007, getting some time there now. And I just wanted to say that today I'm here as an impacted person testifying. I support SB 1. Section 2, though, I would like for you to individuals coming home from incarceration and people that are in recovery. And I believe the way that Section 2, putting it the way Section 2 is written and putting it in the hands of, or the decision making in the hands of DPH could hinder some of the best people from actually getting jobs in that position and offering peer support. And I say that, and I won't take up too much of your time. I really appreciate you inviting me on, but understanding the fact that a peer role is based off of lived experience, and that same lived experience could prevent someone from getting a job. Meaning that, whether something that they've done early in their active addiction or what happened, something in their past could prevent them from actually getting one of those positions. So I would like to at this time just say that I'm in support of SB 1 in that particular Section 2 is the one that I'm speaking of, and reference to the peer support, but just like to see that language written differently, as well as including justice involved individuals providing that level of peer support, which forensic peer support. If there's questions about what forensic peer support is, I'd be more than happy to be the expert in the room on that. I think I'm done.
Thank you, Mr. McGraw.
Thank you.
I want to thank you for using your experience to advocate for others, and congratulations on what you've accomplished.
Oh, thank you. Thank you, Rep. Gilchrist. Appreciate it. I said
And
there are more.
I don't see any hands, but we have your testimony. And so thank you for your time today.
Sure. Thank you. Thank you so much again. Bye.
Next, we will hear from Kay Hairston Wells.
Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Kay Hairston Wells. I'm a resident of Bridgeport, and I'm here in support of SB 1, Enact Equalizing Comprehensive Access to Mental, Behavioral, and Physical Health Care in response to the pandemic with language changes. Today, I speak as a community worker, a grandmother, and doula. Grandparents Raising Grandchildren, a satellite program I hosted in the 90s as a program director for the town of Stratford, provided a space for aging parents to gather, vent, get information, eat, and heal. Elderly, mostly Black and Brown, faced with the responsibility of raising their children because of addiction, desertion, or the death of their own child. They were tired, broke, grieving, and ill-equipped to meet the developmental needs of those children, whose consequential future often included truancy, delinquency, incarceration, and even death. 30 years later, these situations remain common. My own daughters of varying income levels were coerced by medical professionals to start labor by unwarranted induction, all ending in cesarean section, seemingly now the standard of operational procedure for women of color. I watched as one daughter was wheeled into surgery because of the threat of cardiac arrest during labor. I prayed while she suffered hallucinations and other side effects of the opioids given to her for postpartum pain. And I agonize now as I watch her move about as an elderly woman suffering with back pain, often unable to stand, walk, or sit because of the epidural she received and the trauma that followed. I could have easily become one of those grandparents raising my grandchildren. The pandemic did not create the deep racial inequities in our state, but we hope it will move Connecticut to address them. This bill offers opportunities to dismantle components of systematic racism and move Connecticut closer to health equity. Disparities in healthcare today will continue to be paid for by our families, our communities, and our state tomorrow, but the opposite can also be true. As a doula, I'm trained to recognize irregularities like perinatal depression, eclampsia, womb trauma, and provide information for the management of life-threatening health conditions. Listen and provide clients with appropriate information for resources like housing, baby equipment, psychological services, and drug counseling. Teach effective pain management without drugs, and give Black and Brown clients credence and a voice. My identity, like experiences, and those of my Black and Brown sister doulas opens avenues and implement change that will not occur through status quo. More specific doula benefits are outlined in my written testimony. Specifically, I strongly support the following components of SB 1, declaring racism as a public health crisis, and the language change of lines 204 through 207 to reflect.
Ms. Hairston Wells, you've reached your 3 minutes. If you'd like to give a conclusion, please.
I will conclude to reflect a doula means a trained non-medical professional who provides physical and emotional and informational support to a pregnant person before, during, and after birth, in person or virtually. Doula support not only helps alleviate Black maternal morbidity and mortality in Black communities, but empowers and equips clients with skills and confidence to parent, spare our elders from a responsibility of ineffective child rearing, get Black babies out of the go directly to jail system, increase familial stability, and lower criminality and other subsequent stress-related issues in our Black and Brown communities, as eloquently presented by Zaria Smith and others today. I appreciate the efforts of the study to equalize access to mental behavior and physical health care in Connecticut. Thank you for the opportunity to submit this testimony regarding the doula profession. I urge you to support SB 1 to define doula profession.
Thank you so much, Ms. Hairston Wells. I don't see any hands, so thank you for your testimony and your time.
Thank you.
We're going to now go back to number 26, Robert Goodrich.
Thank you, Representative Gilchrist. My name is Robbie Goodrich, and I'm the Executive Director of RACE, a Waterbury-based education advocacy organization that fights for racial justice in our schools. And I'd just like to thank the committee for some grace that y'all gave me, because I had a 6-month check-in with my newborn at 11:40, and I couldn't observe my time that I was selected for. So I appreciate it. The rest of the committee, I'd like to urge you to read some of my submitted testimony, but I'd like to summarize and then engage the committee if there's any questions. So we believe our education systems sit at the intersection of all systems of oppression, including our systems of healthcare. Racism is a public health crisis. So declaring it so is a meaningful act that shows our legislature clearly acknowledges the current social context, the history of racism as a social determinant of health in Connecticut, and the need for anti-racist policy frameworks to remediate the harms of hundreds of years of policy decisions and processes steeped in white supremacy. A policy brief prepared by Project Hope states that race strongly influences other socioeconomic factors, that a relationship between race and other lifetime outcomes strongly exist, and that policy initiatives that support solving race-based disparities work. So when I think about our support for SB 1, I think of it in 3 ways. I think of it in a way that allows us to acknowledge this current social context, but also allows us to accept what it is that systemic racism is in this context at the state legislature. So I'd like to put on the record that government-sanctioned policies and practices that have facilitated the upward mobility of white Americans and created barriers to mobility for non-white or Black Americans is the bullseye for this bill. Now, our local experts, HES, have prepared quite a healthy and robust advocacy portal to look at that solves some of the systemic racism that exists in Connecticut. But most importantly, Section 6 and 7 include a Truth and Reconciliation Commission. And to be clear, when disparities are hidden right, either on purpose or not, they turn into public health and safety issues over time, in some cases immediately. And I'd just like to pinpoint to this committee that back in 2018, this legislature passed a bill that allows any committee to seek a racial and ethnic impact statement. And that is a clear policy that is not being used. And when we think about racial justice and racial equity, and we have a tool that was created and advocated for and is not being used, that should be a strong starting point for the legislature, if it can't commit to declaring racism a public health crisis, to addressing bills and seeing their impacts on the record, just like a fiscal statement. So if this committee doesn't support declaring racism a public health crisis, I do strongly urge you to start using the racial and ethnic impact
Mr.
statement.
Goodrich, you've reached your 3 minutes. If you'd like to give a conclusion, please.
No, I'd just like to conclude that it's really important that we are able to embrace an anti-racist policy framework, use the Commission on Equity and Opportunity, and start using the racial and ethnic impact statements if we're not, in fact, going to declare racism a public health crisis.
Thank you, Mr. Goodrich. Impressive use of Zoom. We do have a hand raised, Senator Anwar.
Thank you, Madam Chair. Thank you so much for your testimony. Would you be able to finish the last part? I saw part of the slide, but I could not read it. So if you don't mind completing that for us.
In terms of the solutions for systemic racism?
Correct.
Right, so there's a whole host of solutions that include increasing the access to Husky, to addressing the barriers to health by supporting pathways to sustainable reimbursements for community healthcare systems, and also to specifically target health disparities by embedding health equity in all policies. That means engaging institutions like Health Equity Solutions and experts like the Government Alliance for Racial Equity to come in to work with agency heads and using this piece of legislation and that Truth and Reconciliation Commission to really drive forward what we think in the social justice community needs to happen at the legislative level for every bill, not just stuff in the Public Health Committee, but in education, the Committee on Children, and our criminal justice committees as well. So this is just a starting point.
Thank you. And may I just clarify, did you see anything in this bill that takes away from somebody else or anyone else?
No, I really didn't.
Okay.
I find it hard to believe that that would be a claim.
Okay, good. I just wanted to make sure. Thank you so much for your testimony. This is very helpful. Thank you, Madam Chair.
Thank you, Senator. And thank you, Mr. Goodrich. I don't see any other hands. Thank you for your testimony and your time. Next, we will hear from Mag Morelli.
Thank you, Representative Gilchrist and members of the Public Health Committee. My name is Mag Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services. On behalf of Leading Age Connecticut, I'm pleased to provide testimony on Senate Bill 1030 and that concerning long-term care facilities. Over the past year, the aging services field has been at the center of the global COVID-19 pandemic. COVID-19 is a virus that has targeted the very people we serve. As such, our member organizations have been uniquely impacted by the pandemic, unlike any other healthcare provider sector. We are proud of their efforts. Leading Age Connecticut members have faced this pandemic head-on and continue to do so as they protect and compassionately care for the most vulnerable older adults in our state. The bill before you today reflects many of the recommendations that came out of the pandemic-related Nursing Home and Assisted Living Oversight Working Group. Leading Age Connecticut actively participated in the working group, and our written testimony provides comments on all of the sections of the bill, but I will now just briefly touch on a few sections. Our first request is that the committee consider adding to this bill the recommendations of the Working Group Subcommittee on Infrastructure and Capital Improvements. Specifically, we ask that the financing and funding options be made available to nursing homes so they can finance necessary maintenance and improvements within their physical plants. Regarding the bill itself, I want to first point out that sections 1 through 12, if passed, would apply not only to nursing homes, but also 6 other licensed settings. Each of these settings is unique in their service delivery and is regulated through separate state and federal laws and regulations. We do not believe that all the sections of the bill should apply to all of the settings, and we have attempted to address this in our written comments. We do, regarding section 4, we don't support this section of the bill, which would require that providers always have available on staff a licensed healthcare professional who's certified to initiate an IV line. Regarding nursing homes, most contract with a professional service to initiate the IV therapy if it is needed. However, most nursing homes never need to provide this service, and those that do tend to specialize in it. Therefore, we do not agree with this universal mandate. On section 13, we have a lot of written comments on this section, but I want to focus on the staffing level. We understand the interest in raising the minimum staffing requirements that are currently listed in the Public Health Code. We do, however, want to reassure the committee that both the Public Health Code and federal oversight regulations currently require nursing homes to staff at a level that meets the needs of the residents. That is the standard. The bill proposes 4.1 hours of direct care per resident day as a minimum standard, but it also proposes specific ratios per license category within but it also proposes specific written ratios within that category. To mandate specific ratios of CNA, RN, and LPN within an overall minimum staffing level goes beyond the concept of flexing, goes against the concept of flexing your staffing to meet the needs of the resident, and flies in the face of our new acuity-based reimbursement system, which is expected to be implemented later this year. These specific ratios are based on a 20-year-old study. Yes?
You've reached your 3 minutes. If you'd please like to give a conclusion.
Sure. I just want to say we do think that you need to address the Medicare reimbursement with regard to staffing. The staffing data shows very clearly that nursing homes that currently staff at high levels are not reimbursed for the cost of that staffing, and we need to address this before we move into an acuity-based system. And finally, on section 14, we support the establishment of a comprehensive statutory framework to govern and facilitate the use of technology by residents in nursing homes. It's important to establish good public policy on this very important issue, and we need to do it right. Our priority is to ensure the self-determination, privacy, and dignity of the nursing home resident. And the bill before you applies only to nonverbal residents, but we would prefer and strongly suggest a more comprehensive statute be established that's inclusive of all situations. Thank you. I'd be happy to answer any questions.
Thank you, Mag, for your testimony as always. We'd appreciate your help in expanding the section that you just referenced, if you have language that we could consider. Let's talk about the money, which is where you got to follow the money.
Yes.
There are two components to this. There's the operating side and the capital side. So much of what we talked about in the subgroup on facilities has to really do with significant capital investment in some areas, but we did discuss some things that could be loosely construed as upgraded maintenance that might be something we could obtain through budgets. And I'd like to focus on that first. Again, I referenced I don't want to say found federal dollars, but the dollars that come from the relief package. And we're all still sifting through the terms, or some of those terms haven't even been written yet, from what I can understand, for how those funds may be used. But I'd appreciate a further dialogue with you about identifying some of the lower cost maintenance driven needs that we identified previously, and perhaps we can make the case that some of those relief funds would be allocated for that purpose. With regard to the capital component, now we're really talking about probably getting into the queue on bonding, and that's a whole nother ball game when it comes to come up with the funds. But I, for one, have not given up on trying to accomplish that. So I appreciate the points you made about, frankly, what's not in here. It's not really the facilities piece because of the money kicker in this whole thing. But I'd be glad to partner with you to see if we can devise a means by which we can make that case.
We'd be happy to do that, Representative Steinberg. These are very old buildings. They've been in need of some maintenance and capital improvements, and now with the pandemic, we see other needs that may be required regarding the HVAC systems and air circulation systems, and just space in general.
Well, so I owe you a subsequent meeting to see what we can come up with. I think on the capital side, our expectations have to be modest, but definitely worthy of further conversation while this moment is still upon us.
Thank you. Happy to.
I don't see any further questions, which surprises me. I guess you covered things so well.
Well, thank you.
Thank you again. We'll talk.
Thank you.
Sure. Next up, surprise, surprises, Matt Barrett. How did that happen? He's not quick on the draw as you were, Meg. Come on, Matt. We may have caught Matt unawares. So I tell you what, why don't we move on to number 58?
Are we a good representative?
Now
Steinberg?
you're good. Now we can see you. Please proceed.
Thank you. Sorry about the technical problem there. Good afternoon, Representative Steinberg, Senator Abrams, and to the distinguished members of the Public Health Committee. My name is Matt Barrett, and I am President and CEO of the Connecticut Association of Healthcare Facilities. And thank you for this opportunity to testify concerning SB 1030, an act concerning long-term care facilities. I'm pleased to be joined in our conference room by Bill White, a longstanding association board member and member of our association's legislative committee. Mr. White is the operator and administrator of Beechwood Rehabilitation and Nursing Center in New London, Connecticut. We have submitted written testimony to the committee, and I will begin with section 4 on licensed and certified staff to start intravenous lines. We're asking the committee to recognize that due to RN staffing shortages, most nursing homes must contract with a long-term care pharmacy to secure qualified staff to start intravenous lines. Accordingly, we recommend that the language be modified to include 24-hour IV starts by contracted staff. Concerning section 3, we appreciate that the proposed PPE stockpile requirements seek to establish a 3-month statewide stockpile acquired and managed by the Department of Public Health for nursing homes. Due to limited nursing home storage space, we're asking that the legislation provide the option for the PPE to be earmarked for a specific nursing home, but actually housed in a central storage site managed by the state and accessed as needed by nursing homes. At this time, I'm delighted to introduce Mr. Bill White.
With regard to infection prevention and control, we agree in elevating the status of infection preventionists in our Connecticut nursing homes. Most Connecticut nursing homes have designated full-time IPs, while smaller nursing homes may have one or more part-time, specifically trained IPs with additional duties. Noting that RNs who specialize in IPs remain a hiring challenge for nursing homes, especially for smaller nursing homes, we recommend the amount of time required for an IP be adjusted based on each facility's bed count, demographics of the facility's surrounding area, and individual factors contributing to infection control risk levels, with flexibility for smaller nursing homes. With regard to staffing, our association supports the effort to ensure adequate staffing at all nursing homes and to compensate all nursing home caregivers and employees at a level that recognizes their value. However, we favor a focus on elevating the status and importance of long-term care staff through recruitment and retention strategies and providing long underfunded nursing homes with significant new state and federal funds. Finally, concerning establish a daily minimum staffing ratio of at least 4.1 hours of direct care per resident. To help inform the implications of increasing minimum staffing ratios, our association obtained the support for the Center for Health Policy Evaluation and Long-Term Care to provide a framework for estimating the costs of increased minimum staffing ratios in Connecticut nursing homes. The full report is attached to our written testimony. In closing, we recommend nursing homes should be given the flexibility on where to direct the percentage of staffing resources to RNs, LPNs, and CNAs.
Mr. Barrett, you've reached your 3 minutes. If you'd like to give a conclusion, please.
Thank you so much. Well, we thank again the committee for the opportunity to testify, and we'd be happy to answer any questions you may have.
Thank you to both of you for your testimony. Matt, a comment you made earlier with regard to the allocation of PPE. Did I hear you correctly in suggesting that you wanted to explicitly stipulate the allocation to each facility? I wasn't quite clear on that point.
Right. Thank you, Representative Steinberg. As we read the bill, we understand that the stockpile that will be held by the Department of Public Health will be at a central storage location, and that there will be sort of the estimate of what that stockpile entails includes a 3-month supply to all Connecticut nursing facilities. We really appreciate that provision. I'd like to express out loud. But that many nursing facilities don't actually have the storage ability to house 3-month supply of PPE. It's a significant amount of PPE, And so we're asking that that PP sort of remain in the central DPH site and accessed as needed by the facilities.
That sounds eminently reasonable. I'm sure that's something that could probably be worked out with the those who are going to put together the central facility. But that's a point that we're going to need to keep in mind, that you're right. That could represent a fair bit of material to store in some of our older, smaller facilities. I would be confident that we can find a way to make that work and still assure that inventory is transferred on a timely basis to meet needs of specific homes. Thank you for that. Representative Cook has a question.
Thank you, Mr. Chairman, and I'm sorry for my non-video. My service is kind of delayed today. Matt, it's great to see you guys, and I want to thank you all for your work and dedication to continuously partnering with us. I want to address the pushback a little bit on the staffing levels. I couldn't get Mag, and so I'm sorry. By default, you're going to get some of the questions. I hear you have a pushback with the minimum staffing levels and our increases, and you and I have discussed this numerous times over several years. What is your recommendation moving forward if you are not acceptable to the proposals that we have in place right now?
Well, thank you thank you, Representative Cook, and it's good to see you also. First, I want to express in very clear terms that we are 100% in support of increased staffing, including the very significant amount of new state and federal resources that we believe will be needed to increase staffing. But you're quite correct. We don't favor kind of the forced distribution of staffing as currently proposed under the language of the bill as corrected, 4.1 hours per resident day. It really comes down to this. We think we need the flexibility to direct the percentage to LPN or RN or CN that is directly related to the needs of that facility, and sort of a cookie cutter kind of demarcation that indicates, 2.8 of CNA or 0.75 and 0.54 doesn't allow that kind of flexibility. So that's really kind of point number one. Point number two is that the sort of resources that would be needed to go from a minimum of 1.9 minimum staffing, which is currently the requirement. And I think we all recognize that Connecticut nursing homes are staffing considerably above the 1.9. But I would be greatly concerned that all Connecticut nursing facilities, perhaps many, according to the Center for Policy Analysis that we had reviewed this, would not be anywhere near the 4.1, at least as it's demarcated right now, and that there would really be hundreds of millions of in dollars and resources that would be needed to address those concerns. So we favor directing those resources into the system, into the rates. We always point out that we feel there's $135 million shortfall in the current system. And with census down as much as it is right now, we think that a 14 or 15% rate increase is probably needed to address our occupancy down by at least that much. And so we think there's a very considerable amount of state and federal resources. We hope some very significant amount of resources in the federal funds that are coming to Connecticut can be earmarked and directed towards Connecticut nursing facilities. But if we don't have that, the staffing issues will just be exacerbated, and it will contribute to the financial insecurity and instability of the system.
We may have lost Representative Cook for a moment there. Well, in any case,
if there's a lull, I'd offer Mr. White, an expert in this area, to offer a concluding observation with your permission, Representative Steinberg.
Please proceed.
Jonathan, am I back?
You're back.
Okay, do you mind, Matt, if I continue for a moment?
Oh, not at all, Representative Cook.
Okay, thank you. I'm sorry, I hit the wrong mute button. So my question would go from there. So a few years ago, we did a rate increase, and then a good amount of the staff never received the rate increase because the facilities held on to that rate increase. And then they turned around and said, oh, well, we can't give it to you now because of the COVID expenses. So as much as I absolutely want to continue to push for rate increases, it truly frustrates me that the money that we have been past allocated didn't get to the necessary folks in a timely manner. And that was specific dollars for direct care staff and CNAs and the nurses on the floors. So I hear you, and I don't disagree that the staff does not deserve more money, but how do we ensure that that money goes directly to the people that we have allocated it for when it has not in the past? What assurances do we have to go to that level?
No, thank you very much, Representative Cook. And I would acknowledge that I was aware that there were some timing issues in terms of when staff received pay raises in terms of the previous wage and benefit enhancements that were generously recommended by Governor Lamont and adopted by the legislature. But in all the instances I looked into, all of those pay raises were given retroactive to when the beginning of the period was supposed to, when they were effective. And so in the final analysis, in my opinion, nobody was short of their pay raises, even though I acknowledge that some of them were delayed. But those that were delayed were provided retroactively. I think the regrettable part of some of the wage and benefit packages is that we've adopted in the past, and though they have recognized the value and importance of earmarking funds specifically for wage and benefit enhancements, no dollars have been left behind to address the operational shortcomings of the system right now. We talk about the $135 million shortfall that that's being experienced, and all the added burdens and needs of the system, amounting to over $500 million as far as we can estimate, but no dollars have been earmarked to address the underlying operational issues that our nursing homes face. So I believe we can have a system that is auditable and that we can assure will be go into the pocketbooks of our hardworking nursing home employees. And that's what we've experienced in the past, in my opinion.
So I would think that we're going to respectfully have to disagree, because I have letters that show that those staff did not get their raises, nor did they get retroactive pay. And quite frankly, there should have been no excuse for a facility to hold on to the dollars that was directly supposed to go to the staff. But we'll move on to that. My next point would be the issue when we talk about staffing ratios. We require one staff to every 4 to 6 infant and toddlers, and then 10 for children that are up to a certain age. So if we require that for our infants and toddlers, but we do not require that for our elderly folks who we know have higher needs that are much more complicated to move and transport and work with. I think that a staffing ratio, although we know that it's supposed to be need-based and we know that that doesn't happen, clearly follows the precedent of guidance by profession. What I mean by that is CNA breakout away from the RN versus, the director of nursing and fill in the blank. So how do you suggest that we move forward if you do not like the breakdown of the staffing recommendations? How do you suggest we move forward, given the fact that in my world, 1.9 hours of care, which I can tell you numerous facilities are getting at max 1.9 hours of care. And some folks don't even get that. Some folks aren't showered for a week. Some folks don't have their hair washed. They're not toileted, but maybe 2 times a day. And I'm not saying every facility, but there are some. So my question for you would be, how do we move forward to guarantee that the ratios are increased, that the needs are met, but at the same time, we have the ability to oversee, to give more than 1.9 hours of care? Because I know for myself and for you and anybody else watching, we care for our own individual selves far more than 1.9 hours in a given day.
No, thank you, Representative Cook. And your points are well taken. I do want to state for the record my belief, my professional belief, that all Connecticut nursing facilities are staffing above the 1.9 level. And I'll even go further and say that I concur with you. I think the 1.9 level is somewhat of a ridiculously low standard. It's some 30 years old, and that we could work together to increase the minimum standard. Our association would support that. I think we have to carefully consider the fiscal implications of that, but doing that work shouldn't sort of be sidetracked just because there are resources needed to do it. I think one of the things that we're learning here is that if we continue to ignore these considerable needs of the sector, including the important needs of our employees, then we're going to have a system that is going to continue to perform or has the opportunity to perform at much better levels than it's performing right now. And so I think we could reasonably have a conversation about increasing the minimums, but we would not support hamstringing our facilities to directing resources to RN and LPN and CNAs. Some facilities may want to invest and need to invest, given their client population, higher in RN. RN has staffing shortages also, and to have these sort of forced distributions of the increases, I think would really not get the quality outcomes that we're all looking for.
Well, Matt, I think that if we give a minimum staffing ratio of, hypothetically, if you have 24 patients on a floor and we say there's got to be 5 CNAs at all times, that's a minimum standard. But there is there is nothing to prevent any facility from staffing above that minimum standard. And I think that that's really something that we have to look at, that there should not ever be a CNA on a floor of 24 residents, and that's the only CNA on the floor. So I think, and that's happening regularly, and that happened before COVID. So, those are things that we really need to look to prevent. And at the end of the day, this is really about respecting those folks, our elderly folks. And I don't know if you heard me when I was talking about talking to the commissioner, but we are not affording the respect or the dignity to our elderly population. And that for me is really the crux of this issue. And they deserve much more from us. And that's, we can go back and forth about this. I will leave it there. But I just really hope that we can see above some of the dollars and cents and the handcuffing, if you will, and realizing that this is about making a system better that's not actually working for the folks that need it now. So thank you guys for everything.
I certainly respect your advocacy and look forward to working with you in the committee, Representative Cook.
Thank you,
Thank
Mr.
you,
Chairman.
Representative. I believe you just highlighted the real challenge in instituting ratios into statute, but we certainly are all in favor of the objective, and we just got to figure a way to do it equitably and, as Matt has pointed out, in a way in which we achieve our objective, which is quality of care and appropriate coverage.
Mr. Chairman, it's Representative McCarty. I apologize. I can't get the raise the hand piece on my phone device. May I be recognized?
Well, we recognize you both for your need to speak and your gumption and making sure you get a chance. So let's continue.
I really appreciate it. Thank you so much, Mr. Chairman. And I'd just like to start with a comment to Bill White, whom I know very well, who runs a long-term care facility right next to me. And I just want the committee to know that some of these administrators went way above and beyond during the pandemic. Bill White actually shared his PPE with other facilities that were shortchanged during the pandemic. So I wanted him to have that recognition. He certainly had a model facility throughout the whole pandemic, and we really look to him for guidance. Having said that, I am particularly a strong advocate for Section 10 of this Senate Bill 1030 and also Section 14. I know that throughout the pandemic, we really had a difficult time meeting the social, emotional well-being of our residents. And with that, the particular subcommittee that I served on the Oversight Council, we looked at that and thought that an essential caregiver program was an area that we thought was very important going forward. In the case where you have long-term shutdown and isolation, that we have to find a means to allow our residents to have that social interaction with their families, and an essential caregiver would meet that. So I'm just curious from Matt and Bill if they would be supportive of working on an essential caregiver program in the state. And then my last question very quickly, and I'm sorry, I know it's a long day, on Section 14, I'm so pleased to see that part put into this bill about allowing for video camera in the nursing home. For years, we've been trying to work on that initiative, and I want to recognize both parties for their work, especially Matt and Meg, on working to try to implement that. So thank you, Mr. Chair. If they could just comment briefly, thank you.
Yeah, thank you so much, Representative McCarty. And then I'll begin to ask Mr. White to follow up. But yes, we have devoted a considerable time to a companion bill regarding essential support persons that is introduced, and and there's a public hearing on in the Human Services Committee, and that is House Bill 6634. And admittedly, we haven't spent as much attention on the public health version that is included on essential caregivers in Senate Bill 1030. Having said that, I think there's conceptual support, and I think that we have demonstrated our willingness to work with the advocates and the Department of Public Health and legislators on coming to an essential caregivers or essential support person initiative that can comply with the CMS rules that they're governed with, but then be more specifically or narrowly tailored for circumstances when visitation is very severely restricted, as in the case of a public health emergency. And certainly there's no better example of that than what we've been through over the last year. And so I do think that there's an opportunity to for an initiative there. I do think it has to be specific to when visitation is restricted in order to be in compliance with federal rules, because as we've seen in recent guidance or rules coming out from CMS, when the restrictions are lifted, then there is no access, nothing impedes access to visitation in a long-term care facility. And really, the underlying need for an essential caregiver initiative really diminishes considerably when we're on the other side of this pandemic.
Well, thank you, and I appreciate those comments, Matt, but I think what we're trying to do is go beyond that and look beyond. When you have a prolonged shutdown, some of that isolation creates such severe health issues. So we'd like to see the essential caregiver maybe elevated to a different status so that they would be able, in a lockdown and even with restrictions, if they met the appropriate protocol with the protection pieces and they went through the training, that they would still have some access to be allowed into visitation. So that's a piece I think we will need to work on going forward. I think there is a difference between the support person and the essential caregiver. And then just finally on the video camera piece, if you wouldn't mind.
Oh yeah, thank you, Representative, and I appreciate all the work that you have done on that issue for many years. In fact, it may very well be that you were the first legislator to introduce such an initiative, and it's been you've been a very gracious person in terms of hearing us out on our concerns regarding those initiatives related to confidentiality, the costs of implementing video monitoring and surveillance, and even technologies to encourage and facilitate visitation in nursing facilities. So we very much appreciate all the work you have done there. Once more, there is a sort of, coming together, a very well developed piece of legislation, House Bill 6552. Our sector has made additional comments, and we would like to see some changes there. But so many of the issues that have been a concern to the industry in the past regarding confidentiality, cost, notice, and so forth are addressed in this comprehensive bill. And so we're looking forward to working with the Public Health Committee and the Human Service, but strike that, that would be the Aging Committee. And that bill is actually already favorably reported, House Bill 6552, on coming to a final agreement on the language that addresses, I think, our remaining concerns, small that they may be, considering so much is addressed in the bill, and advancing the very issues that you have advocated for many years, Representative McCarty.
Representative McCarty,
Bill would like to comment.
This is Bill. As you and I have talked many times, and I always appreciate the time you give me is if it can be done safely, then I would go to any lengths, and I think my peers would go to any lengths to bring two people together. I got to see last week a daughter hug her mother for the first time in a year. If we can find a way to make those interactions safe, even during a pandemic, I think that's something we would all support.
Thank you both very much. It was good seeing you today, and I appreciate your comments. Thank you so much, Mr. Chairman, for allowing me to speak out of turn. Thank you.
I wouldn't say you were speaking out of turn, just in a little different way. You know, I think these last couple conversations have highlighted how challenging it is to do the right thing. We know what we need to do here. We know what the problem is. Running the language such that it actually meets the need is a real challenge. So I want to thank everybody for having been so deliberative with this aspect of the debate. We'll continue to try to work the language. So thank you for that. I don't see any other questions. Thank you for your time today and for helping us try to figure this out and for representing your members so well. Next up is Anna Doragazi, followed by number 59, Antonia Edwards.
Thank you, Mr. Chairman, ranking members and members of the Public Health Committee. My name is Anna Doragazi, and I am one of the policy directors at AARP Connecticut. We are a social mission organization that advocates on behalf of individuals aged 50 and older, and on behalf of our nearly 600,000 members in Connecticut. I'd like to thank you for the opportunity to express our strong support for SB 1030, an act concerning long-term care facilities. We submitted lengthy testimony that details our support for the full bill, but I know my time is limited, so I'm going to focus my remarks on AARP's support for the sections of SB 1030 that relate to visitation and staffing. Regarding visitation, many of the nursing home and assisted living oversight working group subcommittee meetings featured nursing home staff, residents, and their loved ones who shared heartbreaking stories about the impact of restricted visitation. There are a lot of people testifying today about the trauma and loss they've experienced in the past year, and I want to thank them for sharing their stories. We support the sections of SB 1030 that relate to visitation and reducing social isolation, but we would also suggest that the committee consider addressing what should happen if facilities do not adequately implement sections 8 through 11 of this bill. Regulations are only as strong as our ability to enforce them, and I know a big source of frustration for residents and families this past year has been the uneven application and interpretation of CMS and DPH guidance across facilities, and feeling like no recourse was available when they felt that they were inappropriately denied visitation. While we support Section 14 of SB 1030, which would permit nonverbal residents to install cameras in their rooms, we prefer the language in a bill that just passed out of the Aging Committee, House Bill 6552, an act concerning the rights of residents in long-term care facilities to use the technology of their choice. Technology holds great potential to reduce isolation and help people stay connected. And while we strongly support cameras and other widely available technology, we think it should be available to all residents, not just those who are nonverbal. Regarding staffing levels are critical to quality care in nursing homes. Low staffing levels mean that residents can't get out of bed. It means they can't use the bathroom or eat in a timely manner. Staff risk physical injury and cannot give residents the time and attention they deserve. Visits with loved ones may be limited or canceled, and it's more difficult for facilities to contain the spread of COVID-19 and other infectious diseases. AARP very strongly supports the 4.1 hours of care per resident per day recommended in Section 13 of SB 1030, although we believe there may be a drafting error in line 164, which references 3 3/4 hours of care by a registered nurse. We believe this should probably say 3/4 hours of RN care per resident per day. AARP acknowledges and appreciates the tireless work of elected officials, state agencies, long-term care workers, and many others to respond to an unprecedented crisis during the past year. But the bottom line is that our systems failed.
Ms. Doragazi, you've reached your 3 minutes. If you'd like to give a conclusion, please.
Sure. Yep. The bottom line is that our systems failed older and disabled residents, and they all deserved so much better than what we gave them. SB 1030 is the result of a lot of conversations about how we can build a better system of long-term care, and AARP urges its passage. Thank you.
Thank you for your testimony, and we will look at that bill coming out of aging if that language seems to meet the need to a degree that ours doesn't. Thank you for that. And I hope our lawyers were also paying attention when you mentioned that potential drafting error. That does sound like a pretty rigorous 3 3/4 hours, if that's what we're talking about. We will take a look at those things. I don't see any questions for you, but we will read your written testimony very carefully. Thank you for testifying before us today.
Wonderful. Thank you.
Next up, number 59, Antonia Edwards, followed by Tamika McPhail. Antonia.
Hi, good morning. How's everybody doing?
We're doing pretty well. How about you?
Thank you. I want to say thank you to all the Mr. Chair, Mr. Steinberg, the Madam Chair, also the esteemed members of the Public Health Committee. I want to give a specific shout out to Senator Anwar, who made me aware of SB 55. And although he doesn't know what I'm going to say, he created this platform for me to be able to voice my opinion and tell my personal experience and explain why racism is not just a public health crisis, it's a public health emergency. So I just want to start off with saying that I adamantly agree and approve with SB 55. I understand now that it's wrapped up under SB 1, so I approve the whole bill. I'm going to start off with my personal experience, so it's going to be very hard for me. I'm extremely perturbed by the blatant implicit racism and biases that I witness on a daily basis in the medical, mental, and also educational fields in Connecticut. It's not even remotely settled. I work in the communities as a family and community advocate, free of charge. I do it to give back. And I did this because my son is 22 and he's autistic. And I felt like everything that I learned back in from 1990 to now, there are so many people that didn't have the opportunity to learn what I know, and I wanted to give back so that no other parent had to go through what I went through raising a young Black man who's autistic in the inner cities of Boston and the suburbs. I'm extremely heartbroken for me to sit on so many boards. I attend many equity and equality meetings, community meetings, symposiums, conferences. With each encounter, I leave with the same disappointment of the lack of cultural competency in the citizens, healthcare providers, service providers, educators, and even some legislators, some of the things that they say. I say all this to emphasize the fact that racism is indeed a public health emergency. My daughter and I have fought vigorously for the past since 2017, tirelessly to obtain appropriate medical and mental health services for my 2 minor grandchildren. Both needed extensive and comprehensive treatment due to a kidnapping, physical abuse, and possible sexual assault of their stepfather. Instead of putting the children first, we were constantly being spoken to in a belittling, condescending way and treated like third-class citizens. We were never taken serious of our personal reports of risk or injury and possible injury to others for our own kids. The older minor child, while in a serious acute situation, was kicked out of a mental health facility in the middle of the night in a parking lot. This continued an abrupt discharge with no medication, no service plan, and when asked, was this appropriate or legal, we were told that they would call the police to get us off the property. This is all over a miscommunication of a peanut allergy. Nothing other than the fact that they were in fear of a peanut allergy. Both my daughter and myself, but mostly my daughter, our professional backgrounds were investigated simply because of our names, not because we gave anybody any permission to do so, and our history and work in Boston. My daughter's name was changed, so she knew because the employers had called her and told her that somebody had been trying to ask did she work there, and they had the information wrong. So nobody gave them permission to investigate my daughter's last name, but they called to see where she worked at, was she indeed a nurse, what level of medical care did she work in. This information, yes.
If you reach your 3 minutes, if you
okay,
conclusion.
I'm going to give you the conclusion because my thing is there. And in closing, I would just like to ask that, and I'm just going to make it perfectly clear, that I really believe that the Truth and Reconciliation Commission should be created, and it should be concentrated specifically for a company just for Black American descendants of slavery. The oppression and systematic racism stems from slavery here, and I don't believe that anybody should have to go through that. Black Americans are all affected by the historical injustices of slavery, and we have the right for pursuit of equal justice and happiness. To create this, the study would have inequities and inequalities for Black American descendants of slavery. Without doing so, nothing would make any sense. We cannot afford to lose another loss of life, and basically for the Black and Hispanic community. And I say all this to say that because our founding our reports weren't taken serious. My granddaughter, because she had auditory hallucination and visual hallucination, she then murdered my grandson. So my grandson died on August 7th because nobody took us serious. They made a mockery of us. They ridiculed us. They called DCF on us. All this stuff was unfounded, all because of cultural implicit biases and racism. And all of this is documented. We have everything in writing. We have everything to prove what we're saying. And this happens all the time. And it happens to a lot of Black people from the community. They just don't say anything because they don't think anybody's going to take them serious. So as a result of us not being taken serious, my grandson was then murdered by my granddaughter on August 7th because she thought, because of PTSD, she thought the kidnapper was coming back to get her, and she heard auditory hallucinations or visual hallucinations. I'm asking that you take this SB1 and SB 55 serious, and I'm asking that you please declare racism as a public health emergency in the Black communities. I'm asking you to do so because I'm wearing my heart on my sleeve, and I'm asking you to do so that my grandson's name, his life, and his death is not in vain. And so if you could do this for me, I'd greatly appreciate it. I'm not looking for anything else other than to remedies and resolutions. And
I can assure you we're going to take it very seriously, and let us all offer our condolences on your loss.
So this is my grandson, and I'm gonna this hearing is about him, and I can now say his name, Javon Navon. And I want everybody to know that because of the racism, he died.
Thank you for that. I believe Senator Anwar has a question for you, followed by Representative Kavros-DeGraw.
Thank you, Antonia and Mr. Edwards. Thank you for your testimony. I did not even realize we have spoken a few times, but you never shared this painful experience that you've had. I'm so sorry that you've experienced this.
Thank you.
And I think our hope is that we as legislators will stand with you and the community, because enough is enough.
Enough is enough. It's enough.
And if there was anybody, and I hope there's nobody, but if there's anybody who claims of any background that there is no racism in our state, what would you say to them if you had that opportunity? I want people to have that empathy, and I sometimes don't see it, so that's why I'm asking you this question.
I say that people are in significant denial. I was on a call with you yesterday in housing, and I think that people who don't live in diverse communities, don't want to come out of their comfort zones, don't understand the impact of systematic racism in America, but especially in the northernmost state like Connecticut, and it's been going on for over 400 years. And I keep explaining it stems from slavery, but Black American African Americans come from different diasporas. So anybody who's Black, regardless of where you're from, you are treated, you know what I'm saying, with implicit biases and racism simply because of the color of your skin. And no other group of people have been treated like this in America other than the Black American descendants of slavery. And so my mission, I'm not mad, as I said in the other meeting, I want correction. I want it in name of my grandson. Everything Connecticut owes it to him. We didn't ask for this. We're not from here. My daughter's lived here more than I have, and it's impossible to see the kind of racism that I see in the last 3 years, and people who have lived here their whole life don't see it. It's impossible. If you don't see it, you're in denial. And so this is my grandson. This is proof that racism exists in Connecticut. He died because the nurses, the doctors, the staff members at the acute hospitals, the DCF workers who were told false stories, ridiculed us. They treated us like third-class citizens. They didn't believe us. And everything that we said, that my granddaughter said, and the drawings that she did, and the stories that she wrote, she did it. It's sad. So I fight every day for all other parents, but I'm fighting for my grandson. All I want is something to be done in his name. to show that this was not all done in vain. I have had the support from the Lieutenant Governor. She did issue my grandson a citation, so in Mayor Justin Elicker, so that I have had support from, you know, hierarchy, whatever. However, it's not them. It's the people in the community. It's the service providers. It's the teachers. It's the people who are culturally incompetent. And I want it to stop. I don't want another kid to die as a result of this cultural incompetency, implicit and racial biases in Connecticut. Every other northern state is diverse. Rhode Island, Massachusetts, where I'm from, New York, Connecticut is way behind the times. It's so reminiscent of the Jim Crow era for Black people. So anything I can do to assist, I would greatly appreciate it.
Thank you, Ms. Edwards. I cannot thank you enough for your words and sharing your pain. I just also want you to give you some words of encouragement that in my conversation today, there were medical students who have come, and I know there are people from healthcare background who have come to support this.
Right.
Encouraging, and I'm hoping that we can do better in our educational efforts, in our training at various levels, so the clinicians have cultural competence and understanding, so we do not have these challenges. That's one part of the puzzle. There are multiple other parts, but this commission would at least start some of that process. Thank you for your testimony.
I thank you, and also, and I just want to close with saying, Senator Looney, you mentioned that those who ignore history are doomed to fail to repeat it, and that is so true. And I want to thank Senator Looney for making that statement. And again, if we can have a commission to just show the historical damages and disparities of Black people from slavery, you'll see why it exists today. Because some people believe that the effects of slavery don't exist today, and that's wrong. And I just feel like we need to do that. And if you could do that for me, I'd be greatly appreciated.
Thank you. Thank you,
We have another question for you, Representative Kavaros-Jagraw.
Sure.
Thank you so much, Ms. Edwards, for being here today. I cannot imagine how hard it must have been to live, because I know how hard that was to listen to. So I thank you for your bravery. I thank you for your honesty, and I thank you for your advocacy on behalf of not just your grandson, but your entire community. Because what you say is absolutely correct, and it's a collective trauma that Black people have experienced, continue to experience, and it creates an environment that is not just when you go to the doctor, what you're there for. It creates another trauma because perhaps you've had, other people had experiences like this where they're not listened and where they're not valued, or, I know of some of those experiences of friends in my own life. I do want you to know that as I was reviewing legislative surveys from my primarily white district this week, there are people who are very focused and very, they want me to focus on issues of equity and issues of making sure that things are more equitable. So I want you to know that there are people out here who like you.
Thank you.
Who want those things. I do want to ask you, and Dr. Anwar was sort of touching on this at the end, because you have served your community in so many various ways and on so many boards, what kind of training, because we hear about diversity training, but what kind of training do you think people need to go through to get that cultural competence?
I think the people in the medical field, like Dr. Anwar said, the cultural competency, team them up with people in the community. You know what I'm saying? Just like teachers that come out of school. You can't teach in the inner city if you have never been in it. So I think that UConn does a great job of it with the LIN program, where you have physicians, you know what I'm saying, who actually work in tandem with people in the community, a family, you know what I'm saying, so they can understand what actually goes on. I also believe that there should be a higher recruitment of African-American doctors. There should be an emergency push right now for Black doctors. If I come to your office, you can't possibly understand who I am and treat me as a psychiatrist or a physician if you have no clue where I came from. And so I think that having that likeness will be better. You know what I'm saying, and so that also will create some of the lack of cultural incompetencies. And I think that Connecticut should do a major push, whatever they need to do, just like they do with businesses, to get African American doctors in here. And I'm just letting you know that today's the first day that I publicly did this. Only certain people know about it. My daughter is basically cracking up. She didn't lose one kid that day; she lost two. And so I'm standing tall for my daughter, and I'm still fighting for people in the community. And so I really appreciate Dr. Anwar for making me feel comfortable to say this today. So I'm saying this today to speak for all the people who don't. There's a lot of parents that are suffering in silence in the Black community. They feel like if they say something, they'll get in trouble, or if they say something, nobody will listen. So I am here to say that this absolutely exists. But it's an emergency, all hands on deck. We need Black providers in the community. We need those who are of other races to have that cultural competency and pair up with, people in the community so they can understand us. And I just want to say this. I know this may sound a bit much. I come from Boston. I went to school in Needham. I have been around every race there is. My family and our friends are diverse. Other people aren't. But we as Black people, we're trained to know every other race. I know all the Italian foods, all the Irish foods. I know everything. However, white people aren't trained to know us. They find it very difficult to understand us. So if you're going to be in a profession where you service people in the community, it should be mandatory that you know all cultures, and not just the Black culture. But I'm here today to specifically speak for Black people, and I just really believe that this commission should be done a truth and reconciliation for us to heal. I will not leave Connecticut until I see that's done. And I can be anywhere I want to be. I'm an empty nester. My kids are 34 and they're 22. I really believe that with everybody working together, we can make this happen. And that's what I fight for.
Well, I can't thank you enough. So much of this testimony will stay with me long after today. And I want to call specific attention to the fact that what you're saying is that people are not even complaining because they know their experience is not unique.
No.
And because they know that when they complain, there is nothing that happens afterwards. So I hope that we all take this today as a clarion call to do something in your grandson's name and in the name of all the people that we won't know.
Right.
Because you're absolutely right. So thank you again so much.
Right. I just want to let you know that the facilities from which were responsible, I don't blame DCF. I have a really good rapport with DCF. I've never met a bad social worker. It wasn't even the DCF or higher. It was always the facilities, the service providers. And so I just want to let you know that nothing's been done on their behalf since then. I mean, and so that's been since August of last year. So that just goes to show how people are going through stuff and they just sweep it underneath the rug. It's just sad.
I again can't thank you enough. So thank you so much for being here today.
Thank you so much. I really appreciate that.
Thank you again for all your testimony and for your working with others, helping others, and all your tracking. You're still doing that. I don't see any other questions.
Okay. I thank you so much for listening. Yeah, thank you so much for listening to me. Have a wonderful day.
You too. Next up is number 60, Tamika McPhail, followed by Audrey Thompson.
Good afternoon, everyone. I'm sorry I did not unmute. My name is Tamika McPhail. I live in Bridgeport, Connecticut, and I stand in support of SB number 1. I serve as an Earth's Natural Touch I am an Earth's Natural Touch Birth Care and Beyond interdisciplinary doula student and a mother of 6. And Ms. Edwards, I just want to say thank you for your testimony because you do speak volumes for many of us mothers here. As a doula, what we see as far as in the healthcare system and racism, mothers are not given the opportunity to make decisions about their birth. They are having things done to them, episiotomies. They're having things done to them and their babies that they don't agree with. Black mothers are dying 4 times more than white mothers are. In my own experience, I'm a mother of 6. I almost lost one of my children in birth, trying to tell the doctor that the baby wasn't moving. We didn't see a heartbeat. I was induced. They tried to give me an epidural. After 13 hours of that, they did an emergency C-section and my son had to be brought back to life. And that was my second child. And each child after that, I sustained some type of traumatic experience. I had 4 different OBGYNs because I thought maybe it was just the doctor. I have given birth at 3 different hospitals because I thought maybe it was just a hospital. But I have come to see that it's not just the hospital. It's not just the doctors. It's a systemic issue. I am now the family doula because I don't let any of my friends or family go in to give birth alone because I know what can happen. Women, Black women go in to give birth and they don't come home. Babies don't come home. I just lost my 6-week-old nephew last March. And there's just things that happen that it's hard to recover from. And it's important for us to recognize doulas as professionals because we bring a benefit to childbirth, especially for women of color. We help give them power, you know. They get to say what they want and what they don't want. Their labors are generally shorter. They have less anxiety. They're using less pain medication. And just the overall experience is better when.
Ms. McPhail, you've reached your 3 minutes. If you'd like to give a conclusion, please.
Thank you. I just, want to go on to say that there are racial disparities in pregnancy, and a doula definitely helps create just a better outcome for birth for mothers of color. And so I hope that we're able to come to some consensus about adding doulas into the healthcare for pregnant women and birthing women.
Thank you for your testimony. I think it helps us all understand how important the doula's role can be in being the patient's advocate. With your experience with the system, you can help assure better outcomes, for which we're all very appreciative. And we're all pleased that you believe that the bill will be helpful in that regard and hopefully improve the circumstance for so many women of color. So again, thank you for your testimony. I don't see any questions, but we really do appreciate your coming to share with us today. Thank you. Next up is number 61, Audrey Thompson, followed by Catherine Morris.
Ms. Thompson, you're on mute. If you want to unmute yourself.
Okay. Good afternoon. Can you hear me? Hello?
Yes, we can hear you. Go right ahead.
Okay, good afternoon, Senator Abrams, Representative Steinberg, and members of the public health community. My name is Audrey Thompson, and I'm concerning long-term care facility with changes. I'm for the 1030 Act, Senate Bill 1030, because I think it could help with the level of staffing at the facility. I work at the Villa at Stamford in Stamford, Connecticut. I've been in this field for over 30 years. I've been at the Villa for 25 years. It was Smith House, then someone took it over. So I'm with this present company for 5 years. I love what I do. And I like taking care of the elderly, and I've been doing it so long, and it's like the resident becomes like a family member to me. And I just like to communicate with them, take care of them, and, do what I can, listen to them and enjoy them, Hello? Hello?
Yep, we can hear you. Go right ahead.
Okay.
We're listening.
Yes. With this pandemic, it hit all of us very hard. And I consider myself, being in this field for so long, a strong person. But during the pandemic, it affected half of the staff, which kind of weakened me as a worker because I didn't know if I was going to get sick or not. So that was one of my main things. I had a resident got sick, went to another floor and stuff like that. Some came back, some didn't. So that affected me too. And through the whole pandemic, you know, I haven't really taken, most of us, they haven't gotten a vacation. And it's like, you know, the residents' family can't come in. So we have to be the point of contact with the direct care. And I really love what I do. Even, I mean, the whole floor is not mine, but, you know, they'll come up to me, you know me by name. Audrey, I need this. Audrey. I said, oh my gosh, I don't know what you all gonna do if I don't come for a day. But I just enjoy what I do. And I'm an advocate for my patients and I'm an advocate for the workers. And if I need something for my patients, I'm gonna get it because I'm not gonna stop until I get it.
Ms. Thompson?
So if I have, hello?
Hi, Ms. Thompson. You've reached your 3 minutes if you would like to give a conclusion.
Yes, so this bill, you know, the Senate bill 1030, if it's gonna help to more staff, because lately we haven't had much staff, and that's my biggest concern. We need more staff in the unit so we can give more care and spend more time with the residents, because, you know, we need it at this time. With the family can't come, we are the point of contact. So we need to have enough people to give the care, to talk to them, to just be there for them, to listen to them. You know, so, I mean, I'm not going to take much of your time, but we need the help.
Well,
please.
Thank you. Thank you so much for being here, Ms. Thompson, and thank you for the incredible work you do. You know, as someone used to say to me when I was in my previous career, you do God's work. And that's what I think of you today. And how lucky the people that you work with are to have you with such a positive attitude. And such a love for what you're doing for them. So thank you so much. And I know that you and the other workers and the residents and, you know, have been through quite a trauma really in dealing with this pandemic. And we want you to know as legislators that we recognize that we're listening and that we're doing our very best to try to make things better moving forward. So there is a question, Representative Pettit.
Thank you, Madam Chair. Thank you, Mrs. Thompson, and thank you for all your service to so many people for so long. My question is, you've been in the field for 30 years, taking care of people hands-on. What is your perception as what is needed more? Do you feel like we're very, very short on CNAs? We're very, very short on LPNs? Where do you think the biggest need is? If you had to pick one spot, where do you think the biggest need is in terms of care in the homes?
CNAs. The direct caregiver. We are the direct caregivers, and you need more CNAs to give because, you know, I keep saying we need more people on the unit. I just don't think people are listening. And I, hard worker, I like to see my floor run right. If there's a problem, if I go to the nurse, I'll go to the supervisor, I'll go to the administrator if I have to, you know, but I think this CNA's level is not there. And many times I'm there, I'm getting frustrated and I'm stressed right now with the system. It's emotional.
Sure. You want to take care of people and not leave them in need. Yeah. On an average day with average acuity, how many people can you care for in a shift? Is 4, 5, 8? What's a typical load for you?
Well, I do the 3 to 11 shift, and you're supposed to have they give 3 CNAs, so you'll have 10 patients each. But sometimes the third person doesn't come until a couple hours after. You know, that doesn't cut it for me. I want the 3 CNAs on the unit from 3 o'clock, not 5 o'clock, or because you, the two that's there, gotta pick up that extra shift. So somebody's saving and somebody's back. And I'm frustrated.
That's it. You gotta be 15 minutes early and be on time, be prepared for your shift. I thank you for all the beautiful work you do, and thank you for taking the time to testify.
Thank you.
on the needs in
Thank
the
you
home.
for listening. I'm glad, because I've been putting it out in the atmosphere, and I'm glad it's being received. Thank you very much.
Thank you, Madam Chair.
Thank you, Ms. Thompson. It is being received and we do hear you. And
Thank you.
Please, thank you so much for the work you're doing. Have a
Thank
great
you
day.
too. Thank you all too for the job you're doing.
Thank you very much. Appreciate
Thanks.
that.
Bye.
Next we have number 63, Catherine Morris. Go right ahead.
Thank you. Dear Representative Steinberg and esteemed members of the Public Health Committee, my name is Catherine Morris and I'm testifying as a known scholar activist throughout Connecticut, a graduate student of public policy at UConn, and a steering committee member of CT Equity Now, and the daughter of Jamaican immigrants trying to live a healthy and prosperous life. When I first moved to Connecticut, I lived in Ansonia and Trumbull before moving to Bridgeport. From this, I learned how my zip code could dictate my health and my quality of life. Not only did my education suffer, my access to healthy food, clean air, unpolluted nature, and opportunity suffered as well. I've since lived in Storrs, New Haven, and now Hartford, and the pattern remains the same. Where there are more people who look like me, I have a lower chance of living that healthy and prosperous life. And this is not caused by the character of the city or my fellow residents, but rather the oppression we endure due to the color of our skin. This is why my research and work focuses on intersectional environmental justice, systemic racism, and health equity. I'm testifying in support of SB 1 because we must declare racism a public health crisis and take the serious steps to advance health equity across all social determinants of health. This means mitigating racism in housing and the natural and built environment, addressing the lack of affordable healthcare and the excess of biased providers, ending over-policing in neighborhoods and schools, closing the racial wealth gap and achievement gaps in education, increasing food and nutrition security, and strengthening community governments. While the path of progress is never easy nor straightforward, there's a clear beginning for hopeful journeys, and we are at that beginning, but only in making this declaration and passing SB 1 do we take that first step. I'd also advise that the next couple of steps include administering immediate distribution of essential health resources, supporting community mutual aid networks, and canceling rent and eliminating homelessness across the state. Only then can we truly begin to equalize comprehensive access to mental, behavioral, and physical health in response to the pandemic, which is killing Black, Latinx, and Indigenous people at disproportionate rates. Now's the time for us to commit to the work of rectifying the past and healing our wounds. Now's the time for us to choose people and equity once and for all. Thank you.
Thank you so much, Ms. Morris. What a pleasure to hear your testimony. I think you are a very humble person because not only are you looking to live a healthy and prosperous life, but you're working hard to make sure that others can do the same. And that's really something to be commended. So I thank you so much for your testimony. And I am just so impressed. You give me hope for the future of our state and the future of our world when we know that there are young people like you out there willing to work on these issues. Representative Gilchrist.
Thank you.
Thank you, Madam Chair, and thank you, Ms. Morris. I just want to echo what Madam Chair just said. I just appreciate everything you're doing to try and change the trajectory of our state and improve people's health. And so thank you for being here today.
Thank you all for being here and for considering my testimony and others' testimony. My heart is still with Antonia and Tamika in the last few speakers. Thank you for hearing us all.
Of course, it's our pleasure. And also, I want you to know that I agree with you that this is just, a first step in a longer journey. And so I hope that not only making the declaration, but also having some policy behind it and some, attempts at starting down that path. I hope that that can be appreciated and that we continue to work on this, because this is certainly not the finale or the destination. It's just the beginning. So Senator Summers.
Yes, good afternoon, and thank you for your testimony. I was wondering if you could speak in more detail when you mentioned biased providers and the different locations that you lived. I know you said you lived in, I want to make sure I have this right, Trumbull, then Storrs, Connecticut, which is very rural and very open. And then I think you said New Haven and Bridgeport, and that you had different access to healthcare in those different places. Could you speak more to that too? I'm really interested in that. And when you talked about the biased providers, could you speak more to specifically what you mean by that, or an example?
Yeah, so I first lived in Ansonia, and then I moved to Trumbull and then Bridgeport. I lived in Storrs as a UConn student. I lived in New Haven a couple of times, and I now live in Hartford. In terms of biased providers, I'm speaking generally in terms of research, but also in my personal experience with respect to, when you experience microaggressions, when you go to get a checkup from your nurses or your doctors, to I've unfortunately witnessed how my mother was treated when she was pregnant with my little sister. I've also heard the very harrowing stories of my aunts nearly dying in their birthing processes for my cousins. I know what it looks like to be dismissed during mental health emergencies. I've seen that with relatives of mine who struggle with schizophrenia. So again, that's why Antonia's really stuck with me. But yeah, so for that, in terms of biased providers, my experience personally in the different areas has not, it wasn't to speak towards that so much, but I do support, of course, Section 11 that speaks towards getting implicit bias training for those in the maternity sections. Yes, sorry, did that answer your question? I think there were other parts to it.
Kind of. So if there's implicit bias training in the maternity section, do you think that should apply across the board? Just not for
I do. I really do. I am conflicted because there's a lot of research that speaks on sometimes there's varying degrees of effectiveness when things are mandatory if there's not the proper consensus building amongst the staff in terms of how you go about implementing these things. However, I think it's necessary. Like it should still be mandatory, but how to address the fact that there will be pushback that may negate results is the next step of that work. Yeah, absolutely. But that also, in terms of the maternity and infant care specifically, I also very much support anything that will allow doulas to do the work that they need to do. It's very necessary.
So can I ask you another question? You said that the biased providers, that you had seen it with the way your mom was treated when she was pregnant from the nurses and the physicians. So did you find that more from the nurses or from the physicians themselves, or can you speak to that? I'm really curious on that, because I've talked to a lot of different folks. I represent an area that has a very large Native American population, and Groton is pretty diverse. We have people from all over, all different backgrounds, and it's been interesting to talk to them about sort of the bias in healthcare, and some of the comments that I've gotten from, regardless of what your skin color is or what your background is sometimes the maternity nurses are just not nice. So I'm curious as to what that specifically, if you could speak to that more. Did you was the experience of being felt, I don't want to put words in your mouth, but being felt like you were dismissed or not listened to? Because I'm hearing that like consistently across all different races in that particular area. So sometimes it's hard to distinguish. Can you speak more about that at all? Or
yeah, absolutely.
That would be helpful.
Yeah, absolutely. There was, of course, you're interacting with the nurses a lot more, and the difference between how her fears and concerns shifted when she had a Jamaican nurse, like we're Jamaican. So maybe it was the added familiarity that made it especially positive.
Right.
But she was essentially dismissed in terms of her fears, particularly as this was her fourth child. So people were just like, oh, you should be able to
You got
handle
this down, right?
get it together. You know what I mean? Rather than really hearing her. And she ended up having to stay in the hospital for an additional week because her blood pressure was too high and she was suffering through fibroids. But for the fact that those things were clearly present issues at the time of the delivery that eventually turned into an emergency C-section as well. Yet she was dismissed for hours before then. That's very much the problem. And of course that could have went in a worse direction very easily.
Right. Were you there with your mom, or did she have somebody with her, or were you there the whole time?
I was only there before the C-section, of course.
Okay. Do you think it would have been different for her if she had a doula present? She would have been able to be heard better, or be attended to in a different manner?
Absolutely.
Absolutely. Okay.
Yeah.
All right. I thank you for that. I'm just trying to get a better, a more concrete example of what you mean, because sometimes we use words and people have different interpretations of what they mean. So it was very helpful for me to get that example that you were able to give. I appreciate it.
No problem. As a social scientist, I appreciate follow-up questions. So no problem. I personally.
I'm
Are you
all
all
set.
set,
I'm
Senator?
sorry. Yes,
Okay.
thank you.
Representative Kavos Gabra. Thank you so much for your testimony today. I want to, since you are a social scientist, I want to just dig a little bit deeper about diversity training versus bias training. Why we need bias training, not just diversity training, because I think that there is a difference, and especially in terms of what we're talking about today, I think that that sort of helps frame the conversation in terms of why this is necessary.
Yeah, so I would say the difference when I see a lot of research in terms of diversity training, a lot of the times that as it's come up in like my education at UConn has been related to the functionings in non-medical sections, non-medical fields specifically. However, when it comes to bias, I think knowing very specifically the history of racism within the medical field, I think would be very telling. But in terms of diversity training, if the distinction is being made very clearly, that might look like showing how different illnesses show up on different race skin tones, for instance. Like that's a very specific form of, I suppose, training and understanding medical issues across races and ethnicities and skin tones. Whereas bias is specifically like, hey, there was a period of eugenics that played out in the American medical field. And there was a period of forced sterilizations, and there was Tuskegee, and there was so on and so forth, which I think is also extremely relevant in terms of when we deal with larger public health issues. This might be tangential, but it's something to address in terms of racism in a historical context and how we're having to handle vaccine disseminations given the COVID-19 pandemic now. So if you just need another very specific tangible reason for why these trainings are necessary and useful.
I think that's absolutely true, because not only have I heard people reference those historical situations in terms of the current vaccination rollout and in terms of the take up of those vaccinations. But also, I've had colleagues and friends say to me, you don't have to look historically because we hear these stories every day. I believe it was Dr. Morris who was not listened to and most recently. So I thank you for that, because I think that, I'm sure there is going to be more literature, or there probably is literature that speaks to what you just shared in terms of specifically in the medical field. So thank you so much again for your testimony today.
Yeah, I would just like to add that there are intersections in terms of what the Truth and Reconciliation Council would like to address when we're talking about mental health issues at the intersection of police brutality. Oftentimes, those are instances where care or ambulances were called to handle a mental health emergency. And we also know that there's a disproportionate amount of Black Americans who suffer psychosis who are imprisoned, kind of maybe as a result of something that they did while having a psychological episode. So these things kind of work in tandem with each other, which is why I appreciate how SB1 is seeking to address them in relation to one another.
That's a really good point. Thank you very much.
Thank you for having me. Bye.
Wait. Just want to make sure no one else had any questions for you. Trying to get rid of us too quick there.
Sorry.
Oh, that's okay. Nope, that looks like it's it. Thank you so much for being here, and keep up the good work.
Have a great day.
You too. Next up, we have Lucinda Canty.
Hello, everyone.
Welcome. Go right ahead.
Okay. So good afternoon, members of the Public Health Committee. My name is Lucinda Canty, and I live in Windsor, Connecticut. I stand in support of SB1, particularly Section 10. This policy is crucial to doulas in Connecticut. Title protection is crucial and provides a stronger identity and credibility and prevents misrepresentation of the profession. A doula is a non-medical professional trained in childbirth who provides emotional, physical, and informational support to persons who are experiencing labor, or have given birth. A doula's purpose is to help people have safe, memorable, and empowering birthing experiences. As a certified nurse midwife with 26 years experience in providing healthcare to women, it was alarming for me to learn the number of women who die annually in the United States, and that Black women are disproportionately represented in the number of maternal deaths. I wonder how a country with all the resources, technology, and education can have numbers comparable to countries that lack resources, even countries that are experiencing conflict and violence. I never thought that race and racism would play a role in women and if a woman would survive childbirth. In addition to being a nurse midwife, I'm an assistant professor of nursing at the University of St. Joseph and a researcher. I interviewed women who almost died during childbirth. All the women I interviewed had a high school diploma to doctoral degrees. They had support from their partners and their families. They started their pregnancies in the first trimester, attended all prenatal appointments, were considered healthy when they started their pregnancy, and they still almost died. And I say that because of implicit bias, because people think that these women are at fault. So when I talk to these women about their experiences, the common theme was a need for education and improved relationship with their healthcare providers, how race and implicit bias had an influence on their care, and how their lack of mental health evaluation and support, it was just not there. Doulas can address all of these areas and improve their overall health and well-being. I reflected back on my own childbirth experience when I had my son 11 years ago. First, I did not even realize that as a Black woman, I was at risk of dying. I had gestational diabetes, I had a cesarean birth. I could have been a part of those statistics. Although physically I recovered without complications, I had a difficult time adjusting to motherhood. The father was involved, I had family support, but I still found myself in a lonely space. And I was constantly questioning myself and wondering if what I was experiencing was normal. I didn't feel comfortable talking to my family. I couldn't talk to my obstetrician. I just felt like at first I couldn't articulate my needs, but I also felt that no one would understand what I was going through. And I wish I had a doula to help me transition into motherhood easier. At the time, I didn't have the financial resources to pay for doula care. I was insured, but I had limited income because I was on maternity leave. You know, doulas are one solution to decrease poor maternal health outcomes, especially among Black women. There's lower rates of cesarean birth, lower rates of low birth weight babies,
Ms.
and
Canty?
increase, oh yes.
You've reached your 3 minutes. If you'd like to give a conclusion, please.
Okay, sure, I'll wrap up. And I know that my focus has been on Black women because they're disproportionately impacted. If you improve the healthcare of Black women, you improve the health of a community. If you improve the healthcare of Black women, you improve the health of all women. So I just want to say that I am supportive of this bill and that I just want doulas to be recognized so that we can move forward and getting them certified so they can get compensation for their services. Thank you.
Thank you so much, Ms. Canty, for being with us today and for the work that you're doing on helping us get better outcomes for women through their childbirth and for their children as well. So I really appreciate that. And I just sit and shake my head when I hear those statistics over and over again. And this, I believe, is a step that is needed and long overdue. And I think we just have to keep looking at what the research tells us might improve it, because it's just not acceptable.
Yes, and just look at Black women as being human and that they have a right to a safe childbirth.
Of course. And I appreciate what you're saying too, that, you know, if we make sure that this is something that can help us address this horrific situation with the statistics that you shared about Black women and the mortality rate, it will help all women. I agree with you with that as well. And children, and that's what we want to do. So, so thank you so much for being here. I don't see any questions. Really appreciate having you.
Okay, thank you.
Next, we have number 66, Elizabeth Stearns.
Thank you, Senator Abrams, Representative Steinberg, and esteemed members of the Public Health Committee. And thank you also to all the CNAs who testified with passion and truth today. I assure you that the family advocates stand beside you in your ask for increased staffing ratios. This afternoon, I'm not speaking from my submitted testimony, but will be supplementing it with spoken testimony of additional facts, concerns, questions. None of what I say is hyperbole. I'm Elizabeth Stern. I'm a daughter. I live in Stonington, Connecticut. Many listening today know that my mother died in a Connecticut nursing home on November 3rd. She did not die from COVID-19. Today, I'm not grieving her death as much as I'm plagued by the 8 months prior to her death that she was in isolation, isolated from her loving family. As of November, there have been more than 40,000 excess deaths in nursing homes not attributed to COVID-19. Regardless of what many may think, these excess deaths continue, as does nursing home isolation. I ask that Connecticut address and honor those who have died and those who continue to live in isolation in long-term care facilities by restoring the residents' rights that have been lost since 1987, the rights that have been waived for over a year. A primary factor contributing to the 40,000 excess deaths is and continues to be the lack of monitoring, advocacy, and support provided by family. Establishment of an essential caregiver for every resident who chooses to designate one and will begin to establish residents' rights. The response to thousands of calls and letters to Connecticut DPH and nursing home administrators is we're following CMS and CDC guidance. CMS guidelines are just that, guidelines. The word should carries no weight. It appears that CMS has little authority with contractual regulatory agreements, thus creating grave loopholes in the endorsement of directives and guidance. In a word, the guidance has not and is not working. While my oral testimony may seem out of sync with today's agenda, I assure you that the reaction of many long-term care facilities to the revised March 10th CMS guidance has not been welcoming. Connecticut advocates are maintaining a record of nursing home responses that demonstrate ambiguous interpretations of the March 10th revisions and insensitive responses.
Ms. Stern, you've reached
Yes.
your 3 minutes. If you'd like to give a conclusion, please.
Okay. I want to conclude by saying this is not a dollars and cents problem. To date, Connecticut's reluctance to establish an essential caregiver, as 17 other states have, speaks volumes. The decision not to address mathematics as short-term number 5 is upsetting. I ask Connecticut legislators to demonstrate their understanding and support of this important EC program with swift action and enforcement of law that begins immediately to address grave oversights regarding the quality of life of those who have been left voiceless and isolated. I ask you to strike lines 124 and 125 from section 10 and replace it with a reasonable establishment date. Additionally, please strike line 132 and replace it with, quote, as determined by a resident or a resident's representative. 1 year, 2 shots. What now? How much longer must long-term care, people who live in long-term care, be isolated? The goalposts continue to be moved, and as restaurants, salons, and tattoo parlors open up, our loved ones in long-term care continue to be told they have limited access to family and essential support.
I'm going to have to stop you there, Mr.
Okay.
Boone. I
All right.
apologize, because actually the first thing I want to say to you is that I'm so sorry about the loss of your mother during this. And I just really, that must have been very difficult.
Not as difficult as the isolation, I assure you.
Yeah.
It really was not.
Yeah, under those circumstances, yes, I understand. And I really thank you for coming here. I think that the perspective of, someone like you who's lived through this, seeing your loved one be isolated in that way, it's really important that we hear that and that we consider it. So we do hear what you're saying. I don't see any other hands, so thank you so much for being here.
I look forward to further action, Senator Abrams. I really do, in a swift manner. Thank you very much for today's opportunity.
Thank you. Next, we have number 67, James Kitt. Pete? James, are you there? Oh,
Yes,
go
I'm
right
here. I'm
ahead.
sorry.
I see you.
Sorry
That's
about that.
okay.
I'm at work.
No, I'm probably saying your name wrong, so go right ahead.
No, you actually said it right. James Kitt, like a first aid. Okay. I just want to give a brief overview of what I feel like is the main thread of really comprehending the implicity of racism as attributed to a public health crisis in Connecticut, which is under the current proposed bill SB 55, which I'm fully in support of. If you look through the history of Black people in America, you can see that, one, we had slavery. We flew through slavery into Reconstruction era, Jim Crow era, which led to redlining, mass incarceration, the perpetual locking out of wealth, medical resources, and all the things that we can attribute to living a long and lasting life. And I feel like a lot of people aren't really comprehending the root of racism in America, and as it applies to the Black people who were here in America at the time of slavery and the offset of slavery being abolished. And I feel like if we really looked at the thread of the existence of Black American descendants of chattel slavery, we will really begin to see a clear synopsis of why racism in America is existing and has existed for as long as it has, over 400 years. If you look back, you will notice that every interaction that society and the US government, including the state of Connecticut, has had is chance and opportunity to do something right, to change the standard of living for the descendants of chattel slaves, for them to actually go through and actually not only acknowledge, but to also take part in the healing processes for these people who faced atrocities like lynching, which was also committed in front of children and women. There was also burnings where we would literally see our own relatives burned alive. There was instances of bombings on towns. There was instances of veterans coming home expecting to have a boost up in society, but virtually and almost explicitly being locked out of any tangibles that was supposed to be just given, but instead were restricted, and stopping these lineages of family lines from having an equitable chance at life. And I feel like every time we venture away from the root cause of slavery within Connecticut and within this country, we get farther away from the truth, from actually having a real reconciliation about the damages that these people have suffered. I personally am a Black American descendant of chattel slave. I have slaves on both sides of my family. And you know what I see? I see all the negative results of being part of a lineage that was rooted in oppression, rooted in atrocities, and rooted in savagery. And just
Mr.
looking back.
Kit, you've reached your 3 minutes. If you'd like to give a conclusion, please.
Okay, just to wrap this up, if you look at most of the preliminary problems within the Black community, which is a diverse community, you will see that a lot of complications that Black people have come from lineage trauma. It comes from perpetual trauma, not only within their lifetime, but within the next generation's lifetime and the next generation's lifetime. And it's going to only lead to situations like this. Unless we get a real due redress for the descendants of chattel slaves, I really feel like we're not really seriously tackling the problem of racism. But I do support this bill, and I thank you for my time.
Thank you so much, Mr. Kit. I really appreciate you taking the time to share that with us today. And I want you to know that as it's a humble start to try to address some of what you talked about in this bill. And we, I certainly, and I think many of my colleagues acknowledge that, but we also feel that it has to start somewhere. So I hope you can appreciate that it's certainly, I would never say that this is the be all and end all. It is not. But I hope that it is something to say that we hear you, we acknowledge what you're talking about, and we will continue to try to do our best.
Yes, I hear and I acknowledge and I appreciate the time to be able to contribute to this conversation.
Well, we appreciate your contribution. So thank you so much. Have a really good day.
Okay, thank you.
We'll keep working. Next is number 68, Doris Maldonado. Hello, Ms. Maldonado. I think we heard from you the other day. It's nice to see you again.
Nice to see you again. Buenas tardes, good afternoon, Senators Abrams and Anwar, Representatives Steinberg, Gilchrist, and distinguished leaders of the Public Health Committee. My name is Doris Maldonado, and I'm a Latina voter from West Hartford. I stand in support of SB 1, Beyond the Pandemic, with equitable inclusivity. I'm a certified teacher and a community health worker, statewide bilingual health information specialist for PATH-CT, and the Connecticut representative in the National Family Voices Cultural Responsiveness Task Force. PATH-CT has been providing informational and emotional support to hundreds of families who have a child with developmental or health-related needs since 1986. CT Casa, Kids as Self-Advocates, empowers youth ages 13 to 26 with special needs with a continuum of peer-to-peer empowerment. Tying community benefit spending to needs identified by communities is critical, especially to already marginalized communities. Many states have laws outlining community benefit spending requirements and reporting standards, but Connecticut does not. In Connecticut, 9.6% of financial community benefits are a far greater part of a hospital spending than spending 0.4% on community-specific programs. COVID has demonstrated the need and value of local community resources to maintain health in the times of vulnerability. PATH-CT promotes meaningful participation in the health of all special needs families in all communities by providing a triage of hope, peer support, and information to those coping with similar situations, the organizations that serve them to reduce isolation and social determinants, empowers families and as advocates for their children, and reaffirms their values as caregivers. We also support providers with cultural responsiveness training and engage in those overdue conversations. Declaring racism to be a public health crisis or emergency offers a clear path to intentionally acknowledging and addressing disparities and inequities. According to the U.S. Office of Minority Health Resource Center, Hispanic health is often shaped by factors such as language, cultural barriers, lack of access to preventive care, and the lack of health insurance. Females and several racial ethnic minorities groups are at greater risk for experiencing 4 or more adverse childhood experiences, and 61% of adults have at least one ACE. Many do not realize that exposure to ACEs is associated with the increased risk for health problems across the lifespan. Across the country, at least 185 different entities have declared racism a national public health crisis, as well as 20 municipalities in Connecticut. I'm a Latina with disabilities, adoptive mother of 17-year-old twins with special needs, and a thriving foster toddler. Between my children and I, we have over 15 disabilities. Health access is an essential human and civil right. Minorities with disabilities are perpetually marginalized and outcast even a year after we were forgotten and remanded to isolation without voice or choice. My eldest son,
You've reached your 3 minutes. If you'd like to give a conclusion, please.
Thank you. My eldest son, now a senior in high school, survived 16 days with a false negative diagnosis and subsequent suicidal ideation right after the world shut down. And right after my mother passed away, and following my aunt every other month thereafter. My 16-year-old niece was just diagnosed with COVID last month. Last year, I had electrical shock treatment. We survived daily with COVID, but my son works at a market. My partner is the only Latino LPN, formerly a CNA, and one of 2 males in a residential facility. I'm already orphaned. Please don't allow me to bury my children because of systemic neglect. Keep your promise. Thank you.
Thank you for being here with us today. Again, Ms. Maldonado, it's good to hear your perspective on these bills.
Thank you.
I don't see any questions at this time, so have a nice day.
Thank you.
Next is 69, Durrett Idosio.
Hi.
Hi, welcome. Go right ahead.
Yes, good afternoon. My name is Dorothy Docio. I live in Waterbury, and I have worked as a CNA at Glen Hill for 7 years. I come before you today in support of SB 1030. I really love my job as a CNA, although I do it out of choice. I'm actually an accountant because I love caring for the residents. I enjoy talking with them, and I generally like doing everything for them. I profoundly see and believe that if we live long enough, we will see our second childhood. And this is why the care we give, my coworker and I, we give it out of sheer love. I feel that when care is driven by money and not love, the nurses and the CNAs, I feel, are treated like fools, and the residents suffer. One way that this manifests is low staffing. To save money, nursing homes will staff at the bare minimum. When this happens, CNAs like me must rush around trying to complete our task in 8 hours. This leaves us no time to converse with the residents, to provide them with social interaction that they strive on. We also have no time for ourselves. My coworkers and I often skip our breaks to get everything done. This is very stressful, and ultimately the care that we provide is not adequate. Another issue we deal with in the home is poor infection control training. We are often given contradictory directives. We need better education and topics we can ensure, providing care is safe for ourselves and for our residents. The training should be offered in multiple languages. Our staff is bilingual, and it's mostly given in English only. Working during the pandemic has been the most stressful time in my life. This is only worsened when enough PPEs were not provided. We were often forced to wear a mask that was only deemed to be worn once. We felt like fools. I personally felt like a fool marching to my death, but I still went to work, and we continue to work caring for our residents. I strongly support SB 1030 because it seeks to address these issues. This bill will increase staffing ratio. Currently, the ratio, I would never say what it is, which is desperately needed. This will make giving care easier and less stressful. This bill will also create training standards that ensure multilingual staff receive the same training as English-speaking staff. This is critically important to ensure quality of care is provided universally. Finally, this bill will require homes to provide 3 months of
Ms. Adocio, you've reached your 3 minutes. If you'd like to give a conclusion, please.
Okay, in conclusion, I think that most people, I don't think they're understanding the needs and the value of CNAs and the LPNs. I will take the RNs out of it because we are the grunt workers. We give the hands-on care. We are the eyes, the ears, and everything to the facility. We see everything. If we don't see and we don't report, nothing is basically done because we are seeing the resident 24/7 once we're there. So I think the appreciation for CNAs should be more noted. We need more staff. We need better pay rates because CNAs basically live on the poverty level. And I think.
Thank you so much, Ms. Adosa, for your testimony today. I hope that there are at least some provisions in this bill that address some of your concerns. It was certainly our intention. And we do very much appreciate the work that you do. It's vital. And we thank you so much for what you're doing, that you've chosen this career. I don't see any questions, so have a wonderful day. Thank you for your work and thank you for being here.
Thank you.
Next is number 70, Chelsea Daniels.
Hi.
Hi, go right ahead.
All right. Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Chelsea Daniels, and I'm a licensed practical nurse working on a behavioral health and psych unit at Fresh River Healthcare in East Hartford, or East Windsor, I'm sorry. I work 32 hours weekly on the 3 to 11 shift. I'm here today to testify in support of Senate Bill 1030 with some small changes to the staffing ratio language. First of all, thank you for changing the staffing ratio to 4.1 direct care hours. We have been pleading for a change like this for years. With a ratio like this, homes will be forced to hire more workers so that we can be in compliance with this new law. The only change I would suggest is changing the LPN hours to 0.75 and the RN hours to 0.54. I'll tell you why that matters. I'm an LPN, and in terms of direct care, CNAs and LPNs give more direct care than RNs. As of right now, I'm responsible for 34 patients. Most of them have a high acuity psych and medical history, and I also have half unit of a dementia floor. To be short and straight to the point, workers like me need more staff to do our jobs. This is not optional. It is a must if the state wants us to continue to care for these residents. We are no longer providing care for the little elderly neighbor next door who fell and ended up in a nursing home. Some residents are combative. They require time and attention for redirection. For example, here's how I prioritize my shift. I work an 8-hour shift. 7 of those hours are dedicated to residents and their needs. 1 hour is designated for oncoming shift narcotic counting, report from the offgoing nurse, a possible lunch break, offgoing shift narcotic count, and the nursing report. Again, I care for 34 residents. So in 7 hours, that breaks down to about 12 minutes of care per resident. And that does not equate to a continuous 12 minutes. That is 12 minutes in total throughout the day, the entire shift. That means 12 minutes dedicated to preparing medications. Some people have a lot of meds, administering treatments, which can be a lengthy process, administering medication. Some people need encouragement to take it, and documentation on multiple platforms. All while hoping to have time for the basic conversation that most residents are eager to have. If we include other unexpected events that happen frequently, falls, admissions, doctor and nurse practitioner orders, phone calls, various incidents, then we barely have time to take the breaks that are legally available to us, if we have time to take them at all. It has been extremely difficult working with so many residents. Connecticut has just become comfortable allowing us to work under these conditions. The patient to staffing ratio has not changed in years. We are exhausted. I have a family at home and I can't continue to burn myself out at work. I love what I do and I need to make a living, but I'm seriously considering a career change. I'm frustrated with the brokenness of the medical system and I am tired. I will leave you with this to ask. In order to pass a bill like this, we need to have funding for staffing. My residents deserve to have quality health care. Nursing home workers are always left out of the budget or included in an extremely disproportionate way. Please pass Senate Bill 1030 and help us advocate for funding for nursing homes. We need it. Please treat us like heroes.
Ms. Daniels, you've reached your 3 minutes if you would like to give a conclusion.
Yep, in conclusion, thank you for the opportunity to testify today.
Thank you, Ms. Daniels, and thank you especially for giving us that very clear understanding of what your job responsibilities are and what your workday looks like. I think that's very helpful. Representative Foster.
Ms. Daniels, thank you so much for being here and testifying with us today. You work in a healthcare center in my district, and I just wanted to thank you so much for the work that you do to care for people in our community. And also, I did read your name in the news on WNPR this last weekend, and I just feel like you've given us a lot to work with, and I want to make sure you know that you can come to me at any time, and I'd be happy to work with you in any way that I can. And thank you for helping share your story and your experience with us today in our decision-making process. Thank you.
Thank you. We appreciate your support.
Thank you. Thanks, Senator Abrams. That's all.
Thanks, Representative Foster. I don't see any more hands raised, but thank you so much for your testimony. It was very helpful. Appreciate it. Have a great day. Next is number 71, Rhonda Caldwell.
Hi, good afternoon.
Hi,
Senator Abrams. Thank you. Senator Abrams, Representative Steinberg, and other ranking members of the Public Health Committee. My name is Rhonda Caldwell. I'm a lead organizer at the Hamden Action Now activist group. We're a group of folks in Hamden demanding equity and justice to the Black, Brown, and Indigenous people. I'm submitting my testimony today along with a broad coalition of Black, Brown folks and disabled folks in Connecticut who are in full support of SB 1 and SB 55. Let me start by saying I'm speaking on behalf of the medical rationing that has been conducted in wake of the COVID-19 public health crisis. We are generally in favor of this legislation, but we have some changes that we'd like to see in the legislation. So regarding the language that we would like to see added to SB 1, our advocates have been calling upon the Connecticut DPH for almost a year to issue uniform guidelines to hospitals prohibiting disability, age, or race discrimination and the rationing of life-sustaining measures should rationing become necessary because of COVID-19. Many other states long have since issued this type of guidance, and as of today, the Connecticut DPH continues to refuse. It should not matter which hospital you go to or your race, age, or disability. No one should be denied treatment based on racist policies, such as SOFA scores that are designed to result in a denial of treatment, whether based on a discriminatory policies, absence of any policy, or implicit bias. Implicit bias is a part of our American culture, and basing life-sustaining healthcare measures because of it continues to make sweeping decisions on healthcare options that are made available to Black and Brown people who are most often born with healthcare vulnerabilities and pre-existing conditions. Our Connecticut DPH has refused to issue critical guidance, hospitals utilizing a specific criteria for patients to receive care uniformly. And at this time, each hospital around Connecticut continues to make their own decisions on who receives life-sustaining care currently and have widely varying policies, putting all vulnerable people at further risk. Although my fellow coalition members, along with my coalition members, I strongly urge you to add specific language to address this matter. One of which is prohibiting any kind of policy that gives care based on age, race, or ethnicity. Unacceptable. There should never be an age tiebreaker, okay, on making these kind of considerations. Also, we should actually never have a person be admitted to a hospital and have a piece of equipment be taken from a current patient and given to a patient who has been added in, who has just been recently admitted to the hospital. And SOFA scores, you know, they must include reasonable accommodations during triaging folks, and based on, and really, it should be not, you know, we have to understand where these SOFA scores are just numbers, and we cannot attribute a number to mortality rate. It's unacceptable. So that just leads me to my second point of my comment with you today. This is just another example of the systemic
Ms.
racism and
Caldwell,
bias.
you've reached your
Yes,
3
ma'am.
minutes. If you'd like to give a conclusion, please.
I'm going to summarize now. So in summary, this is just another example of the systemic racism and bias that continues to plague our society. In this case, as with the continued intersectionality of killing of Black and Brown people by police officers, ongoing housing segregation in the state of Connecticut, over disciplining of Black and Brown students in school, creating the ongoing school to prison pipeline, wage discrimination, and all of which precipitates pre-existing health conditions, makes it clear that racism is a public health crisis in the state of Connecticut. And I mean that literally. After enduring all of this, we arrived to a hospital seeking to receive fair and equitable life-sustaining treatment, and hospital boards and old-style hospital death panels are deciding whose life has more value and who gets to live and who gets to die when rationing care. Racism is literally a public health crisis, and we urge this community to make these changes to SB 1 and the passage of this very desperately needed legislation.
Thank you so much for your testimony, Ms. Caldwell, and the work that you're doing, your ongoing advocacy. It's greatly appreciated and greatly needed. So thank you for that. I don't see any hands raised, so thank you for being here and have a wonderful day. Next, we have number 72, Sinai Jahara. I'm sure I'm saying your name totally wrong. If you'll please correct me.
You were kind of close. It's Sneha Jairaj. Hi everyone, and I want to give a big shout out to all the healthcare workers in this Zoom call, like especially the CNAs and the LNs and everything, because you all are definitely doing the work, and also the organizers. This is tiring. So my name is Sneha. I live in Rocky Hill, Connecticut, and I'm in support of this bill declaring racism to be a public health crisis. Well, this says that it's a response to the pandemic. I think we needed this declaration since the beginning of America, in quotes. While I could talk about personal ways racism has affected my immediate family, well, a lot of people on this call can. I'm going to focus on my workplace. So I'm a contact tracer for the Department of Public Health. I work at a local town department, and racism has showed up in my job multiple times as a contact tracer for the state. And so one way that racism has been seen is, one thing I do as a contact tracer, first of all, is call people who are COVID positive and provide resources if they're needed, and also just track the symptoms as well. And also call like different places if they have like a contact with a positive person, then we also just sort of let them know like, oh, hey, a positive person was here, right? So currently I'm a contact tracer for a town that is majority white. And so you would think I'm calling up a lot of people who are majority white. However, this is inaccurate. The people who I'm reaching out to are mostly people of color, employees working at Walmart, and also the overnight people of color shift workers at Amazon. So we see a lot of this like exploitation of workers of color in these corporations, which I think a lot of people just aren't speaking out about, just because there's so many protections that are given to corporations, and definitely in regards to COVID. And when we even look at these different sorts of places, right, like Walmart, for example, like, yes, the managers, most of them are white, but when you look at the employees, most of them are people of color. So then we see like this disparity already, and it's mostly the employees getting COVID. So we see this sort of exploitation already of where's the PPE, are people getting notified that they are around people with COVID, and a lot of times, they're not. So I think I think there's a lot of like stories that contact tracers can tell of a lot of different things happening in Connecticut, around Connecticut. And something that someone also said about nursing homes as well, like that the nursing home culture was always like not good to CNAs, like even before pandemic started. But what the pandemic does is the pandemic accelerates, or it really shows what all the problems of America are. So even with with the nursing home, for example, like the CNAs, they need to get paid more. Like what they
Ms.
get paid, like,
Jairaj, you've reached your 3 minutes. If you'd like to give your conclusion, please.
Oh, okay, thank you. Sorry. Okay, yeah, let's see. Okay, in conclusion, I'll just end with like Data Haven's like statistic. on like how the Northeast end of Hartford's life expectancy is 68 years old, but Avon's life expectancy is 88 years old. So we see this 20-year difference in life expectancy in towns that are 10 miles apart. That makes no sense, and that's just criminal, honestly. So definitely public health crisis needs to be addressed in policies that address economically, because we know that poverty is directly linked to health, right? So we need to increase people's wealth, and how to do that is we need to make sure everyone has food, housing. So this is so linked to a food crisis, housing problems, and not just food, healthy food. We need to make sure people are eating well too, because everything that we're eating, is impacting us. And that same thing with COVID too. When we have a good, strong body, it's gonna help against the comorbidities. And thank you so much for giving me the opportunity to talk.
Thank you so much for being here and sharing your perspective with us. We really appreciate it. I don't see any hands raised, so thank you for being here and have a wonderful day.
You too. Thank you.
Next, we have number 74, Michelle Embry-Q. Go right ahead.
Thank you, Chair Doherty, Abrams, Chair Steinberg, Ranking Members Huang, Summers, and Pettit, and distinguished members of the Public Health Committee. I am Michelle Embry-Q, Chairman of both the Newtown Board of Education and the CABE State Relations Committee, and I'd like to speak to SB 1. The Connecticut Association of Boards of Education strongly supports the efforts to ensure that students have the school and community support necessary to help them deal with their social and emotional needs, particularly as those needs have been exacerbated by the impact of the pandemic. We are concerned, however, that a provision of SB 1 as currently drafted would not be practical to implement. Section 1 proposes to require that boards of education conduct an exit interview with students who withdraw from school prior to graduation. Some students may be unavailable or unwilling to answer some of these questions or participate in such an interview. As an alternative use of resources, CABE has long supported the interagency partnerships to connect children and families with comprehensive services, including counseling and mental health, and it would be more valuable to ensure that school districts have resources available to proactively identify students in need of support and make sure that the supports are available. So CABE supports greater and sustained resources that expand access to mental health services and support comprehensive wraparound services. It's also imperative that our professional development be made available to teachers to enhance their ability to support students who have experienced trauma. I thank you for your attention and happy to entertain questions at this time.
Thank you very much for your testimony. I believe that that portion of the bill is really to look at whether or not a student may be withdrawing because they're not getting the supports that they need to stay in school, and to make sure if they do withdraw that there is a plan in place for their future, so that they could move ahead with their lives. So obviously we're willing to work with you and to come up with a way to accomplish that if this particular language doesn't do that. But I think it is important that we make sure that students are not leaving school because of situations that we could address for them.
Absolutely, we would agree with that, and it may just be in the wording, and we would be happy to work with you on making sure that that wording is something that we can implement in our school systems.
Yes, thank you so much. I appreciate your willingness.
Thank
I don't
you.
see any hands raised, so thank you for being here, and let's keep working on that part because I think we both want the same outcome in the end. So thank you so much.
Thank you.
Next, we have number 73, Dana Schmidt. We can't hear you.
Sorry, thought somehow I got missed.
Nope, go right ahead.
Okay. Good afternoon, Senator Abrams and representatives and members of the Public Health Committee. As you can see, my name is Dana Schmidt. I'm a licensed clinical social worker and I'm a school-based behavioral health clinician working in school-based health services for community health centers. I would like to thank you very much for allowing me to speak today and provide evidence to contribute to the need for the SB1 and Act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. I've worked as a therapist since 2003 in Connecticut, and I have worked primarily with underserved and underprivileged adolescents and their families. Right now, I currently work in a school-based health center, providing individual, primarily individual therapy for adolescents and family work through telehealth as we are just entering back into the schools now. I thought it would be best if I quoted some of my students and parents on how the need for the service is. A junior female that I see said, I like the fact that we can do telehealth sessions around my school schedule. And when I come back to school, I will have you to go to when I have panic attacks. I am really anxious when I am in school regularly, but wearing a mask makes me feel even uglier and insecure. I am really glad that you are in the school when I go full time so that I can have you to come to as a support. A junior female that I see, this has helped me a lot during the pandemic in multiple ways. The most valuable thing about having sessions is it feels like I have a safe space to let go all of my feelings to a friend. It doesn't feel like I'm being forced to talk to an adult. It feels like I'm talking to one of my lifelong friends. A 10th grade student, I am very grateful to have my therapist. She has helped me with my anxiety so much in ways that she doesn't even know. I look forward to our sessions every week. I feel so good not having to rely on pills, thanks to being able to meet with my therapist and have video sessions through telehealth through this pandemic. One more is a sophomore student who came from New York City. The parents moved right in the beginning of pandemic from New York City
Ms.
to.
Smith, you've reached your 3 minutes if you'd like to give a conclusion.
Yep. So right in the beginning of the pandemic, and she said, I had a lot of underlying things that I needed to work on as far as my expression of emotion, lack of socialization, anxiety, and depression. The pandemic and the school in New York City didn't help with these feelings either, considering the amount of stress that I went through. However, therapy has helped me to open up more than I would ever without it. I have been able to put myself in situations I am not necessarily comfortable with. An example being talking to new people first and writing emotions that I feel down on a piece of paper. Dana has been helping me to battle the various issues. I really appreciate you letting me testify today. And the adolescents, many, many lives that school-based services help is so crucial. And the access to care is so crucial. Thank you very much. If there's any questions.
Thank you, Ms. Smith, for being here and for testifying. Appreciate hearing those personal remarks. And thank you for the work that you're doing.
Thank
Have
you.
a great day.
You too.
Next is number 75, Tanya Beckford. Go right ahead.
Okay, here I go. Good afternoon, Senator Abrams, Representative Steinberg, Senator Anwar, and the members of the Public Health Committee. My name is Tanya Beckford, and I live in Manchester, Connecticut, and I have worked at Newington Rapid Recovery Rehab Center as a CNA for 24 years. I love walking into my residents' room and seeing their faces light up when I enter. Although some of them are battling Alzheimer's dementia, which causes them to forget my name at times, they know that I am a friend. I am sick and tired of hearing the word heroes being thrown around from frontline employees, essential workers, especially those in the nursing home, hospitals, and other healthcare setting, because we have been disrespected throughout this entire pandemic. Whenever a hero catches COVID, they have to also worry about providing for their families and paying their bills. Instead of providing the proper PPE to protect their employees and the resident in their care, some employers choose to ration out PPEs, forcing some of my coworkers and I to wear trash bag because we didn't have enough gowns. I don't only blame nursing home operators, I also blame Barbara Cass, the Chief of Healthcare Quality and Safety at DPH, who said that we prefer to wear trash bags. This level of disrespect is just disgusting, to say the least. Our residents depend on us to provide their daily ADLs, which include feeding, exercising, entertaining, and spending time with them, especially now that their families are not allowed in the facilities. The service we provide are not just essential, but necessary for their survival. Better staffing level will impact the resident greatly because we would be able to spend more time with them to feed them hot meals before the other meals become cold. We will be able to give them timely care when they are soiled. We will be able to give them the quality of care that their already taxpayers' money are paying for. I know that it sounds like a broken record, us asking for more funding for staffing and raises, but if these bosses wasn't using 365 days a year as a blood sport with administrators on ciphering the proceeds from the funding that are allocated for nursing home for the care of our residents, from providing sustainable staffing, then it wouldn't seem like a broken system that you guys are providing funds for, because of hearing so much testimony about this systematic abuse in areas that are powerless in their voices, which are our elderly residents. So why would someone want to come into a nursing home and work hard for just $14 an hour when they could go to McDonald's or Wendy's for the same amount of pay, but less stress and risk? I support SB 1030 because it addresses some of these issues. This bill would require nursing home to keep a 3 months stockpile of PPE at all times, which is a good first start, but it should be 6 months stockpile. This bill will address low staffing by raising standard for ratio, which will improve the quality of care we can provide our residents. While there's nothing in this bill to address low wages, I believe these two proposals will make a positive impact on nursing home fields. Please pass
Ms.
SB
Beckford, you've
1030.
reached your 3 minutes. If you'd like to conclude.
Thank you for your time.
Thank you very much, Ms. Beckford, for being here, and thank you for the work that you're doing. And I heard you when you said you don't like to be called a hero. You'd rather see action. I understand that. And this bill is our attempt to try to do that. So thank you so much for being here. Next is number 76, Darlene Dupre. Go right ahead.
Yes, good afternoon. Thank you very much, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. Can you see me? Have I done this correctly?
Yes, we can see you and hear you. Go right ahead.
All right, thank you. My name is Darlene Dupre. I'm a charge nurse working at Westside Care Center in Manchester. I've been a nurse for 12 years working in the long-term care setting. In 2019, I spoke in front of the Appropriations Committee about staffing. 2 years later, I've witnessed no remarkable changes that affect direct care for the patients I serve, and I truly serve my patients. Senate Bill 1030 would make some of those changes needed that I have been waiting at least 2 years for. I want to just interject a little bit. Anybody that knows me is not at all surprised. I want to applaud Representative Cook. I've had the opportunity to have this committee meeting on all day today, and I've learned a lot, and I've seen some faces of people that I didn't know. I commend her for myself and my coworkers for bringing forward what happened to the money that was set aside for the frontline workers. Hazardous pay, as hazardous pay is described for the military, we were in hazardous pay. So thank you for that little interjection. I celebrate the handful of states who have, after years, changed their mandated hours per patient per day from 1.9 hours to 4.1 hours. As a floor nurse, I have an average of 30 to 35 patients in an 8-hour shift. Honestly, I'm lucky if I can spend 5 to 10 minutes with each patient. We no longer care for the simply aging patient. Our patients are being sent right from the hospital, which much higher levels of care, or acuity, which seems to be a big buzzword these days. Much higher level of care needed from the nurse and nursing assistants. Can you imagine your loved one in a long-term care setting and only seeing a flash of the nurse in 8 hours? Can you imagine you worked hard your whole life with the reassurance that the government was going to take care of you? What a slap in the face to our ill and aging population. My God. But today we are all here to talk about changing Connecticut's mandated hours per patient to 4.1. This bill would be an improvement. I only ask that you change LPN hours, which I am, to 0.75 instead of keeping them at 0.54. I would be remiss if I
Dupre,
didn't.
you've reached your 3 minutes. If you'd like to give a quick conclusion.
Oh, wow. Okay, I'm going to do this one. I would be remiss if I didn't mention the year of the pandemic. We now call ourselves heroes to zeros. I will never forget the sheer fear in the eyes of even the most seasoned of floor staff, but we showed up day after day, shrouded by gross uncertainty, and without PPE, we would not abandon our patients. For those of us that survived, we suffered layoffs, which made staffing even worse. Why the layoffs? Money, of course, money, money, money. This bill mandates minimum staffing hours that make sense, and they've been needed for a long, long time, and requires PPE stockpiles in the event of future public health emergency. I agree the state should be involved with that. These corporations will continue to squeeze every last ounce of life from direct caregivers like me and our patients if you don't pass this legislation. Let me say one last thing.
Well, Ms. Dupree, actually, you're over your time.
Thank
So
you.
I'm going to have to stop you there.
That's okay.
But I do very much thank you for being here and for testifying. And I do want you to know that there are many people on this committee who recognize the work that you've done during the pandemic. And we do very much appreciate it. And this bill is, just a small attempt at trying to acknowledge that and to try to move things forward. So
I hope so. Thank you, Senator Abrams, and thank you all the members of the committee for your time today. Good day.
Thank you.
Thank you, ma'am.
Next is number 77, Carol Cruz. Right ahead.
Thank you. I moved my camera in the wrong direction. So good afternoon, everyone. My name is Carol Cruz. I'm a woman in long-term recovery from substance use disorder and as well as depression. I just want to thank Senator Abrams, Senator Hong, Representative Pettit, and also other speakers, Ms. Smith, Ms. Morris, and James Kite, I believe his name was. I'm sorry. I'm a little nervous, first time doing this. So I'm here to testify in opposition of Section 2 of SB 1 and equalizing comprehensive access to mental health and behavioral and physical health care in response to the pandemic. I just want to also just shine a light on, we are still in a massive epidemic of opioids that is reaching marginalized communities, all folks of all races and ethnic, economic backgrounds. But in this section, I wanted to oppose because we're looking to authorize the Commissioner of Public Health to provide the certification and education and peer support. So I am a certified peer recovery support specialist. I have been for the last 7 years. I also do training in around with agencies like CCAR, and I have had my training through Advocacy Unlimited as a peer support, but I am certified by the Certification Board of Connecticut. And I feel that our position would be compromised if we were to have to be credentialed by the Commission of Public Health, which mainly license I'm a person that reaches people due to my lived experience. I am a non-clinical role, and it's super important for me to wear that hat where I don't have bias or agenda, and I'm able to build rapport and trust with the people that I serve. So if we turn this into a more clinical, it wouldn't look any different as a licensed drug and alcohol or behavioral health counselor. And the CCB is well equipped with giving us the necessary standards and ethics to help us in our role. So what I'm looking for is for us to build a better workforce and platform for peer supports. We have many people that are working in their and volunteering in their lived experience, and we need to provide that out there, helping those that are struggling not only with the pandemic, but with the epidemic. So with that,
Ms. Cruz,
I'd
you
like
reached your
to-
3 minutes if you'd like to give a conclusion.
Yes. So I just want to say that we must trust the science, which is the data, and that's working, and keep building a better workforce for the peer role. But we also know the art, and that's about human connection. And we all know that we've been very disconnected during the pandemic. So peer support can provide alongside of peer-centered care. And we've been doing it for decades. And we don't need to be part of an agency that has no idea of what our role is. And we do need the support of dismissing this part, and please support our bill of 6588. Thank you.
Thank you so much, Ms. Cruz. It might be your first time, but you were very effective. And so I hope it isn't your last time coming before one of our committees and testifying. There's a couple questions for you. Hang on. Representative Kennedy.
Thank you, Madam Chair. And more of a statement than a question. I just wanted to welcome my fellow Milfordite and friend, Carol Cruz. Thank you for being here. But most importantly, thank you for all the advocacy work that you do. You do so much in not just the Milford community, but the surrounding communities. And I know how passionate this is for you. So thank you for being here to testify. It's wonderful. And you did a great job. So
thank you so much.
Thank you, Representative. Representative Betts.
Thank you. I think I need to take lessons from you on how to give testimony. You did an excellent job. Even if you said you were nervous, I thought you were pretty compelling with what you said. And in particular, I completely agree with you about the value and importance of peer-to-peer communication, particularly from people who have actually lived and gone through it. And I absolutely agree with you. You probably have more skill and ability to help another person because you have gone through it as to any other kind of licensing thing that DPH would provide to you. Not everybody should have to be licensed to be able to help another individual. And I know several people in the Bristol area who have done that. So I wholeheartedly support what you're advocating for. And I also thank you for taking the time and dedication to doing it, because it really does make difference for people who are trying to recover. So thank you very much.
Thank you so much. And I just wanted to add that I'm not opposed to collaboration. I'm all about community collaboration and connection and caring. So I truly believe that we could collaborate, but I don't feel that we need to be licensed as peer recovery support specialists.
Thank you.
All set, Representative?
Yes, thank you.
Sorry, I just never know with technology if someone just got cut off, so I try to make sure. Thank you so much, Ms. Cruz, for being here, and have a wonderful day. We appreciate it.
Thank you so much.
Next, we have number 78, Sarah Lemaster. Welcome.
Hello, thank you. Thank you. My name is Sarah Lemaster. I'm the Manager of Government Relations and Public Policy for the Community Health Center Association of Connecticut. I wanted to first thank the committee for raising Senate Bill 1, and this is, I think, a really vital step in moving forward and building back better. The Community Health Center Association serves Connecticut's health centers serve 400,000 patients every year. Many of these patients identify as members of communities of color. Many of them are Hispanic, they're Black, they're from from a lot of different racial races and ethnicities. And our health centers really pride themselves on being able to effectively serve these communities. I'm also immensely proud of the work that our health centers have done in responding to the COVID public health emergency. At the start of this crisis, we rolled up our sleeves. We just acquired and distributed millions of units of PPE, including N95 masks, gowns, hand sanitizer, everything we could find. Not only that, but our health centers have been immensely flexible in the way that in restructuring the way that they provide care to their patients. At no point did I ever hear that anyone wasn't able to take care of someone. We restructured what we did. We bent over backwards. We figured out how to continue providing care to our communities. This bill is really important for a number of reasons, and I specifically want to address sections 5 and 6. Section 5 creates within the Office of Public Health an Office of Public Health Awareness and Response. At the beginning of this pandemic, we had stockpiles of PPE and other equipment for health center staff. Some of it was disintegrating because there wasn't enough oversight, or we didn't check enough boxes. I know that the state stockpiles didn't have adequate amounts of PPE to address a public health emergency of this magnitude. There were things that had been expired in various corners for years and years that were not usable. I had providers that had to tie on masks or tape them to their faces. This created a tremendous amount of chaos. So really creating this office is a really important step in making sure that the state, our health centers, our hospitals, that every healthcare entity will be able to be safe, make sure their patients are safe, and make sure that their providers are safe in the event of another public health emergency. So thank you for making sure that that was a section of this bill. In addition, sections 6 and 7, I think correctly identify and articulate the scope of the impact of racial disparities in our healthcare system. And I think that more importantly, these sections really set in motion a slew of policies that will help the state to correctly identify and address the different aspects of our health system that are inequitable.
Ms. Lemaster, you've reached your 3 minutes if you'd like to give a conclusion.
Thank you. I just wanted to say thank you again for raising this bill, and I look forward to questions.
Thank you so much. Representative Cavros DeGraw.
Yes, thank you, Ms. Lemaster, for being here today. I think you were on the verge of saying something about the inequity in the health system. So if you wouldn't mind just finishing that, I'd like to hear from your perspective where you see the most in the inequities.
Yes, thank you. So our health centers, so 61% of health center patients receive Husky and Medicaid benefits. Many of our health center patients, as I mentioned earlier, are identify as being from communities of color. It's important in any legislation moving forward that with the goal of addressing inequities in the health system, that we have a discussion about the scope of limitations within Husky benefits, and we need to make sure that our discussion ensures that patients who receive those benefits have equitable access to care and to providers that can take care of them. In a lot of cases, there are administrative and other barriers to receiving that level of care, and the discussion moving forward needs to encompass the scope of expanding Husky benefits to include individuals having access care to additional providers. That's what I'm trying to say. So thank you.
And could you, is that when you say the administrative barriers, is that what you mean, the access to the providers, or what are the administrative barriers?
So from the health center perspective, for example, I know that Representative Foster has a bill in another committee to allow Medicaid recipients to access dietitians. Our health centers would love to be able to hire a dietitian, but because of various barriers in Medicaid administration or in the way that these benefits are administered, it's not feasible to do so. Dietitians would have a tremendous impact on many health center patients. A lot of our patients are diabetic, they have hypertension, they have chronic issues that they would greatly benefit from having access to that level of care because of various different components of the way that these benefits are administered and the way that the payment structure that's in place. Access to those it is harder to make that connection from the standpoint of the health center to the patient to the provider. So I'm just saying that we need to have a holistic scope in terms of ensuring that access to different components of the health system that may not be encompassed by this bill entirely need to be addressed, if that makes sense.
It does, and I really appreciate that. I am familiar with Brett Foster's bill. I actually am co-sponsoring that, and I think that you're pointing to the larger issue that if we can work on some of these health issues sort of at the root cause, which could be food insecurity or diet, then we will have better outcomes and that actually saves money in the long run. So I appreciate that you referenced that bill and for your testimony today. Thank you so much.
Thank you.
You all set, Representative? Good. I don't see any more questions, so thank you for being with us today.
Thank you very much.
Appreciate it. Next, we have number 79, Raphael Podolsky. Oh, great. Sorry about that.
Senator Abrams, thank you very much. Thank you, Senator Abrams, Representative Steinberg, members of the Public Health Committee. Thank you for the opportunity to testify today. My name is Raphael Podolsky. I'm a lawyer and a housing policy advocate with Connecticut Legal Services, and I'm here to speak in favor of Senate Bill number 834, which is the bill about notice to tenants of drinking water contamination. I think the bill's fairly straightforward. Under existing practice, what happens is if there is any kind of, if there's contamination in drinking water, notice goes out to the consumers of the water, but for purposes of water companies and other providers, consumers are the people who are their customers. So effectively, the notice goes out to the customers. In rental housing, the customer of water, unlike say electricity, is not typically the tenant, the occupant is typically the owner of the property. And all that the bill says is if the property owner gets such a notice, the property owner should pass it on to his or her tenants. Without that, the tenants are unaware that there's a problem with the drinking water or other equivalent situations. The language of the bill is such that it's not entirely clear if it covers all providers of water or not. I hope you will make it so it does cover all providers and sources. And with that, I think it's sort of a common sense bill, and I hope that the committee will support it. I'm happy to answer any questions I can.
Thank you very much for that testimony. I agree, it is common sense to let the people who are consuming the water know the quality of the water that they're consuming. So it is my intention to try to address that in some substitute language and get it right. So thank you for being here. Hang on one moment. Senator Wong.
Thank you, Madam Chair. I just wanted to take a moment to say hello to Rafi and thank him for all of his longstanding, tireless work on behalf of housing and all various aspects of legal support services. I miss you in Hartford, and I hope you are well and healthy. And thank you as typically advocating on behalf of protecting renters and consumers. So kudos to you. It's great to see you. I hope you're well and safe and healthy.
Senator, thank you very much for those thoughts. I appreciate it.
I don't see anything else, so thank you for being here. Appreciate your testimony today.
Thank you.
Nice to see you. Next, we have number 82, Faris Sasa. It was
Yes.
close.
Yes, that was close. Thank you very much, Senator Abrams. Thank you very much to everybody for the opportunity to speak today. So my name is Faris Sasa, and I'm a second-year medical student at Quinnipiac University's Frank H. Netter School of Medicine, and I'm also a resident of Hamden, Connecticut. And today I'm here to speak in favor of the bill SB1, an act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. And my thoughts today are my own. And so as we enter over 1 year into this pandemic, now seems to be a good time to analyze our response and whether we were able to take effective actions to protect ourselves. And I think the answer has emphatically been no. So as a society, we were unable to prevent the rapid spread of the virus. We were too cowardly to enact tough health and economic policies that would have saved lives during the beginning of the pandemic. And ultimately, we were too arrogant in reopening during the summer, causing the dramatic spikes we saw during the winter. And so with these local, state, and federal failings, these ultimately led to the unnecessary deaths of over 535,000 individuals. And so with the dramatic effects of climate change, the rapid rate of urbanization throughout the world, and the continued destruction of the wilderness, the risk of another pandemic level illness just increases by the day. And this is why I believe sections 4 and 5 of the proposed legislation are incredibly necessary steps that need to be taken to both understand the pandemic we're still working through and to prepare ourselves for the inevitability of the next pandemic. And so if we continue our analysis of our pandemic response, one thing becomes abundantly clear, and that's those identifying as minorities within our community have endured an unequally heavy burden during this pandemic. Minority communities consistently suffered greater losses and received less help, even though the SARS-CoV-2 virus treats us all equally. Within our own state of Connecticut, Black individuals are dying from COVID 25% more than white individuals. Hispanic individuals are dying 50% more. At the height of these disparities, deaths among Hispanic individuals reached 100% more than white individuals and 50% more for Black individuals. All this data was collected from the UConn Health Disparities Institute. And then looking at vaccine distribution, Black individuals have only received 3.4% of vaccinations, and Hispanic individuals have received 5.2% of vaccinations. This is despite making up 10% and 14% of the state's population respectively. And this doesn't even account for the unequal burdens of disease that these communities have suffered. These issues of racial inequality in healthcare do not start and stop during this pandemic. These numbers are a continuation of a long-standing and disturbing trend that has seen the systematic mistreatment of racial and ethnic minorities at the hands of the healthcare, criminal justice, and economic systems, the effects of which on the health of these communities has been detrimental. Therefore, I believe it is imperative that this bill be passed, which includes sections 6 and 7. These sections looking to declare racism as a public health crisis and to establish a Truth and Reconciliation Commission to examine the racial disparities in public health care. This bill is a desperate needed first step to righting the centuries of mistreatment of these minority communities at the hands of the powerful. I thank you all for your time.
Thank you very much for your testimony, Mr. Sassa. We really appreciate it. I don't see any questions, so have a nice day. Next is number 84, John Brady. Go ahead, Mr. Brady.
Good afternoon and happy St. Patrick's Day, Senator Abrams, Representative Steinberg, and members of the committee. My name is John Brady. I'm a registered nurse and the Executive Vice President of AFT Connecticut, a union of 30,000 members in healthcare, education, and public service. Thank you for the opportunity to provide testimony today. AFT Connecticut supports SB1 and would like to offer some thoughts and suggestions. We agree with the objectives of Section 1. The reason that students withdraw from school should be identified when possible, and resources should be provided to that student. We ask that as we provide this needed support, that we also recommit ourselves to providing support during the student's academic career and address issues in real time that will decrease the withdrawal rate. We believe these two efforts work in tandem, and we support both. Section 4 and 5 concern a study by DPH on the state's COVID-19 response and preparations for future pandemics. We agree it is critical to fully understand our response and be better prepared for the next pandemic. Sections 6 and 7 recognize racism as a public health crisis and address it. This pandemic has made the issue even more clear, and we support this as a policy for the state of Connecticut and these efforts to address it. Section 8 addresses staffing in intensive care units. We support a ratio of 2 patients to 1 nurses in an ICU. We would suggest that this be listed as a minimum ratio, with the ICU nurse able to make a 1-to-1 based on the acuity of the patients. We would also suggest that there would be enforcement mechanisms, including fines if hospitals violated this section, and that non-nursing staff would not be decreased with the implementation of these ratios. Section 18 deals with community needs assessments and steps to make them more responsive to the communities that hospitals serve, and we support this effort. Currently, Hartford Healthcare is involved in a certificate of need process, which has entered labor and delivery services to a predominantly rural, low-income, and brown community in Wyndham. We have concerns that the needs of the community have not been fully taken into account, and that the last community needs assessment did not fully reflect the community needs. This bill addresses that. I want to thank the senators who have proposed this legislation and commend you on your commitment to Connecticut's children's, parents, and caregivers. And thank you so much for the opportunity to testify today.
Thank you, Mr. Brady, for taking your time to give us your feedback on the bill. Really appreciate it. I don't see any questions, so have a nice day and thank you for being here.
Thank you.
Next is number 85, Danielle Cleary.
It's okay, it's Claire, but everybody says that, so no worries.
Okay.
Good afternoon, everyone, senators and honorable members of the Public Health Committee. My name is Danielle Claire. I am a school-based health clinician at Broadbrook Elementary School employed by Community Health Center, and I'm here to speak on SB1, an act equalizing comprehensive access to mental, behavioral, physical health care in response to the pandemic. So in my experience with school-based health clinics, I've noticed that it's imperative for reaching those in need of services who can't access them because parents can't bring them, and especially because of the financial requirement. Co-pays are high, deductibles are high. I had a parent the other day, I felt so bad. She said, if it weren't for you guys, I wouldn't be able to have my kids in therapy. She has 6 kids, and she's very grateful for the fact that we're all here to help her and help her kids, especially through the pandemic, which has been challenging. In my experience in a non-school-based health clinic, I've seen a lot of parents back out of therapy when their kids really need it. And so I'm grateful for the school-based health clinics able to reach those clients. And it is important to kind of expand where those school-based health clinics are so we can reach everybody. Well, everybody we can. And so throughout the pandemic, I think school-based health clinicians have been beneficial because we've been able to work in person with a lot of the clients. Most of us have, whereas many agencies are still doing telehealth, and a lot of my kids have not been able to do telehealth. So when I was back in person, everybody was excited and thrilled that I was a real person and not a face on a screen. So I feel like if the school-based health clinics were not an option, that a lot of these kids would not be getting the help that they need. And just kind of a word from one of my kids. I started seeing in the beginning of the pandemic, she told me she's grateful that she can come. She feels better. She can use different coping skills when she's sad. And it's nice to be able to come when she's at school so that she can do her after school activities and not have to worry about anything else. So in summary, there are many benefits to school-based health clinics. They've been helping children for many years, reaching those in need who are not able to access services otherwise. And I think there's further need for more school-based health clinics throughout the state so we can continue to provide the services that we need. They need, not us. Sorry. Woo, that was a lot.
We understood what you meant.
Okay.
Thank you so much for being here and for your testimony and for your spirit of the day, it looks like. So happy St. Patrick's Day.
You know what? I forgot to say that in the beginning. So happy St. Patrick's Day. Thank you for the opportunity. I hope you guys are able to get done soon. I know that's a lot of stress. So have a wonderful rest of your day.
We really enjoy hearing from everyone. So thank you for being here. Appreciate it. Next is number 87, Irma Rappaport. Go right ahead. Ms. Rappaport, we can't hear you. It looks like your microphone's, it looks like you just muted yourself. So if you can unmute. We still can't hear you or see you at this point. Ms. Rappaport, why don't we try to work on that, and I'll move on to the next person, but I'll come back to you, okay? So next is number 88, Jane Highland.
Hello.
Hello,
Are they
go right
here?
ahead.
Oh, thank you. So good day, Senator Abrams, Representative Steinberg, and honorable members of the Public Health Committee. My name is Jane Highland. I'm the Director of School-Based Health Services for the Community Health Center Incorporated, headquartered in Middletown, Connecticut. And I'm presenting testimony on SB1, an act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. And I'm going to be presenting testimony on behalf of Deirdre Bennon. Deirdre is a family nurse practitioner. She practices at 2 school-based health centers operated by Community Health Center. And Deirdre is vaccinating at Pratt & Whitney Mass vaccine site today. So she asked me if I would step in for her. So in Deirdre's words, last week, I saw a high school patient for an in-person physical exam. In reviewing the patient's chart, I noticed that months ago, the student had lab work, which was extremely abnormal and indicative of new onset diabetes, potentially leading to liver disease and high cholesterol, as well as another metabolic disorder. The patient had been referred to the endocrine specialist that they had seen previously, but for varied reasons, the appointment had been delayed until April. The child had elevated blood sugar levels in the clinic despite not eating that day. So I sent the child immediately to the emergency department at CCMC to receive treatment. My ability to see the student in person in school allowed me to identify a significant health risk, intervene, and get the child the care that was needed. In my medical practice, I often identify students in need of behavioral health services, and I work very collaboratively with the social worker in the school-based health center to give and receive referrals when needed. I perform a PHQ-9, which is a depressive screening on each of my patients over the age of 12. My screenings for mental health issues don't stop there. Other days, like today, I have a patient who does not screen positive on the PHQ-9, but who has a behavioral health need that I am able to identify by talking to them, asking about their lives, and from the trusting relationship that we have established over the years. I learned that that patient, who I saw for a medical appointment for an unrelated diagnosis, had recently lost a parent and has been isolated because of the pandemic. This student has been having daily anxiety and panic attacks since the death of the parent. The student has never sought out help or discussed this with anyone before today. I was able to provide a warm handoff directly to the social worker, who met immediately with the student to engage them into services. I frequently make referrals to behavioral health for other concerns: depression, acute stress, family issues, suicidality, self-injury, grief, or history of abuse and neglect that I identify because I get to know the student and I have the time to ask about their lives. The real beauty of the school-based health center model, especially within the high school setting, is that we are helping a generation of young people learn how to advocate for themselves, and we're teaching them how to be responsible and access care. School-based health centers are so effective because of the access that the students have to us as providers.
Ms.
I want
Highland,
to
you've
thank
reached
you.
your 3 minutes if you'd like to
Certainly.
give a conclusion.
Thank you. Yep, I thank you very much for your time. I hope my testimony helps demonstrate the value that school-based health centers provide to our children and to our communities.
Thank you very much for your testimony, and please thank Deirdre for her service in giving out the vaccine, and tell her that you represented her very well.
Oh, thank you so much, Senator Abrams.
Thank you for that.
Thank you.
Have a great day. I don't see
Thank
any
you.
questions at this time. Next, we'll go back to 87 again. Ms. Rappaport.
Thank you.
Oh, good. Go right ahead.
Sorry about that. I have a new laptop. I went to my phone. Thank you. Good afternoon, everyone. I'm testifying in favor of the Bill 1030, Section 10, about establishing an essential caregiver. My mom passed away in a nursing home last month. I finally got to go in to be with her the few days before she died. She was critically dehydrated, which caused kidney failure. I saw up close terrible bruises, skin tears, dry skin, pressure sore, teeth not brushed, and stick-thin limbs. I was a witness to how it was without me helping her in the home every day, which I did multiple times a day for 6 years before the pandemic, because I looked in her windows several times a day. Whenever I came up to the window, she was always sitting alone in front of the TV until it was mealtime. And then CNAs came in for a short time to set up her food and sometimes feed her. My mom had severe Alzheimer's, but still knew who I was and said my name. She did not know anyone in the home. Isn't that important enough that I should have been allowed in there and not just see her 6 feet apart at a weekly outdoor visit, or through a window where we could only wave at each other, but I could not help her eat or drink or take good care of her body? Shouldn't I have been allowed in there when I heard her screaming at the aides helping her with the blinds closed? but she did not scream when I helped her. Shouldn't I have been allowed in there so I would have known it was very hot in the room she was moved to during the pandemic, but they kept the windows closed? She was unable to walk or hear well. The only quality to her life was to feel loved. Shouldn't I have been allowed to sit with her and hug her and hold her hand, to bring her outside in the fresh air whenever the weather was nice? I saw things at the window that weren't right and called or shouted through the window so many times during the 11 months. Sometimes they said they were busy. Sometimes they glared at me. I was a big help to them before the pandemic, but now it's just adding to their burden with my requests. One nice afternoon in the fall, I was at the window looking at her anxiously as I heard her saying, "I can't stand it in here. I want to go out there." And she pointed in my direction. I called home immediately and then came back to the phone and they said, "Sorry, we're too busy." Too busy to make the life of one of their residents a little happier? That's what this is really about. That's why an essential caregiver is needed for every nursing home resident forever. We make their lives happier. Not only that, but the love and help and support we give them is really vital to their lives. I would respectfully ask if the rule makers of these visiting restrictions have gone up to the closed window of a resident's room at a nursing home and seen how difficult it is communicating to the resident and staff. I would ask if they think they can help a resident of a nursing home drink in order to avoid dehydration and UTIs when standing on the other side of a window. I myself did not work outside the home or socialize during the 11 months my mom was in lockdown. I was not a health threat to residents, especially wearing a mask. And now that vaccinations are being done, there's even less excuse not to let essential caregivers in so they can add to their family's quality of life and keep
Ms.
them
Rappaport,
alive.
you've reached your 3 minutes if you'd like to give a conclusion.
Yes, before it is too late, like it was with my mother, who I miss so much. And even if the pandemic ends, essential caregivers need the elevated status of this title to gain more respect from the home for all the help and close monitoring of their loved one, which can only be done on the inside. Thank you so much for letting me testify.
Thank you. And thank you for your patience in helping us get you on to testify. Appreciate that. And I just have to say that I'm very sorry for the loss of your mother. It was, a terrible time to have to go through that. No time is a good time for that, but this was a particularly difficult time to have to go through that. So my condolences. Hold on a minute, Senator Anwar.
Thank you, Madam Chair. Thank you, Ms. Rappaport, for your testimony, and I'm sorry for your loss. But your testimony was very critical because I can tell you your story is similar to thousands of stories in our state, except some of them may not have been as bad, and then some were unfortunately a little worse. But I just want you to know, yes. And again, look, the people are trying to do the best that they can, but having a family member and a patient advocate is very critical. And I think now, as more and more people are getting vaccinated and the nursing home residents are also vaccinated, we have to follow some of the better CDC guidelines to try and get access. I think we were not prepared intellectually and otherwise, and we saw some of the worst case scenarios of the disease spreading. And then many of the times it was because of lack of enough PPEs for the workforce, and the mixing of the patients was part of the challenge in the process. But your testimony is similar to what I have heard from a number of families who have had their loved ones get unwell. So thank you again. Thank you.
Thank you.
Thank you, Ms. Rappaport. Thank you for being with us today. And again, so sorry for your loss. But keep up your advocacy. It's important.
I certainly will. I want everybody I know who isn't able to get in to get back in before it's too late. Thank you.
Thank you. Next, we have number 90, Mary Avery.
Yes. Hi, good afternoon, Senator Abrams, Representative Steinberg, ranking members and members of the Public Health Committee. My name is Mary Avery. I am an AARP volunteer and a daughter of a parent who received services in a local nursing home before the pandemic hit. I am an advocate for and speaking in support of Senate Bill 1030. I advocate increased staffing ratios, training for staff, adequate infection control, training with infection control practitioners to drive that training and to protect the most vulnerable residents. I'm also a registered nurse. My mother was nonverbal as her Alzheimer, actually her dementia increased and she required a lot of care. For example, she required about 30 to 40 minutes to be fed. I visited every day or paid someone privately to feed my mother because the staff didn't have time to feed her. And it was heartbreaking to visit and see so many other patients languishing in bed or in wheelchairs, and many ate their meals cold. The workload for the staff was too heavy. And I visited daily because I needed to keep an eye on things too, and to demonstrate that my mother had an advocate. In the 13 months my mother lived in the nursing home, I was invited to 2 treatment plan meetings. That's inappropriate. And that's not regulation. And it's inadequate, obviously, to plan, evaluate, or coordinate care. I worked as a nursing assistant before I went to nursing school, and the staffing ratio was similar. Now, that was 45 years ago. Staffing ratio today is similar to what it was so many years ago, but the residents today are much sicker. I might have had the same amount of residents, but only 2 of them, 3 at the most, needed feeding. So the workload wasn't as heavy. The other thing I would say is most residents in the long-term care facilities need more time, not less, for ADLs. Feeding, bathing, dressing, toileting. My mother walked into the nursing home. She used a walker. However, within about a month, she was wheelchair bound. She was wheelchair bound because staff, although they knew how to help her, did not have the time to get her up and ambulated. So bottom line is, we need to remember we will all age. And is this the way we want to be treated? Is this the way we want our family to be treated? I urge you to pass Senate Bill 1030. That's why I became an AARP volunteer, really to advocate for seniors, because I'm going to be a senior really soon too. So, so there's a little self-serving, but it's the right thing to do. So thank you.
Thank you very much, Ms. Avery. I already meet the senior criteria by AARP standards, so I'm already there. So I appreciate your advocacy.
Okay, thank you.
I don't see any questions, so have a nice day. Thank you for being here.
Thank you. You too. Bye-bye.
Next, we have number 91, Samantha Liu. Go right ahead.
Good afternoon, Senator Abrams and esteemed members of the Public Health Committee. My name is Samantha Liu, and I'm testifying today on behalf of Health Equity Solutions, where I serve as the policy analyst and advocacy specialist. And I'm also testifying today as a member of the Doulas for Connecticut Coalition. I'm speaking today regarding Senate Bill 1, Section 10, defining the doula profession. So we strongly support defining the doula profession, and we just want to thank the Department of Public Health for their continued support, and especially in SB 1 for the doula profession. We support efforts to study to determine whether the Department of Public Health should establish a state certification process for doulas, and respectfully recommend the Doula Scope of Practice Review Committee include a doula representative to help inform the committee. Defining the doula profession is crucial to doulas here in Connecticut and can really advance health equity by offering a key step towards Medicaid reimbursement. So title protection provides stronger identity and credibility and prevents misinterpretation of the profession. I know that you're all aware of the dramatic inequities in health in our state, and that these are not new to our current situation. So I won't read my testimony today that we've submitted, but I just wanted to highlight and uplift a few key pieces of the doula profession. So doulas empower pregnant people to have safe and informed birthing experiences by providing comfort, care, and safety during, before, and after birth. Doulas can specialize in a variety of evidence-based skill sets to support the birthing person, newborn, and family, and works as a member of the client's multidisciplinary team. A doula does not give medical or clinical advice, as well as does not perform medical or clinical tasks. So increasing equitable access to doula care services, particularly in minoritized communities, has been shown to improve health outcomes for both mothers and newborns. We believe that moving towards more equitable access to doulas starts by defining the doula profession with SB1, and we just respectfully recommend that lines 204 to 207 reflect that a doula means a trained non-medical professional who provides physical, emotional, and informational support to a pregnant person before, during, and after birth, in person or virtually. And our recommendations are also listed in our testimony. Thank you so much for the opportunity to testify today in support of defining the doula profession. I'd be happy to take any questions.
Thank you, Ms. Liu, for your testimony, and thank you for the work that your agency does. We appreciate it. I don't see any questions at this. Oh, excuse me, Representative Gilchrist.
Thank you, Madam Chair. Sorry for the late hand raise. I just also wanted to thank you, Ms. Liu, for not only the work you do at Health Equity Solutions, but your work on the Doula Coalition to bring so many different voices together to get us a really strong proposal. So thank you.
Thank you.
Okay, thank you very much for being here. Have a great evening. Next, we have number 92, Stephanie Dakers. Stephanie, are you here? I don't see you.
Hi.
Oh, there we go. Go right ahead.
In support of SB 1030, good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Stephanie Dakers Dawkins. I live in Hamden, and I've worked at Regal Care New Haven Nursing Home as a CNA for 3 years. I come before you today to urge you to pass SB 1030 with changes so we can improve nursing homes for both the staff and residents. I love working as a CNA because I enjoy working with people and caring for the elderly. Within my role as a CNA, I can see the positive effect my work has on the lives of my residents. I do feel frustrated, though, by the staffing levels in my home. We are always shorthanded, which results in staff falling behind in our responsibilities and becoming burnt out. One person cannot do the job of 3. With the way things are currently running by nursing home operators, we are being set up to fail. Another thing that frustrated me about work is the lack of PPE for me and my coworkers. We are healthcare workers, and yet we are not treated this way by the management or the state. We are not provided with the PPE we need from management. When we are given PPE, we are told to reuse it, even when it is a single-use PPE. This leaves us vulnerable to not only contracting the virus, but potentially giving it to our coworkers, our residents, and our family. I support SB 1030 because it would address both staff and inadequate PPE in nursing homes. The ratios in SB 1030 are great, although I would increase LPN hours and reduce RN hours. I would also remove the proposal to increase shifts to 12 hours. That will only make burnout among staff worse. Furthermore, I think the proposal to mandate nursing homes have a 3-month stockpile of PPE is good, although I would increase that to 6 months. With these slight additions, I think this bill will go a long way in improving nursing homes. Please pass SB 1030 with these changes, not just for nursing home workers like me, but for the residents that we care about and care for. Thank you for your time.
Thank you very much for your testimony. Appreciate having you here, and thank you for the work that you're doing.
Thank you very much. You too. Stay
Have
safe.
a nice evening. Next is number 94, Roha Youssef.
Hello, Senator Abrams, Representative Steinberg, and members of the Public Health Committee.
That's a lot.
I have special greetings for Senator Kasser, who represents our interests in Stanford, Representative Gilchrist, with whom we have worked in the past, Representative Linehan, who welcomed us with open arms when we testified for mental health services before the Committee on Children, and Senator Moore for her encouragement during our testimony before the Human Services Committee. My name is Roja Yusuf, and I'm a member of 2 student activism groups at Brian McMahon High School at Norwalk. I am testifying on behalf of those groups in our sister program at Stanford High School. I am testifying in support of SB 1, especially Sections 6 and 7 about racism as a public health crisis. I will summarize our written testimony. We have just finished celebrating Black History Month at my school, but this testimony and this bill are about Black futures and the futures of my Hispanic, Indigenous, and Asian classmates and those who will follow in our footsteps. The declaration in this bill is an important step because it represents the state's official acknowledgement of the lived experiences of hundreds of students and sets the state on a path to review policies and practices that perpetuate racism, as noted by the resolution of the City of New Haven and the remarks of Bob Duff, our hometown state senator. I am proud to say that my hometown has already charted a path. Since July 2020, my school district has been conducting to review and identify the racist curricula, policies, and practices that do not support the social, emotional, and academic success of students and may actually contribute to the marginalization of scores of students. And just this morning, the mayor of Norwalk and the city's Equity and Justice for All Commission announced the hire of a firm to lead a review of city policies that, as one speaker said, may perpetuate inequities in our city. Remember, the policies of cities and schools touch many aspects of students' public health lives, aspects of our lives that have been revealed by the pandemic and racial strife. I'm talking about unstable housing, access to physical and mental health care, food insecurity, and school discipline policies. Given the role that a cross-section of my classmates play in our city and school districts' policy reviews, we encourage the committee to include student representatives, especially Black, Hispanic, and Indigenous students, on the Truth and Reconciliation Commission, the creation of which is a critical and crucial first step on the state's healing journey. We realize and encourage you to pass the Senate Bill 1. Thank you for this opportunity for me to testify.
Thank you, Ms. Youssef. You give me much hope that change will happen. You are a very articulate and very knowledgeable young woman, and we are so grateful for you taking the time to testify in front of us today and for your advocacy for this particular issue, and I'm sure many other issues as well. So thank you for that. Hold on, we have some questions for you. Representative Gilchrist.
Thank you, Madam Chair. Thank you, Ms. Youssef. I love the program at Brian McMahon and love working with you all and learning from you all. So thank you for being here, and thank you for your recommendation of including young people on this board. I think that is a fantastic idea, and we can really learn a lot from you all. So thank you.
Thank you so much.
Thank you, Representative. Senator Moore.
Good afternoon, Youssef. I just want to congratulate you on being a young person who understands the greater impact of racial disparities and racial injustice that's taken place. And I leave my hope with you and young people like you. I have some other young people who are in high school or in early years of college who are doing this work. And I think you are the hope of the future, and you're the ones that are really going to make a difference for us. So I want to thank you. I'm not surprised at your delivery. I'm seeing a lot of young people who understand, who are not just mimicking something that they read, but who understand the greater impact that this has. And I think your recommendation is a great one. When people come to the table and they don't like something or they think it could be better, it's important for you to have a recommendation. So I salute you in that also. And
thank you so much.
Thank you, Madam Chair.
Thank you, Senator. I don't see any other hands raised, but thank you so much for being here. And really, you do give us hope for the future. So keep up the good work.
Thank you so much.
Have a nice evening. Next, we have number 97, Miguel Castro. Are you there, Mr. Castro? Oh, hello, Miguel. How are you? Welcome. Go right ahead. Miguel, you're on mute. So try that again. There you go. Go right ahead.
Thank you, Senator, and thank you, everyone. And I appreciate the opportunity. I am sharing my thoughts today with regards to SB 834. And before I begin, I would like to acknowledge and recognize the great and tremendous work and leadership that both Senator Abrams and Representative Steinberg have, and others have really put into this great piece of legislation that is going to advance not only awareness, but also opportunity. My name is Miguel Castro, and I am a former council person, and I'm currently the chairman of the Connecticut Hispanic Democratic Caucus. I am here in support of this Senate bill, SB 34, an act concerning water quality notifications. And it's important to know that environmental racism can take many forms, from workplaces with unsound health regulations to the siting of coal-fired power stations close to predominantly non-white communities. It can mean citizens drinking contaminated groundwater or being schooled in decaying buildings with asbestos problems. Many of these problems face low-income communities, the undocumented community as a whole. But race is often more reliable indicator of proximity to pollution and many issues that affect minorities in our community. Combating environmental racism may risk falling down the policy of the age of COVID-19, and yet with non-white people more likely to die from the virus, the higher instances of complications for minorities are always enhanced. The factor of asthma and heart disease and members of our community, minorities, the undocumented community, it is enhanced even more. Environmental racism is a part of the broader picture of systemic racism, which must be fought to bring about a fairer society by creating a mechanism in which our community is properly informed, properly notified in both Spanish and English. Is
Mr. Castro, you've reached your 3 minutes if you'd like to give a conclusion.
Yes, ma'am. It's a win against environmental racism. And I believe that this bill, SB 834, do exactly that. Thank you for the opportunity to speak.
Thank you, Miguel. Just to be clear, you're speaking on behalf of the caucus?
Yes, I am.
Thank you. We really appreciate your taking the time to testify today. Obviously, it sounds like it is something very central to the mission of your caucus. And we're glad to have you be here to comment on it. I don't see any questions for you. It may be a reflection of the time of day, but we appreciate it nonetheless. Thank you for taking the time and being so patient and being with us. Thank you.
Thank you. And thank you, everyone.
Next up is number 98, Gregory Allard, followed by 100, Nicole Hampton.
Good afternoon. Can everybody hear me okay? All right, great. So good afternoon, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Greg Allard, and I'm the president of the Association of Connecticut Ambulance Providers, president of the Connecticut EMS Advisory Board, and vice president of American Ambulance Service in Norwich. On behalf of the Association of Connecticut Ambulance Providers, I wanted to raise a concern with Section 13 of Senate Bill 1, I did provide written testimony so that you can look at that at another point, but I'm just going to summarize today. Section 13 of this bill requires the Commissioner of Public Health to establish a pilot program allowing EMS personnel to conduct home visits in consultation with community health workers. We appreciate the recognition of EMS and the value providers can have beyond responding to emergency situations. I do, however, want to point out in 2019, the legislature recognized the value of mobile integrated health with the passage of Public Act 19-118, Section 64 through 68. The establishment of this pilot program would be duplicative to the efforts of this act. Unfortunately, the implementation of MIH and a process for approving MIH programs was not adopted by the Department of Public Health due to a budgetary concern. We did suggest some language changes in our written testimony, and again, I would refer you to that. And we did ask for you to fund the Office of Emergency Medical Services. They're looking for an oversight position to allow for the MIH program to exist. OEMS would have the ability to approve and deny such programs, ensure local provider input, and provide transparency. The legislature should make it clear that this be a priority and leaving it up to local healthcare providers and the community to establish such programs. Again, we don't think that this pilot program is needed to implement MIH and to develop home visit programs with community workers. So we need your help in supporting that Public Act 19-118 and require DPH to comply with the intent of the legislation while ensuring appropriate funding. Thank you for the opportunity to provide testimony. Our association and EMS providers throughout the state stand ready and willing to work with the committee on strengthening healthcare for all citizens. Thank you.
Thank you for your testimony and for all of your good work. I know you put a lot of time into this subject of getting MIH up and running.
Thank you, Representative Steinberg.
Yeah, certainly do. Obviously, we're going to cut DPH a little slack for the past year, given that they've been, I guess the word preoccupied is an understatement with everything else they've had to get done. And under the best of times, we know they often struggle to have the resources to take on the new responsibilities we add on to them every year. So to your point, I share your impatience with being able to move forward with this. I recognize it may be still some months before that's a realistic assumption. But to your point, the funding has to be there to make it all possible. And this is something we will look into further.
Thank you.
I don't see any other questions. Thank you for reminding us our responsibilities here. Let's see what we can do.
Great, thank you so much.
Next up is number 100, Nicole Hampton, followed by 101, Patty Morse.
Good evening, Senator Abrams, Representative Steinberg, and the distinguished members of the Public Health Committee. My name is Nicole Hampton, and I am employed as a certified peer recovery specialist and recovery coach professional. I volunteer for the Connecticut Community for Addiction Recovery Bridgeport, as well as co-chair both the Catchment Area Council Area 1 and 2, 3, 4, and the Billable Peer Support Group. I'm testifying today in opposition of Section 2 of SB 1. This section seeks to authorize the Commissioner of Public Health to provide the certification and education of peer support specialists and specify the peer support services that a certified peer may provide to another individual in the state. This section is concerning and further consideration is needed. I feel like the authenticity of the peer role would definitely be lost. Currently in the state of Connecticut, the Department of Mental Health and Addiction Services endorses a statewide curriculum and exam through Advocacy Unlimited known as the Recovery Support Specialist designation. In addition, the Connecticut Community for Addiction Recovery offers a professional designation as well. Both of these designations, along with others offered in our state, can be used towards obtaining the Certified Peer Recovery Specialist certification through the Connecticut Certification Board. The CPR certification is the only one in the state of Connecticut. A certification by definition must be third party. A certificate program should not ever be confused with a certification. Through the International Credentialing and Reciprocity Consortium, the Connecticut Certification Board offers a standardized, valid and reliable, and legally defensible Certified Peer Recovery Specialist certification. The expertise of the Connecticut Certification Board does not lie in the provision of peer services, but in credentialing in the behavioral health arena. Keeping our state certification under the CCB would allow us to make changes in real time versus waiting for legislation if under DPH. On March 9th, the Insurance and Real Estate Committee held a public hearing to hear HB 6588, an act concerning mental health care and substance abuse services. Section 4, not 2, of the HB 6588 will establish a statewide task force to study insurance reimbursement for peer services. This bill is highly supported across the state. Having this task force in place would elevate and formalize the discussion at a state level and make officially recognized recommendations ahead of the next session. I'm humbly asking you to please strike Section 2 of SB 1 and support the passage of House Bill 6588 and help Connecticut take the critical steps towards improving our system of care through essential peer support services. Thank you so much for letting me share your time.
Thank you, Nicole. Obviously, if you've been listening today, you realize that you're not the first person to have testified in opposition to Section 2 of the bill. Obviously, we want to make sure there's appropriate oversight, as we do for everybody who comes in to care with patients or people in need. Let me ask a question. I don't know if it's been asked before. Is there a national organization and a national standard for this role?
Yeah, it's actually international. It's through the International Credentialing and Reciprocity Consortium. And so, like, through the Connecticut Certification Board, they are also, like, I could go to 18 other states with my certification by just transferring it.
Well, that really does answer the question. We often look for some sort of broader standard to assure that Connecticut's, which tend to be a little tougher than other states for a lot of areas, would be comparable. So you've given us a bit to think about. As I said earlier, we will look at the Aging Committee bill. Perhaps we can add that to ours or combine it, as you say. But it's very important that we have people with the lived experience really providing the assistance, and we do not want to frustrate that.
Sounds good.
All righty. Thanks for sticking with us all day. Really appreciate it. And next up, we have Patty Morris, followed by 103, Takesha Everett. Takesha, Dr. Everett.
Good afternoon, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. My name's Patricia Morse, and I'm the President and CEO of Connecticut Baptist Homes in Meriden and Pierce Care in Brooklyn, Connecticut. They are two not-for-profit aging services campuses, both providing continuums of long-term care, including skilled nursing. I'm pleased today to provide testimony on Senate Bill 1030, an act concerning long-term care facilities. And I would specifically like to address Section 13 of the bill regarding the conversion of rest home with nursing supervision licensed beds to the higher level chronic and convalescent nursing home licensure. Connecticut Baptist Homes is a campus in Meriden offering a continuum of aging services, including a 60-bed nursing facility. We have 30 rest home with nursing supervision licensed beds. We support the proposal to eliminate the distinction between CCNH and RHNS licensed nursing home licensure categories for the purpose of establishing a single minimum direct staffing level requirement for all nursing homes. Our nursing facility cares for 60 people on two separate 30-bed units. One unit has 30 licensed CCNH or skilled beds. The other, a separate unit, has 30 licensed rest home with nursing supervision beds. There's literally no distinction between the two units. The residents that we care for are the same. Their acuity levels are the same. The staffing levels we provide them are the same. The RUGS categories that are generated by their care needs are the same, and all 60 beds are duly licensed and certified to provide care under the federal Medicare guidelines. I'm sorry. My computer didn't go up. Let me see. Oh, it was in the wrong place. While at one time there was a difference in the level of care needs between the residents cared for at one level versus the other, that era of nursing home care is gone, and the acuity level of all of our residents now reaches or exceeds the qualifications of the CCNH or skilled level of care. From a regulatory perspective, we're held to the same standards of care at both levels of licensure. However, from a reimbursement standpoint, the Medicaid rates we're paid are very different. We receive approximately $45 less per day from Medicaid on the rest home level compared to the skilled level. In the 2018 rate letter issued by the Department of Social Services, the rate calculated by the state based on annual occupancy was $256.76 per day.
Ms. Morse, you've reached your 3 minutes if you'd like to give a conclusion.
Thank you. The rate issued or paid to us was only $166, a difference of almost $90 a day. While we support the proposal to eliminate the distinction between the skilled and rest home levels, the rate paid for those converted licensed beds must be increased to the same rate level as the current skilled rate paid to the facility. Based on recent requests, facilities who are seeking to eliminate that rest home level and convert their beds to skilled are permitted to do so, but with a rate that is calculated based on combining the two, dividing them by 2, and creating a blended average rate. This process of blending these rates would lead to continued losses that we cannot sustain. Therefore, we ask this bill specifically address this issue and require an increase in the rest home nursing supervision rate without lowering the skilled nursing rate. Thank you for this opportunity to testify in front of you today, and I'd be happy to address any questions that you might have.
Well, thank you for your testimony. I confess I was unfamiliar with your circumstances. So I have a couple questions. First of all, how long has this been going on?
I've been licensed in the state of Connecticut for over 40 years, and we've had 2 licensed levels of care, the skilled level and an intermediate level. And I think probably 40 years ago, that made sense. I think as acuity levels changed and we cared for more acute people in nursing homes aren't rest homes anymore. We don't take care of that level of client. Community-based services have come into play, and I think a lot of those people are cared for at home and come into nursing homes for short periods of time or for longer periods for more acute needs.
Now, I will say that at least for, I don't know, do you have Medicaid patients?
70% of the people that we care for are paid for by Medicaid.
Well, this leads into my question, which is obviously, if it's Medicaid related, it's related to Department of Social Services that has purview on a lot of the reimbursement aspects. And I'm wondering, when was the last time you had a conversation with them?
I think those are ongoing. I think that the predicament that we're in now is that we would like to eliminate the rest home with nursing supervision in a number. There aren't many of those beds left in the state of Connecticut, but in order to do that, we need a new consideration in terms of the rate discussion. In the past, it was a certificate of need request to relicense those beds from rest home to the CCNH level of care. But I think that there could be a different methodology and process that would be more expeditious to do that.
Well, thank you for educating me at the very least, and I imagine there are other members of the committee who are not familiar with this distinction as well. To be fair, when there's money involved, we're not always in a position to do that much about it. But certainly it's a conversation that needs to take place, whether in this bill or in something subsequent. We really appreciate beginning our education. It sounds like we have a ways to go here.
Thank you for your time.
Thank you. Any other questions? If not, thank you. We will move on to Dr. Everett, followed by 104, Liz Gustafson.
Evening, Representative Steinberg, Senator Abrams, and the distinguished members of the Public Health Committee who are experiencing quite a long day. My name is Takesha DeWine Everett, and I'm testifying today in my role as the Executive Director of Health Equity Solutions, which is a nonprofit organization with a statewide focus on promoting policies, programs, and practices that result in equitable healthcare for all in the state of Connecticut. Before I go on, I want to acknowledge and thank the team at Health Equity Solutions, as well as my students at the Yale School of Public Health, who are allowing me at this very moment to take a break from our advocacy and activism class to watch this hearing. HES has already testified in this committee on several provisions of Senate Bill 1. Doulas and community benefit in a different hearing, and race, ethnicity, and language data. So I will only reiterate that this proposal creates efficiency and improves the state's ability to assess and address inequities in health. Health inequities are rooted in structural racism and its wide-reaching impacts. The cumulative impact of these barriers to health is invisible unless we evaluate and seek to address health disparities. This proposal standardizes data collection by the state using categories that are granular enough for the vast majority of Connecticut residents to see their identity reflected in the options, without creating a burden on service providers to collect this data. Today, I'm going to focus on Section 6 and 7 of SB 1. We cannot address a problem we are unwilling to acknowledge. Declaring racism a public health crisis is a commitment to intentionally anti-racist policymaking, and it is long overdue. It is the first step in dismantling the racism that is so pervasive in our government and in our governance. Since the summer's uprisings against outrageous violence perpetuated on Black Americans and the injustice of our pandemic's path to death, disease, and poverty, as well as even the recent murders and violence against Asian Americans, it is really important for us to learn from what we have seen in COVID-19. We need to declare racism a public health crisis and the impact that it has so that we can begin to dismantle its impact on us. To date, 20 municipalities in the state of Connecticut have already done so. A declaration is an important step, but it is not far enough, and it is far from all that we need to do. The council proposed in the bill here would do important work, and we suggest committing it to anti-racist structures in government, committing to anti-racist structures in government to make the insidious invisibility of racism in our ways of doing and being visible and address them. We recommend establishing and staffing a health and all policies approach in the executive branch and require it to meaningful community participation. We dedicating staff to producing racial and ethnic impact assessments to be completed on any proposed bill. We also recommend reviewing and making recommendations to embed equity in existing policies and practices overseen by the Connecticut
You've reached your 3
General
minutes.
Assembly.
If you'd like to give a conclusion.
I thank you so much for this opportunity and welcome any questions and conversation.
Well, thank you again for all you do and your eloquence on this subject. I think today we've heard it in a lot of different ways, but the theme is very clear and strong. Some people have some questions for you, starting with Senator Anwar.
Thank you, Mr. Chair. Thank you, Dr. Everett. I've been reading your work and looking at your work, and I'm a fan of your work. I wanted to thank you for all that you do. I had a group of interns who were working, and I said, let's make a list of the movers and shakers in our state who can actually address the challenges of after we declare racism as a public health crisis, who are the ones who can actually fix these things, and then who would be part of a dream team of members who can actually address this. And then your name was on the top of everybody who looked at it. So I wanted to just mention that to you. And I think you were about to say some other things that can be done to improve this, and I would love to hear that.
Thank you, Senator Anwar. I was ending with one last bullet point and saying adjusting Section 15 to analyze disparities in the distribution of resources during the pandemic and make recommendations to remedy those inequities. And I would like to take the opportunity in answering your question to acknowledge and respond and thank you for your leadership on this issue.
Thank you. And I think that there would be a need to have some personnel dedicated to this, as you have alluded to. And I think that was part of one of the versions that we had. And I'm hoping we should be able to address that, because with this monumental intellectual work that would be needed with a group of very insightful and experienced individuals who we hope would be part of this commission that would require some bandwidth of putting things together and putting it into legislative action strategy. So I completely agree with you. Thank you so much for your testimony and your work.
Thank you, Senator Anwar.
Thank you. And we next have Representative Foster, followed by Senator Moore.
Dr. Everett, it's always a pleasure to hear from you. Thank you for being here with us today. When I was listening and reading and hearing testimony today about the different sections of this bill, Section 7 has itemized different places where racial disparities can exist that likely influence people's outcomes. And I think that what this is getting at comprehensively is that there is a system in which that needs to be addressed, where there are multiple ways in which people's experiences of racism have long lasting and incredibly detrimental impacts on people's lives. Do you feel like Section 7 has addressed the whole scope of like the built environment, the system in place that needs to be addressed? Is there anything that's missing? And then do you feel like there is anything that we could be doing in our advocacy of this work that might help bring people along with us to make these changes happen in the legislature? Because I've been listening to this advocacy today, and I feel like I feel comfortable with the word reconciliation, but I feel very uncomfortable with the stories that we've been hearing today. And I feel like we have to get to the point where people acknowledge the harm, which I think Section 6 does. But do you feel like we have gotten a comprehensive enough plan in Section 7 to really start to address where we are? Because I know I often get nervous about the concept, and I think a lot of academics who address health disparities, the idea of declaring racism a public health crisis feels good, like you've satisfied something. But then like that is a step, an important step, but then more needs to come next. So do you feel like we've done enough here to get to with this step?
It's such a big question. So what I'm going to start it by saying, I think that we have to be mindful. Racism has existed forever. The dismantling of it will take time, and we have to be mindful not to boil the ocean. So when I look at Section 7, I think it is an important step and an important start to look at some of the most disparities, the systems that have been the most harmful and the most impactful on the lives of people of color in Connecticut. Can we do more? Possibly. Do we need to start somewhere? And is this an effective, efficient, and wonderful start? Absolutely. I also think that we have to get ourselves kind of out of the fear of talking about and acknowledging racism. And I think this is the really great part of pairing two words together, or two terms, I'll say, reconciliation and anti-racism. So there's this entire movement around anti-racism, which allows us to say, first and foremost, we are not going to pretend that racism doesn't exist. We're going to acknowledge that it is, and that our role in the work that we do individually and collectively is to dismantle racism wherever we see it. And so I believe that this is an opportunity for us to be actively racism and push past the debates and the conversations or discussions around whether you or I individually are racist, and really focusing on the system that racism is and the insidiousness that is at play in affecting the lives of people in Connecticut.
I appreciate and thank you a lot for that. And then I hope you don't mind, I heard a couple of questions earlier from some of my colleagues that I think we're sort of getting at, can we address poverty or mental health and get at the same thing, but be more equitable in our treatment? And I'm wondering if you could sort of explain to us why racism specifically needs to be addressed separate from income and socioeconomic status.
Absolutely. So I got to think about how I do this in like a 3-minute response. I think I can handle it. First and foremost, when we look at the system when we look at how people have systematically been treated, have been impoverished or overrepresented in socioeconomic disadvantage, you will always find that there is an anti-Blackness and a combination of positive overt or covert racism at the heart of it. So when we look at our history and the historical context of how we've built communities, that includes looking at redlining, racial covenants, race was the core of it. And that's how we then get over representations of concentrated poverty, because of how we then tied race and racism to who could have a job and who could work where and all of those pieces. It's the same with our education system and how that's connected to how we fund how people have work and how we fund that through taxes. So all of these things are fundamentally built on the foundation of racism. So yes, we could address poverty, but if we never get to the core of why poverty exists, not just, and let's be very clear and fair about saying poverty affects everybody regardless of race, but there's a disproportionate effect on people of color. So if we talked about poverty but never addressed the core of how we got there, we can't really eradicate the system of poverty. And honestly, it's what we've been doing for years now. We've been addressing the symptoms, poverty, mental health, etc., without addressing the core. This allows us, by declaring racism and focusing on racism centrally, to address all of those issues. And the last thing I want to add to this is it's not an either or a zero-sum game. If we address racism, correct the systems that are in play that perpetuate inequity, both in health and everything else that exists, then we make it better for everybody. It's really a principle called targeted universalism. You set the goal and then you target your sights on the people who are the most disenfranchised, the most disadvantaged by whatever the system is, and everybody wins. There's a nomenclature of rising tides lift all boats that's not right. If a boat has a hole in it, a rising tide capsizes that boat. And when you think about that, that's the experience of people who've been living with racism all of their lives. And I'll end it there because I think I could keep going, but it's not fair. You all have been here for a very long time and I am not in professor mode. So thank you.
I know you have your students watching you. Can I ask one more question? Do you mind? Oh, okay.
This is your hearing. I'm here for you.
I know, and I think since you are sort of the preeminent expert here, that I get that hearing your sentiment on this is important. So my last question is sort of gets at what you were talking about, how the rising tide lifts all ships, metaphor that people are often using. I think we've heard a little bit about maternal mortality and the doula language here. And so I feel in this public hearing a lot of stress that I felt hearing and thinking and imagining my friends at the age where they're having children, and that their life experiences would make that experience that seems very universal and shared significantly different for us, and that our outcomes would be significantly different. And I feel like we're at this place where we need to get uncomfortable. We need to be comfortable with discomfort to have these conversations moving forward. And I don't know that that's that's the end all answer for being there. But since I know your students are sort of watching also as we're having this conversation, and that we're all sort of wrapped listening to you as the expert as we're making this decision that'll hopefully make a significant positive difference in our state. Do you feel like the way that that we can sort of move for the platform here, do you feel like there are things that have been happening in this conversation that are helpful or harmful to the movement moving forward? Can you talk a little bit about the things that have been happening in this public hearing and how those can contribute, like how sort of misrepresentations of the experiences of women of color or sort of oversimplifications of things could actually be harmful, and examples of the exact thing that's contributing to the elevated levels of stress and cortisol that could be partially contributing to differences in mortality?
Thank you for the question. I'm going to start by saying, if we are comfortable in our everyday existence, then we are just perpetuating the status quo. And we all have to push ourselves to where change happens in anything that we do. It happens in the point of discomfort, when we push ourselves past our comfort zone and go into that realm of uncomfortability. And that's when we're pushing ourselves towards change. So I think we have to have the difficult conversation conversations. We have to have them in difficult ways. We also have to honor the places where people are. We have to honor that people have ignorance when it comes to the issues that people are facing every day. We have to honor that there are stories that are untold and that are trying to be told about what people are facing. And when we bring that together and we're talking about maternal mortality, I can speak to you as a Black woman in America. I have a PhD. I am highly educated. I am a middle-class individual, and there is not a day that goes by that I don't experience racial trauma. The experiences and the memories of being a child who was treated differently because she was Black, being a woman who was treated differently because of her gender, and the intersection of being a Black woman, those things happen to me daily. Now, just imagine if you are a mother, a person giving birth, trying to give birth, and all of those daily micro and macro aggressions are happening to you consistently and constantly, what that does on you and the impact of the baby. We have to realize that the Black maternal mortality problem is a racism problem. We have studied this for a long time. There's no real other answer as to why we are having famous women who have all the money in the world still having poor maternal outcomes. And the same is happening for impoverished women who don't have all the resources and access. So I think it's important, I'll kind of wrap up by saying this. It's important for all of us to push past our comfort zone and get into the space where we are uncomfortable and we are learning. That's where the learning happens. We also have to be very careful about a single narrative. And we need to be mindful and understanding that everybody's normal is not our everyday. And that's not, and we need to be able to have a lens of cultural humility and really open our eyes to seeing that people are living in different Connecticuts in this state, and they're experiencing things differently, no matter how great we think we are. Simultaneously, we rank high every year in health as a state, like somewhere between 4 and 5, but simultaneously we're number 41 or 42 on health disparities. That's a story we have to unpack and a story we have to tell. And at the root of that is the difference that exists in our state.
Well, that was my last question, but it's always, I always learn a lot from hearing from you. So thank you for that. I wish I could, it's upsetting, but it's also, it's always a really great educational experience. You give me things to work on every time we talk. So thank you.
Thank you.
Representative, you could always talk to her offline too. I bet you could learn a lot. Senator Moore.
Good afternoon, Dr. Everett. Representative Foster, you asked a lot of the questions and talked to, and Representative Senator Anwar, I want to thank you first of all for even bringing this out. It's a difficult place to be. And Dr. Everett, I want to say I'm so appreciative to have listened to you, because I think what you know and what you shared today should be a precursor to these hearings, to try and get people to even understand how difficult this is. I think sometimes people think just because I'm a Black woman that these conversations are easy and they just come off the top of my head, but it's my lived experience for all these many years. I just got off a call with another senator saying, I feel like I've stepped back 50 years in my life. It's not a good feeling. It's just not a good feeling. You frame the messages very differently from what I've known from the past. But until there's that, come to that point of admitting and acknowledging what has happened and how we got here, we will never be able to do anything, even through legislation, because legislation is only as good as the people who enact it and the people who enforce it and the people who believe that something is wrong. I heard someone ask earlier, why is racism a public health crisis? And I think they were sincere in asking that. And if there's that many people who don't understand how it impacts all of us, regardless of race or ethnicity or gender, you don't even understand the basic core of that, then we're at a place where we really do have a problem, because it comes through education, it comes through health, it comes through housing, it works its way through all of those things, because it's the systems. And if we don't break down systems one at a time or collectively, nothing is going to change. A declaration means nothing unless the work is really done behind it. So I so much appreciate you. I should record you as my morning listen to, because you bring such great insight to the subject, and it is very difficult. And I guess I don't want to be comfortable. I want to be comfortable, but I guess I shouldn't be comfortable because it is an uncomfortable subject. But until we're willing to have those tough conversations, we're not. Would you ever recommend the whole legislature going through some type of doing racism or racial justice training that we could all try and get to a level playing field on some of these subjects?
I recommend every human who has the ability to do undoing racism or anything that helps understand the pervasiveness of racism in our country, and particularly how it is a particularly United Statesian ideology around racism, because it's very different in other countries. Colorism and racism exists in other places, but the way we have monetized it, institutionalized it, made it a part of our structure in such a way that many of us on a day-to-day basis cannot figure out if that's what is happening. And even those of us who are experiencing it, self-doubting and questioning ourselves if that's what's happening, that's the insidious nature of it. So that was a long answer of saying, yes, if any opportunity is available to any legislator or the legislature as a whole to really unpack and understand the connection between racism and the historical and contemporary context of it, I would encourage it.
So thank you so much. I really do appreciate you. Thank you. Thank you.
Thank you, Senator Moore.
Thank you. Thank you, Mr. Chair.
We have one more question for you, Representative Zupkis.
Thank you, Mr. Chair. Good afternoon, not morning, good afternoon. First of all, I have to say you have a great smile, so keep smiling, it's beautiful. I do have a question. So, you know, you bring so much knowledge to the table and an understanding. So I guess in essence, this bill is looking for funding, right, for positions and that, but what is it that needs to happen to kind of pivot, I guess, where we are, right? So that's what we're talking about. So, you know, just having money and doing these things, like, to me, I believe there are programs out there that aren't working that we're funding, and we should really look at what's working and what's not, because a lot of things are working. So let's look at what's working and what's not, and then let's really fund what, in essence, is going to work. And I don't know what is going to work. So if you could say, this is what needs to be done, this is what needs to be, does it need to be kind of a study, a group to get together and come up with things? What needs to happen, I guess?
Answer the question. I fundamentally think that we know enough. We don't necessarily need to study more. I think we need to put our knowledge into action. And what I mean by knowledge into action is I think we need to understand. We need to understand kind of the systems that are at play. We need to begin to evaluate all of our things through an anti-racist lens. I again in my testimony have talked about health equity in all policies. I'm going to take a step back though and connect a few things really quickly. I think that declaring racism, understanding its impact, but also a commitment to dismantling it, eradicating it, and a commitment to saying we don't want to be the 41st state in the country on health disparities. We want to be number one. And when you pair all of that together and put our understanding about what it takes to do that, I think we can evaluate. What are we using our resources on, and how are we using those resources effectively and impactfully towards the goal of everyone, no matter how you came to live in Connecticut, has the opportunity to be healthy, happy, and live a wonderful life in these state boundaries.
And so I agree with you. And so looking at that, because as you said, we already know, right? We already understand, but what is it going to take to, you know, funding? Okay, you hire a person to do this, you hire a person to do this. And I'm really asking the question. So, and maybe this is going to have to be discussion, and I would love to talk to you offline, but what is it exactly that money will go to change it, right? because we can fund a ton of programs. We can do a lot of things. And we've done that, I believe. The state, we're always funding programs and doing things. And to me, it seems like, you know, for as long as I've been in the legislature, we're funding things. And what I hear from people is it's not getting better. Okay. And maybe we've gotten a little better, but it's not where we want to be. So how do we, you know, we're here and we want to get here. How do we just get there? What has to happen to just get there?
Okay, Representative, I'm going to answer your question, but as I do so, I just want to acknowledge I'm going to go off screen because I have a puppy that is barking very, very loudly. And so I just need to go and pick him up while I answer your question. So I think the commitment to understanding what the core issues are that we need to change is what's going to be the difference. So we don't want to throw money at something that we don't have an opportunity. We don't want to throw money at something. We don't want to study something. We already know kind of what's working and what doesn't work. I think it's the core thing about moving us from point A to point B is the commitment to the point of saying, this is the core cause of our issue, and we are committed to changing that issue. We need to have dedicated people, time, and energy that is supportive of changing the issue. For me, I'm saying dismantling racism, being anti-racist in our activity is the focus of what we need to do. We need to commit a lens to that in everything that we are funding and every program that we are doing. How is that advancing health equity? How is it advancing the health of our people in the state? That to me is the difference of what we're asking for that hasn't been here before.
Okay. Well, thank you. Thank you. And I would love to chat with you offline at some point.
I welcome it.
Because I sat with, and I know it's getting late and it's St. Patrick's Day, but a long story short, I sat with Senator McCrory. And we were in Hartford and we had a panel and we brought people in and they brought this young man in and after hours, and there were advocates and everybody and they had great ideas. And this was, 3-4 years ago and nothing happened. And so, it came down to this young man. I said, what are the 3 things you need? And he said, I need a cell phone. I need clothes because, my parents, whatever, terrible home life. And then he said, I need love, right? And you can't legislate love. And so I really, I would love to be involved and help. I just want to make sure what we do is doing it. We hear about it all the time. And we just need to make it happen. And I don't know what that is, but I want to make sure if this bill passes and the funding gets put to it, we're not in 2 years sitting here again saying the same things. Thank you, and keep smiling. Cute puppy.
Thank you. Thank you.
Well, you managed to smile even with a dog on your lap who's not always behaving. So we really do appreciate you taking the time. We have a lot of dogs and cats in this committee too, so we're very appreciative. No more questions. Thank you again. And obviously we have work to do. We really appreciate it. Next up is number 104, Liz Gustafson. And then we're going to go back. We missed somebody, Sharia and Ashmead. But first up is Liz.
Hi, good evening. Senator Abrams, Representative Steinberg, and honorable members of the Public Health Committee. My name is Liz Gustafson, and I'm the State Director of NARAL Pro-Choice Connecticut. I am here to testify in support of SB 1, but for the sake of time, I will be summarizing some specific components. So one of the components that we submitted testimony for is the proposal to define the doula profession in Connecticut. Reproductive freedom includes full autonomy to make a decision if, when, and how someone decides to start or grow their family. And for many women, there is trouble accessing timely, culturally appropriate care due to systemic and structural inequities throughout our current healthcare system. This policy proposal is crucial to doulas in Connecticut, as ensuring title protection provides stronger identity and credibility and prevents misrepresentation of the profession. The testimony provided by doulas today provides great insight into what they do, how they assist providing safe, memorable, and empowering birthing experiences, and why we must expand access to their care. Also discussed today, it is well documented that access to doulas aids in improving health outcomes for both mothers and infants, while also reducing the need for costly interventions such as cesarean births and epidural pain relief. The United States is one of only 13 countries in the world where the rate of maternal mortality is now worse than it was 25 years ago. Additionally, as we continue to navigate and understand the longer-term impacts COVID-19 has had on our communities, it is abundantly clear that existing racial disparities and health inequities have only been further exacerbated by the ongoing public health crisis. Sexual and reproductive health care needs do not stop during a global pandemic, and it is fundamental that we meet this moment. This is not only a matter of reproductive freedom, but is also a tangible step towards addressing the ongoing reproductive injustices in our state. I also wanted to comment briefly on Section 6 and 7, which one would declare racism as a public health crisis and would also establish a commission to study the impact of institutional racism on public health. So as mentioned, our systems are built upon decades of racism, inequity, and white supremacy. These two sections provide both a public acknowledgement that racism is a public health crisis and is also a commitment to begin the process of undoing the harm caused by burdensome barriers and gaps in access. While it is not a final solution, it is a critical step that must be taken at the state level. NARAL Pro-Choice Connecticut stands with the Connecticut campaign to address racism as a public health crisis, and with those who have and continue to courageously share their truth and lived experiences in today's hearing. Again, for the purpose of time, I will note that more in-depth recommendations for Section 6 and 7 are included in my submitted testimony, and many of which were just discussed by Dr. Everett just now. So in closing, Connecticut is positioned to build upon its bipartisan history of protecting and expanding reproductive freedom, and will truly be able to do so by implementing measures that address ongoing harms and disparities exacerbated by systemic racism and institutionalized barriers. Everyone deserves to be able to start or grow their families in safe and healthy communities with dignity, with compassion, and the ability to
You've reached your 3 minutes if you'd like to give a conclusion.
Awesome. And the ability to thrive with access to the resources and support needed to do so. SB1 is a step forward towards fostering a clear pathway towards making this future a reality for all of our communities. And we urge committee members and the General Assembly to support this really important bill. Thank you so much for your time.
Thank you for your testimony today on behalf of NARAL. Liz, I don't know if you were listening much earlier in the day. We had testimony from a doula who expressed, based upon her experience, that there were typically worse outcomes for pregnant women of color. Does that correspond to your knowledge about the statistics in the state of Connecticut?
Yes. So we are members of the Connecticut, the Doula Coalition, because as advocates for reproductive freedom, that includes all pregnancy and birthing outcomes as well. And so in Connecticut, babies born to Black mothers are 3 times more likely to die in their first year of life. And babies born to Latina mothers are more than twice as likely to die in their first year than those who are born to white mothers. And it's clearly a racial justice issue, but I think earlier, someone said, if you support the healthcare of Black women, right, that benefits the communities. If you invest in the health of Black women and Black mothers, you are helping the health of all women and all infants.
Well, thank you for that. Obviously, it's something that, as you say, not only are we making the family healthier, the community better, we're probably avoiding bad outcomes that have lots of costs to, not only the psychic cost to the family, but cost to the state in having to deal with some of the ramifications of failure to deliver quality care in the first place.
Absolutely.
Thank you for that. I don't see any other questions. So thank you for sticking with us all day. And we really appreciate it.
Thank you so much. Good to see you.
Thank you. Next, we have Sharia Ann Ashmead, followed by Amy Badini.
Hi, good afternoon. Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Sherry Ann Ashmead. I'm a CNA at Regal Care of New Haven. I have worked as a healthcare worker at Regal Care for 7 years. I love my job because it gets me the opportunity to care for my resident. It is a passion for me to help those in need. I am here today to ask that you pass the Senate Bill 1030 with some changes because it will bring much needed improvement to the nursing home industry so that residents can receive proper care. Even though I love my job, what frustrates me is that we work in an environment where risking our lives to do something we love is often unappreciated. Most often, we are looked at as if we are the problem, and the work that we do as CNA is overlooked and underappreciated. With proper staffing, we will be able to spend more time caring for each resident according to their need. It will help to offer our residents with better quality of life. One area that this bill gets wrong is the 12-hour shift section. 12-hour shifts will not solve our staffing problems. If anything, it will make them worse. We're regularly mandated to work and are burnt out because we are doing double jobs due to understaffing. Changing our shifts to 12 hours will demoralize the workforce even more, and we are already low. Another area I would change is the penalties for not giving access to PPE to workers. I have worked on a COVID-19 unit and we were treated like we were outcasts. We had to take home our paper gowns, wash them in disinfectant water, and hang them up to dry so we could take them back the next day for some form of protection. We wore our N95s for 10 days or more till some of our faces were breaking out. There was no education, so we were also spraying those masks with chemicals and inhaling those chemicals, thinking we were disinfecting the mask. We didn't have enough gloves at times, so we were moving from one resident to the other with the same gloves just to make sure care was given and we were protected. While management hoarded the supplies, jeopardized the residents and also the staff. This kind of behavior did not warrant any penalties or fine from the DPH, and this bill doesn't change any of that. We need strong penalties so that when management withholds employees access, there are repercussions. Please pass this bill. Thank you for your time.
Thank you for your testimony. You've reinforced many of the things we've heard today, and obviously we need to take a look at the section of that bill. We've heard from several workers that the 12-hour shift is potentially problematic, and some of the other comments you made as well. I don't see any questions, so thank you for testifying today. Thanks for coming back because we missed you earlier. We really appreciate it.
Thank you for having me, Senator.
Sure. Number 105 next is Amy Bedini, followed by number 106, Sheldon Tobin.
Good afternoon, representatives, and thank you for your public service here in Connecticut. My name is Amy Bedini, and I'm speaking today in support of Bill 1030, an act concerning long-term care facilities. You've all heard individual stories, mine's no different. Locked out for a year, I've witnessed the unnecessary, rapid decline of my 76-year-old mother and my adopted 98-year-old grandmother. What I'd like to focus on in this bill is the role of families. My involvement with the Family Council made me keenly aware of many shortcomings in long-term care facilities in Connecticut. Unfortunately, this pandemic revealed the desperate need to formally recognize the invaluable role of family members in the care of those living in long-term care. This bill must firmly address the role of families. Section 8, the establishment of families councils, it's not strong enough. It must include language that recognizes the advocacy and educational role that families serve for residents living in long-term care. I would like to see stronger language that says family councils support resident life through advocacy and education. Section 5, Infection Prevention Committee, must include a family council member. This would support the communication issue that Section 8 is already trying to address, the poor communication that the pandemic showed. Section 10, essential caregiver. The language says that the facilities will determine who a resident's essential caregiver will be. Honestly, do you believe a facility is going to know who knows the resident better than the family member would? This absolutely needs to be changed to recognize the invaluable role of families. Additionally, there needs to be a clear distinction between an essential caregiver and a visitor. An essential caregiver is not a visitor. This should, and they should never be restricted from a facility, even during an emergency situation. Had there been a recognition of the established relationship between the facilities and family members, much of the heartache may have been avoided. Not only do all of these sections need to be effective immediately, there needs to be a clear explanation about the enforcement of the bill if facilities don't abide. This vulnerable population does not have the time to wait another 7 months, let alone another 10 months. Isolation resulting in failure to thrive has caused the death of too many. That's 100% preventable by recognizing the role of family. And finally, I addressed the enforcement again. That needs to be addressed. I've become aware of the vast discrepancies among long-term care facilities in the state when it comes to the implementation of the guidelines. Some have embraced the compassionate care visits that CMS tried to state, and others said, no, that's just another extra visit. So if those issues are addressed, it would be a wonderful step forward to prevent this from ever happening again. Thank you.
Thank you, Ms. Bedini. Appreciate your testimony and you're bringing your experience to our attention so that we can make the best bill possible. I don't see any questions, so have a good evening. Next is number 106, Sheldon Taubman.
Good afternoon, Senator Abrams, Representative Steinberg, members of the committee. My name is Sheldon Taubman. I'm an attorney in the Benefits and Elder Law units of New Haven Legal Assistance, where I mostly represent low-income healthcare consumers. I'm here to support SB 1, intended to address health disparities. And I also wanted to emphasize 3 concerns with it, even though we strongly support it. First, advocates for peer support have made clear that they want to strike Section 2 in favor of HB 6588. Second, there is concern about the composition of the Reparations Commission, that it really have strong community representation. But third, I want to talk about what's missing in this bill, which is designed to address health disparities, and that is the lack of a mandate for DPH to finally issue long overdue guidance prohibiting the discriminatory rationing of healthcare in times of crisis. Brief history is more laid out in my testimony written, but beginning on March 25th in writing, a request was made by a group of disability organizations asking the governor and DPH to issue uniform statewide guidance to all hospitals prohibiting discrimination if rationing has to happen. But DPH has failed to act now for almost a year. And as a result, several Connecticut hospitals acting to fill the void issued their own highly problematic guidelines, which effectively discriminate against people with disabilities, older adults, Black, Brown, Indigenous, and Asian people. Some of the violative provisions we found have been fixed, but other hospitals continue to have problematic provisions. For example, a 5-year test for survivability having nothing to do with COVID, having nothing to do with survivability to discharge, that will be used against you. You lose points because you won't live for 5 years. And we all know that directly impacts Black and Brown people and obviously older people. In addition, several hospitals have and had, and one still has at least, a specific discriminatory provision saying people with severe and irreversible neurological conditions aren't even eligible for consideration for life-sustaining treatment. Once it was learned that hospitals were adopting these rationing criteria, which disadvantaged other groups besides people with disabilities, those other groups got involved. And now 39 organizations around Connecticut, dating back now for a year, have continued to ask DPH to act, and it refuses to do so. And the excuses have varied from, well, we're in the middle of a crisis, so we can't deal with it, to we're past the crisis, so we don't have to deal with it. One of the things they said in January was that we will not be rushed into acting. And that was 10 months after the first request went to DPH and the governor. And I should point out, other states have done this a long time ago. Most states during the pandemic early on reacted and issued statewide guidance. So now we have a situation where we have hospitals that have a provision on the books that says if you have advanced or irreversible neurological event or condition, you're not even eligible. I have many more examples. I'd be happy to provide them upon questions.
Mr. Tubman, you've reached your 3 minutes if you'd like to give a conclusion.
Sure. So based on that history, it's clear that without a legislative mandate, no timely action will be taken by DPH to issue statewide guidance to ensure uniform anti-discrimination protections for all state hospitals. And therefore, I urge you to adopt the language, which is it's at the back of my written testimony. And this is language that's been put together by that broad coalition and representing, again, people with disabilities, older adults, Black, Brown, Indigenous, and Asian folks, all of whom are concerned about this affirmative discrimination going on where hospitals don't have anti-discrimination protections and DPH refuses to issue guidance. Thank you.
Thank you, Mr. Taubman. Representative Pettit.
Thank you, Madam Chair. Thank you, Mr. Taubman. Trying to look for your testimony, but I don't think it's been loaded on the system yet. So you can educate me legally here. The groups you're talking about, would not they be protected under the American with Disabilities Act in terms of access to this care, or is there some quirk of the law where they wouldn't be able to bring suit to obtain the care that they're looking for?
Well, bringing suit is way too late. And in fact, the governor and DPH in refusing to act, they've written letters to the advocate saying, oh, if a case comes to our attention, please, we'll be sure to act. We're not going to know about this. It's going to be silent. It's going to happen in the hospital. The patient who dies doesn't know. The family doesn't know. And even if you do and you bring a lawsuit, that's not what we want. We want to stop discrimination. You're right. The ADA says that you can't single out various kinds of conditions for discriminatory treatment, but that won't help you. I mean, just one of the hospitals, they've be clear, this has been changed, but other hospitals have similar. One of the hospitals said adults with severe trauma, adults with advanced untreatable neuromuscular disease like ALS, those who are dependent on all activities of daily living due to a progressive chronic comorbidity, a long list of things, and kids too, kids born with genetic abnormalities, they were all singled out that they can't get treatment, or at least they're going to have extra points against their score and less likely to get treatment today to survive to discharge from COVID or whatever. So the law's there, but it doesn't help us if DPH doesn't do what most other states did months ago and say, hospitals, here's the rules with detail, following the Office for Civil Rights of the Department of Health and Human Services also issued guidance. We just have to make it clear we really don't understand. We just can't figure out, why does DPH not want to do this? Why do they keep making up all these excuses? And here we're talking about a bill to address things which are, a lot of it is unfortunately implicit, but it's really hard to get at. But here's a situation where hospitals are including affirmative provisions that are discriminatory or refuse to even issue something in writing that makes it clear we can't do that.
Okay, thanks. So as I expected, so academically, theoretically, the answer is yes. Practically, in terms of timing, you don't want to be running to try to find the judge at 9 o'clock to get somebody dialysis or on a ventilator. So it's a great philosophical academic solution, but practically it doesn't function well. Okay, I thank you for that. And I don't know what the role, the new Office of Health Strategy, DPH, what the interplay will be in some of these issues. So I guess that'll be for us to work out a little bit. But thank you for that discussion.
Thank you. I mean, just to be clear, we're asking for something to happen now, and we may get another spike, right? We could, unfortunately, one of the variants could be a problem. We've been asking for this for the year, and there's no reason the state can't do what other states long ago did.
I appreciate that. Thank you, Madam Chair.
Thanks, Representative Pettit. Representative D'Amico.
Thank you, Madam Chair. Thank you, Sheldon, for coming and testifying about this important issue. So just to follow up on Representative Pettit, you said that your testimony is not online, or?
Oh, I didn't say that, but Representative Pettit said that, and I believe him.
Okay. Well, again, I don't want to belabor this, but just for the benefit of myself and my colleagues who apparently don't have the benefit of your written testimony, did you want to give us a couple of examples of some of the more egregious situations, or have you already covered that?
I hit on some of them. But one of the hospitals right now has a policy that says if you have a severely limiting condition that's likely to result in death, that is factored against you. And even one of the hospital that says for survival of 5 years, if you've got a condition that's likely to cause death within 5 years, that's going to be ruled against you. I think we've already heard testimony today about extreme disparities in terms of life expectancy based on race. There's no question about it. It's extreme. So if you have a situation where the written policy of the hospital says, you look at it, the person's not going to last for 5 years, and if so, either they get points against them, or maybe, as in the case of the other hospital, you aren't even considered for getting treatment, then it's obviously going to make things actually worse than they already are.
And I appreciate that. And so now, do you have language that you would like included in one of the bills, or do you have a separate bill? Because I know you've made some inquiries about this, recently. So where do we stand now? Is there language that you want included in the bill?
Yes, there was a separate concept bill 566 that was sponsored by Senator Lesser and Representative Tercio, and that one hasn't survived at this point. But this bill seems to be the bill that would appropriately address. It's about health disparities. It's about addressing discrimination. And attached to my testimony, I'm sorry that it's not up there yet, but attached to my testimony right in the back is the actual language that the coalition has come up with that we would urge the committee to look at. We'd be happy to discuss with you any concerns you have with it, but that language was developed in consultation with national experts as well. So the idea is to follow something which makes sense, which other states have done. Utah and Tennessee did this months ago. This is not, cutting edge or anything. This is like kind of standard. So Utah, Tennessee, other states already did essentially everything in there. And I should also point out, Hartford Hospital has done this. Their guidance was initially really problematic. They had a 5-year survivability test, but they got rid of all those problematic provisions, and their document is now fine and consistent with the bill language, which is attached to my testimony. I think Kevin Brophy from CLS also has the testimony, has the language with his testimony, and a couple of the other people as well.
Okay, thank you very much. I appreciate it, and hopefully we can get something resolved. Thanks, Sheldon, and thank you, Madam Chair.
Thank you, Representative. Yes, sir, you're not the first person to bring this to our attention today, but we greatly appreciate your testimony and the opportunity to look at this issue. So thank you so much for being here. Have a good evening.
Thank you.
Next we have 108, Callie Gale Hellman. Go right ahead. Thank you for being here.
Hi, thank you for having me. Sorry, I just have to get my, okay. Thank you so much, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Callie Gale Heilman. I live in Bridgeport, and I'm here testifying in support of SB 1. I am the president and co-director of Bridgeport Generation Now. We organize in Bridgeport to build power to end systemic racism and corruption so that we can build the just, equitable, and livable city we know is possible. At Gen Now, we also organize the Bridgeport Anti-Racism Collective, which is a supportive space for people in the Bridgeport area who are dedicated to developing their own practice and commitment to anti-racism in all areas of their lives. And in fact, we're holding an Undoing Racism training for Bridgeport leaders in May. So I'm taking off my org hat right now, and I'm here speaking to you as a white woman who is committed to anti-racism, and I'm also here as a mother. So I am so grateful that I heard Dr. Everett's testimony earlier. Representative Zupkis said that we can't legislate love, and I would respectfully disagree. If we can legislate hate, we can legislate love. And how do we know that we've spent 400 years legislating hate? Because racism as a system is the concept of race, which we know is invented, plus the concept of prejudice, which is the hierarchy, right, of white supremacy, plus the power to carry out laws, policies, and violence. So it is in that power, right, who has held power to legislate that has built the system of racism. And so the commitment to ending it comes from each of us. It comes from the personal level and then moves out from there. So we can end racism by enacting anti-racist laws, policies, and budgets. And those laws, policies, and budgets must be directed at ending racial disparities in our state. As Dr. Everett said, Connecticut ranks number 41 in the country when it comes to racial health disparities. And I know as a woman that the healthcare system and medical profession is not supportive of pregnancy and childbirth. Connecticut sees substantial and persistent disparities in maternal deaths by race and ethnicity, and Black women are 3 to 4 times more likely to die during or related to pregnancy than white women, regardless of socioeconomic status. So I'm here, specifically testifying in support of the policy proposal for title protection for doulas. I have worked as a doula among my own friends and family. I gave birth to 3 children, and I know firsthand the process of birthing, which is, at its core, it requires that women go within and find power and strength within. And that process requires that a woman feels safe and supported and empowered. And our current structures and systems do not allow, especially when racism, misogyny, and sexism can be present in the hospital or
Ms.
in the
Howman, you
care.
reached your 3 minutes if you'd like to give a conclusion.
Yeah, in the process from pregnancy all the way through postpartum, that is the reason for the disparities. And so I'm just so grateful to have been here today. I'm so grateful to have heard Dr. Everett's testimony, and I just strongly support SB1, and thank you for having me and for your leadership.
Thank you. Representative Zupkis.
Thank you, Madam Chair. Hi, Callie. Thank you for coming, and I appreciate your advocacy work. But of course, you mentioned my name, so I had to say to you, I'm a mom too, and my kids are of a different race, and so I don't know of anyone in the legislature since I have served, or before I served, maybe, I don't know, but not since I've served. I don't know one person that legislates hate. I know every single person would want to have a better society and more love. And although I don't believe utopia will ever exist, but we do want love in our society. And I think we need more of it. I think we need more of a lot of things, quite honestly. But when you say you don't agree with me, how do you legislate love?
Well, so I guess my response to what you said was in an attempt to explain maybe a little bit deeper, just like the definition of systemic racism, which includes a pillar that is power, right? And power, where does power rest in democracy? It rests with lawmakers and policymakers. So who is able to carry out certain structures and systems that perpetuate racism in our society. And so, whether hate is the intention, right, is not necessarily, I don't know anyone's intention. However, the outcome of an unjust society, the outcome of racism, is an outcome that is not, like we both agree, is not love, right? It's actually an outcome of society that neither of us want. And so the way to legislate love, in my opinion, is to legislate anti-racist laws and policies. And the way to legislate anti-racist laws and policies is to to commit to you personally making the commitment to voting on those bills that have a clear focus on ending racial disparities in Connecticut. So like Dr. Everett said, like the bills that are going to lift Connecticut from number 41 to number 1, right? Like, yeah.
So
to me, that is love.
So I have personally been called a racist for some votes that I've had, and I don't have a racist bone in my body. And so I think if we can come together as a legislator, and I'm reaching out to the woman that I just spoke to, Takesha, I think is her name. I can't wait to sit down and talk with her, because I agree we can all be better. I do agree to disagree that we can legislate love. I cannot write a bill to say, love one another, love your children, love your family, be a better family unit. We can't legislate those things. I think we can educate and work towards those things in certain ways. But as an example, with SB 1, there's good stuff in it, but then there's some stuff that really has to be fixed. So I think if we want to focus on one thing, we can't have a bill with 100 different things in it. It's got to be strictly focused, because the legislature tends to take a bill and add all kinds of things in it. And if there's something that you can't support, then you're considered not helping society or things. So I would say we don't need those kinds of bills. We need specific bills to really get to what we want and how we want to move forward and agree to do it. So I just wanted to thank you. I would love to write a law that we all love our children and we all take care of our kids and be better family units and all of those things. It just won't happen, right? We can't, we legislate the speed limit and who drives 55, right? So I wish there was a way to take one specific thing and work on it to get it really in a great place and not add so many other things to it.
Well, and I can't speak to the, the legislative process of how you all are going to get to the bill that, in your committee that, but I, if you don't mind, I did want to just respond to one thing that you said. So in our practice, in my personal practice as an anti-racist, something that is part of the practice is the commitment to confession. And the confession is, I am a racist. And it is not, it is okay. I can say that. I can say it because, and the reason why I can say it is because racism, like Dr. Everett said, is baked in, built into our country and it's the air we breathe, it's the water we swim in. And we don't, as white people, we often see ourselves as, outside that system, as not perpetuating it, as not upholding it, as sort of, it's something else that happens to other people. But when we admit and when we say, hey, you know what, like I am both affected by it because it dehumanizes me too. And like I am a part of it. And that is why I'm committed to ending it. And that is why I'm committed to this practice. It allows for that opening. It allows for that opening of your heart to the work. And so I just wanted to offer that to you as one woman to another,
Well, thank you. I appreciate that. And all my friends of color, I will share that with them, who I love very dearly. And I exercise with them every morning and love them. So thank you. I do appreciate what you do. And I hope there will be one specific bill and not a bill that has so many other things in it that just doesn't work for whatever reasons. And I hope there will be one specific bill that we can all agree on to do something that's going to work. Because as I said to the other woman, we're here every year talking about the same thing. And it seems like things that maybe have been put into place or not aren't working. So I think we need to get to what's working and let's do it and move our society forward. Thank you.
Thank you very much, Representative Zupkis. Senator Moore.
Hi, Callie.
Hi, Senator.
Callie, a million times I tell you this, I appreciate the work you do, especially as a white woman, because it's one thing when it comes from people who have been on the receiving side of bias and racism. It's another for someone to be woke, as they say, woke. And so I think about, I've heard this asked a couple of times about programs and how are programs going to change anything and how's funding going to change anything. Those are ends, right? Those are methods to get to where we need to get. And you can't legislate love, but you can start to acknowledge that there is a problem and we are willing to deal with it. It is not a program. It is not there's no program in the world that is going to change systemic racism. It is the hearts and minds and dedication of people like you. Dr. Everett was on earlier. There's other people who have been talking on about the work that needs to take place, not just in the legislature, but within ourselves as individuals. First thing has to happen, and I know you know this, is that you have to first admit and you have to declare it, that it does exist and that you're committed to making those changes. And that's what I appreciate about the work that you're doing and how you come forth every single time. And, you know, I know I tell you this personally, but I really wanted to be out in the universe. If I could multiply you over and over again, there would be enough people out here who would be spreading the word, because those conversations don't need to take place at tables with people of color because of the experience. Those conversations need to take place among white people and have real honest to goodness conversations about how the systemic and structural racism has created all these other problems that we have. And it's not about putting a program together. It's not about funding a program, because those programs can go on forever until we decide to change our heart. And I think mine is more of a commentary than a question, but I just want to acknowledge the work that you do and say how much I appreciate you expressing it here. And if you want to respond to me, that would be fine. I haven't seen you in a while.
No, I just wanted to say thank you. Yeah, I'm so happy to be here. And you know, I just actually wanted to say very quickly thank you to the Doula Coalition, because this is why I came here. And then I heard Dr. Everett's testimony, and then I was just like, oh my God, you know, it just it came up from my spirit. So I'm very, I just feel so grateful to be here and to be your constituent.
You know, we started with the doula last year, and I joined the coalition and talked to them a lot because understanding Black maternal health and the difference that they can make in healthcare. And that's the systemic racism. Like, if you keep them blocked out and they're not allowed to be a part of the system, then they can't help make the changes from birth. And then as time progresses, our children continue to face other problems with mental health, physical health, disparities are created. So it's like, this is the root cause of why we are here in this mess today.
Absolutely.
It's racism that has created these problems. So I want to thank you for being my constituent and being supportive of what needs to get done and doing the work. So thank you.
Thank you.
Are you good, Senator Moore? Thank you, Senator Moore.
Thank you, Madam Chair.
Senator Anwar.
Thank you, Madam Chair. Thank you, Kelly, for your testimony and your wisdom that you've shared with us. I wanted to touch a little bit about this legislation of love mindset. And I think that, look, the reality is that we legislate values. Our budget is based on values. And if love was a value and we humanize our fellow humans as equal, as like our family, and when we look at each other as a family, we automatically want to do good by them. And we want to talk about not me, but us. And that is what love is. When you talk about communities, not about making a law for my child or my mother or my father or my wife, right? You're making policies about fellow community members. And if you have a starting point that they are equal, and if something wrong has happened to the people who are your equal, you have to undo that. And you have to fix that. And that requires us to actually say that, look, we have made a mistake. And even I was not physically involved in that mistake because I was inheriting that mistake. And I would have known, had I been in that time, I would have not done that. And you cannot go back in time, but you can go forward. And I think that's what legislating love is. When we have to talk about our housing policies, when we have to talk about our healthcare policies, when we have to talk about allocating resources, I think that's how love is shown, in my opinion, and that is how it would be legislated. And I think that's what you were alluding to, rather than saying that you're going to go and hug each other. No, you hug each other by putting values and resources where they need to be. And I think some of these legislations are going in that direction. And then another way of showing love is not to say no to something because there's one little piece of something that you don't accept. But the larger good that you're going to do through that, you say, you know what, this is 95% of what I want. I'm not going to walk away because of the 5%. And when we have this conversation, come to the JF meeting and listen to it. You will see people saying no to it for 5%, 2%, 1% reason. And that's when I say it's not love at that time. It is politics. That's what I'd say. Thank you so much for bringing up this very important conversation that actually made me think, and I could not help but share my thoughts. Thank you. Thank you, Madam Chair, for allowing me.
Thank you, Senator. It looks like that's it, Ms. Helm. Thank you so much for your time today and for this very productive conversation. Thank you. Next is number 109, Yvette Young.
Hello, everyone. Good evening.
Go right ahead.
Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Yvette Young, and I live in Windsor, Connecticut. I stand in support of Senate Bill 1, more specifically Section 6 and 7, to declare racism as a public health crisis in the state and establish a commission to study the impact of institutional racism on public health. Racism or discrimination based on race or ethnicity is a key contributing factor in the onset of disease. It is also responsible for increasing disparities in physical and mental health among Black, Indigenous, and people of color, BIPOC. And this was from medicalnews.com. For centuries, BIPOC individuals have had to endure extreme physical and mental trauma. These lived experiences have had an impact on the health and wellness of these individuals, impacts that have been passed down from generation to generation. The systemizing of racist practice has left many people of color in conditions that are not adequate for wellness. Racism is a catalyst for the disparities that exist in the 5 areas of the social determinants of health. The World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age. The 5 categories are economic stability, healthcare, neighborhood and environment, education, and social and community context. Research has shown that people of color are disproportionately negatively impacted in all 5 areas. The Black maternal rate currently is at 48. Communities of colors often do not have a primary care doctor or have access to preventive care. Food insecurity is 2 times higher in communities of color. Children of color are disciplined at a higher rate than their white peers and often pushed out of the education system. People of color, especially Black men, have the highest representation in the prison system, and the list goes on and on. The COVID-19 pandemic highlighted the inequities that exist in our system and has intensified the disparities people of color were experiencing. People of color have been dealing with a health pandemic and a racial pandemic over the past year. Racism has had and continues to have a massive impact on the lives of people of color, and as a result needs to be classified as a public health crisis. As a woman of color, I do not want to have to worry about my wellness. I do not want to have to worry about the wellness of my parents and my loved ones. Every day I wake up, I must navigate through a world that is built to oppress me. I know that my Blackness makes me a target for inadequate treatment on a personal level, as well as for my overall health and wellness. This reality is why I find it necessary to advocate for the needs of the BIPOC community. Until we admit as a society that we live in a nation that is built on racism and begin to correct the disparities that have resulted from centuries of oppression, the health and wellness of people of color will continue to be compromised. Senate Bill 1 is an opportunity for our state to lead the pursuit for racial justice with action. I stand with the Connecticut Campaign to Address Racism as a Public Health Crisis and ask that the following recommendations also be considered. And in the interest of time—
Jen, you've reached your 3 minutes if you'd like to give a conclusion.
Thank you. In the interest of time, those recommendations are included in my written testimony. So in closing, I urge you to support Senate Bill 1. It is time for this nation, for the state, to repair the damage that has resulted from racism. It is time to prioritize the health and wellness of BIPOC individuals. It is time for Black, Indigenous, people of color to heal. Thank you.
Thank you, Ms. Young, for your very effective testimony. Thank you for being with us tonight. I don't see any questions. Have a good evening.
You too. Thank you.
Next is Jim Icabellis, number 110. Go right ahead, sir.
Good evening, Senator Abrams. It's a pleasure to be with you here and the members of the Public Health Committee. I'm Jim Acabellis, the Senior Vice President of Government Relations at the Connecticut Hospital Association. I'm here to testify on Senate Bill 1. As I've said to this committee before when I've testified this year, we are 1 year away from when our lives changed and may have changed forever due to this pandemic. Hospitals became a foundational partner with the state in fighting this pandemic. Since it began, we have set up countless COVID-19 testing centers, and now we are a key part of the vaccination program in Connecticut. It amazes me every single day, and I'm so proud to be able to say every single day that I work for the healthcare workers who have been operating at a sprint, but for the length of a marathon. They are amazing, and it's an honor to be here. As I said, our lives have changed forever. Things have become evident to many people that weren't evident before, and Senate Bill 1, I think, addresses a lot of those programs. It's an important bill. It's a very important bill. And there are many provisions in this bill that we wholeheartedly support. Our testimony details our comments by section. It's a 6-page testimony that goes through section by section. I want to highlight a couple of things before I discuss one problematic section. We encourage the committee to align this bill with other bills that the committee and other committees have working on. The community benefits section. This committee already voted out a community benefits section. In fact, this afternoon we had very positive conversations with the Office of Health Strategy to come to resolution on that bill. We need to align those. There are a couple of sections like that. There are also a couple of sections where we need to align the sections of this bill with ongoing work. The Maternal Mortality Review Committee has been up and running for a number of years. The maternal mortality law has been in place for a couple of years. We need to align and work these sections of the bill into the existing work of that has been going on. But most importantly, I'm here to ask you to delete Section 8 of the bill. Section 8 establishes nurse-patient ratios in intensive care units in the hospital. The bill requires that there be 2 nurses per patient in an intensive care unit in the hospital. We are opposed to statutorily imposing nurse-patient ratios on hospitals because it doesn't recognize what we think is really important: the extraordinary work of the nursing leaders in Connecticut today that take into account both the acuity, the severity of every patient, that on a daily, hourly basis make these decisions. So
Acapellis, you've reached your 3 minutes. If you'd like to give a conclusion.
Absolutely. So we oppose Section 8 of the bill, and I'm happy to answer any other questions, but it's important to note that hospitals since 2015 have been providing detailed information to the Department of Public Health related to staffing plans and staffing ratios. So thank you.
Thank you, sir. Representative Pettit.
Thank you, Madam Chair. Thank you, Mr. Acabellis. I would tend to agree with you. I think legislative body establishing criteria for staffing at a place is critically as important and variable in terms of intensity depending on the time of the year and what happens to walk through the door is a very risky proposition. But my question really goes to the previous speaker, Attorney Taubman, about rationing and the like, and I wondered if you would make some comments on that issue in general for the hospitals.
Sure, thank you. I caught part of it. I was logging into, but I think I understand the question and understand where Attorney Taubman was. And let me fill in a couple of other details. First of all, I think it's important to say that we are fortunate in Connecticut of all the work that the hospitals did and did not have to use any crisis standard of care policy in Connecticut ever once. That is important to say. Secondly, it's important to say that hospitals do not discriminate. We are governed by, as you said, the ADA and comply with the ADA. Some other part of this conversation. we have been having conversations with the Department of Public Health. We support them developing statewide guidance. Let's be clear, we support them doing that work. We understand what they have said is we want to do this work. It's important to us and it's on our list of things to do. We are monitoring what is going on across the state. And if need to be, we will up our timeline to get to this work. But they didn't only do that. They reached out to the Office of Civil Rights. The Office of Civil Rights became a technical advisor to them. The Department of Public Health looked at two policies, one from Hartford Healthcare that Attorney Taubman said was one that they supported. The Department of Public Health said the policy from Yale New Haven Health was also one that they supported. They sent those policies out as models to the other hospitals. We amplified that message and sent them out to the hospital saying, if you don't have a crisis standard of care policy, use these as guidance to create one. If you do have one, use these as guidance to and address what could be concerns in there. I can't address, these documents are not static documents. They are socialized with the community. They change based on medical science. They change based on changes in the science of COVID-19. So I can't comment on what version Attorney Taubman was talking about, but so the department and then us amplifying these two as models, the department then reached out to the hospitals and said, okay, please provide us with what you have been doing in order to use our recommendation to use these as models. So the department has been following up that way. But we do agree with Attorney Taubman that a statewide guidance is important, but it's important to have a broad, important conversation about crisis standards of care. They are important decisions and they should be broad decisions with many stakeholders. So I hope that answers what I think was your question, Dr. Pettit.
No, it does. Thank you. And I just wondered, I don't know how recent it was, if you have a feeling if most of the hospitals have responded and started the conversation and started to implement these policies, or if it's too early to know who's going to be willing to voluntarily put these policies in place at their institutions.
Well, I think I want to unfortunately address one of your words. When we talk about implementing them, we haven't had to implement them because we haven't been there, but to have a policy available. The last conversations with the department were probably about a month ago when they reached back out to the, may have been a little longer, time is sort of fleeting now. They have reached out to the hospitals to have them respond on how they have been developing the policies. The department has said all along that they wanted to get to this in March, but I don't have any sort of up-to-date anything further than that.
Well, I thank you, and we survived the Ides of March, so happy St. Patrick's Day, and with that, I will yield. Thank you, Madam Chair.
Thank you so much.
Ides of March, forgot about that one. Thank you.
Yes, happy St. Patrick's Day.
Representative D'Amico.
Thank you, Madam Chair. Thanks, Jim, for coming in and testifying. And I appreciate your explanation that you just gave to my colleague, Representative Pettit. And I appreciate all the efforts, the massive efforts that the hospitals have made over the last 12 months. You certainly can't understate any of that. But I was just curious to know if you had any knowledge of some of these policies that Mr. Taubman referenced a couple of speakers ago. He said that other states adopted policies long ago. Would you happen to know the specifics of the policies that these states did adopt? And if so, why in the world is it taking us 12 months to do something that they did in a couple of months?
I have a different understanding of what the other states did. Sheldon, Attorney Taubman is correct that other states have come to agreement with the Office of Civil Rights. What happened I know in Tennessee, and I'm pretty sure it was Alabama, Tennessee and Utah, is states had policies which the Office for Civil Rights felt violated the ADA and violated federal law. So they came in and said, we need you to affirmatively change those policies. So that's one group, but there are other states, Attorney Tubman is correct, such as Massachusetts, who have had crisis standards of care. I would refer you to the Department of Public Health on the timing, Representative D'Amico, because I think they can, I don't want to speak for them, but I can tell you what they have done with respect to the hospitals. But their response back to Attorney Taubman, I would refer you to the Department of Public Health. They're probably best to answer that.
Okay, thank you. I was just curious because I know you stay on top of things, Jim. So I just wanted to explore that.
I try.
Yes, indeed. All right. Thank you very much. Appreciate it. Thank you, Madam Chair.
Thank you, Representative. Representative Carpino.
Thank you, Madam Chair. Hi, Jim. How are you?
I'm great. Thank you.
I just wanted to touch base on your staffing question. As I'm making my way through testimony, I haven't gotten to yours yet. If a staffing minimum such as this were imposed on our ICUs, I'm really worried about the consequences for the patients and the liability of the hospitals. So to that end, if a staffing ratio like this were implemented, could we potentially be facing ICUs reducing their capacity if they didn't have the appropriate staffing, or closing down portions, or diverting patients? I just see a cast of awful things that could potentially occur. And we were so fortunate that our ICUs were able to manage the unthinkable conditions and do it so well over the past year. I'm just concerned for a patient care always, and B, the long-term ramifications. I understand the potential legal liabilities if staffing were to fall below a new requirement, but I'm worrying about the potential for losing beds. Can you talk to that at all?
Yeah, Representative, thank you for that question. And I try not to come before this committee and sound like Chicken Little, the sky is falling, but I agree with you 100%. I think that let's recognize what this bill says. 2 nurses per patient. That's what this bill says. 24 hours a day, 7 days a week.
Excuse, can I just stop you there for a second? I think that was a mistake in the writing. It's supposed to be the reverse.
Well,
Okay, so I just want to make that clear because it will be corrected. So I
understand. Thank you, Madam.
Okay.
Well, I would hope that it's corrected with obviously that I'll get back to you, Representative Carpino, but Senator Abrams, that kind of gets at another concern of mistakes happen and errors happen in statutes and whatever. This is something that we think should be handled on the ground as opposed to in legislation that could cause other problems. But yes, Representative Carpino, I think the bigger issue is where this is currently drafted, 2 per patient, or flip it, 1 for every, is where do we find the nurses today, even if we agree it is a good thing? Hospitals in Connecticut have had to bring in healthcare workers from out of state. We have provisions in executive orders which have allowed flexibility in licensure. We've had to increase the ability to have nursing students come into hospitals during this time. It has been extraordinarily difficult. I don't think you are incorrect at all about what some of the consequences could be. It is something that we feel really strongly about, that it does not belong in statute. There are long-term unintended consequences. We think the legislature took the right approach a number of years ago, requiring hospitals to provide information to the Department of Public Health on their staffing by units, and then to go back in the following year and talk about how they managed and what situations if they didn't hit the ratios, why they didn't do it. So that has been in place since 2015, I believe. So that is the approach that we believe is the right approach. But I agree with you completely, and thank you for that question.
No, and I appreciate, and I assumed that that was a typo or perhaps some, well, we won't even go there. I was hoping it was a typo. I assume nothing in this
It's a
building.
scary typo.
Yeah, I assume nothing, and I thank you, madam. And my last question, and I want to be clear. I can't speak to best practices. I leave that to the medical professionals and the hospital administrators and the nurses who are there on the front lines. So I understand that best practices and putting things in statutes are very different. I would always advocate for best practices, but as this is an issue before us right now, are you aware of any recent increase in medical errors in Connecticut hospitals and ICUs that might be driving this legislation? I am not, but if there is something objective that is driving this, please educate me so that I better understand.
I do not have any information on why this provision was added to this bill. And it's, I don't know why it was added to this bill. I have not heard of anything except for significant praise on how the hospitals handle this in their ICUs. So we are as surprised as I think you are on why it is in here.
Thank you. Thank you, madam. Thank you. It's good to see you, and I appreciate your information.
Thank you.
Thank you, Representative Carpino, and thank you for your understanding and me interrupting you. Senator Anwar.
Thank you, Madam Chair. Thank you, Jim. Excuse me. I wanted to clarify, how many ICU nurses have you had a chance to talk to specifically about this in the last few weeks?
How many acute care nurses?
No,
ICU nurses?
Yes.
We talked to our, in the last few weeks, probably I haven't, but we have had continuous conversation with our nursing leaders. We do it on a monthly basis.
Okay, nursing leaders, which is the leaders are not doing hands-on ICU care.
Okay.
So nursing supervisors are not involved for the most part in hands-on ICU care, except in dire situations. But I'll repeat my question. How many ICU nurses that are providing hands-on care to the patients have you had a chance to talk to?
I have not. I've had conversation with the nursing leaders.
And maybe that is the reason you've not heard anything. Because when you say I've not heard anything except praises, I think arguably I can suggest that maybe you have not been talking to the right people. I can tell you, I have been talking to ICU nurses some days every single day for 10 hours a day. And the ICU patient, when we are managing those patients, you're taking care of their blood pressure, oxygen, blood tests. You are not able to use the restroom. And the nurses have been doing God's work and nothing less than that in the last many months, but literally every single day, even prior to the pandemic. Many other parts of the country have been very clear. They have made this provision, and they have made it because it is inhumane to have somebody take care of critically ill patients and have 3 patients and maybe 4 patients in some situations. And I know you're representing the Connecticut Hospital Association, and there's a cost involved with this provision because you will have to hire more nurses to take care of that. But you have to also look at the fact that there are some challenges when you are having nursing staff not be able to get lunch, not be able to use the restroom, be working nonstop. One of the most dangerous profession when they make a list of the professions, nursing is considered one of the most dangerous profession there is because they are losing their backs in their age 40 or 45 range. The reason is they have to lift these heavy patients, take care of them, and go from patient to patient. In the intensive care unit, those patients aren't able to move and move themselves. These nurses are doing the work at this time. Yes, they get some help from each other, but it's still the same nurses. I would urge people who are not in the position of authority to result in loss of jobs of the nurses to talk to them. And I can get you to meet them all as long as they know that their jobs are going to be protected and they would not be impacted by saying and speaking the truth. And right now the nursing staff it is not the right thing to do to actually have them have more than 2 patients in the ICU. The fact that we left it up to the hospitals to make that decision has resulted in what we are seeing right now, that many of the cases, it's not happening, except some hospitals have made their own rulings, but it's not across the board. And the fact that it's not across the board is the reason why we have to put something like this into a law, because laws are made for the people who don't follow ethical, moral boundaries. The good actors don't have to worry about it because they're always good actors, but there are not some good actors that are out there. And that's why we have to make some of these rules. And they are relevant. If you talk to nurses who are actually directly impacted, you would be surprised that there would be very few who will say this is not a good idea. And if you have any
Senator
questions,
Anwar?
yeah.
I just wondered if you had a question there.
Yeah, I just want to clarify because Madam
I know, but
Chair,
I think you have. So there's other people waiting to ask questions. So I just want to make sure we get to them.
okay, so I would love to talk to you more about this, but that's where I stand, and that's the rationale for this.
I am happy to have those conversations.
Thank you, Madam Chair.
Thank you, Senator. Representative Betts. Representative Betts, are you there? Good. You're on mute though, sir.
Yep.
Oh, I think we lost. There you go.
Now you can hear me. Sorry about that.
Now we got
Thank you very much. And thank you, Jim. One of the concerns I have, not just with this legislation, but with laws and legislation in general, is a lot of people turn to it as if it's going to be a solution to a particular problem. And it's my own view that there are times when we may try and do good, but we don't have the expertise or the experience on how to make it happen. And what I'm really confused by is this requirement, and as the good chair lady said, it was a typo, but is it our role, our business, or are we the right solution to take care of nursing care criteria? Because I personally don't have the first idea as to what would be appropriate. I do believe that people who are in intensive care get the very best possible care available and possible. I do not think it's a money issue. I think they're, committed to taking care of the patient and bringing him back. So my question is, and I'm not trying to put you in a difficult position, but do other states try to address these problems without legislation? And if they do, getting back to Representative Carpino's question, it strikes me as if this is a real opportunity to create a lot of lawsuits that could be avoided. And I wonder if you have any knowledge nationwide or locally about that.
Thank you for that question, Representative Betts. My understanding is that the state of Massachusetts has a nurse-patient ratio for ICU units, and California has nurse-patient ratios, but I am unaware of any other states that do. Most other states that I'm aware of have what we have, which are nursing plans, require nursing committees, requiring reports to the Department of Public Health to monitor and then follow up the way we do in Connecticut. So that's my understanding of what is out there in other states.
And the other one, just to follow up on it, I have been on a board of directors for a hospital, and I had the experience of serving on a quality assurance committee. And if any error or mistake is made, it goes to that committee and they make recommendations to try and make sure that does not happen again. That seems to me to be a logical system in terms of communicating and identifying what needs to be done, per case, per hospital. Again, I'm not so sure legislation is, one size fits all. Obviously, there are a lot of other hospitals, as you just said, around the country that do not do this. And all I know is I think they've done a great job. I think they've done the best they can. And the inference that they haven't, and we need to add more, I think is not accurate. And I just don't see the benefit to them or to the hospital or to the patients by just coming up with a number. And obviously, if we did that, we might be the only one in the country. So should all the other hospitals do it? I mean, I think we should be our own boss and determine our own policies by the medical care professionals and not legislators as well-meaning as we are. So thank you very much, Madam Chair, and thank you, Jim.
If I may, Representative Betts, I think it's also important to note that we in Connecticut have a sort of a landmark initiative going on, which is high reliability, which is when it is based on the science of high reliability that is used in the aviation industry and the nuclear power industry, which is to make sure that everybody throughout the hospital, and we have trained tens of thousands of hospital employees, can stop the line, can make sure that they can ask every question, that they can cross-check every question, and we are really proud of that. But I should address something that Senator Anwar said is we recognize the stress that healthcare workers have always been under, but have been under in the last year. I think we have had conversations at this committee, had conversations about, we currently recognize these healthcare workers, and I may have not been as artful when I talked about them working at a sprint for a marathon length of time, but they have been doing this, and we recognize its impact, and we recognize that the provisions of this bill talks about equitable access to mental health care. That is an important topic. We had a conversation with our human resource leaders along with the Department of Mental Health and Addiction Services to make sure that all of their resources are getting to where they need to go. I can't stress enough that we recognize and we are concerned about what this lengthy pandemic is doing to the healthcare workers, as it's doing to all of us, changed our lives. It is impacting them. So I think that was important to note as well.
Thank you, sir. I just want to take this moment to ask committee members, we're going into our 11th hour. And if we could focus on questions, we'll have plenty of time to debate the merits of these bills. So I want to make sure that we use our time wisely and are respectful of one another in that. So let's see if we can stick to questions.
Okay, I'm finished. Thank you very much.
Oh, I'm sorry, Representative Betts. I thought you were finished. I apologize. Nope. That was not directed at you in any way, shape, or form. I didn't mean to interrupt you.
Okay.
Okay, I think that's it. Thank you very much for your time and for your testimony today. We really appreciate you being here.
Thank you. Happy St. Patrick's Day.
You as well. Next is, number 113, Sonia Jelks. Welcome, Councilwoman. Nice to see you. You're on mute, I think. Well, you're not on mute for us here, but.
Can you hear me now?
We can hear you. Go right ahead.
All right, thank you. Good evening, Chairperson, Senator Abrams, Representative Steinberg, and the distinguished members of the Public Health Committee. My name is Sonia Jelks, and I'm a resident and city councilor of the great city of Meriden. And I'm also the Connecticut director for a national nonprofit, the Corporation for Supportive Housing, and I'm here to express support for SB 1 and for Senate Bill 834. On Senate Bill 1, specifically, I want to express support for Section 6 and 7, the portion of the bill that will declare racism as a public health crisis. While my background is not in the healthcare field, my work in the community as a counselor has allowed me to work with our local health department on issues of community health, which have often highlighted the disparities in health outcomes for people of color and health challenges in which they may face daily. As many have already pointed out in earlier testimonies, historical systemic racism and institutional racism, the lack of access to healthcare, limited access to healthy living environments and proper nutrition, economic disparities, and just a general mistrust of the medical profession and trauma from racism has helped to contribute to these health disparities. And COVID has only highlighted these disparities, particularly with Black and Brown populations. The work that could be addressed in this bill is so important to me personally and professionally, as I've experienced the effects of COVID in the health of my family members and those in my community, because this pandemic has been incredibly destructive on our elders and on our families. So you're aware a similar resolution to declare racism as a public health crisis is currently before the Meriden City Council. And thanks to organizations like Health Equity Solutions, this is happening in many other communities around Connecticut and the country. Locally, we're trying to do our part in eradicating health disparities for vulnerable members of our community. And I would encourage the state to also take action and help this work by creating state level requirements to set standards for local health departments and health partners to help make these systemic changes to improve healthcare and outcomes for all. I also appreciate the impact of the zoning restrictions that are included in this bill for housing, as they are also health determinants they're also determinants of your health based on where you live and the quality of healthcare that's available to you. As a Southern-born resident now living and serving in Connecticut, I'm very grateful and encouraged that the state of Connecticut is having these discussions. And I appreciate the legislative opportunities to really look at addressing racism head on. I appreciate the effort to create the Truth and Reconciliation Commission, and I give much respect to that title because I think that, you know, dealing in facts and truth around racism and trying to build reconciliation is important. And I do believe that, you know, as we're looking at the institutional racism and its long-held effects on people of color and the efforts to find solutions is important. And I would just like to suggest to members of the commission that would be formed be very diverse and most specifically include the voices of the BIPOC community, as these are really
Ma'am, you've
about
reached
the
your
health
3 minutes
concern.
if you'd like to give a conclusion.
I also just quickly want to say that I am in support of SB 834, which requires property owners to also notify tenants of water notifications from municipalities. Landlords are in the best position to make these assessments and calls for their tenants. And I would just encourage you to protect all of our residents, those that rent and also own property. Thank you so much for the opportunity to testify today.
Thank you very much, Councilwoman Jelks. It's so great to see you, even if it's virtually. I wondered if you could, you touched on it for a second, but for the commission, is there any particular representation that you think might be helpful for us to consider?
I'm appreciative when I looked at the makeup that was being suggested, that there are legislative bodies and agencies that are mentioned. I would like to just make sure that, you know, most of these bodies and agencies are not necessarily diverse. And so I would like to encourage that if there are participants that are assigned, that they do represent some diversity. Obviously, diversity and knowledge and experiences are included. I would like to see there be some community advocacy groups that potentially become involved, especially groups like Desegregate Connecticut, which spends quite a bit of time on zoning laws, which we know have roots in systemic racism. I think that we may be lacking some educators who I think may be critical in helping to educate about racism and about, you know, the impact on communities. And so I think that if we, you know, include education as a part of this commission, I think that would be important. Obviously, you know, housing experts. I think one of the young people earlier, and I'm 48, so I can say young people, suggested that there be some youth participants, and I think that that's also important. And obviously, people with lived experiences. If there are people in our community in Connecticut that, you know, have done work and research and have great advocacy on behalf of racism and combating it and helping us to become an anti-racist society, I believe that they should also be included as well.
Thank you very much for that answer. I don't see any other hands raised, so thank you for being here. Thank you for all the work you're doing in our community to address these issues as well. And it's always a pleasure working with you. So
thank you.
I appreciate you taking your time to share with us tonight.
And thank you guys so much for your time and stamina and your work that you do on behalf of the state of Connecticut. Good to see you again.
Good to see you.
Bye-bye.
Next is 115 Rob Brill. Welcome.
Good evening to members of the committee, particularly Senator Abrams and Representative Steinberg. I'm Rob Burrill. I'm president of District 1199, the New England Healthcare Employees Union. We represent about 25,000 workers in Connecticut, including about 7,000 nursing home workers. I'm here today to speak in support of Senate Bill 1030 with some changes I'll speak about in a second. And also, I would like to voice our support for Senate Bill 1, particularly Section 6 and 7 to declare racism a public health emergency. What we've seen during the course of the pandemic has been that both the work that our members perform and the care delivery system are tremendously racialized. No one knows more than our members where the intersection of race and class can result in deadly impacts on people's health and life experiences. Our members have been both sacrificing and suffering through the course of the pandemic for the past year. So with that, I would say that we applaud the committee for raising this bill. We feel that it's a strong start towards a much needed conversation about the quality of care that we give to the aging in Connecticut and to the addicted population. We know that over 4,000 nursing home residents have died. Many thousands of them, of our members, have also gotten sick. Of course, this is a Medicaid population and a Medicaid funded workforce. And again, we know that those workers and the patients are disproportionately Black and brown and overwhelmingly low income. Many of the workers have to work multiple jobs because their wages are so low. And, obviously this is a publicly funded workforce. So we think that Connecticut really needs to take steps to lead in moving workers who are dependent on public dollars for their livelihood out of poverty, and also in terms of the care delivery system to make sure that we are adequately staffing and providing for services that allow long-term care residents to live lives of dignity. Unfortunately, these days, the low staffing members mean that the workforce is overworked. That has, of course, in large part to do with the pandemic and the danger inherent in going into long-term care environments. 22 members of our union have died in the past year, and an equal number of family members who were not healthcare workers themselves. But it also is a longstanding problem based on the low wages and the difficulty in obtaining benefits. The majority of our nursing home members have their children on Husky for health insurance. Most workers are barely making $15 an hour. And so what that's meant is that there's been a collapse in staffing across long-term care, whether it's group homes, home care, or nursing home.
Mr. Burrill, you've reached your 3 minutes if you'd like to give a conclusion.
Yeah, just briefly, what we're looking at is improving the staffing ratios in the bill, making sure that there's oversight. We oppose the shift language of 12-hour shifts because that will just destroy workers' lives and ability to care for their families if they have to drop second jobs, and that there needs to be PPE access that's mandated with strong penalties to protect the livelihood of the workers and the people that they care for.
Thank you so much, Mr. Burrill. I have to say that, again, it's been a year now that many of us have been in contact with your membership as well as your union and the leadership that you guys have had over the course of this year in speaking out and advocating for your members. And I really thank you and your whole organization, your hard work and helping us, stay aware of what was happening on the ground floor. So it was really important to have your involvement. So thank you for that.
Thank you, Senator Abrams.
I don't see any questions at this time. So thank you very much for being here. Thank you for your continued work, and have a nice night.
You too.
Next, we have 116 Franklin Ude.
Yep.
Thank you, Franklin. Go right ahead.
Senator Abrams, Representative Steinberg, members of the Public Health Committee. My name is Franklin Ude, and I live in South Windsor, Connecticut, and I stand in support of SB 1, Enact Comprehensive Access to Mental and Behavioral Physical Health Care in response to the pandemic. I strongly believe that racial equity should be a top priority for our communities. That's why I come before you to make the case as to why racism must be declared a public health crisis in Connecticut. This will be a critical first step because we can begin to address this problem as a systemic and structural issue rather than the faults of individuals. If we can pass legislation addressing this issue, we can begin to root out these problematic structures that keep racism so deeply embedded in our system. Being a Black man, I have seen the effects of racism on health outcomes in people, friends, and family that I interact with in every aspect of my life. Systemic racism itself is a social determinant of health, creating inequities across all other social determinants of health, such as housing, food, income, and built environment, and access to healthcare. In turn, Black people experience disproportionately higher rates of infant mortality, asthma, heart and lung disease. We've also seen these inequities made worse by the COVID-19 pandemic, where we've seen Blacks and Latinos experience higher rates of infection due to them making up a lot of the essential workforce and living in more crowded housing, coupled with the inequalities that they already face. This pandemic takes a more serious toll on them and their white counterparts. I personally can attest to this based on what I've seen in my field of work. I currently work as a research assistant in a sickle cell clinic where I interact with sickle cell patients on a regular basis. Due to the fact that this population is mainly Black and African American, they collectively experience racism and inequities in the social determinants of health, as I mentioned before, housing, food, access to healthcare. And when they have sickle cell disease, management of their disease becomes much more burdensome since they don't have the basic necessities that have an impact on health outcomes. From these patients, I've heard stories about longer wait times in the emergency room, being expected to have higher pain threshold, labeling as drug seeking when they need a pain medication, as well as lack of trust with their providers. The racism and social inequities in this population faces a greater burden of disease for a condition that is already debilitating and even deadly. I'm convinced that if this population wasn't predominantly Black and African American, the situation will look very different. Specifically, I strongly support the components of this bill because when we look at this as a structural issue, one that limits the ability to live well and thrive, we can then begin to dismantle the system-driven conditions that have a negative impact on our health outcomes. The pandemic did not create racial inequities in our state, but it did in fact expose and exacerbate them. I hope we'll move Connecticut to address them and move Connecticut closer towards health equity.
Thank you, Mr. Udy. Thank you so much for your testimony. Senator Anwar.
Thank you so much, Madam Chair. Thank you, from Mr. Uday, for your testimony and your work. And now with your public background, I know you have a master's in public health and you've been working on the sickle cell related area. Have you seen situations where the patients do not get the pain medicine during crisis?
Yeah, so usually because I'm a research assistant, so when patients come in for a research visit, we pretty much ask them about any past issues with sickle cell pain or anything like that. So we've heard stories about doctors and providers refusing to prescribe them something because they might think that they're trying to con them out of medication or that they're drug seeking. Or if they're going into the emergency room, they're expected to wait longer than other people. So it's just constantly whenever pain is involved, and whether it's they need medicine or to need a transfusion and need immediate medical attention, there's always that just stigma there that remains a big obstacle in them getting care. So, and then at some points it pushes them to not even go, because then they say, I'm going to go back to the emergency room to get the same thing that they did to me 2 weeks ago. And it just gets very tiring for them.
I think that's what I was reading on the research as well, that the pain control, even individuals with fractures aren't getting any pain. So thank you for your testimony. This is very helpful. And thank you for making South Windsor proud.
No problem. Thank you.
Representative Foster.
Hi, thank you so much for being here today and speaking to us. I'm really glad that you have come with expertise on sickle cell disease. I think it is often a condition that is the perfect example of how racism has impacted care. And there's been a lot of research actually recently since the murder of George Floyd that has used sickle cell disease as the sort of example of how racism is real and exists in our healthcare system. Are there any examples besides pain medication, which I think is one that I hear a lot about? Are there other examples you could share with our colleagues here today about how treatment of sickle cell diseases is different than care for other diseases, and that has been attributed to it being tied predominantly to a Black or African American community?
So sickle cell is an inherited blood disorder. So it's like a genetic condition. And when you think about other genetic conditions, whether they're blood or inherited, those conditions, for example, hemophilia, which has a much lower prevalence than sickle cell, even though both are relatively rare, hemophilia is almost like half of what sickle cell is. But hemophilia benefit from more comprehensive treatment care centers around the globe, around the country. And hemophilia isn't something that affects just predominantly Blacks and African Americans. Like you'll see people, even white people with hemophilia, but even the disease that's more rare than that has more options for care and providers with that specialty in the certain condition. Whereas sickle cell, we don't have as many hematologists that specialize in sickle cell, nor the level of comprehensive care available in the country. And you notice that the sickle cell population is predominantly Black. The discrepancy is very clear as to what the priorities are when it comes to who gets care and who doesn't. If everyone should get care for any of their conditions, that's just me. But when you have a condition that affects predominantly Black and African Americans, the one that doesn't, and that condition that's much more rare has more access to care and more options than the one that has a higher prevalence, the discrepancy just becomes very stark.
Thank you so much for sharing. Thank you so much for sharing that. I think I had read at some point that there was a disparity in funding, and as you mentioned, the hemophilia example between sickle cell disease and I think that shows that the disparities in care exist from the research all the way to treatment and execution, and execution of care. So I really appreciate you so much for being here and sharing your expertise with us. Thank you.
No problem.
Thank you, Rep. Foster. I don't see any of your hands raised, but I have to agree with that thank you so much for sharing that. It's very enlightening to hear those statistics and the difference in the care. So thank you for being here, and we really appreciate your testimony tonight.
Thank you for having me.
Next is number 117, Totlin Riley. Welcome, go right ahead.
Thank you. Good evening, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Totlin Wyndham Riley, and I'm a CNA at 60 West Nursing Home in Rocky Hill. I have worked here for a little less than 10 years since the day they opened, but I've been a CNA since 1995. I love my job, and I take it very seriously because I love to put a smile on the residents' face. We are who they see every day. We are their family away from their family. I provide activities of daily living, ADLs, and hour of sleep, HS care for the residents. I am here today to testify in support of Senate Bill 1030 with a few changes. Specifically, I want to see penalties for staffing violations and PPE violations included in this bill. New staffing ratios are all well and good, but if they cannot be enforced when they are not followed, then they are not useful. Workers like me know that even now staffing levels are not always followed. So why would they be if we increase them? Access to PPE needs to be a violation because currently it is not. Stockpiling PPE is great, but if workers have no access, we are right back where we were when the pandemic started. DPAs told us then that access to PPE wasn't a finable offense, and it still isn't in this bill. When you don't give workers access to PPE, you put everyone at risk, including our residents. Proper PPE and infection control protocols have to be followed at all times. When we are short-staffed, we have to work much harder, and we are not paid enough or appreciated for what we do. If we have better staffing at all times, we will not have to double the amount of work like we do currently. We already feel overworked, overwhelmed, tired, and frustrated. We already don't always finish our work in a timely manner. With better staffing, residents would get better care. How can they get the care that they deserve when we don't have enough staff? Having too many residents at a time will not give them proper care. I like that this bill changes the staffing ratios to address the need for better patient care. Please pass Senate Bill 1030 with the mentioned changes. Thank you for your time.
Thank you, Ms. Riley. Thank you for your testimony. Thank you for the work you do. I'm sure you do bring a smile to the people that you work with. And we appreciate it, and especially appreciate what you've been through during this pandemic.
Thank you.
Thank you so much for sharing your experience with us tonight. Next, we have 123, Lauren Ruth.
Good evening, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Lauren Ruth, and I'm testifying today on behalf of Connecticut Voices for Children, a research-based child advocacy organization working to ensure that someday Connecticut is a thriving and equitable state where all children achieve their full potential. Connecticut Voices for Children supports Senate Bill 1, an act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. While this bold package of proposals is in response to the pandemic, we applaud that the bill includes language to address systemic inequities that predated COVID-19 and set the stage for the virus to disproportionately ravage communities of color. In consideration of time, I'll only be discussing Section 6 and 7 right now. Section 6 declares racism a public health crisis. We support this declaration as a critical pathway to interrogate the ways that racism degrades the health and well-being of residents throughout various aspects of state systems. Connecticut's most vulnerable communities, particularly low-income families and people of color, are more likely to be exposed to adverse social determinants of health, such as food insecurity, limited access to transportation and employment, housing instability, and the rotating door of Connecticut's criminal justice and child welfare systems, which makes managing chronic health conditions and gaining access to preventative care really difficult. Educational gaps and disproportionate school disciplinary practices impacts children's eventual earnings potential and inflicts trauma on students, which damages their health from childhood through adulthood. Section 7 establishes a Truth and Reconciliation Commission to study racial disparities in public health. In particular, it's charged with examining racial disparities and institutional racism in laws and regulations in the criminal justice system, racial disparities in access to healthy living resources, including food, public safety, and clean air and water, in access to healthcare, in hospitals and long-term care facilities, and in access to safe, affordable housing. We urge this committee to also consider the systems I discussed just prior, including child welfare, education, transportation, food systems, and employment. With that in mind, we suggest expanding the membership of the proposed Truth and Reconciliation Committee. First, two stated goals of the commission are to understand racial disparities in the criminal justice system and in residential zoning, and yet the co-chairs of the Judiciary Committee and the Housing Committee are not given membership or designees on the commission, and we think they should be included. Second, we advocate that community voice and youth voice are critical aspects of equitable, impactful, and sustainable public policy. As such, we would recommend including spaces on the commission specifically for impacted community members and young people. Third, we would urge the Public Health Committee to appoint expert organizations to help meet each goal. The currently listed membership is rich in public health experts. However, Goal 2 talks about criminal justice. Goal 3 talks about access to food, clean air and water, and public safety. Goal 5 is relating to nursing homes and other long-term facilities.
Ruth, you've reached your 3 minutes if you'd like to give
Sure.
a conclusion.
Goal 6 is to understand the impact of zoning restrictions on disparities. So we listed potential members to consider in our written testimony. And if you have any questions, thank you for your time tonight.
Thank you for being here, Ms. Ruth. Appreciate the testimony. I don't see any questions, so thank you for your input and have a nice evening.
Thank you.
Next, we have number 124, Tiana Rea. Are you there? I do not see you. Tiana?
Hi, how are you?
Oh,
you me now?
I can hear you now. Go right ahead.
I'm sorry, it's my first time.
That's okay. Go right ahead.
Hello, Representative Abrams. I'm sorry, Senator Abrams and Representative Steinberg and members of the Public Health Committee. Thank you for allowing me this opportunity. My name is Tanya Rai, and I'm from Tallinn, Connecticut, and I would like to express my support for Bill 1030. My mother, Janice, has dementia. Psychiatric care, family loving interactions, emotional support, and medication management are critical to her care. If she does not have personal loving interactions, she becomes anxious and restless. If she does not have someone to talk to, she becomes depressed. If her daily hygiene needs are not met, she will become physically ill. If her eating needs are not met, she will lose weight, which can cause additional health risks. If her physical needs are not met, she will become immobile. Pre-COVID-19, myself or one of my sisters would visit my mother daily to ensure all her needs were met. As soon as we entered the unit, she recognized us as her daughters, walked up to us, hugged us, and would proceed to having a conversation with us. We brought her food we knew she enjoyed, food she fed to herself. We changed her bedding weekly and did her laundry. We provided her with basic hygiene needs to ensure she was clean, and this also reduced the potential for bacterial infections. We took her out every other Sunday and every holiday for family outings attended by 4 generations. She was happy, mobile, and required minimal medication. During the COVID lockdown, my mother was held prisoner with no visitation. Her dementia prevented her from using the telephone, which left no means of communication from her family. I'd hate to think she felt abandoned, alone, and scared. She was not able to verbally express her feelings, nor were we able to determine her feelings based on her actions or her behaviors. We were helpless and mistakenly trusted her facility to care for her in our absence. During this time, she became immobile, stopped feeding herself, lost weight, and was kept on a sedative medication longer than required. I'm sorry. We were provided video calls. We discovered she had unexplained bruises on her eye and jaw. She could not comprehend a video chat. When we had our first outdoor visit in the summer of 2020, we discovered she was placed in a wheelchair and was no longer mobile. The staffing levels at long-term care facilities are less than adequate. The staff are not screened, tested, or educated for the specific needs of Alzheimer's or dementia care residents. The PPE, infectious disease prevention procedures, are inconsistent among the staff. The lack of video monitoring inhibits family members, essential caregivers, from monitoring the well-being of the resident. This bill requests that the administrative head of each long care facility ensure that its staff is educated regarding best practices for addressing the social, emotional, and mental health needs of residents in all components of person-centered care. The bill requests that the Department of Public Health establish an essential caregiver program to be implemented by each long-term care facility.
Ms. Raya, you've reached your 3 minutes if you'd like to give a conclusion.
Thank you. The program would set visitation requirements for essential caregivers of long-term care facility residents, require essential caregivers be provided the same infection prevention and control training and testing standards as received by the paid staff. If these requirements were in place in the past, residents would have received optimal care. Their essential caregiver could have been in place, thus freeing up staff for other residents more care for other residents more adequately. That concludes my my testimony. By supporting this bill, nursing home residents like my mother will be ensured of having access to qualified and educated staff, proper infection control supplies, and consistent family support. I'm in support of Bill 1030. Thank you for your time and consideration, and I hope that you will join me in supporting this bill as well.
Thank you so much for your testimony. You know, it's difficult to hear these stories, and I'm sorry for what you went through with your mother. She certainly was fortunate to have you and your siblings there, you know, and now advocating on her behalf. And I just want you to know that we hear you, and as hard as it is to hear these things, you know, I can't even imagine going through it. And it's so important that we hear these stories. So thank you for sharing that with us. Representative Pettit.
Thank you, Madam Chair. Thank you, Mrs. Ria, for your testimony. Two quick questions. I've asked some other people, and I wonder what your perception is as to what the home would need in terms of help. That is, do they seem like they're lacking in CNAs, LPNs, RNs, number one, and two, would have ongoing video monitoring been of any utility to you and the family during this time? You said you had intermittent video chats, but you had difficulty with that. But for you to be able to video monitor, would that have been helpful?
That is correct. The video monitoring to be able to watch her periodically throughout the day to ensure that A, she is out of bed, B, that she is being fed, and C, that she's out of her room. With my mother's dementia, she just wants to talk and feel as though someone is listening to her, or she just wants to, she'll kiss you to death, but she just wants to hold your hand. And I honestly feel as though she is being left in her room alone, facing the doorway with nothing else to do for the entire day but to watch the people walk by, and all she can do is say, hello, hello. Because, and this goes into the staffing levels, because there are 44 residents on my mother's dementia unit. There's 44 residents, and this is like childcare. It's adult daycare. They have specific needs. And there are 2 nurses on the floor. So that's 1 nurse to 22 patients that has to continually go throughout the day to distribute the medication. And I've only seen at any given time a total of 3 CNAs. So that tells me, and if each one of these residents, dementia care residents, if they need to be fed a meal, how much time do you think a CNA is spending with one individual to feed them? Now, during COVID, my mother lost 16 pounds the last 3 months. And we had to fight tooth and nail to get compassionate care visits to be able to feed her so that she would gain weight. My mother has always been a slow eater her entire life. She eats like she's the queen. And it takes more time than 30 minutes to feed her a small meal. And sure enough, once we were given those compassionate care visits, we were given 2 hours, 3 times a week at mealtime, dinner time. And it took us those 2 hours to feed her a complete meal. But she ate 100%. Now, according to the family meetings that we were having, I would always ask, well, what is the percentage of food she's eating? They would always say to me 75% to 100. Well, if she was eating 75% to 100, why is she all of a sudden losing weight? Or why did she lose weight? She's not eating that much in 30 minutes or less. If you're one CNA and you have 11 to 12 residents that you need to care for and feed, there's no way that you can get them all done in a 30-minute time frame. So
Absolutely.
So when I talk about staffing levels and I talk about the camera, if I had the camera, I can see exactly what is going on with her. Pre-COVID, I was able to see every day, any time of day, exactly how she was being cared for. For a year, I was not able to see that. In that year, and I wish I had the pictures to show you the difference between January of 2020 and January of 2021, where my mother no longer knows my name. She no longer walks. She no longer feeds herself. She no longer gives herself a drink from a cup. All of these things in just a year, I was told that that COVID caused her dementia to rapidly excel. I have not heard any statement from the CDC or Department of Health relating to that. What happened is that because dementia patients roam around from room to room and to people, looking for that emotional connection, although they don't think as clearly as we do, they still feel emotion. And they're looking for that emotional connection. And so they talk to each other, they hold hands with each other, and they visit their rooms with each other. And they take whatever they want, which is why we have to put their names on everything. This is their connection. This is their love. And this is their daily routine. And what I feel happened is that during COVID, when we were all locked out, these dementia residents were heavily medicated. And I'm going to make this bold statement. Put on a medication called Remeron, which is supposed to increase their appetites, so I was told, during COVID. Okay, my mother had COVID. She was quarantined for 14 days. She didn't require hospitalization. She required the Tylenol and the vitals being taken and so on and so forth. But why was she kept on Remeron for 45 days? Because this medication also kept them in bed. They were roaming around less. They were interacting less. They were touching each other less. They were infecting each other less. So rather than watch them and entertain them, they were medicated, so they were in bed. And it wasn't just my mother who after 8 months ended up in a wheelchair, but it was numerous other residents as well. Residents that I used to see, that my mother I used to call it the girls club. And the 6 of them would hang around together and hold hands, and they'd eat dinner together. And they would ask me who was going to pay and who was going to tip and all these wonderful things. They would all walk around together. All of them were in a wheelchair in 8 months. How is this so? How is this possible? Because you don't have enough staff there to watch them. And I didn't have a visual to be able to act sooner. Because had I known that that was occurring, I would have acted a lot sooner than today.
Well, you've done a great job here. Thank you very much for your very descriptive, and I think very, in spite of the emotion, very calm and very good.
My face is hot.
very good testimony for us. So thank you for all the love you showed for your mom and that you're showing right now by being here. Thank you so much. Thank you, Madam Chair.
Thank you all for the opportunity
Thank you,
today.
Representative. Yes, we really appreciate you being here. Your testimony has been very effective, so thank you.
Thank you.
Oh, I'm sorry. Hang on. Can you hold on, Representative Betts?
Thank you so much. Sorry for the late raising of the hand. Thank you. That really was very well described. Unfortunately, I've gone through some situations with relatives like that as well. But I would also say, while everybody's frustrated with the nursing home and the lack of staff, I think the government, federal and state government, plays a role too, because it is all about money. And if you do not provide the actual payment for the actual cost, you're obviously always operating on a financial deficit. And I think we need to own up to our responsibility for not providing sufficient finances so that more staff can be hired and that more things can be done to improve the situation, whether it's with, videos, which I think was a very good example, but just simply better communication and trying to avoid that situation where people are being medicated for the wrong reason. So I shall remember your story very well for a long time, not only because I can relate to it, but I hope you don't stop advocating and informing people about this, including Ombudsman and Department of Public Health, because you are spot on. And
I had the best ombudsman representative working with me, and she taught me everything that I know today. And she fought with me. She fought very hard with me to get just those 2 hours a day, 3 days a week. It was incredible how much I had to fight.
It really is numbing. And unfortunately, COVID was something that nobody was prepared for and didn't know how to respond to. But that's a reason. It should not be the excuse for not trying to maintain our loved ones. And again, I will point out to you, I think the government also plays a role, because a lot of nursing home owners will say, hey, look, I'm only getting paid this amount on the dollar, and there's just no way of being able to make it work. And if we're mandating them to do all these things, then we have to step up to the plate and provide sufficient funding so they can do what you and they are asking for. So thank you very much. And thank you, Madam Chair.
Thank you, Representative. And thank you again, Ms. Reyes, for your testimony. Really appreciate it.
Thank you all so much just for listening.
Wish you the best.
Thank you.
Next is number 126, Jean Mills Araha.
Thank you.
Hi.
Good evening. My name is Jean Mills Arana, and I'm the managing attorney of the Stamford office of Connecticut Legal Services, where I practice elder law. I served on the Nursing Home and Assisted Living Oversight Working Group and on its staffing subcommittee, which was very ably co-chaired by Representative Cook. The legal aid programs support all the provisions of Senate Bill 1030 with some minor suggested substitute language. As a member of the Staffing Levels Subcommittee, I'm going to address the bulk of my testimony to the staffing provisions of Section 13. Inadequate staffing in nursing homes is a long-standing problem. In the 1970s, my mother, a registered nurse, worked nights in one. Her job was to administer medications and do compliance paperwork, but she couldn't bear watching the call lights of the residents go unanswered due to lack of enough nurses' aides. Instead, she went to the residents herself to help them, and she eventually left that job because she couldn't meet the residents' basic needs with the available staff. In 1987, the Federal Nursing Home Reform Act was passed, requiring every nursing home to have sufficient staff to care properly for its residents, but not mandating any specific numbers of hours of care. And under a regulation promulgated over 30 years ago, Connecticut requires only 1.9 hours of care per resident per day. In 2000, the Federal Department of Health and Human Services reported to Congress after studying nursing staff levels and quality care for almost 10 years. That study found that a minimum of 4.1 hours of nursing care per day per resident was needed to meet quality standards. Resident acuities only increased during the last 20 years, so a similar study today might well find a higher necessary minimum. Not surprisingly, many studies found that better staffed nursing homes had better outcomes during the pandemic. The Mathematica report found that Connecticut nursing homes with higher staffing ratings had significantly fewer cases and deaths per licensed bed. In New York City, facilities with the lowest staffing ratings had almost twice the death rate of facilities with high staff ratings. And I cite others in my written testimony. The pandemic also showed the number of social workers and recreational staff is too low. But staffing levels are not important just during a pandemic. Many studies over decades have found that staffing levels are too low in many nursing homes, leading to bed sores, malnutrition, dehydration, injuries from falls, preventable hospitalizations, and death. Connecticut Legal Services programs have supported nursing home staffing level increases for many years. Now that our attention has been focused on the needs of these residents, and after they've suffered the highest proportion of illness and death in this pandemic, we owe it to them to make improvements in our long-term care facilities for the future. 4.1 hours of care per resident per day is a modest ask, given that this minimum was established over 20 years ago and backed by extensive further studies since. It also offers potential cost savings as unnecessary hospitalizations are reduced by better care.
Mr. Ronha, you've reached your 3 minutes if you'd like to give a conclusion.
As someone else mentioned, there's typographical errors in the math, and I offer substitute language for that. In my written testimony, I talked briefly about the testing requirements and electronic monitoring, but I will leave that to my written testimony. I also would just like to say I appreciate all the CNAs and LPNs who have testified, and I'd like to mention that the 12-hour shifts in the staffing provisions are optional, not mandatory, and that was discussed extensively in the subcommittee, but I just wanted to make the point that that is not mandatory. Senate Bill 1030 makes many changes to improve the quality of care and make needed positive difference in the lives of residents of long-term care facilities. Please support this important bill. Thank you for considering my comments.
Thank you so much, Representative Cook.
Thank you, Madam Chairman. And Jeannie, it's great to see you. And I want to thank you for your commitment and your dedication to this cause. I do have a question as you've made aware that you were an important member of our subcommittee, and it's been a pleasure working with you. And we discussed the staffing levels. I want to thank you for pointing out that the 12-hour shift was just a suggestion, not a mandate or a requirement, but something that we would hope people would look at as an option. As we learned in our subcommittee group as well, hearing from people both inside and outside of the facilities, do you think that the 4.1 hours of care divided up by profession, CNA, nurse, and the like, could you speak to that a little bit? I know that that was something that you had addressed and we had addressed significantly, but I'm wondering how you feel about that after listening to the testimony of some of those folks that opposed to that.
Yeah, I appreciated what the LPNs were saying about they felt like they needed more time that is allocated in the bill. I would be very concerned about reducing the RN time because many of the studies of nursing home care really show that RN time is very critical to the quality of care. You know, I'm relying on that 20-year-old study for the numbers. They did actual time studies of how long it took people to do certain things and what they thought was the minimum needed. So I think it's important to designate that. I don't think we want to skimp on the RN time.
And do you want to briefly discuss your views on the essential caregiver piece?
I think the essential caregiver piece is very important. I think some of the criticisms that were raised by previous testifiers are important in terms of, I don't think the facility should designate who the essential caregiver is. I think that should be left to the resident or the family, because I think they're the people that know. I believe there is another bill out there with a more extensive essential caregiver program that might be worth taking a look at.
Yeah, I believe there is as well. And my last question is, how do you feel about the conversation of putting cameras in rooms, exactly for the reasons of which we have experienced over the last year about not being able to see our loved ones?
I think it's very important for people to have cameras in rooms. I thought there's a lot of good language in section 14 of 1030 about you know, respecting the privacy of roommates, which is something we at Legal Services have always been, you know, concerned about. I disagree with section 14 where it says that it's only for nonverbal residents, and I think that's a mistake. I think it should be available to all residents who choose to use it, with the important safeguards for other people's privacy.
Thank you for pointing that out. I completely agree. I don't think that it needs to be just a nonverbal individual. And thank you again for your dedication and commitment, and I look forward to working with you in the future. Thank you, Madam Chair.
Thank you very much, and thank you as well.
Thanks, Representative Cook. Thank you so much for your testimony tonight. I don't see any other questions, so have a good night, and thank you for helping us with this, you know, very important issue.
Thank you so much. Thank you for all that you folks are doing.
Next is 127, Karen Grossman. Go right ahead.
Hi, thank you. I want to thank the senators and representatives who are here and for this opportunity to speak. I will be very brief. I want to support Bill 1030, and I'm going to just briefly address section 8, 9, and 10. Section 8 is on the importance of the family council. And my mom is 96 years old. She's at Sunrise Senior Living in Stamford, and she's had, all told, excellent care. The family council for the past 2 years has saved me. It's so wonderful to have support from people in the same situation, and everyone's experience is a little different. We learn so much from each other, and we've come up with some great ideas for Sunrise, and I think they've been mostly appreciative of the group. There's a little bit sometimes of an us versus them kind of thing, where it's almost easier for them not to have to deal with large numbers of people who want whatever it is they want. So there is a little bit of tension sometimes, but all told, they've been pretty good. And I definitely support this legislation, this suggestion that all senior living facilities and assisted livings have some kind of family council to represent their loved ones who can't always speak for themselves. More importantly is the role of the essential caregivers that I believe is section 9 or 10, and that role be elevated. I had the same experience, and I won't go into the details because it's been said so well by so many others, of my mother's a year ago being, she walked, she was full of life, she was exuberant, she was positive, she was energetic. And a year later, after this lockdown and all those months of not seeing her, she's a different person. And we tried so hard to do the FaceTime and the Zooms, and she just looked at the machine and had no idea what it was. And maybe she saw a picture of me, but she didn't know she could talk to me. And she just didn't get it. So it was just more frustration, as was standing outside and waving to her from the window and thinking that would make her happy. I mean, it just made her more confused and more frustration. And before COVID, she had 5 children who all came to visit her, who were all regular parts of her life, who sat with her through meals and took home her laundry and brought her presents and took her out to lunch. And a year later, she doesn't know where they went. She doesn't understand why her family isn't there with her. So that role of essential caregiver, which finally last week, because she's now on hospice, unfortunately, she went from being fully healthy to, and I had the same experience with the Remeron, which I didn't even know she was on it, but found out she was
Ms.
on
Grossman,
it.
you've reached your 3 minutes. If you'd like to give a conclusion.
Yes, I would like to recommend that elevating the role of essential caregiver and perhaps even allowing 2 essential caregivers. I was there this past Sunday and wanted to see my mom with my brother, who drove hours to get there, and they wouldn't let, the rule was 1 essential caregiver. We've both been vaccinated. We're both more than 2 weeks after the 2nd vaccine. We wear masks, we social distance, and yet they wouldn't let the 2 of us in together. And for my mom, who one-on-one conversation is difficult, she would love to just listen to 2 of her children, and she didn't have that opportunity. So yes, elevate that role. That's critical for the well-being of our loved ones.
Thank you so much, Ms. Grossman. Again, you know, these are difficult stories to hear. I can't even imagine going through it. But thank you for taking your experience and helping us learn from it.
You're
so that we
welcome,
can
guys.
do
You've all
better.
been wonderful. I wasn't planning to stay up for all these hours, and I can't turn off my machine because it's all been fascinating. So great job. Really, we're making some progress.
Thank you. It really is. And it's all good if we can come out of it with something meaningful that really, you know, impacts the situation, and we can do better for our, you know, our parents and loved ones that are in these facilities. So Representative McCarty.
Yes, thank you very much, Madam Chair. Very, very quickly. And thank you, Karen, for sharing your stories with a very powerful. I'm so pleased that you're advocating in favor of the essential caregiver program, because I align my remarks with yours on the importance of that program. But I'm curious, at Sunrise, did the Family Resident Council, have you ever heard of the resident advocacy program? Did you have any resident advocates at your facility?
The executive director of the facility joins us at our monthly meetings, and we usually ask for 1 guest that we request. Sometimes it's a nurse, and sometimes it's the Alzheimer's specialist, the woman who runs the Alzheimer's floor. So we can get a speaker, but no, I haven't heard of that specific program at all.
I won't take up the time tonight, Madam Chair, but I think it's important, as we're looking at the overall health of the long-term care facilities, that there was a program, and the Ombudsman is very aware of it. It's a resident advocacy program, and we used to have hundreds of these advocates that would go throughout our facilities, and now we're really down to just maybe 20, and I think it goes in companion with the essential caregiver. So I just wanted to point that out, and just kind of curious if whether Karen had heard of it.
Or are they paid professionals, or who
They
are
work
they?
with the They work with the state ombudsman, and they are trained under the ombudsman program. But over the years, the program has dwindled down from when we had hundreds. But our long-term care ombudsman is aware, and I just wondered whether your facility had one there. So
We work with Mairead, and she's been wonderful, just so helpful when we need her. She's been terrific. But I would love to learn more about this at some point. I will contact you. Thank you.
Thank you, and thank you for the privilege, Madam Chair.
Thank you, Representative, and thanks for bringing that up. I'd love to have a conversation with you about that program and learn more about it. Sounds like it's something that we could use. Thank you, Ms. Grossman. I don't see any other hands raised. Again, all the best to your family and your mom, and thank you for being such a great advocate.
Thank you.
Next, we have 129, Emma Jean McLyman. Emma Jean, are you here?
Yes, I am.
Oh, there you are.
I'm
Thank
at
you
work.
so much.
I'm sorry.
Thanks for being here. Go right ahead.
Yes. Good afternoon or good evening, Senator Abrams and the rest of the team. I am reading from my phone, so I'm going to be on off camera. My name is Imogene McClymont. I'm a CNA of Touchpoint of Farmington, the SEIU District 1199, New England, before the Public Health Committee. In support of the SB 1030, an act concerning long-term care facility with changes. Good morning, Senator Abraham, representative of Steinberg, and member of the Public Health Committee. My name is Imogene McClymont. I live at Hartford and have been working at Touchpoint of Farmington for the past 14 years. I am a certified nursing assistant and I am also a cosmetologist. I have received an associate degree in health information management at Capital Community College, and I am currently enrolled in Charter Oak State College for the bachelor's in health information management. I am here to testify in support of Senate Bill 1030 because it will be a significant step in helping workers like me. The population we take care of are now more combative, sometimes dangerous, and required equal care. As a result, it is difficult to hire and retain staff at the current rate of pay while working in these conditions. These days, few people are willing to enter the field of long-term healthcare when comparing the risk of catching a deadly disease on the job, combined with the risk of taking it home to your family. Because of this, nursing homes are facing drastic staffing crisis. We have less and less people working and less people applying to work at nursing homes. During the pandemic, we worked tirelessly. We were physically and emotionally stressed out, not knowing what the outcome was going to be. We lost lots of residents in this dreadful virus, and some of our coworkers became ill from the dreadful virus. It was very sad because most of us are mostly attached to us. Passing this bill would be a start to treating workers how they should be treated. We need better staffing so that the residents would have more interaction with us and so they can receive better care. Our residents deserve way better than what they are getting now. I urge you to pass this bill because it would significantly address and improve the funding and chronic staffing issues facing nursing home according to the state. Please pass the Senate Bill 1030. Thank you for your time.
Thank you so much for your testimony, and thank you for the work that you do. It's very much appreciated. We've heard a lot of stories and we know how hard that you work, and we really do appreciate it, especially during this pandemic. So hopefully this bill will address some of the concerns that you have. I don't see any hands raised, so have a wonderful night. Thank you for being here.
Thank you, Senator. Bye-bye.
There's one more person to testify, Gretchen Raffa. Gretchen, go right ahead.
Good evening, Senator Doherty Abrams, Representative Steinberg, and honorable members of the Public Health Committee. My name is Gretchen Raffa, Senior Director of Public Policy, Advocacy, and Organizing with Planned Parenthood of Southern New England, testifying in support of Senate Bill 1, an act equalizing comprehensive access to mental, behavioral, and physical health care in response to the pandemic. I want to thank you all for listening so wonderfully today to hours of testimony and still allowing me time to testify because I missed my spot earlier. I really am grateful. So I will make this quick. You know, Planned Parenthood believes all people should have access to quality, affordable health care, regardless of who you are, where you live, your income, or if you have health insurance. Health equity is at the center of Planned Parenthood's mission. And as you know, this unprecedented health crisis has further expose vast health disparities in our state and country, including its disproportionate impact on Black, Indigenous, and other people of color. We know our patients are forced to confront the intersection of these devastating crises, the disproportionate impact of the pandemic and pervasive systemic racism that leads to racial health disparities and life-threatening health outcomes, economic insecurity, and more. Racism has a public health impact. And as healthcare experts, Planned Parenthood knows racism is a public health crisis. This pandemic has sent a message loud and clear. People need more. Any barrier to healthcare is dangerous and harmful. We support this bill, specifically highlighting the sections that would directly address and work towards improving the health of women of color. As you can reference in my written testimony, there's a lot more details and statistics regarding each section. We commend the committee for specifically focusing on pregnancy and postpartum care and maternal mortality and morbidity, and including the importance of doula care to improve maternal and child health outcomes, as well as highlighting the need to advance breast health care. SB1 is an opportunity for our state to lead the pursuit for racial justice with action. We stand with the Connecticut campaign to address racism as a public health crisis and support their recommendations to be considered. Deeply entrenched systemic racism in healthcare has resulted in Black women who are 50% more likely to be uninsured than non-elderly, non-Hispanic white women, facing barriers in accessing the quality, unbiased healthcare services and social support they need to lead healthy lives. These inequities often result in delayed or misdiagnoses, higher rates of STIs, increased breast cancer, and maternal mortality rates that leave Black women 3 to 4 times as likely to die from pregnancy-related causes as their white counterparts. This must change. We are a proud member of the Doulas for Connecticut Coalition, led by doulas from across the state. You've heard from them and advocates earlier today why SB1 is significant to doulas in our state and a path towards title protection, which is crucial and provides stronger identity and credibility and prevents misrepresentation of the profession. Planned Parenthood of Southern New England has long fought for a person's right to control their reproductive lives, which includes planning their families, having a healthy pregnancy, giving birth to a healthy child, and raising their family in safe and healthy environments.
Ms. Raffig, you've reached your 3 minutes.
And we
like to give
urge
a
you
conclusion.
to pass it, and thank you so much for your time tonight.
Thank you for being here, Gretchen. I'm glad that we got to hear from you on these important issues. So thank you for sticking it out to the end. And
Thank you. You too.
I don't see any other hands raised. So thank you so much and have a good night.
You too. Thank you, everyone.
And to everyone on the committee, as always, it's just such a pleasure serving with all of you. And I really appreciate your stamina today, as you always have. And Representative Foster, your daughter's adorable.
Thank you, Mary. Thank you, Rep.
There have been a number of young people in and out of the screen. I think we're interfering with bedtime.
I think so too. I think
If not theirs, mine.
Oh, good night. Good night. So go read a book. Enjoy your red time. I just want to remind you that we have a committee meeting at 9 o'clock on Friday. So we will see you all back then. Thank you. And thank you so much to our staff. Great job again, you guys.
Thank you, Beverly.
Thanks,
everybody.
Bye.
Good night.
Good night, Beverly.
Night.
I'm not even telling you to shut up. Bye.
No, you may as well be sure.
Bye.
Hi, Phil.
Hey, Beverly, how are you? Nice to see you. Are you up in the Capitol at all these days? Bev? It's Phil.